virus is a double-stranded DNA virus envelope belonging to the orthopox genus of the poxviridae family. It is closely related to the smallpox virus. The natural reservoir has not yet been identified. However, largest animal reservoirs are in squirrels and giant pouch rats. The incubation period is 5 to 21 days, and the period of communicability is 1 to 2 days before the rash till the scabs fall off. The case fertility rate is 1 to 2%. However, it is noted that it increases to 11% in primarily vulnerable age groups, such as extremes of age, children, elderly population, and in pregnant females. This is an electron micrograph photo of the monkeypox virus. As we can see, the envelope structure of the virus. This slide represents the nature of geographic distribution of the monkeypox virus. As I initially mentioned, it was first reported in Democratic Republic of Congo in 1970, and it was primarily confined to West Africa in that decade. Following this, it spread to the Central African Republic, and in the 2000s, it spread outside Africa into US, and since then, it has acquired a global. Of late, it has acquired a global character. Cases have been reported in the Eastern Mediterranean, Western Pacific region, and even in India. The clinical features of monkeypox. Monkeypox is a self-limiting disease with symptoms lasting for 2 to 4 weeks. The prodromal phase is 5 days associated with fever, with rash, myalgia, arthralgia, malaise, and fatigue. The classical feature that distinguishes it from other exanthematous fevers is its lymphadenopathy. The severity is related to the age of the patient. As I initially mentioned, the vulnerable groups are extremes of age, the vaccination status, the nutritional profile, and the presence of comorbidities such as diabetes, hypertension, and cardiovascular disease. It is noted that monkeypox usually complicates into secondary bacterial infections such as bronchopneumonia and can also lead to corneal ulcerations and progressive blindness. The evolution of the rash of monkeypox. The rash usually begins within 1 to 3 days of the onset of fever, and it involves in the pattern of initially present as a macular lesion, followed by papillary, vesicular, and the pustular phase. The classical lesions of monkeypox are described as vesiculopustular, and it subsequently becomes a deep-seated, well-circumscribed, umbilicated lesion until the scabs fall off. This table contrasts the 3 classical exanthematous fevers that we know: monkeypox, chickenpox, and smallpox, which was eradicated in 1980. Monkeypox is closely related to smallpox, both being having a classical centrifugal distribution, but what distinguishes them is the presence of classical lymphadenopathy in the monkeypox illness, and the distinction between monkeypox and chickenpox is the pattern of rash distribution. In monkeypox, it is a centrifugal spread, which starts in the face and then spreads to the rest of the body, while in the case of chickenpox, it is a centripetal distribution, where it starts in the chest and back and then spreads to the rest of the body. The diagnostic approach of monkeypox is by the PCR method. The sample collected from the lesion is subject to an PCR analysis, and the identification of monkeypox clinches the diagnosis in correlation with the classical clinical picture. The management of monkeypox is primarily supportive, with increased emphasis on preventive measures. Prevention is a key strategy, and it is by isolating the patient, ensuring that she or he resides in a separate room with a separate ventilation and wears a triple layer mask. All skin lesions should be covered to the maximum extent possible to limit the spread. And although it is noted that prior smallpox vaccination has resulted in more than 85% protection in the recent epidemic, and there's increased emphasis in research on the Immunovune vaccine, which is a third-gen small vaccine to provide protection against monkeypox. However, it must be noted that there is no cross-immunity with the chickenpox virus. This slide further elaborates on the supportive management that I talked about. So we can manage fever by using antipyretics, itching pruritus by antihistamines, nausea vomiting by antiemetics, and the skin rash by antiseptic measures, and in case of refractory skin lesions, using topical antibiotics like mupironic acid and fusidine. The current scenario of monkeypox is as follows. As per the WHO data, to the time when this study was conducted, there were 22,845 cases of monkeypox worldwide, with 4 cases noted in India and USA having the highest number of cases. Now coming to the discussion of my paper, my study was a cross-sectional observation study. It was conducted in the emergency department of JNMC Hospital, Aligarh. The study population was 100 emergency health workers, which consisted of 60 doctors and 40 nursing staff. And the data collection tool was a self-administered questionnaire, which was presented in English and in a vernacular language, in Hindi. After obtaining the necessary approval from the Institutional Ethics Committee, the sampling frame was obtained from the Medical Superintendent's office. This was followed by the sampling process in which multi-stage sampling was done to identify probable participants from each department. And then using simple random sampling, the subject population was chosen and interviews were conducted using the self-administered questionnaire. The aims and objectives of the study to assess the readiness of healthcare workers regarding monkeypox prevention and management, to assess the knowledge of healthcare workers regarding the background, and to raise awareness regarding monkeypox among healthcare workers. The questionnaire was a self-administered questionnaire provided in English and Hindi, and it assessed 4 main knowledge domains: the virus structure and background, the epidemiological aspects, the clinical pathological profile, and the prevention and management. It was single best answer type, and results were evaluated on the basis of the overall aggregated score and individual scores in each section. The following graphs represent the results of my paper. The respondents, there are 40% nurses and 60% doctors, as initially mentioned. And if we compare the awareness among doctors and nurses on the basis of the various question aspects that I talked about, 50% of doctors and 20% of nurses were aware about the structure and background of the monkeypox, the virological aspects. 80% of doctors and 20% nurses were aware about the epidemiological aspects. 80% of the doctors and 20% of nurses were aware about the clinical profile, and 60% doctors and 15% nurses were aware about the management and primarily the most important part, the preventive strategies for the monkeypox. Overall, regarding the current spread, 90% were aware, while 10% were unaware of the comparison of the current spread of the monkeypox virus. If we compare among the various subject groups, 100% of doctors and 75% of nurses were aware about the current spread, while 25% nursing staff were noted to be unaware. A main focus of my questionnaire was regarding the non-availability of the vaccine. Although there is increased research on the immunovax, but it has been noted that there has been no solid data on whether it is effective enough to prevent against monkeypox. Therefore, the strategies regarding monkeypox have been primarily isolation and preventing contact with infected persons. But the concerns regarding availability of vaccine, 80% doctors noted that it is of grave concern, as we have learned from experiences in the COVID-19 pandemic, while 90% nurses did not seem to resemble significant concern with regards to the availability of a monkeypox vaccine. Sir, coming to my discussion, the earlier studies, knowledge of monkeypox among participants was relatively low, particularly as regards to the epidemiology, the clinical profile, and management, as this study was conducted prior to the WHO declaring it a public health emergency of international concern, which was done so on 23rd July. My study was done following this announcement, and therefore, my study showed an increased knowledge regarding the monkeypox virus. And in a similar study done by Vishal and others, which was again conducted following the declaration, it was noted that the awareness was satisfactory among the respondents. Now, coming to the main aim of my study was to acquaint us with the importance of what an effective management of public health emergency requirement is, that it requires an effective, comprehensive, coordinated, and practical response. It is essential to involve all stakeholders in the decision-making process, upscaling the regular capacity, increasing the risk communication mechanism, development of efficient laboratory surveillance tools, estimating burdens of disease by having a solid surveillance system, and planning for adequate and essential deployment of resources. These are my references. Thank you. Yes, sir. Following that, sir. Yes, sir. Nothing, sir. Sir, I used the OpenEpi software to identify the sample size, and it was calculated to 102. And using that, for practical purposes, I converted that to 100. And for the purpose of orientation, I used 60% doctors and 40% nurses on an arbitrary basis.
Arbitrary basis. Yes. There was no this thing.
So in the initial calculation sample size, using the OpenEpi software was calculated 102. But I did not consider the variable of differentiating among the various healthcare groups in
Okay.
that particular calculation. It was calculated 102, and for practical purpose it was 100. But for the purpose of dividing it into the various subject groups, I did that on an arbitrary basis, 60% doctors and 40% nursing staff, on the basis of the availability of healthcare workers in the emergency department of the tertiary care hospital in which I conducted the studies.
That time there were no cases detected in India.
There was there the time there were 4 cases detected in India. Sir, when the
All
study
were
was
travelers from
Yes, sir.
yeah. So
No,
so far Indian indigenous cases not
No, were not detected.
So what was could have been the possible reason and which in your study probably it was missing in the part? Why it was not detected too much in India or not even one case?
As I observed from my study was that I alluded to an initial study which was conducted prior to the declaration of WHO as a public health emergency of international concern. In that, there were significant knowledge gaps noted in the understanding of monkeypox, primarily because it's endemic in Central and West Africa. But following the declaration, the increased media coverage, the increased literature reviews that are happening, and the increased emphasis on the study on the concept of monkeypox and the lessons that we have learned from COVID-19
COVID,
pandemic, not to
yeah.
repeat those mistakes again.
Yeah.
So we have realized that our communication mechanisms have become stronger.
Yeah.
And that was I was alluding to that fact.
Probably is that one. Another reason is this monkeypox is higher risk is homosexuals and this thing, which is probably less common in India compared to Africa and this thing. And our COVID preparedness has worked is probably with monkeypox, which says that. Thank you for a presentation.
Thank you. Good. So now to invite the second presenter, Dr. Jay Tiwari, who will be presenting on a cross-sectional study to evaluate prevalence of diabetic kidney disease in type 2 diabetes patients. So you have 7 minutes to present and 2 minutes for discussion.
Please stick to the time so that we will finish it in the right time.
Is someone keeping time or
That is there.
because the buzzer is not,
visible for us.
yeah,
So give us a 7-minute bell and a 9 minutes.
Yeah.
yeah, because we are not understanding. So shall we keep our alarm, like timer?
7 minutes they have said.
No, but is it visible here? It's not visible here. For you, is it visible? 7 minutes? It's visible. Okay.
Okay.
Start.
Good morning, respected judges and everyone present here. I am Jay Tiwari, MBBS third professional student from King George's Medical University, Lucknow. And I'm going to be presenting my paper titled A Cross-Sectional Study to Evaluate the Prevalence of Chronic Kidney Disease in People with Type 2 Diabetes mellitus in a Tertiary Care Center. So, Type 2 Diabetes mellitus, it leads to a lot of vascular complications. One of the key ones being chronic kidney disease. Chronic kidney disease affects 20 to 40% of people with diabetes, and it is a major cause of morbidity. It was highlighted by the fact that the third National Health and Nutrition Examination Survey, which was conducted across 10 years and had 15,000 participants, it showed that associated kidney disease, it was the biggest contributor to increased mortality in people with type 2 DM. Moreover, the presence of CKD increased the risk of all-cause and cardiovascular mortality in type 2 diabetes. So, the aim of the study was to document and categorize demographic, anthropometric, and physiological risk factors of CKD in type 2 DM in India, and to evaluate the magnitude of each risk factor, namely age, duration of diabetes, HbA1c, and body mass index in its etiology. So, this was an observational, single-center, and cross-sectional study which was performed at a diabetes care center in Lucknow. Out of the total 504 eligible patients, which were above the age of 18 and of either sex, we could get the required data from 435 patients. Demographic data, estimated glomerular filtration rate, serum creatinine, urinary albumin creatinine ratio, and HbA1c levels were the data which were collected, and the appropriate statistical tests were applied. People with the diagnosis of acute kidney injury, symptomatic urinary tract infection, history of hematuria, or were undergone renal transplant or were on maintenance dialysis, or participants of any other study in the previous 3 months were excluded. Even the pregnant women were also excluded from the study. So coming to the results, these were the parameters which we got. The average age was around 51 years, And as we can see, the majority of the patients, they lied in the 36 to 65-year age group. We can see 26%, 32 and 24. These constitute the majority of the subjects in our study. The sex distribution, it was approximately equal, with the males coming in at 52% and the females at 48%. And the average BMI was 25.7. So we can see a lot of patients were in the overweight and obese category. These constitute approximately 55% of the subjects. Now, for the duration of diabetes, the average came out to be around 7 years. Those who had a history of diabetes for the past 1 to 5 years, they constituted 44%. And 6 to 10 years, 32.67%. So these two were the major groups. HbA1c average was 8.55%, and estimated GFR came out to be 80.2 milliliter per minute per 1.73 meter square. And for the stages of CKD, the majority were in the stage 1 and stage 2, as can be seen here, 35% and 37% respectively. Now, when the effective GFR, it was plotted against age in years, we can see that we got a graph which had a negative correlation between these two variables. And the correlation coefficient, it came out to be minus 0.365. And this correlation was significant because the p-value came out to be less than 0.01. Now, similarly, when the BMI was plotted against effective GFR, again, actually we got this graph to have a positive correlation. The correlation coefficient was 0.353, and again it was significant because the p-value was again less than 0.01. When the duration of diabetes was plotted against eGFR, we got a negative graph, negative correlation, and this was again significant as the p-value was 0.03. So in total, this table summarizes that fact. All the correlation coefficient and the p-values are given. Over here we can see the HbA1c. It was, when plotted against eGFR, the HbA1c, it had a negative correlation, and it was not even significant because the p-value was 0.239. So this was not significant over there. Now, this table shows the combined eGFR and the urinary albumin-creatinine ratio in our subjects. So we can see for urinary albumin-creatinine ratio, the majority of the patients, 62%, they were normoalbuminuric, means they had a urinary creatinine ratio of less than 30 milligram of albumin per gram of creatinine. 35.86%, they were microalbuminuric, and only 2% were in the macro range. And over here again, showing the previous data, in stage 1 and 2, these constituted the major proportion of the subjects in the study. So coming to the discussion, now it is known that the prevalence of CKD increases with age, as the age-related abnormalities predispose older people to increase the risk of CKD. Much evidence exists demonstrating obesity as a risk factor for reduced effective GFR and CKD. The Framingham study cohort showed that BMI could predict the reduced kidney function irrespective of the presence of other comorbidities like diabetes and hypertension. But our results did not really match that. We saw that with increasing BMI, the eGFR was also increased. It had a positive correlation. So this can be explained by the fact that BMI does not really differentiate between the muscle mass and the total body weight. It is a very quantifiable number because it just takes the weight. It does not take into account whether it is of muscle mass or the body weight. So that is why we had that positive correlation. And HbA1c levels, it was negatively correlated as I showed you, but the result was not significant. So we can say that historical glycemic control over sequential values of HbA1c, it can be a better predictor, which can be sought for in further studies. So in conclusion, it showed consistent and recent epidemiological data showing inverse relationship between eGFR and age and duration of diabetes and positive correlation with BMI. The absence of urinary albumin-creatinine ratio, it should not be an indicator of normal renal function. And with decreased eGFR, we should start monitoring the patient. And moreover, we can say that because the study was conducted in an urban center with patients receiving optimum diabetes care, it may not be a very true representation of the general population. So more studies can be done in this aspect as well. These were my references. Thank you.
Thank you, Jay. Very good presentation. You also maintained time. Congratulations for that. Just tell us what was your thoughts in looking at the correlation between BMI and EGFR when you were planning for the study, and why only BMI? Why not waist circumference or any other markers of anthropometry which measures obesity?
Sir, for BMI, it was a bit more simpler. We just took the weight and the height. So it was more simpler, and for other measurements, it would have taken a bit more time. So to make it a bit shorter, so we went for the BMI.
Right. And did you also look at the correlation with blood pressure? And the
No.
duration of hypertension, coexisting
No, sir,
hypertension
that
and
was
blood
not
pressure?
included.
Okay. Thank you very much.
So only one question was that you didn't find a significance of the BMI, but you had taken a waist ratio, it would have come probably. Second thing is that another most important risk factor is the hypertension.
Yes, sir.
Another is retinopathy. Probably you didn't look at the retinopathy.
Yes, sir.
Coexistent retinopathy. You just took the patient 545. You told cross-sectional study. Cross-sectional studies in a population you have mentioned, but it was a hospital-based clinic study, is it not?
Sir, the patient that we took. it
Now,
was
when you say
more of like a
cross-sectional whole population, because these are all, say, epidemiological studies like diabetic nephropathy and all,
Yes, sir.
it should be whole population screening because it's difficult, but agreed that you have done a small study in a hospital-based. Thank you. Thank you for nice presentation.
So you are third MBBS student, right?
Yes, ma'am.
So for that, it's really a good thing. And what was your role exactly in this particular study?
Ma'am, I was more inclined towards the literature review, the writing
Yeah.
portion, trying to sort out the writing part, and sometimes also in the statistical portion. to
Okay.
sort out
So who had collected the data?
Ma'am, it is actually my dad's center.
Okay.
So my dad, along with the hospital staff over there,
Okay.
they used to do most of the part.
Fine. But it was a good effort. Good.
Thank you.
Good presentation. Thank you.
Thank you.
So coming to the next one, I invite Dr. Arvind Kumar for presenting on lung ultrasound, a possible approach for detection of COVID-19 severity associated.
So good morning all. Thank you ACP. Is it not showing? Good morning all. Thank you ACP for this opportunity. Respected judges, seniors and my dear colleagues. The title of my research is Lung Ultrasound, a possible approach for detection of COVID-19 pneumonia and associated mortality. So I have no disclosures for this presentation to make here. So over last 3 to 4 years, we have realized that CT scan is the diagnostic modality for COVID pneumonia. In the meantime, we have also realized that it has so much of difficulties in patients who are isolated and to prevent the exposure of healthcare workers in shifting the patient from a COVID area to CT area. So before COVID area, it is established fact in multiple meta-analysis that USG for lung pneumonia is as good as CT in many ways. So in around mid-2020, we have started gaining evidences that it is equally good in COVID pneumonia also. The same thing is being reiterated here by the forest plot that it has showed it has very good odds of diagnosing COVID pneumonia, the finding that we mostly get in terms of interstitial pneumonitis. So with the aim to diagnose and predict the severity, this study was conducted in a single center in a prospective manner at a center where I work, that is All India Institute of Medical Science in New Delhi, from October 20 to January 21 among patients above 18 years, diagnosed with RT-PCR and antigen tests. So they were also classified based on mild, moderate and severe on Government of India guidelines at that point of time. The question on reliability of physicians has been well answered in literature that a physician's ultrasound by a minimal training is as good as that of radiologist. So what we did that besides, taking off demographic data, comorbidities, we also developed this sheet that has been shown at the right side by taking consultants from radiology, medicine and pulmonary medicine to develop a 14-point ultrasound, 6 at back, 4 in front and 4 in axilla. We just tried to note down the profiles, A profile, B profile and C profile at various zones. So A profile means you have a normal lung parenchyma between rift shadow, and if you have a line extending from pleura to the base, it is a B profile, and C is confluent of multiple B lines, that is either a waterfall sign as a shred sign. So after this, we had screened around about 75 patients, and those who fulfilled the criteria, 60 were taken into final analysis, and then they were analyzed. So among the baseline characteristics, what is important to mention is that at our center, the median time of arrival was around 4 days, on which all the ultrasounds were done. So coming to the USG findings that we got in our patients, the median number of B lines in a patient was 35. So to our satisfaction, and the median Jones involvement was 9. The same also happened for 9 as C profile. Around median number of 10 profiles we got in our patients of study. So knowing that the findings were there, we tried to put in a correlation, performance correlations, and we found that they were significantly associated with the development of severity as far as B lines and C profile is concerned. The same thing has been shown here in the scattered plot. Once we put them in bivariate logistic regression, what we found that the number of B lines and abdominal areas were significantly associated with severity at 28 days as well as mortality at 28 days in terms of number of B lines. So now we try to calculate what is the sensitivity and the positive likelihood ratio. So if you take 25 lines in one patient, that has around 1.6 likelihood ratio of positivity as well as 80% sensitivity. If 6 zones were involved, the PLR was 2 with around 100% of sensitivity, and the same thing also happened for mortality. So we draw ROC curve, and what we found that for mortality as well as severity, these kind of findings were significantly associated, as we can show by the area under curve was being 0.78 and 0.87 respectively. So they were quite a good agreement for both the categories. So in discussion, so it is a useful and effective alternative. So at the same time, we had 1 or 2 studies showing that they are correlating with the severity with the pneumonias. But what was new that we tried to develop a prediction model by seeing the abnormal lung fields as well as B lines, and the Jones were also predicting about the severity of pneumonia. So there were some limitations. It was a single-centered studies, and there was no follow-up as far as the ultrasound is concerned. So we had done 1-point ultrasound, and then we have correlated the outcomes at 28 days. And sample size was limited, so the power may be an issue. So what is there to conclude for us that an ultrasound in a busy ward by residents has a good prognostic modalities in a COVID-like pneumonia situation. So it also suggests that 1-point contact could have a good prediction, and because it was a small study, so if you combine this with a larger studies like this, multicentric, so probably we will be able to develop a triaging and prognostic mechanism which would help us exposing our healthcare workers. And we never know when we are going to get a situation like this pandemic, when we have to again cover up like this. So we need to develop modalities where the exposure is less, the patient care is optimal, and we try to give optimal care without, getting burden on healthcare system, because we all know that CT scan has some issues as far as availability and as well as the exposure issues. So I have some acknowledgements. All the patients who suffered in COVID-19 and those who are part of this study. Besides this, my head of the Department of Medicine and Anesthesia, and the whole team of this sonography from Department of Anesthesia, Medicine and Radiology who had done this study. So thank you very much for your patience hearing. Thank you very much.
Yeah, it was a nice thought that lung ultrasound should be done in COVID patients. Now we are having emergency departments almost everywhere and it upcoming in medical colleges. But then, although the sample size is low, how did this lung scan helped you in management? Did it help?
So, ma'am, at that point of time when we were doing this study, there was some evidences that they do categorize in moderate and severe diseases. Definitely, at the time in emergency, when the patient had first contact, there's so much of cure, so much of anger because of COVID, we were not able to. What it did to us is that we were able to tell about on CT scan, we put it quite early, let's say in 2 or 3 days back, at the time of first contact.
Okay, but
We used
then
to tell.
could you find out the severity as we used to get on chest X-ray, that the zones on chest X-ray, that 6 zones, or on HRCT we used to get the scoring
Yes, ma'am.
out of 25. So was there anything like that comparable on ultrasound?
Yes, ma'am. It was closely associated with severity. More than 6 zones or more than 25 lines. Just count the numbers of B lines in all the zones, add them up. If it is 25 or the zones were 6, it was a severe COVID at some point of time.
But then how did you rate it on sonography?
So, by the counting the number of zones.
By B lines and
B
the...
lines and number of zones.
okay.
And C profiles, the profiles when we have multiple B lines in confluence, that is a waterfall sign.
Yeah, that's what I was asking. Waterfall sign was the...
It's a good study, sir. That what one this thing is that only number was less. Probably was it because of ethical problems or initial?
Yes, sir. I think it is a very less number because at that point of time, there was no
Well,
study.
was that ultrasound was available easily in the emergency in the COVID
Yes, sir. In
first?
our setup, all the residents has to go to the training time.
Yeah.
I am do- all
Second thing is that is there a observer variability? Because once you do CT scan, so I can get a score like this and I can see, somebody else can see. Here, do you have any modes where you can
Very
have
genuine,
reduce the
very-
observer variability?
Yes, sir. Very genuine concern. So we had put that into initial limitations. But what we did afterwards at the time of analysis, all the pictures were then put among the radiologists together with the physicians. So to avoid that. So once they came into the same page, then we tried to analyze that.
The last question, can the, in a lung condition, can the CT scan anytime replace the CT as a best diagnostic modality?
Sir,
Maybe in the COVID pandemic and acute condition to rule out pneumothorax, patch, all those things, whatever is that, can the CT be replaced? Because
Sir,
CT is the standard mode.
Sir, this is definitely a very small study, but what I feel personally, I am in ultrasound for last almost 7 to 8 years. This is the demand of the time. I mean, we say it a new stethoscope.
Yeah,
So
that's what I was-
if training is being given at a center, so we can utilize this a very good modality, sir.
So very good presentation, and just trying to learn from you that did you get an opportunity to do the follow-up ultrasound on one particular patient and correlate with the CT findings, especially when they're getting into the fibrotic stage? So was there an opportunity
Yes,
on
sir.
doing
So that was an important limitation. We didn't really do a next ultrasound, but what we did, we at least, we saw them at 28 days, whether they died or survived, and what was the maximum severity in this duration. So that is the limitation, sir. Thank you. Thank you very
Thank you
much.
for a nice presentation.
Last one question from my side, because I am a pulmonologist. I am very eagerly and to learn from you, and it was very nice presentation by you, sir. And my one query is that, do you have any correlation with the inflammatory markers with the ultrasonography findings? And one more thing is that all the patients you have enrolled in your study, they belong to from ICU, or maybe they categorize it to mild, moderate, severe, or might be they are severe COVID patient. What kind of patient
Ma'am,
you have included?
The
in your
first
study?
question, I have almost done all the inflammatory markers. I have made the table also because I tried to practice in the morning, and so they are not practicing in time. So they correlated well. The number of gens, the zones were correlating well with the CRP's D-dimer and procalcitonin in many cases. I mean, those were superimposed. And the second part of your question is that, I mean, how do you classify it?
You have enrolled 60, I think 75 patients in your study. So what were the categorization of those patients? They were belong to severe class of the COVID at the time of, at what time ultrasound was done? during the study process?
So all the patients, the median time of arrival to our emergency department was 4th day. So it started from a range of 2 to 8 days. So all the ultrasound done was on the first contact. Those were a positive RT-PCR, and then we saw their severity. So all of them were done ultrasound the first contact. So few of them move into you can see around 60% of the patients were severe. Moderate was around 35%, and very less percentage mild. Milder were those who were very apprehensive for admissions. So also we did ultrasound on those patients. Thank you very much.
Thank you,
Thank you.
Dr. Arvind. So we'll move to the next presentation by Jignesh Gupta, prevalence and awareness of and unawareness of hypertension and its control in different cohorts in Bikaner.
Good morning, everyone, respected judges. I'm Dr. Jigyasa Gupta, presenting our study on prevalence of awareness and unawareness of hypertension and its control in different cohorts in Bikaner, northwestern zone of Rajasthan. The prevalence of hypertension is increasing rapidly, especially in developing countries like India. Better control of high blood pressure can lead to prevention of 300,000 of the 1.5 million annual deaths from cardiovascular diseases in India. Recently, we are observing increasing prevalence of early age onset of hypertension. We screened 10,259 adults by organizing camps in different parts of Bikaner, rural and urban area. Blood pressure measurement was done as per guidelines by Omron, automatic digital BP monitor. 3 consecutive readings of blood pressure were taken in each case, and final 3rd reading was considered for statistical analysis. Hypertension is diagnosed when blood pressure is more than or equal to 140/90, and pre-hypertension was more than or equal to 120/80 to less than 140/90 as per JNC 8 guidelines. All subjects were evaluated as per performer. The overall prevalence of hypertension in our study was 32.26%. 19.96% were known hypertensives, while 12.30% were detected for the first time, and they were unaware of their hypertension. 25.42% were having pre-hypertension stage, while normal blood pressure was only present in 42.31% subjects. Out of 2048 known hypertensive cases that were under treatment, only 53.5% were controlled to target blood pressure, while 46.5% were uncontrolled. Overall prevalence of hypertension was found to be 32.3%, including known hypertensives 20% and first-time diagnosed hypertensives 12.3% who were unaware of high blood pressure. This is a tabular form for prevalence of hypertension, age, sex distribution of subjects. Prevalence of hypertension was found to be significant, 11.6% in younger age group, 18 to 35 years, with very high prevalence of pre-hypertension, 26.6%, which was alarming. As the age advances, prevalence of hypertension increases. Prevalence of hypertension was more in males as compared to females, below 55 years of age, but above 55 years of age, it was almost equal in both sex groups. Distribution of cases according to educational qualification in relation to hypertension. Prevalence of hypertension, pre-hypertension was found highest in undergraduates and lowest in uneducated, probably because of stress for career. Then a prevalence of hypertension in occupation related. Prevalence of hypertension and pre-hypertension was found to be highest in retired old people, and clerks, followed by businessmen and professional, and lowest in labor class and farmers. Then according to residents, prevalence of hypertension was high in urban population as compared to the rural, but prevalence of pre-hypertension was almost equal in both groups, in both the sexes. Prevalence of hypertension in relation to alcohol intake and tobacco and diabetes mellitus. It was found that prevalence of hypertension was more in alcohol consumers and tobacco chewers, and significantly high in diabetes mellitus. Out of 2048 known hypertensives that were under treatment, 53.5% were controlled to target blood pressure and 46.5% were uncontrolled. Out of 3,310 cases of hypertension, 1262 were detected for the first time during examination in the camp, and they were unaware of high blood pressure. Conclusion of my study: increasing prevalence of hypertension in younger age group and high prevalence of pre-hypertension is alarming, and they must be evaluated for secondary hypertension. Ignorance about uncontrolled blood pressure despite under treatment will not give benefit of hypertension management. Pre-hypertensive subjects must be targeted to prevent progression to hypertension, and there is a need for government policy for mass medical education programs so as to create awareness regarding hypertension, benefits of its control, including lifestyle, regular antihypertensive therapy, and compliance to the management and regular monitoring of blood pressure. These are my references. Thank you.
Thank you, Jigasa, for a nice presentation. Hypertension is such a common disease, it's almost not recognized. So your study showed, is it a rule of half is there, or is it a rule of 1/3 now? 1/3 is people have got already hypertension. If you see together, your percentage is 11 plus 23. So almost 30% of people have got in the hypertension growth. And again, 40 to 50% people are not controlled.
Yeah.
What did you find? Is it a rule of half or a rule of 1/3?
Rule of 1/3, basically, most of the people, they forget how to take at regular intervals, the medication. They are not compliant with the medication. And once their BP becomes normal, they just stop taking medication.
And other thing is that you have taken to, reaching the target is 140/90 or 130. That's the target. If you see, probably still more prevalence is there.
So 140/90 was our
140/90
target.
is still higher for the JNC 8.
According to JNCA.
Yeah. No, to bring down to this. Okay. How many percent were, refractory hypertension did you get? Did you look at it? Those are on 3 medications, not controlled. You didn't tell.
We did not take that.
Yeah, the targets will keep changing with the comorbidities as well. So 140/90 cannot be a blank target. So that's one. So in your demographic area, what do you think was the main reason for 2 categories? That is, one category is the unawareness of hypertension, and the other is hypertension exists but they're still not controlled. What, according to you, could be the reason in your demographic area from your study?
Thank you, sir, for the question. I think most of the people, like I said, they are not compliant with the medication, and we saw a lot of early age onset pre-hypertension in young adults, 18 to 35 years. So they should be evaluated for secondary hypertension as well.
So when you had collected the data, you said that you had taken 3 readings, and the 3rd reading was considered as a reading for your particular study. So why the 3rd reading was taken, and why average of these 3 readings were not taken?
Ma'am, because usually the first 2 readings, they can provide, patients are mostly anxious, and so that is why there might be like more blood pressure detected wrongly in first 2 readings. So we took like the 3rd one.
Okay, fine. It was a good attempt, and the sample size is also large, so it is more than 10,000 almost. So from where this sample size was taken? Was it a hospital-based population, or it was a general population like?
It was, so the camps were held in almost like across the city, both in rural and urban areas. And
But then the population was fixed like rural and urban, or it was random?
it was random.
Okay.
For regular health checkups, the camps were held.
Okay.
And there we took the blood pressure readings.
Okay. So, any educational or awareness activity was planned after this? Because your conclusion was that awareness and education is important. So, was anything like that planned after the study got completed?
So, we are trying to basically do mass education by holding camps everywhere, and to young adults, we ask them to get themselves checked for pre-hypertension and evaluate their stress and anxiety, and there is a lot of lifestyle changes that young adults should.
So you
be
have
counseled
planned
for.
it?
Yes.
Okay, fine. Any questions from the audience? Yes. Yeah, you.
Ma'am, that was a very nice presentation. I just want to ask that the JNC 8 has been superseded by AHA guidelines. That elevated blood pressure is considered between 120 to 129, and stage 1 of BP is 130 to 139, and stage 2 of BP is 140 and above. So in your study, I think it was done after the AHA guidelines came. So do you think you missed out some stage 1 hypertension patients in your study?
No, sir. We only took JNC. We strictly followed just JNC 8 guidelines.
I think that was what I pointed out. She has taken that JNC 8, but this latest guideline says 120 above we should consider as a patient.
Right, sir. Right.
Okay, thank you. Next presenter is Mimamsa Jindal. Clinics but no clinical training, decoding the impact of COVID-19 lockdown on Indian medical undergraduate students.
So, if you can make these arrangements when we are discussing question and answers, it will save our time.
7 minutes, one bell, 9 minutes, another bell should be.
नहीं तो बाद में जब हमारा डिस्कशन चलता है ना, तब आप नेक्स्ट प्रेजेंटेशन अपलोड कर देना. You can begin, yeah.
Good morning, everyone. I, Dr. Mimamsa Jindal, am here to present my research paper on the topic Clinics but no clinical training, decoding the impact of COVID-19 lockdown on Indian medical undergraduates. This study was done under the guidance of 2 professors at UCMS and GTB Hospital, and it has been approved by the ethical committee of the same premise. To ensure the continuity of medical education, online conventional teaching methodologies had to be replaced with online teaching, therefore jeopardizing bedside clinical training, which had been entirely based on patient interaction and daily visiting the hospital till then. To quote Dr. William OSLER, what you read, you might forget. What you see in clinics, you'll always remember. Clinical postings allow medical students to correlate their cognitive learning domain with the psychomotor domain. Through this study, our aim was to find out the effect of COVID-19 lockdown on clinical training of Indian medical undergraduates by analyzing their perceptions both before and during lockdown. Our primary objective was to compare these two learning experiences, and our secondary objective was to find out the reasons behind the above obtained differences. So this was an observational, online cross-sectional survey, a multicentric study done amongst third and fourth year medical students. We chose to include third and fourth year students and exclude first, second year interns because third and fourth year students was the population which had been exposed to clinical training both before and during lockdown. The study was done over a span of 3 months from December 2020 to February 2021, and the sample size was not prefixed because of the massive coverage and flexibility offered by online surveys. Our questionnaire comprised of 3 main domains. First, socio-demographic details such as age, gender, course year, college name, the type as per the ownership whether government or private, and the state in which college is located, which was further classified into categories 1, 2 and 3 depending on the COVID-19 case burden in that state. Second, mode of clinical training during COVID-19 lockdown, which was quantified in terms of number of hours of online and in-person clinical training separately. Lastly, perceptions about clinical training were recorded in 2 ways. First was the Likert scale-based comparison, and second was an open-ended question. We'll see the details later. Statistical analysis was carried out in a threefold manner. Categorical variables which were obtained from the demographic data were shown as percentages, and the association was tested using chi-square test. Continuous variables which were obtained from the Likert scale were represented as median and interquartile range, and since the data was skewed, we had to employ the non-parametric Wilcoxon sign rank test. Lastly, themes were analyzed from the text responses and thematic analysis was done. So we received a total of 1,000 responses from 191 medical colleges across 26 states and union territories of India, with the median response from one college being 6. So we found that most students belong to final year, were studying in government colleges, belong to category 2 states, that is with 1 to 5 lakh COVID-19 positive cases as per the data released by Ministry of Health and Family Welfare in September 2020, and had received only online clinical training during lockdown. This is the Likert scale-based comparison between 8 main parameters and 8 subparts of question number 2. As we can see, we found that students rated clinical training before lockdown as significantly better for all these items. We also tried to find association between multiple factors such as year of study and the state in which college is located, just to find its association with COVID-19 case burden, but that didn't come out to be significant. We also found that proportion of private medical colleges shifting to online clinical training was significantly more as compared to government medical colleges. So this is a chart representing that whether the students received online clinical training, in-person clinical training, both or none, in all these scenarios they found that clinical training before lockdown was significantly better. So for thematic analysis, we organized all the open-ended responses into 4 categories: the advantages and disadvantages of online training, and the advantages and disadvantages of in-person clinical training. Since the advantages of in-person and the disadvantages of online overlap, we didn't make it a separate theme. So while online clinical training was more comfortable, give plenty of time for self-study, was more focused, it lacked patient interaction, had several network issues and poor connectivity. It was difficult to simulate real clinical scenarios, and there was more focus on theoretical knowledge while there was a less emphasis on clinical skills. Also, we found that students in certain states who received in-person clinical training during lockdown, they felt that the number of final year relevant cases in hospitals were less. Faculty and staff were busy in COVID-19 management, and there was an imminent fear of getting COVID, so the physical exposure was also limited. Similar results have been found in a cross-sectional study done amongst 2,000 plus medical students in UK, and they showed that students did not find online teaching to be as engaging, enjoyable or effective as face-to-face teaching. The possible limitations of my study include that since it was an online survey and the questionnaire was not interviewer administered, so there can be some misunderstandings in the understanding of questions, and also we couldn't validate our questionnaire through a pilot study due to the paucity of time. Here are my references. Thank you.
Thank you, Mimaksha. It's a very good presentation, and you also completed on time. A very important topic, and you presented it very well. So, did you look at how the students as well as the teachers adapted to online mode of teaching? Was there any question here on that?
So there was a separate study, not a part of my original study, done by the teachers and the, association at UCMS. Sir, I think the difficulties were on both sides, on the sides of teachers and on the sides of students. We also found that classes which had this provision of polls, quizzes and presentations had a better interaction with students as compared to those without these things. We also followed up the students who had responded in polls and quizzes through their final year examinations, and we found that their performance in their exams was better as compared to other students. Although it was not significant, the p-value did not come out to be significant, but it was better.
Thank you for a wonderful study, and particularly during COVID. So you showed that some of them felt that it is online was good because they were sitting in the home comfortable. How many percentage were that? I was little wondering because some of them would have put up their online teams on and they were not there. That's what we found during the online teaching.
Sir, I remember, I don't need to open the slides.
Yeah, but
76
it was clearly they told they were happy to have online teaching, some percentage.
So 76.21 students said that online clinical training was not as good, although 24% students told that they were enjoying online clinical training because the attendance was better. They didn't have to go to the hospital physically.
Yeah. Okay, thank you. Thank you for this.
Thank you, sir.
Thank you. Okay.
Thank you, sir.
So we move on to the next speaker. We have Kashish Malhotra. He'll be talking about global impact of deep vein thrombosis awareness month, challenges and future recommendations. Start.
Hello everyone, I am Kashish and today I am here to present our research on the global impact of Deep Vein Thrombosis Awareness Month, challenges and future recommendations. Deep vein thrombosis and pulmonary embolism are two interrelated conditions within the venous thromboembolism spectrum with a risk of recurrence and fatal consequences if left untreated. Venous thromboembolism associated with hospitalization is the leading cause of disability-adjusted life years lost in low and middle income countries and second leading cause in high income countries. With over 10 million cases annually, previous studies have well documented the lack of awareness about DVT in the general public and even in DVT patients. So taking into account the significant healthcare burden due to DVT, with many cases going undetected, DVT Awareness Month is observed in March each year. It was legislatively recognized in 2005 by the United States government, followed by other organizations. This global event seeks extensive participation from digital media platforms that connects over 4.5 billion people with an average daily time spent of over 2 hours. While significant financial and human resources are invested in this event, even after 17 years, there is no actual evidence to show the actual impact of this initiative. So we, for the first time, evaluated the global digital impact of DVT Awareness Month on various social media platforms and online digital media without any geographical or language restrictions to steer future policy development. We extracted all the posts from March 2014 to March 2022 using application programming interface of various social media based on the DVT and DVT Awareness Month related hashtags and keywords. We used a broad search query and polynomial regression analysis was done to see overall analysis. Using simplest machine learning algorithm, we calculated the total impressions of hashtag DVT and these impressions indicated the theoretical maximum number of users a given post could have directly reached. The quality of a mention or post was determined by the account's influence, the healthcare stakeholder status, and its overall influence in the healthcare social media. This was done to minimize the manipulation of simplistic measures such as number of tweets, followers, etc. Our analysis was in a way similar to the modern impact factor algorithms for academic journals and Google's PageRank. Similarly, network analysis was done as it provides the capacity to estimate complex patterns of relationships. Each entity was represented with a circle or node, and the node size was set proportional to the number of tweets or mentions received. Similarly, Different colors represented different colors of arguments or communities that frequently go together. We used the following formula in our study. We also did a sentiment analysis to actually get an idea about the actual sentiment about the post. We formulated an emotional scatter plot with pleasure and arousal on its horizontal and vertical axis respectively, which is based on the circumflex model of affect. We used this model rather than simplistic analysis of positive or negative segment that could be easily skewed. Similarly, to understand the global analysis, we studied the relative search popularity for the last 10 years. Google Trends, web search, news search, image search, and video search analysis was done for the search terms DVT Awareness Month and DVT for interest by region in the last 10 years to get an overall idea. Unfortunately, we noted that there has been a declining trend in the DVT Awareness Month total posts starting from 2016. Out of the over total 19,000 posts linked to DVT, only 465 tweets, which is 2.3% of the total tweets, were linked to DVT awareness or DVT awareness month. Similar trends were also noted on Facebook. When we did the hashtag analysis, we found that the key themes linked were DVT, vaccine hesitancy, compression stockings, and USMLE and NEET PG questions. The hashtag DVT amassed over 3 million impressions in March 2022. Similarly, on bibliometric keyword analysis, we found that the posts were linked to COVID-19 and vaccination, hospital stay associated, and contraceptive usage and family planning. We also noted that there is extensive lack of collaboration amongst the top influencers. Even though we were able to identify 51 clusters, over 71% of the influencers never collaborated with each other. Additionally, we also found minimal involvement of news media outlets in this event. Fortunately, we found that most of the posts had a positive sentiment. The majority of the posts were linked to less active but pleasant emotions. However, we noted that this event had very limited global reach. DVT Awareness Month was largely seen as a US-only campaign with very limited involvement from all other continents. However, the search term deep vein thrombosis had a somewhat global reach with limited involvement from the African and Central Asian countries. To conclude, there was lack of targeted action-driven campaigning to promote DVT awareness, especially from the international non-US community. The impact of DVT Awareness Month remains limited, and collaboration is needed amongst all stakeholders to address this preventable and treatable disease. With the preponderance of DVT in all races and ethnicities and age groups, it is pivotal that global action and campaigning is done to promote this awareness event. Digital media has the potential to create awareness at all levels, primordial, primary, secondary, and tertiary levels of prevention, and should be recruited accordingly. Prioritizing equitable involvement from the underrepresented and underprivileged communities shall be focused. Thank you.
Good, it was good presentation. The survey was done in a medical healthcare workers, or it was in a general population?
No, ma'am, this was not a survey. We extracted all the total posts on social media, namely Twitter and Facebook, and based on that we did all our
So it was a general population?
Yes, ma'am.
Okay, fine, good. Any questions from the audience?
So, Kashish, right? Yeah. So very different kind of a study you looked into, very nice, interesting. Just to trying to understand, see, DVT is a medical emergency, right? So how much do you think social media would be impactful in spreading the awareness beyond the emergency room?
Yes, ma'am. Thank you, sir, for your question. We also set up various comparators for this study. Like we also have studied World Heart Day, World Hypertension Day, and similar World Heart Failure Day. And we also noted that for those events, their impressions were in like hundreds of millions, and their collaboration was more than 90%. But when we compare to this, it had declining number of posts and a very limited collaboration. So I think in that aspect, it is important to...
I think that media and this thing will play a long part. COVID probably everybody knows because it was such a this thing. Diabetes, more people know, hypertension, less people. So DVT, if you make it like long flight syndrome, if you had put probably more people who are traveling in flight, they would have known. If it is only DVT, if you say, common public may not be knowing, and even the medical professionals, if you concentrate, maybe the awareness will be much better.
To tackle this, we also included the normal terms, like it is also a similar event like stop the clot, blood clot were also included in our
blood
search
clot.
query. It was also included in our
If you
search
say
query.
blood clot, people will think clot in the brain. They won't think the DVT. Yes. So if you want to specific, long flight syndrome, at least some of the educated people who are traveling in flight will be aware. COVID, if you tell COVID, everybody is aware. If you say DVT, I think very certain population. Thank you for a different kind of study.
So I invite the next speaker, Shivam Verma, who will be presenting on association of serum uric acid levels and insulin resistance in diabetic and non-diabetic population.
Very good morning to the honorable judges and all gathered here. I am Dr. Shivam Verma, working as a post-MD PhD candidate in ICMR in Department of Physiology, King George's Medical University. I am extremely thankful to Professor Narsingh Verma, Professor Anuj Maheshwari for giving me this opportunity. So today's topic is association of serum uric acid levels with insulin resistance in pre-diabetic and drug-naive diabetic subjects. So uric acid is a product of the result of chronic inflammation and inert metabolic end product of purine metabolism. Uric acid is the part of story that's running with metabolic syndrome. Metabolic syndrome or syndrome X is a major clinical challenge in current practicing scenario. Metabolic syndrome includes hypertriglyceride levels, increased BP level, increased waist-hip ratio, and increased BMI with hypertension, and all those stories linked with a common thing, that is insulin resistance. So mechanism of uric acid to work on insulin resistance and the glucose pathway is the AMP activated protein kinase that's help in insulin signaling, and it stimulates the level of gluconeogenesis and the insulin mediated endothelial nitric oxide release. So the aim of our study is to find out association of uric acid levels with anthropometric parameters and insulin resistance in pre-diabetic and drug-naive diabetic subjects. So to measure the anthropometric parameters, including those of upper body fat distribution, and to establish the relationship between insulin resistance and the uric acid levels in pre-diabetic and drug-naive newly diagnosed diabetic subjects. The cause of including the drug-naive diabetic subjects is to avoid the confounding because of the drugs used by the patients, especially the oral hypoglycemic drugs. The study includes 124 urban drug-naive diabetic Indian subjects above 18 years of age from general population of city of North India, and all pre-diabetics and the newly drug-naive diabetic adults have been included of any age group irrespective of the sex. Anthropometric parameters were recorded by in-person interview. Uric acid levels are measured by enzymatic calorimetric method, plasma glucose was measured by Godpauth method, and the serum insulin was measured by ELISA. And the insulin resistance has been calculated by using this formula of HOMA-IR, this glucose into insulin divided by 405, and fasting levels has been collected both for plasma glucose levels as well as serum insulin level and the uric acid level. Anthropometric parameters have been taken by in-person interview, and the parameters we include is height, weight, BMI, ABSI, body roundness index, waist to height ratio, waist to hip ratio, triceps skin fold thickness and all. So the result shows that serum uric acid has significant positive correlation with HOMA-IR, that is insulin resistance, with p-value of 0.001, and serum uric acid has significant and positive correlation with fasting plasma glucose with p-value of 0.01, that is significant. And serum uric acid also has significant positive correlation with fasting serum insulin with p-value of 0.0001. That's highly significant. So in this chart I want to show that these are the anthropometric parameters, especially height, weight, BMI, neck circumference, waist circumference, hip circumference, sagittal abdominal diameter, skin fold thickness, and waist hip ratio, and also the weight to height ratio, body roundness index, and the serum uric acid with systolic blood pressure and versus diastolic blood pressure. So the figures showing with red have highly significant value: weight, BMI, sagittal abdominal diameter, and the waist hip ratio. So this shows that the serum uric acid levels are much lean toward the components that are showing the visceral adiposity, because at present scenario BMI is not very valuable parameter for measuring the especially challenging the anthropometric parameters, because BMI can't tell us absolutely how's the visceral adiposity, because visceral adiposity is the main culprit then in comparison to overall adiposity. So we can see that clearly that sagittal abdominal diameter has much significant p-value in comparison to other parameters as a neck circumference or waist circumference only, and the BMI also. BMI goes with it, but the linearity is toward the visceral adiposity. So Pearson correlation value says the R value of 0.5758. That means these parameters are not very much linear, but they are having directly relation with insulin resistance and plasma glucose level. And its serum insulin have better linearity. The data is less scared. I can show it also differently. These results can tell us the better about the scattering of these dots, can tell us about the linearity of the equation. So the HOMA-IR parameters are lesser scared in comparison to serum uric acid and fasting plasma glucose levels. So the conclusion is that the metabolic syndrome is the key component of both insulin resistance and hyperuricemia. And the story behind this is the visceral adiposity that's nowadays is a very challenging scene, and the lifestyle disorders are increasing greatly, and they are major cause of morbidity and mortality. As we can say that cardiovascular diseases are the most common cause of mortality after road accidents. So the metabolic syndrome is the main culprit, and the story is that when the visceral adiposity increases, the capacity of adipocytes get they are just have more and more fat and getting hypertrophied more and more, and the capacity exceeds, then it creates a necrosis like scenario, and it ultimately results in a level of increased IL-1, IL-6 and TNF alpha, and the uric acid gets produced as an antioxidants, and as it's not a main culprit because the uric acid produced because of as an antioxidant phenomena, but ultimately it leads to hamper the insulin resistance pathway. So the research outcome is that research outcome is that increasing uric acid levels can predict the increasing insulin resistance, and the management of uric acid resistance by the means of can also predicted by the uric acid levels. Thank you.
Thank you, Dr. Shivam. That uric acid is a marker for hypertension, for metabolic is there for so many years, and you found that its waist hip ratio, waist measure visceral adiposity, it correlates well. Anybody from the audience would like to ask question? Yeah.
We measure the waist circumference by using the Jeffries method, and between the ASIS and the umbilicus, in the midway between that, we measure it by using the measuring tape.
Is it anterior-subiac iliac spine and?
Sorry?
What you told, ASIS and?
ASIS and between the umbilicus, the midway between.
No.
I think that there is a lot of controversy of measuring the waist circumference.
So, this question specifically I asked because waist circumference, if you go with the WHO definition, how to measure it, and what point of time in respiration, inspiration or expiration, or mid-inspiration or mid-expiration?
We measured it at the time of expiration.
No.
Jeffries method, I follow the Jeffries method.
No, WHO has very standard method.
Would you like to recommend this uric acid level as one of the criteria for metabolic syndrome, or otherwise what is the impact of this, clinical impact of this study?
The impact of this study is thus, it's quite difficult to measure the insulin resistance in routine clinics, and insulin resistance has been started very much before the time of diagnosis of diabetes mellitus. So by predicting the uric acid levels, we can also know that the patient is going toward the insulin resistance, and we can help out by the lifestyle management or all those lifestyle changes. So reduce the level of diabetes and preventing him at the pre-diabetic stage or in earlier scenarios.
Hello.
Yes. Yes, and obesity and overweight has a directly link with metabolic. Yes, yes, exactly.
Thank you, Dr. Shivam. Now,
Hello.
moving on to
Hello.
next. Ye- Actually,
Hello.
we are behind the schedule, so.
One single question.
Hello?
Thank you, doctor, for your nice presentation. You see, we know that 75% of the uric acid is produced in the body. 25% take from food. So do you think if somebody reduces the weight or take exercise, the insulin resistance we know will be decreased? Do you think uric acid will also be decreased?
Yes, uric level acids are directly reduced by decreasing the weight. As the obesity and the overweight person reduces his weight, the uric acid levels will automatically come down.
Thank you.
Otherwise, it will happen that the patient reduces his taking febuxetate or aripiprazole for 3 or 4 months. After that, if he or she doesn't reduce his weight, then ultimately the uric acid levels again goes up. Thank you.
Thank you.
Yeah, moving on to next presentation by Dr. Ritu Tiwari. She will be presenting on comparison of frequency domain parameters of heart rate variability between women of polycystic ovarian disease and apparently healthy women. You can start.
Okay, very good morning to respected judges and one and all gathered here. I'm Dr. Ritu and I'm senior resident in the Department of Physiology, KGMU, Lucknow. So today I'll be focusing on my topic, comparison of frequency domain parameters of heart rate variability between women with polycystic ovarian syndrome and apparently healthy women. So this polycystic ovarian syndrome was first described by the Daniel Leventhal in 1935 as a syndrome which manifested as the obesity, hirsutism, polycystic ovaries, with all these constellation of all these things. And it's a heterogeneous, polygenic and multifactorial disease. So this is the common endocrine pathology occurring in a reproductive age group, females. The patient shows a common features like increased insulin resistance, adiposity, which has been known to correlate with the autonomic dysfunction also. So it has been also shown that there is an increased risk of type 2 diabetes mellitus as well as the cardiovascular diseases. So I have performed the heart rate variability analysis here, which can be considered as a very good technique to characterize the modulation of autonomic tone. And if I define this heart rate variability, that this is the alteration or variation between the 1-to-1 RR intervals in a ECG. So it combines both sympathetic as well as parasympathetic nervous system functions. We have other diagnostic techniques also like isometric hand grip, but they tell us only about the sympathetic or parasympathetic. It gives us combined analysis. So, and it differentiate according to the frequency oscillations which produce in our body, like high frequency component and low frequency component. The high frequency is a reflective of vagal and low frequency component is reflective of the sympathetic activity. High frequency is produced because of respiratory sinus arrhythmia. And this ratio between LF and HF, it denotes the sympatho-vagal balance. So my aim is to analyze the characteristics of heart rate variability in PCOS. My inclusion criteria is the total sample size was 60 and the cases 30 and control 30. Then in case I use this Rotterdam criteria to diagnose all the patient of age 20 to 40 years and visiting the obstetric and gynecology department of KGMU. The second group was control group, and I've included the women with regular menstrual cycle without clinical or biochemical sign of polycystic ovarian syndrome. Then exclusion criteria, I excluded pregnant and postmenopausal women, those with diabetes mellitus, all those who already have established disease. Dyslipidemia I excluded, hypertension, any history of substance abuse, as well as my patient were drug naive. Anthropometric measurements were taken, weight, height and BMI. Serum insulin, blood glucose were estimated by using the fasting sample blood. Then I recorded HRV by using the AD instrument of HRV 2.0 Power Lab 26T in Autonomic Nervous System Lab of Physiology Department, KGMU, Lucknow. These are my results. The PCOS cases had significantly higher body weight, BMI, waist and hip ratio, systolic blood pressure and diastolic blood pressure. Mean serum insulin and mean plasma glucose were also increased in cases. If we talk about the heart rate variability parameters, especially when we stick to the frequency domain analysis, so the total power found to be increased with the controls, means normal patients. The high frequency component in percentage and high frequency component in millisecond squares as well as HU values, they found significantly lower in cases as compared to that in controls, while mean VLF, very low frequency component, LF percentage, LF in new, is found more with the cases when we compare to the controls. The LF and HF ratio, actually this is the most diagnostic value in frequency domain analysis. The normal value of LH upon HF ratio is 0.5 to 1.45, and it was increased in significantly in cases. This is my tabulated form of results. So the mean age almost similar in cases and control. The body weight were found increased with the cases, height were more in control. BMI around 25.39 with the cases and 20.88 with controls. And the mean systolic blood pressure was 127 in cases and in control it was 116. Mean diastolic blood pressure was 85.85 and in control it was 78.73. And all these, my results were highly significant. The p-value is less than 0.001. Now this is the heart rate variability analysis. The total power were found to be more with the controls because heart rate variability is a good sign for the adaptability. So the total power, it should be increased. The VLF, LF and HF, these all found to be increased in cases, and HF and HF is found in more in controls. When we look towards the LF upon HF ratio, it is found more with the cases. And it is 2.34 as we can see in this table, and in control it is 0.62. So as I have told that this sympathovagal balance is we analyze with the use of this ratio, which should be between the 0.5 to 1.5, and it is very more here, it is 2.34. So I would like to conclude my study here. So the insulin resistance had definitely impact on the heart rate variability. So other cardiometabolic parameters have its own incidental effect on HRV, like BMI and blood pressure. Sympathetic overactivity found in these PCOS patients, in PCOS patient, and the PCOS females had reduced or blunted heart rate variability and altered autonomic function, and which shows that there is a less adaptability to this autonomic system. So this study can be useful because as they have a very high risk of cardiovascular system. So we can, if these females routinely went for this analysis, this risk can be reduced. Thank you.
Thank you, Ritu, for an interesting study on heart rate variability in PCOS. You told that you had excluded the patient who are hypertensives and also patients already on cholesterol medication and all. But you didn't tell about the thyroid function test. Was it done? You didn't mention it as far as I see. And any patients on medications, particularly which changes the heart rate. See, some of them will be on some medication, Ayurvedic, including Ayurvedic. Some of the drugs will change the heart rate.
Yes, sir. Sir, I excluded all those patients. My subject was all were drug naive. They were all not on medication. They were
what about, say, Ayurvedic and all those and things? Because PCOS means they would be on so many medications from outside.
So actually, so my total sample size was less, so I found 30 cases, drug naive patient, and I took history to exclude the thyroid, any kind of thyroid abnormality. So on history, I excluded most of the established diseases.
Okay, but still TSH could have been done as a
because it is very sensitive indicator because I need to exclude all the
And
serious
another thing is the
abnormality also.
baseline ECG, then heart rate variability, no?
Yes, sir. Actually, this
And
HRV,
so many things will
will-
change the heart rate. Coffee, drinking coffee.
So these all were
You did it in your
prerequisites.
lab and all those things.
These all were the prerequisites. There should be no heavy lunch there. Tea, coffee, all were excluded.
Yeah.
And I took it all in prerequisites.
Thank you very much for interesting study.
Okay, sir. Thank you, sir. Thank you, ma'am.
We will call the last alternative method of obtaining lead ECG, Nitin Kumar Srinivas. Is he there or not there? Is he not there? Is he there? Nitin Kumar So all have presented very interesting topics and research mind, and some undergraduates, some of the faculty and also postgraduates. So thank you for the nice research articles.
Sample size of more than 10,000.
Yeah, that is good. Student.
And this had at least some work. And
The only
case
thing is
control.
that whether thyroid was not done.
Yeah, but then a case control study. So
That
it
is
was,
So from my side,
Arvind, yeah, so I also thought like that because of the lung.
she was a gynecologist basically. So
No, she's not.
physician.
No, she's a physician.
Physician?
No, she's a
Physiologist. Then
physiologist.
it's okay. Then two.
What about this?
Lung, only 72 patients in a pandemic. And
That
that
is
too,
true, yeah.
it was not compared
Yeah.
with CT, not compared with X-ray.
Yeah, so we'll do like
Nothing
this.
was done.
This is student.
this girl was, I think, number one.
Yeah. Then
He also did pretty good.
prevalence of
two,
diabetes. Yeah, two.
second?
Yeah, student. Yeah.
Student, I think we should.
Is student. Yeah. Then this is three. Yeah. Thank you.
So, good morning everyone, and I think we are ready for the next session, that is the invited podium presentation for clinical case discussion. Thank you judges for your patience and the participants. It was a wonderful show, and I would request the faculty and the judges to kindly go to the ACP stall to collect their gifts, that is the nebulizer and the neck pillow. And the judges for this session are Dr. Sanjay Shah, so I'll request him to kindly join the podium, Dr. Abhishek Pandey, and Dr. Arun Kumar Kedia. I think all participants are there. Mohammad Mujammal, Atindra Bharadwaj, are you there? Please raise your hands. Megha Sridhar, okay, great. So I would request you to come in the front, so it will be easier for us. Shubham Dubey, Shubham, are you there? Shubham, Rishabh Kapoor, not there? Shubham Dubey, are you there? Rishabh Kapoor, okay. So I would request the judges to take over, and the first presenter is Mohammad Mujammal. So please do come in.
Good morning, judges, and good morning, the esteemed guest. So today, the case study which I am going to present is recurrent hypoglycemia in non-diabetic patient with lisinopril, that is ACE inhibitor. So introducing myself, I am Muzammil Muhammad, currently a medical student in Shadan Institute of Medical Sciences. So going on to the presentation, A 56-year-old female, occupation by housewife, presented to the OPD with a history of altered sensorium since few hours of previous training. And patient was evaluated, and she doesn't have any significant premorbid conditions except for hypertension. No addictions also. History of fever, no history of fever, headache, vomiting, no history of yellow discoloration in urine, except she has a medication of antihypertensive drugs. There was no significant family history also. On examination, the pulse rate was 82 beats per minute and the blood pressure was 150 by 72 mm of Hg, that is slightly on a higher side. Then all the examination, that is head, eyes, ears, nose and throat, they were absolutely normal, and there was no icterus, no signs of icterus, no parotid enlargement also. The CVS disturbances, that was like tachycardia and with some normal blood pressure. Respiratory and GI system was also normal. Now, investigations which were done were CBP, that was normal, hemoglobin was 13.9, WBC was 8,200, platelets were 2.1 lakh. CU was normal, urine analysis for toxic screen was negative, thyroid function test was normal, random blood sugar was 62 milligrams per deciliter, HbA1c was 5.3%, RFT and LFT were quite normal, and other parameters were also normal. The co-symptotropin test was also normal, ultrasound, CT abdomen, everything was normal. Now, the different health diagnosis, most probably they got to be like, there were two causes, endogenous cause or exogenous cause. Endogenous, basically it includes like insulin mediated or insulin dependent. Insulin mediated, it can be like insulinomas, NIPS, insulin antibodies, or insulin independent, they can be like critical organ failure, sepsis, insulin receptor antibodies. Now, exogenous cause, they can also include therapeutic drugs and alcohol toxins and some other drugs. Then the patient was treated in hospital with dextrose in the ER, wherein the patient was better and the hypoglycemic symptoms were relieved. Then we term patient, the patient was diagnosed as idiopathic cause of hypoglycemia and was discharged from hospital. The patient was again readmitted with the same episodes of hypoglycemia in the next 48 hours, and he was again treated symptomatically and he was better. We couldn't find out the cause, and there were repeated admissions. We have done 72 hours fasting test, which showed like RBS was 68 milligrams per deciliter, insulin level was 25 microunits per liter, and C-peptide was 1.1 nanogram per ml. Then, as we have said in the history, that patient was on antihypertensive drug. So the patient was regularly taking the drug lisinopril 10 milligrams for uncontrolled hypertension. Then we asked the patient to stop the hypertensive drug, that is lisinopril, and there was no episodes of hypoglycemia seen again. So most probably the causes would be like the AC inhibitor directly increases the sensitivity of insulin, which may increase the circulation of kinins, which may lead to vasodilatation in muscle, increase in glucose uptake. Or there is one more suggestive mechanism, that is bradykinin-induced downregulation hepatic glucose production, which leads to ACE inhibitor suppression of peripheral sympathomimetic overactivity. There was a case published on ACE inhibitor, that is captopril, way back in like 1985, and these are the key discussions. We can just have a glance on this. Like the key points, we have done like extensive investigations and ruled out other hypoglycemic causes. Then we have, when the patient was discontinued on the ACE inhibitor, that is lisinopril, the hypoglycemic symptoms were improved. And ACE inhibitors, they are one of the most common medications used in diabetic patients. But the trend of ARBs usage have subtended the ACE inhibitor usage. The basic ACE inhibitor improves the insulin sensitivity, which can lead to approximately 3 to 4 folds increased risk of hypoglycemia and diabetic patients, especially those receiving another hypoglycemic agent. Hypoglycemia is very rare side effect of ACE inhibitor in non-diabetic patient. So physicians should be aware that this can also occur in non-diabetic patient and it responds to discontinuation of medicine. Thank you.
What was the duration of the use of lisinopril in this patient when he had the first episode of hypoglycemia?
It was like 1 month, sir.
1 month
1.
from the onset of medication. Did he start with 10 milligram or did he upgrade, up titrate
We
from 5?
basically started with 10 milligrams, sir. But initially there was no improvement in the BP. So we have just increased the dose up to 20 milligrams.
He went up to 20 milligrams of
milligrams.
lisinopril. Okay. What about the urine microalbuminuria analysis? Was it done?
Yeah.
And why is it important?
No, sir, it was not done.
What was the reference range of insulin levels and C-peptide that you have mentioned?
Just it was 25.
Is it normal?
Yes, sir.
So, Muzamil, I think you have reviewed that hypoglycemia in non-diabetic patients, the drugs, and you mentioned the captopril 1985, there was a case report mentioned in the PubMed. So, the 72-hour fasting test, tell me the procedure, how you have done it.
Can you please repeat?
Yeah, you mentioned 72-hour fasting. How you do? Method.
So basically like 72 hours.
In your patient, have you done in the OPD basis or inpatient?
Inpatients.
Inpatients. Tell me the methods. How frequently you will measure, what you will do, how frequently, what is the critical sample?
Sir, at this level, I'm not.
Because you have mentioned, that's why I'm asking. So you should know, because 72-hour fasting test has a clear-cut protocol. So how to do, at what frequency, and like in the initial, it should be in 30 minutes, then it should be 10 minutes. Everything is mentioned there. The second question, if we are making any drug that it is causing any adverse reactions, so there is one criteria known as Nares-Jano criteria. So do you know?
No, sir, I'm not aware of this.
Okay, thank you.
Thank you very much.
Who's next? I think it's coming. Atindra Bharadwaj, is he there? Neurocystic, disseminated cysticercosis should be, I think.
Good morning, everyone, respected judges. Myself, Dr. Atin Bharadwaj, PG resident. I am going to present a rare case of disseminated neurocysticercosis under supervision of Dr. Nishan Konodia, Professor and Head, Hind Institute of Medical Science, Sitapur. Presentation: 47-year female from Sitapur, date of admission 19 May 2022, comes with a chief complaint of headache for last 4 to 5 months, fever for 4 to 5 months on and off, seizure of 1 episode 4 to 5 days back, vomiting for 2 days, 4 to 5 episodes, decrease of vision and hearing loss since morning. History: patient was asymptomatic 5 months back when she developed headache. Gradual onset, not associated with light since 5 months, with on and off fever. High grade, relieved after taking medication. Patients also complained of seizure 1 episode 4 days back. which was tonic-clonic in nature, associated with clenching of teeth, lasted for 20 minutes, followed by loss of consciousness for 2 to 3 minutes. No history of urinary incontinence, stool passed. This is an MRI of our patient showing multiple viable interparenchyma neurocystic sarcosis with various stages of NCCs. Review of literature. Neurocystic sarcosis is reported to be the most common parasitic disease affecting the central nervous system. It usually takes a median of 3 to 5 years of incubation period before the onset of symptoms, and it is caused by larval stage of tapeworm Tinea solinum. It is primary cause of acquired epilepsy worldwide and also a most common cause for preventable epilepsy. NCC is spread by the consumption of Tinea solinum eggs slugged in the stool of the human tapeworm carrier. It is then hatched in the small intestine and disseminated via blood to brain, striated muscles and other tissues. Presence in the world. NCC is predominantly a disease of developing world. Presented with NCC usually present with seizures, and it is often the only clinical manifestation. Other common presentation includes hydrocephalus, headache, and symptoms of increased intracranial pressure. What IDSA says? The Infectious Disease Society of America, IDSA, guidelines recommends thorough history taking, physical examination, neuroimaging studies in the diagnosis and management of NCC. Exposure history should be investigated carefully because of the latency period between the infection and the onset of symptoms. The serological testing methods, enzyme-linked immunotransfer blood assay, is used as a test in patients with suspected NCC. Enzyme-linked immunosorbent assay, ELISA, is not recommended because of high rate of false positivity and negativity. Brain MRI and non-contrast computed tomography scan are the best diagnostic measures in classifying patients with new diagnosis of NCC. Stages of NCC. Because most of NCC cases present in parenchyma, subarachnoid and spinal cyst, imaging studies provide more information than the immunodiagnostic test by incorporating the number, size, location and stages of parasites. The management of NCC depends upon the stages of disease. 4 neurological stages of disease have been identified. These stages include vascular stages, colloidal or colloidovascular, granular or granular nodular, and calcified, that is calcified and nodular. Again, this is the MRI of our patient showing NCC at various stages. Vascular stages, which is the viable parenchymal region with minimal surrounding edema. Second one is chloride stage and granular stage, which shows significant amount of edema, and the last one is calcified lesions with hyperdense lesion without edema. Management. The initial management approach to manage NCC is to treat acute symptoms including seizure. Following stabilization of seizure and anti-epileptic drug, anti-parasitic and anti-inflammatory disease and inflammatory medicine, that is corticosteroid, should be administered. Several randomized trial and meta-analysis studies suggest that the use of corticosteroid and short course of albendazole, that is 50 mg per kg per day for 8 to 28 days as treatment regime, result in the rapid radiological resolution with few seizure 6 months post-treatment. RCT, according to a randomized trial of 120 patients in Peru, the number of cysts determined the choice of antiparasitic in patients with viable parenchyma NCC and seizure. Viable NCC appears round, hyperdense on CT, with none to minimal inflammation of the surrounding tissues. For the patient with 1 or 2 viable cysts, albendazole monotherapy, that is 5 mg per kg per day to 1200 mg per day with meal is recommended. On the other hand, if the patient has more than 2 parenchyma cystic sarci, treatment should include albendazole and praziquantel. Praziquantel with 50 mg per kg divided into 3 daily doses for 15 to 30 days. our patient outcome, based on imaging study, the patient was diagnosed with disseminated neurocystic sarcosis. Ophthalmological examination did not reveal ocular involvement, that is ocular cystic sarcosis excluded. Our patient received dexamethasone, praziquantel, albendazole for 28 days. We have planned for repeat MRI in 6 months after completion of therapy, which therapy will be made to document non-viable calcification of lesion on review. My final thoughts: disseminated NCC is the rarest of rare disease. Only few cases have been reported in literature. Early identification of history, clinical examination, and CT head is mandatory for good compliance of treatment. Treatment as per guidelines include albendazole, praziquantel, in some cases with mandatory corticosteroid. Anti-epileptic use varies with cases. These were my references. Thank you.
So, Atyendra, I think nice effort. So this case, whenever you are presenting a case, this is my feedback, that the management should be emphasized in the way you have managed your case. It should not be like the idealistic thing. So how you manage the case? Tell me.
Sir, my patient comes with the...
Tell me the drugs which you have used, doses and duration.
Yes, sir. My patient comes with the chief complaint of seizure. So first thing first, we have to manage...
No, not what drugs you have given, at what doses, how much duration. Straightforward, single question.
Sir, albendazole, 1200 milligram.
You started with albendazole?
Sir, dexamethasone.
You started with dexamethasone. What dose?
Sir, we gave sir 6 milligram per day, sir.
How many days?
For sir, 28. Sir, my patient was in the IPD for 10 days, sir. So during the first period, we have given IV dexamethasone 6 milligram per day for 10 days. Then after we switched it to prednisolone, sir. With the antiparasitic drug, we started on albendazole 1200 milligram per day with praziquantel.
Which anti-epileptic you have used?
Sir, we have used phenytoin, sir.
You have not mentioned in your presentation the anti-epileptic drugs, the doses.
Anti-epileptic drugs, sir, like I haven't mentioned the...
Because this is a learning exercise also. So whenever you are presenting a case, the case should be mentioned like how you managed. The second, the differential diagnosis. You have not mentioned any differential diagnosis. You straightforward jump to neurocystic sarcosis. What were the differential diagnosis in the imaging?
Sir, in our mind, sir, there was there was difference between tuberculoma, sir. We have differential diagnosis with tuberculoma, but tuberculoma usually comes, the shape of tuberculoma is more than 2 centimeter, and the lesion usually is 1 or 2 lesions, not more than 1 or 2 lesions, sir.
You have not mentioned the fundus examination.
Sir, I have mentioned, but in the end, we have done the fundus examination to rule out...
What is the importance of fundus examination in a patient of neurocystic sarcosis?
Sir, if we start the antiparasitic drug before doing the fundus examination, the parasite which get killed, so ultimately can...
So this is the way we have to improve. Like the fundus examination picture, if you put in a presentation, that will enhance your presentation. Anyhow, congratulations. Thank you.
Just a quick question. You mentioned that there was a history of fever for almost 5 months.
Yes, 4 to 5 months.
You did not do any workout for the fever cause. Did you rule out HIV in this patient?
Yes, sir. We have done the viral markers.
You did not mention in your case.
Yeah,
so these all fine points have to be mentioned in the case in order to support your diagnosis. You have made a very clear-cut diagnosis, making diagnosis of neurocystic sarcosis a very straightforward diagnosis, and then you say that it is a rarest of the rare disease. So a rarest of the rare disease cannot be diagnosed straightforward. Clear?
It should have been a diagnosis of exclusion.
Yes, sir.
With a differential diagnosis in place and rule out one by one. This is how you should be doing it. Questions from the audience?
I don't have a question, just a suggestion. When you present an MRI picture or CT scan, you should not reveal the identity of the patient. You cannot reveal the identity of the patient. the name Shantaba is written on that. So you are not supposed to reveal the identity of the patient when you present anywhere, either in publication or in presentation.
Agreed. That's absolutely true. Thank you.
So for the next podium presentation, I request Dr. Megha Sridhar. She is going to present a case of distal renal tubular acidosis detected to be a Sjogren's, a case Sjogren's syndrome. So Dr. Megha.
Good morning, respected judges and the audience gathered here. Today I'll be presenting a case report under the guidance of Dr. Narayan Swamy sir, who is our professor in Department of Medicine. My case report is titled, A Case of Distal Renal Tubular Acidosis, which was detected as Sjogren's syndrome. So our patient was a 21-year-old female who was a homemaker, studied up till 12th standard, hailing from a small town in Karnataka. She had no known comorbidities. So she presented to us in the emergency room with the following chief complaints. Upper and lower limb weakness since 2 days and neck weakness since that morning. So the history of presenting illness is that this is a 21-year-old female who could perform all her activities of daily living without assistance 2 days back. So her activities of daily living as a homemaker were that she used to clean, she used to cook for the household, she used to wash clothes. Those were her daily activities. So she told us that on the first day, she developed weakness in the sense that she was not able to climb to go to the terrace to hang clothes, or she was not able to hold the clothes and hang them. She was not able to grip the objects in the kitchen. So insidious onset, and this weakness was seen both in the lower limbs as well as the upper limbs, and it was progressive, she said. So both distal and proximal muscles were involved from, this is what we gather from the history that she gave us. And the following day, when she tried to wake up from the bed, she was not able to lift herself off the bed. She was not able to lift her neck either. So first she was taken to a small clinic near her home, and then she was referred to us. So negative history, there's no history of paresthesia, pain, numbness, no band-like sensation, no history of bowel or bladder disturbances, no recent history of fever or diarrhea, no history suggestive of cranial nerve dysfunction, no drug or toxin exposure, or no history of trauma. So past history, just one thing which was significant was that she said she used to have on and off fever since 6 months, used to last for 2 days, and then it would go away. And she did have reduced appetite. So our initial working diagnosis was, so this was a quadriparesis when she presented to us. So was it UMN, was it LMN causes? But UMN causes of quadriparesis would be cerebral palsy, bilateral brainstem.
Megha, can you back to just your negative history? Sir? Negative history.
Yes, sir. So just one.
Yeah. So in the negative, it is coming. So in the negative history, just mention like why you have asked this negative history, yes, mentioning each point.
Yes, sir. So no history of paresthesia, pain or numbness. These are any of the sensory symptoms. So since she came to us as quadriparesis, we wanted to think if it was GBS. So GBS will usually have some sensory symptoms before or along with the motor symptoms that they present with. So that was one thing. No band-like sensation, no history of bowel or bladder disturbances to rule out any cord involvement, sir. No recent history of fever or diarrhea, again for GBS. No history suggestive of cranial nerve dysfunction, again facial nerve palsies could have pointed us towards GBS. No drug or toxin exposure, some toxins like botulism, unlikely here, but could have been a cause. No history of trauma, something that's this acute, just 2 days of quadriparesis. We thought, could it be a high cervical cord trauma which could have caused
at this juncture, I think when the patient, a young female coming with quadriparesis, you are taking GBS as a first diagnosis. You are taking GBS as a first diagnosis and putting the negative history here. Why not it case be a hypokalemic periodic paralysis?
Yes, sir. We definitely thought of that, but just to rule out GBS, since GBS is the more common entity.
But you have not mentioned this is in the negative history, like is there any repeated such episode in the past or not? So that should be mentioned.
Yes,
that should be mentioned. Any other thing which has got relevance in the negative history? Any history of thyroid disease which has got relevance for such type of patient? History of thyroid disease?
No, sir. There's no family history.
Is there any relevance of any thyroid disease which can lead to
I thought hereditary. Thyroid, no, sir. She was not on any medications. No loss of weight. There's no hypothyroid symptoms.
You are suspecting quadriparesis in a patient with hypothyroidism or hyperthyroidism or both? Okay, now move to your presentation, which you are presenting.
So quadriparesis and hyperthyroidism, because hyperthyroidism can cause periodic paralysis as well.
Okay. Because this patient was having fever for a long duration.
Yes, sir. On and off.
On and off fever was there, and she was a patient, young female. So I was looking whether this patient is having some hyperthyroidism symptoms were there or not. So I was looking in that in the negative history also. So moving to this one, have you like the differential diagnosis you have put?
Yes, sir.
Okay, come to your differential diagnosis.
Yes, so we thought it was LMN causes definitely, because UMN, she didn't give any symptoms suggestive of UMN involvement, so we thought it was lower motor neuron. So once we thought of lower motor neuron, we had to think of anterior horn cell. Was it at the radical level, plexus, nerve, NMJ, or the muscle level? So anterior horn cell was very unlikely because it's very acute onset. Polyradiculoneuropathy, again, GBS was one of our main differentials. Plexus involvement, unlikely since it was it was a symmetrical onset. Nerve, again, very short duration to think of nerve, no sensory symptoms either. Neuromuscular junction, no fluctuation as such that she told us, no ocular symptoms, no bulbar symptoms that she told us, to think of myasthenia, botulism, no history of poison, any toxin consumption. So muscle, again, so symmetrical weakness. It is both proximal and distal, but at this juncture, we considered polyradiculoneuropathy and muscle as our anatomical localization sites.
Myopathy you are suspecting?
Yes, sir.
So proximal muscle weakness was there or distal muscle weakness was there?
Both were there, sir.
So which started first?
So she was not able to tell us clearly. She, like as I mentioned, that's how she told us the history of the first day, sir. So she told us history that suggested that both of them started together, proximal and distal.
So what you suspect in typical myopathy patients, which type of muscle weakness is more?
Symmetrical, proximal weakness, lower limb predominant is more suggestive of myopathy.
And what about the neuropathy?
Neuropathy, like it's a very short duration.
No, like I'm asking the muscle weakness in a neuropathy. It will be distal or proximal first?
In
a neuropathy patient.
Distal first.
Distal first. Okay. Move to the next slide.
For Guillain-Barré syndrome, periodic paralysis, and highly unlikely, but we still kept high cervical cord compression, probably some idiopathic atlantoaxial disability, instability that she might have had. So on examination, her pulse rate was 47 beats per minute, regularly irregular. Blood pressure was normal, respiratory rate was normal. Her BMI was on the lower end. She did have dry skin and she had pruritic marks. So on neurological examination, higher mental functions were intact, cranial nerves were normal. But motor examination was what we were concentrating on mainly. So nutrition, normal, symmetrical bilaterally, no wasting was appreciated. Tone was decreased. And power at that point was 1/5 in both upper and lower limbs. And the reflexes were all diminished. Her plantars were bilateral flexor. Again, the rest of the neurological examination, sensory symptoms, cerebellar signs, autonomic signs, all of them were intact, normal, and no other system involvement was found either. So respiratory system, CVS per abdomen, they were all normal. So at the end of examination, our differentials were still Guillain-Barré syndrome or periodic paralysis. So this was her ECG, and this showed PR prolongation along with ventricular bigeminy, VPCs with every alternate normal beat. So this was the first thing that made us think if it was GBS. So causes of VPCs could be cardiac or non-cardiac. We did do a echo on the way to the ICU. We shifted her to the ICU because she had neck muscle weakness already, and we feared that she might go into respiratory arrest. So we shifted her to the ICU, and we were able to get her an echo done. So all cardiac causes were ruled out. So in non-cardiac, the main causes we thought were it was a metabolic abnormality such as acidosis, hypoxemia, potassium or magnesium.
So Megha, I think if I will be at your position, this patient, young female coming with quadriparesis, I will first order serum potassium.
Exactly.
Why to order the ECG first and then going back to the serum potassium? So I think come to that point. Hypokalemia was there. Now
Yes,
move
sir.
on.
So we did do an ABG which showed metabolic acidosis, which is with normal anion gap. We got a serum electrolytes within almost 2 hours, and the potassium was 1.7. So this was the cause for quadriparesis, and IV potassium correction was started right at that point. Patient's weakness started to improve within around 2 hours of starting IV potassium correction. So this was a normal anion gap metabolic acidosis. So it could have either have been GI loss or renal loss, but she had no GI symptoms, none of the drug intake or ureterosigmoidectomy. So we thought of renal tubular acidosis. So samples for urine electrolytes and anion gap were also sent. So day 2 of hospitalization, we got back the results of urine electrolytes, which showed that urine anion gap was 40, which told us that it was renal tubular acidosis. Here again, urine pH was more than 5.5, which points towards distal rather than proximal tubular acidosis. The urine sodium was also more than 25, which also points toward distal rather than proximal. So it was a distal renal tubular acidosis, and for that we also started oral sodium bicarbonate correction.
So this patient was having renal tubular acidosis because you are suspecting there was normal anion gap metabolic acidosis. So in a normal anion gap metabolic acidosis, RTA is one of the differential. There are other causes also. So what are the other causes?
So GI, gastrointestinal causes.
Diarrhea?
She had no symptoms of diarrhea.
Any other drugs which can cause such type of picture?
Amphotericin B can also cause...
Any other drug? In what condition, in a patient in which you are suspecting renal tubular acidosis, the distal one, the urinary pH will be more than? 5.5. What are the other conditions in which the urinary pH will be more than 5.5 and mimicking like distal RTA?
So when they have chronic diarrhea and there's chronic hypokalemia, that can mimic urine pH more than 5.5.
Any UTI which can give such type of picture? Proteus infection. Good.
So coming to the causes of distal RTA, so genetic or acquired. Genetic we kept aside because this is a 21-year-old female. So one of the main causes will be autoimmune, Sjogren's syndrome or SLE. So these were our main differentials, and we sent ANA profile for the same. So day 3 to 4 of hospitalization, patient felt much better. Her ECG, there were no VPCs. She still had a low rate, but no VPCs, and she was. We further probed for any other symptoms which might point us towards Sjogren's, and she did have dry, itchy skin, occasionally foreign body sensation in eyes, and she said she had easy fatiguability, which was why she had confined herself to her house and her household activities. So day 5 of hospitalization, we had got back the ANA profile, which showed anti-Rho bar SSA 3+ titers, which was significant. So we definitely did get the diagnosis of Sjogren's syndrome.
Thyroid function test, TSH. What was the TSH report in this patient?
So TSH was 3.
It was normal.
Yes, sir.
Okay.
So ACR ULAR criteria gives these criteria for Sjogren's syndrome. First one is labial salivary gland with focal lymphocytic sialadenitis.
You can move to the next slide.
Running out of time also.
Yes, sir. So patient was discharged with sodium bicarbonate oral preparation, potassium citrate oral suspension, which helps with the distal RTA as well as with potassium supplementation. Course of oral steroids was also given, 1 mg per kg body weight.
What
with tapering
sodium
dose.
bicarbonate oral preparation you have given?
It's a soda bicarb tablets. And we also referred her to a nephrologist just to make sure that she didn't have tubular interstitial nephritis. So my take-home message is this report highlights a rare but important manifestation of Sjogren's syndrome, which is the second most common multisystem connective tissue disorder. We still aren't, even though it has a prevalence of 1 to 1.5% globally, we aren't diagnosing enough Sjogren's syndrome, at least in our setting. So I think we need to think of Sjogren's syndrome much more because it can also present with variable extragranular manifestations, which 15% of which can be severe or life-threatening. So again, this was a very rewarding case because the patient walked home on day 5 and this was
Okay. Any rodenticide which could cause this picture? So the barium chloride can cause a similar picture. We've had patients of barium chloride injection with severe quadriparesis with, I think, potassium levels in the range of 1.5, given IV potassium. What about sickle cell?
Sir, but this acute...
Any sickle cell trait in the history? Was she from a tribal belt?
No,
Nothing
sir.
of that sort.
She didn't have anemia either. Her HB was around 10.5.
I think your case was wonderful. The only thing is there was some lacuna in terms of presentation. The first and foremost thing is when a young patient presents to you with acute muscle weakness, think of electrolyte imbalance as the first.
Yes, sir.
That should be the take-home message for this particular case. Think of the common thing first, though the etiology may be uncommon.
Yes, sir.
है ना? So the immediate cause is a common cause.
Yes.
So electrolyte imbalance is the most common cause of acute muscle weakness in a young patient.
Yes.
Okay.
Thank you, Megha.
Thank you, sir.
So if Dr. Shubham is there, interesting case of press, or Dr. Rishabh Kapoor, pulmonary hypertension in hyperthyroidism. So,
Yeah, thanks everybody. And I think we should, we'll conclude and hand over to the next moderator.
So I think this is for the postgraduates who have presented the case. Whenever you're presenting a case, I think it should be a proper algorithm. The common first already emphasized, and don't worry about with the questions. Questions are trying just to improve and sensitize you that you have to learn more. Thank you.
3 years selected by the scientific committee. And to judge this we have Dr. Raghunath Rao Digumarti and Professor Nishant Kanodia. So I would request the judges to kindly come on the podium, and I would request all the participants, those who have joined late, please do come in the front so that it will be easy for us to identify. And I would request to kindly be short and quick because we have to finish it by 12:15. So the first presentation is by Yashendra Sethi. Please do come in. And best of luck.
A very good morning to the esteemed judges and the esteemed guest present here. I am Dr. Yashendra Sethi. I am an MBBS intern at Government Doon Medical College, and I will be presenting a very interesting study which we did in the COVID times. It was about thyroid function abnormalities in the acute phase of COVID-19. So it was a cross-sectional hospital-based study, and probably the only study from North India reporting this. So this study was published in Curious Journal of Medical Science recently, and you can scan this QR code to read it in toto. We'll be going ahead with the presentation. We will be discussing about the introduction, the aims and objectives, the methodology, the results, and the conclusions. To start with, we all know that viral illnesses have been known to produce some endocrinal abnormalities, which have included diseases like mumps, cytomegalovirus, Coxsackie virus, and thyroid in particular, has been implicated to enter the cells using the ACE2 receptor combined with the TMPRS2, which forms a critical molecular complex for its entry into the cell. With that being utilized, we must consider here that it's not just the lungs, but it's actually the thyroid gland which has more of these receptors. So with COVID-19, it was always expected that a thyroid abnormality will come with the disease. Going ahead with it, a significant interplay has been observed between systemic inflammatory process produced by these viruses and the thyroid function. But the literature, while the time the study was done, was pointing to both ends of the spectrum. Namely, some studies were reporting subacute thyroiditis, which reported hyperthyroidism in the acute phase, while some studies were reporting hypothyroidism, or decrease in the thyroid hormones, namely T3 and T4. So we also recognize that thyroid abnormalities in COVID patients was always associated to have impact on the mortality and the morbidity. This study was conducted with an attempt to fill this gap in literature and to make a contribution through data from a region which has been underreported, and specifically North India having a mountain region was always required to contribute some data to add to the complete understanding of the disease process. So the study was done with an objective to observe the effect of acute phase of COVID-19 on thyroid function test, to study the effect of severity of the disease on degree of derangement, and to find an association of bioinflammatory markers, CRP, with TFT. We did a cross-sectional study, which was based on retrospective data. The study center was Department of Medicine, Government Doon Medical College. The sample size was 57. It was calculated using the mean differences of a previously reported study using the given formula. The data collection was done through the hospital records from the time period of March 2020 to March 2021, and the thyroid reports were taken with the patients admitted at the time of their presentation to the hospital. The data collection, we actually graded the severity of the disease as per the ICMR guidelines, and this study makes an attempt to correlate clinically judged severity as per ICMR with biochemical markers of endocrinal origin, like the thyroid. And according to the guidelines, we took patients having an SpO2 above 94% as mild cases, between 90 to 94 as moderate cases, and those having a SpO2 saturation below 90% as severe cases. The inclusion criteria included all patients admitted in that time period, and the exclusion criteria excluded the patients that could have been confounded by other variables, including those having a renal function derangement, having AKI, having a bacterial infection, or a procalcitonin raised level of 0.5, or a previously diagnosed thyroid illness. The statistical analysis was done through SPSS, and etiquette tests were applied as per need. The results were very interesting, that the mean age of our sample was for 47.1 years, and you can clearly say that males in the sample reported a more severity of the disease in the sample we had. Now, 28% had raised T4, while 9% had decreased TSH in the entire sample. Among the mild disease patients, most patients had a normal T3, 95%, and TSH, 78.9%. And the moderate disease patient also had a normal T3, but raised T4. Coming to the severe patient, T3 was decreased in 47.3% of the patients, and T4 was raised in 26.3% of the patients. These were the median values. You can clearly see that with the disease severity, there is surely a derangement which we can clearly mark out. And as expected, the variation of CRP was also significant with the disease severity. We used the classical values test to identify that, and the findings were found statistically significant for T3, T4, and CRP. For TSH, it was not statistically significant, but you can clearly see a clear demarcation between mild to severe patients. So the main findings of this test reported were that there was statistically significant difference in values of T3, T4, and CRP across mild, moderate, and severe patients. The median values of TSH decreased with the disease severity, and the median values of CRP, as expected from an inflammatory marker, increased with the disease severity. Now, this was the correlation matrix we constructed to demonstrate how things are being affected. The things marked with the star were statistically significant. The correlation between CRP and TSH was found to be statistically significant in mild patients, and that correlation maintained till moderate severity and severe severity, while that for TT4 and TT3 was very significant for the moderate COVID disease. But as we grow, you can see that there is not much difference in the severity of the disease. So if we are implicating about the impact of COVID on peripheral conversion, it's increasing from mild to moderate disease, but after that, the correlation seems to maintain, which was an interesting finding for us to observe. The other findings were demonstrated in terms of percentages. You can see that the major sample with the mild disease and the moderate disease seemed to show some consistent tendency with severity. T3 was found to be decreased, while TT4 was found to be increased in the majority of the sample, taking them broadly. Coming to the limitations of the study, the study was based on retrospective data, so we could not follow up the patients. And being a cross-sectional study, we could not find a best control group to kind of compare and give a more generalizable findings. But probably with the attempt we made to compare between the disease severity, this was the best possible and feasible study design we could have taken up. Coming to the future perspectives, future studies are surely warranted to explore the molecular mechanisms behind the effect of COVID-19 on thyroid function, and probably other viral illnesses too. So coming to the conclusion, most patients in acute phase of COVID-19 had normal thyroid function. 47.3% with severe disease showed low serum T3 levels. Our study also demonstrated secondary hypothyroidism in around 16% of the patients. Disease severity was seen to directly correlate with the extent of thyroid function abnormalities, which indicates that it's not just about the critical illness or what we call a non-thyroid illness syndrome or a tacitus or thyroid abnormalities or allostasis associated with critical disease, but COVID in itself can cause thyroid abnormalities. And with any viral disease per se, we must not ignore the endocrinal abnormalities associated with it, and it must be a part of our initial screening, especially with a disease we don't know much about. And a negative correlation was seen between TSH and CRP, which indicates the role of the systemic inflammatory process, which might have played a very significant role. And from a study, we could judge that there was not just a systemic inflammatory process, but probable role of COVID like the SARS-CoV virus directly on the thyroid gland and even on the peripheral conversion from T4 to T3. And this all was in concordance with the disease severity. So this is it. Thank you, everyone.
Thank you, Dr. Sethi. Do you have a long COVID clinic?
Yes, sir.
So did you notice any one of your patients listed here coming with hypothyroidism, hyperthyroidism, or an inflammatory thyroiditis?
Yes, sir. Actually with this study we could not do it, but once we connected the post-COVID study, the post-COVID syndrome study, in that we observed many patients who after having a subacute thyroiditis.
Your presentation is about the acute phase.
Yes, sir. This is about the acute phase.
So that is a biochemical thyroiditis, not clinically relevant thyroiditis.
Yes.
Did they at a later date come back with any history of, clinically relevant thyroiditis?
So most patients in this, like most of them didn't come back for follow-up. The ones who reported for follow-up were normal after the initial impact of COVID.
So it's a transient biochemical thyroiditis, but you did notice in your long COVID, clinic that
Yes, sir.
there are instances of
Yes, sir. Yes.
hypo or hyperthyroidism. Which one did you notice? Or all three? Thyroiditis, hypo and hyperthyroidism.
Yes, sir. So actually in the post-COVID study we did, we found that some patients who initially had hyperthyroidism in the initial phase, later they developed hypothyroidism and
Yes,
had to
that
take
is
the
that is typical. You get a thyroiditis, which can be a transient hyperthyroidism, and then typically it goes into hypothyroid. That's the traditional way all the inflammatory thyroiditis will end up. Okay.
How many of them turn to Graves? Oh, you didn't follow. Graves disease?
No, sir. We did not find any grave disease in the sample reported for this study.
Okay. Any questions from audience?
Thank you very much.
Thank you then.
Yeah, Dr. Shushruth? Okay.
Respected judges and my fellow colleagues, I am Dr. Sushruti from St. G.S. Medical College, and today I am going to present my study on real-world evidence and of clinical study of use of remdesivir and/or tocilizumab in severely ill COVID-19 patients. So this is a publication from JAPI. Over the time, we have had use of various drugs that were proposed: HCQ, favipiravir, remdesivir, ribavirin, corticosteroids, then vitamins, BCG vaccine. Remdesivir and tocilizumab have been widely used in treatment in India. Multiple clinical trials are there in Western literature and have given mixed results. But there's a paucity of organized literature in Indian context. That is why we aimed this study with the objectives such that the evolution has evolved from HCQ until COVID-19 vaccine. And that is why we planned this study with the objectives, the primary objective being to assess the clinical outcome of COVID-19 positive patients who have received remdesivir and/or tocilizumab, and secondary objectives to find the predictors of outcome and to study the duration of hospitalization, duration of oxygen therapy, and change in WHO OS score for clinical improvement. So these are the materials and methods. It was a single-centered retrospective observational study in COVID wards over a duration of 8 months with universal sampling with a primary sample size of 521. IC approval was taken, CTRI registration was done. And this was the selection criteria. We included severely ill lab-confirmed COVID-19 patients more than 18 years who had received remdesivir and/or tocilizumab. The definitions we used was as per NIH's clinical spectrum for severe and critically ill, SpO2 less than 94. We had to exclude 48 patients because they had mortality within first 24 hours. Pregnant and lactating women, there were none of them. So we had this primary sample size with 521 patients, which was for final analysis. And we also compared this data with a retrospective cohort, which was used as a placebo group. This was the time when there was no remdesivir and tocilizumab available with the market. This was a case record form. We use an objective scale, WHO ordinal scale, which is like the mode of oxygen, and it gives a score of oxygen to ECMO, invasive ventilation, and even death. So these were the results. So as we can see, we had Remdi with 414, Tosi with just 31 patients, and Remdi plus Tosi with 76 patients. Median age was 56, similar in all the groups. Gender distribution, it was a slight male preponderance. And we had diabetes as one of the most commonest comorbidity, and at least one comorbidity was present in 76% patients. Outcome in terms of survival, for the placebo group, it was 34.6%, but subsequently in all these groups, we found 66, 80%, and 47%. For only Tosi, it was 80%, and this was statistically significant. We've also tried to compare the WHO ordinal scale. So we found that the duration of hospitalization, duration of oxygen therapy, number of days required to bring the change in the WHO OS, and WHO OS change by the drug, how much change was it? And we found it to be statistically significant in all the groups. And especially of note was, even though tocilizumab showed improvement, the duration of hospitalization was very high, 47 days. The oxygen therapy was 45 days. We further went and did a binary logistic regression by backward elimination method, and the model was good. And for remdesivir group, we found these factors to be clinically good predictors. These were the odds ratio. For tocilizumab, we did not find any better predictors. For a remdesivir and tocilizumab group, we found only respiratory rate had admission to be a better predictor. In summary, median age of the patient is 57 years. 76% of the patients had at least one comorbidity, with diabetes and hypertension being most common. Overall survival improved to 64.1% from 34.6%. Remdesivir and tocilizumab given together reduced overall hospital stay, and WHO OSS score changed in just a fewer days. Tocilizumab alone had a good survival, 80%, but it increased the hospital stay, which possibly could be attributed to sepsis as a complication to the drug, and WHO OSS reduced significantly in all three groups. So where do we stand now? We have only remdesivir, which we have WHO solidarity trial, which says no survival benefit. The co-actor trial, which says there's a printing mistake. The WHO solidarity trial, co-actor trial is only for tocilizumab. I would like to remove that. WHO solidarity trial is no survival benefit. ACTT1 trial showed improvement in the time to recover. For tocilizumab, REMAP-CAP trial showed tocilizumab improved outcomes, including survival. EMPACTA trial reduces the likelihood of progression to mechanical ventilation, while recovery trial also showed that improved survival and other clinical outcomes. But in tocilizumab, the co-actor trial is saying that no significantly better clinical status or lower mortality. But a point to note is that even though the recovery trial mentions that steroids have to be given, co-actor trial only tocilizumab was given, and steroids were only fewer patients had received steroids. About remdesivir combined with tocilizumab, remdactor trial is the one. There are very few studies, but it shows no additional benefit. So the take-home message of this publication is to put forth our experience. It is a real-world evidence study, unlike all these trials which have been in a controlled environment. And our study found that better clinical outcomes with remdesivir and/or a combination in comparison with a retrospective cohort in our setup. However, a multicentric trial is needed further to say conclusively. And while this meantime, the emergency approval still goes on for the usage. So these were the limitations. It was a retrospective cross-sectional non-randomized study, hence a prospective multicentric randomized placebo-controlled will be required. And availability of the drugs was a challenge, hence there is a variation in the sample size of the arms. We are working on that, the same. We are trying to have matching in the same, and we will try to reproduce a few more results. These were my references. Thank you.
Thank you very much, Dr. Shoksu. Was the dosage in your of steroids in the previous control or placebo arm or historical control arm and this arm the same?
Yes, sir. 40, it was given 40 milligrams.
So it was a standard dose whether they were on remdesivir or whether they were not on remdesivir in the past. What about the tocilizumab arm?
Yes, sir, for all the 4 groups.
So was it just an affordability which randomized them to remdesivir versus tocilizumab or anything else?
Sir, it was the severity. If the patient qualified for the tocilizumab, only then he was given additionally tocilizumab. So that included.
So that means the inclusion criteria for tocilizumab and remdesivir were different.
Yes, sir. Okay. So tocilizumab was only as per the, we followed the state guidelines about when to give tocilizumab. Only those patients received tocilizumab. So we can say that the tocilizumab only group is the group which is having relatively more critical patients as compared to remdi alone.
Okay.
So for further studies, you require another COVID epidemic.
Yes,
How you will get those patients who you'll give both the drugs without COVID?
I did not get your question, sir.
How will you do a randomized study?
Yes.
If there is no another wave of COVID, that is what sir is asking.
Yes, sir. So now we just could, what we are trying to, we are not going to do a multi-centric prospective study, but what we are trying to do is, in the available data, try to have a propensity score matching, and then do one-to-one match of these patients, considering the comorbidities and age group, and reanalyze the data if it gives the same. We also performed survival analysis. Survival analysis again showed that there was a better outcome with all of these drugs. This was just percentage, but we also did Kaplan-Meier survival analysis.
You will probably need to match it to inflammatory markers, to the the radiological scoring,
yes,
as well as other parameters.
Yes, sir.
Just instead of survival to say remdesivir actually worked.
So one of the key important messages that what we had was WHO OSS score, which was a very objective parameter to stratify the patients. Like, so once we are considering WHO OSS score, the patient is relatively easily classified in terms of the oxygen requirement and the severity. Then we have to consider the comorbidities and age or gender.
The comorbidities seem to have matched in all the groups, so
yes,
that's not a problem at all. Yes, so in fact, there was no comorbidity, they were not admitted by you.
Yes.
Most hospitals refuse to admit patients without comorbidities.
Yes.
Okay, thank you very much.
Yeah. Thank you, sir.
The next speaker, please. Dr. Vishnu Shivam.
Respected judges and one and all gathered here, very good morning to one and all gathered here. I am Vishnu Shivam. I am going to present my research paper on genomic approach to identify association of environmental bisphenol A in daily use plastic as molecular disruptors in breast cancer. So, the last 6 decades have witnessed the introduction of various chemical compounds, bioactive synthetic compounds. One of the compounds introduced was bisphenol A. It is an endocrine environmental disruptor which is synthesized in 1905 and is used as a plasticization in various daily use plastics such as water bottles, thermal residues, children's toys and food containers. This BPA easily leaches out from the containers on varying temperature and pH, and studies reported it in human urine, blood samples and biological fluids. The World Health Organization and FAO issued a safety tolerable daily intake of BPA as 1.5 to 4.2 microgram per kg body weight per day. So the active metabolite of BPA when it entered a bloodstream causes conformational changes in the homoiety of hemoglobin and aromatic amino acid residues such as trypsin, tryptophan, which is observed by spectroscopic methods. So this BPA acts via estrogen receptors and causes overexpression of MDM2 gene, which downregulates P53 tumor suppressor gene and induces cancer cell proliferation as reported in the human breast cancer cell lines. So the hypothesis of our project is shown in the flow diagram. The bisphenol causes expression of estrogen receptors, overexpression of MDM2 gene is reported in the breast cancer cell lines, and they suggest that there is a direct regulation of estrogen receptors by BPA and MDM2, which wholly leads to P53 downregulation, which causes increased risk of breast cancer. So our main objective is to investigate the association of bisphenol A, the active metabolite, and MDM2 SNP309 polymorphism with the risk of breast cancer. So after ethical clearance from the Institutional Ethical Committee, blood samples are collected from the breast cancer patients and control groups. The conformational changes were measured in the range of 200 to 800 nanometer by using UV visible spectrophotometry. The DNA genotyped by tetrams PCR. The primers are shown here, and the PCR products are analyzed by agarose-Gilly electrophoresis. So this is the results in our study. The serum sample shows that the breast cancer patients had increased the mean absorbance at a range of 250 nanometer to 300 nanometer and 360 nanometer to 450 nanometer as compared to the control samples. So the table shows the statistical analysis for the association of MDM2 SNP309 genotype with breast cancer risk. So the allele frequency as shown here, the G allele, the variant allele is increasingly associated with the cases than the controls, which is statistically significant. This means there is the odds ratio is 2.17, that is 2.17 fold increased risk of breast cancer with the genotype G allele. So when coming to dominant phenotype, with reference to the TT as a control, the G in its dominant form increases the breast cancer risk by 2.8 fold, which is statistically significant. Whereas the TT genotype is present more in the control groups than the breast cancer patients, which is statistically significant with the odds ratio of 0.36. So we observed an increased mean absorbance in serum samples of breast cancer patients when compared to controls at this range, which is consistent with those results reported in previous studies. The peak absorbance at 410 nanometer due to hemoglobin is increased in breast cancer patients than controls, which indicate more free hemoglobin due to these conformational changes by BPAQ. Changes in amino acid residues in serum albumin and cytochrome C cause peak absorbance at 250 to 300 nanometer. So this MDM2 SNP309 G allele is increasingly associated with breast cancer patients, whereas T allele is increasingly associated with controls as shown in the table. The MDM2 G variant in its dominant form increases 2.8 fold increased risk of breast cancer, which is consistent with the previous studies reported. So there is an increased expression of estrogen receptors, presence of MDM2 G variant allele in human breast cancer cell lines in the presence of BPA reported by previous studies. So this suggests that the bisphenol A could be responsible for the mutation of MDM2 gene, a T2G variant, and causes overexpression of MDM2 protein, thereby leading to tumorigenesis. So the take-home message is, in conclusion, a significant association between MDM2 SNP309, a T2G variant allele, is associated with the risk of breast cancer in Indian women. The breast cancer patients have more BPK-induced changes than the control groups. Moreover, the direct correlation between the amount or level of BPA quantified and the breast cancer could not be ascertained with this small sample size. Further long-term studies with more sample size of controls and cases may throw some evidence on this. So the take-home message is, by reducing the exposure, daily exposure to environmental BPA, there would be a reduction in the increased risk of modern metabolic disorders and hormone-dependent cancers. So thank you for giving this opportunity.
Thank you, Sivam. Are you a doctoral student or a postdoc?
Undergraduate final year MBBS student.
Your final year?
MBBS student.
MBBS. Okay. Did you do any of these in vitro tests yourself, or you are presenting on behalf of a group?
Sir,
did you do these experiments yourself or presenting on behalf of?
It was my ICMR STS project, sir.
Oh, wonderful. So my question is very simple. You made a conclusion. Go back to your observations. First and foremost, who were your controls? Who were your controls?
Sir, controls are non-breast cancer, no history of breast cancer patient, no other any visible disease, sir, no cancer, sir.
Are they family members?
Sir? No, sir, no family members.
Why?
Sir, family members.
How do you know they are exposed to the same amount of bisphenol A?
Same locality, sir.
Pardon?
Within the same locality, in Coimbatore.
In the same locality, two houses may have a different consumption. One may eat everything in a packet food format, or in plastic bottles, the other may use only steel jug or a glass bottle. So it doesn't mean that they are exposed to the same level of bisphenol A. Can you go to one of your conclusions? How did you conclude that bisphenol A actually leads to a mutation? Go one step back. Yeah. How did you conclude that it causes a mutation in the MDM2 gene? Bisphenol, what a single nucleotide polymorphism actually shows is whether they were born inherently with that SNP. It is not induced by the environmental carcinogen. If it is a metabolizing enzyme, it just means that they are born with that SNP. Nowhere does it suggest that bisphenol A causes this SNP mutation. So in which case you have to prove that it has occurred in the breast tissue. It is absent constitutionally. Did you prove that?
We refer to the previous studies, sir. They proved that in human breast cancer cell lines like MCF7, in the presence of BPA, in the absence of BPA, they showed that BPA induces MDM2G variant and it increases the MDM2 protein, which leads to breast cancer. So
we need to know whether it is constitutional or in tumor tissue. You have done a constitutional study where you estimated the bisphenol A in the plasma, am I right? Not in the tumor.
No, sir.
Okay, so where did you study the SNP? You studied it from the polymers in the blood.
Yes.
Am I right?
Yes, sir.
So you think it is a constitutional change, or they are born with that? It's a germline mutation, or is it a somatic mutation? How do you prove that?
So it could be a somatic mutation, sir.
Typically, SNPs are inherent.
Yes,
they are germline mutations. They are not induced by the environmental carcinogen. Okay, so it is very difficult to prove that the MDN gene mutation actually occurs. Unless you have, let us say, two people in the same family, all consuming the same food, whatever you are postulating, and in them you demonstrate that one of them actually shows the MDM2 gene mutation, the others don't show it. So that's the only way of using a hypothesis to prove that there is a. Typically, SNPs are germline. They don't mean anything. So, second postulation, what does this mutation actually do to bisphenol A? If you think that it is the endocrine disruptor, if bisphenol A was the endocrine disruptor and it caused an MDM2 gene mutation, what did it do actually?
So actually
the SNP. What did the SNP do?
The BPAQ active metabolite adducts to the DNA. It has two pathways, genomic pathway.
I know the pathway. So what is your postulation? Did the SNP can act as the same as the normal, non-mutated? It can increase or decrease. There are only three possibilities, no?
Yes, sir.
And typically, SNPs do not actually matter. You are you and I am me simply because of SNPs. Yes, that is the only difference, okay? Otherwise, everything else is common, right? So you need to prove that it actually increases, decreases, or remains the same as far as the metabolism of estrogen is concerned, or the expression of estrogen receptors is concerned. Okay? Right. Any question? Thank you.
Thank you.
Okay, next speaker, Javed Ahmad Bhatt.
Respected judges and dear colleagues, very good morning to all of you. I am Dr. Javed Ahmad Bhatt, presently working at Sri Kashmir Institute of Medical Sciences, Asora schemes. I am going to present a study, lactic acidosis in DKA, a marker of severity or alternate substance for metabolism. As we know, the lactate level is being increasingly used as a marker of severity of illness and prognosis in multitude of critical conditions like sepsis, ST elevation, MI, trauma. However, its role in diabetic ketoacidosis is not well defined, despite the fact that prevalence of lactic acidosis has been documented in a number of studies in the past. So we aim to study the prevalence, clinical importance, and underlying role of metformin in lactic acidosis in patients admitted with diabetic ketoacidosis. So it was a prospective observational study comprising of 62 consenting in-hospital DKA patients. Data was collected over a period of 2 years. Patient demographic, initial lab data, comorbid conditions, use of metformin, suspected precipitants for DKA and outcome were recorded. Plasma lactate level on arrival, its clinical significance and relationship with morbidity and mortality in patients with DKA was evaluated. So this graph shows the lactate level in our patients. The median lactate level was 2.5 millimoles per liter with the interquartile range of 1.7 to 3.2. We defined lactic acidosis in our patients with a level of more than 2.5 and significant lactic acidosis was defined with a level of more than 5 millimoles per liter. In our patients, the prevalence of lactic acid was found to be around 55% with significant lactic acidosis in 16% of the patients. On comparing patients with the lactic acidosis that was defined as lactate level of more than 2.5 with those of not having lactic acidosis, what we found that there was no difference as far as the duration of the hospitalization, severity of DKA, whether it be mild, moderate or severe, morbidity in the form of acute kidney injury, hypertension, then respiratory disorders like respiratory distress syndrome or need for mechanical ventilation, cardiac arrhythmias, cardiac arrest or CCF, and then thromboembolic phenomena or cerebral edema. There was no difference between the two groups. To assess the impact of higher levels of lactate that we defined in our study as significant metabolic acidosis, with those having lower than 5 millimoles per liter of lactate level. We again found that there was no significant difference as far as these parameters were concerned, except for that there was increased number of severe DKA patients in a group with significant lactic acidosis, and they had hypotension in a significant number of patients. So except for that, no no morbidity parameter was documented in these patients. On comparing those groups who were using metformin with those who were not using metformin, what we found that there was no significant difference between the lactate levels among the two groups. So again, the lactate level were comparable between the two groups. Limitations of our study were lack of detection of type of lactate present in our patients and elucidation of intermediate products leading to utilization of lactate as an alternate oxidizable substrate for gluconeogenesis, and then again lack of means to demonstrate the actual contribution of lactate in acidosis during decay. So we conclude with this that there is a lactic acidosis has a significant presence in patients with DKA. However, it is not associated with mortality or significant morbidity. There was no significant difference in severity of lactic acidosis in patients using metformin. Elevated lactate levels, we hypothesize that may be an adaptation to provide alternate substrate for metabolism in the presence of hypoinsulinemic state characteristic of DKA. Thank you. Thank you very much.
Any question from floor? How many lactic acidosis cases you seen with metformin?
Sir?
You have seen any lactic acidosis cases with metformin?
Actually, I have not myself seen, but since literature is there, so we assessed metformin as a part of a contributory role in lactic acidosis.
Okay. Although it's very, very rarely seen actually.
Yes, sir.
He probably was not, he was born after fenformin was banned. Okay, so he would not have seen it all. Okay. Thank you very much.
Thank you, sir. Thank you very much.
Next speaker, Dr. Suraj.
Good afternoon, everybody. the outset, I'd like to thank each and everybody who are present here and the judges in particular, also the organizers for giving me this opportunity to talk or present my already published paper. This article was published in the JAPI of August 2021. So basically, I will be talking about the efficacy of remdesivir. The previous speaker also has spoken with respect to remdesivir and tocilizumab. I am going to speak specifically with respect to remdesivir. So, a brief introduction. SARS-CoV-2, which causes the coronavirus disease, has led to dramatic loss of human life worldwide, with more than 1 million deaths. Given the virulence of the organism, plus its contagious nature and high morbidity and mortality, the development of an effective and safe treatment, the development and effective treatment was the need of the hour. So, based on this, we decided to do a small study, which was done in during the period of September-October 2020. So, we enrolled 100 consecutive patients who are RT-PCR positive, along with those who are requiring intensive care. So basically, asymptomatic patients were not included in the study. All such moderate to severe ill patients were given remdesivir intravenously, 200 milligrams of loading dose on day 1, followed by 100 milligrams of maintenance dose. The outcomes that we analyzed were the impact of early initiation of remdesivir on recovery, assessed by number of days in the hospital, recovery, biochemical improvements, and death. IV antibiotic was given as per the ICMR guidelines according to the Rajiv Gandhi University of Health Sciences. Use of other treatments like hydroxychloroquine, ivermectin, azithromycin, doxycycline, oseltamivir, tocilizumab or itolizumab, whatever the drugs which were available for treatment were given according to the treating physician's clinical judgment. Asymptomatic patients less than 18, more than 80 were ruled out. Normal HRCT were not included in the study. Pregnant nursing mothers were not included in the study. Newly detected renal dysfunction or liver dysfunction patients also weren't included. Any patients who were having active malignancy or pre-existing malignancy were also excluded. We did the analysis by SPSS statistics with the help of Mediva, our statistical arm. Outcome measures, length of hospital stay, clinical improvement, biochemical improvements, data on the clinical and lab findings, CT scans, radiological involvement, and any adverse effects were looked into. So basically, coming to the results, as you can see, we had 100 patients, out of which 16 patients expired. So we tried to compare, we did an analysis based on what is happening to each of them. If you see, patients who were presenting with dry cough, myalgia, and cough with, and breathlessness at rest, these are the people who are more likely to have higher mortality than compared to the patients who are having just fever, breathlessness on exertion, and sore throat. So, symptom wise, if I have to say what would I like to look in patients who had had mortality, one is breathlessness on exertion, dry cough, and those with breathlessness at rest. When I come to, this is more or less same across the country. We have had the age group somewhere in between 40 to 55. We had 80% at that time. Apparently the men were roaming around and the women were at home. So there's a gender skew. BMI was around 24 and 73. A quarter of them presented without fever. Well, majority of them presented with fever. Tachypnea was there in around 65 people, and the normal respiratory rate was seen in around 1/3 of the patients. Blood pressure, there was not much significant. Pulse rate was not that significant. SpO2, most of the present, because since the patient who we included in the study had to be moderately severe, so they had a saturation of less than 94. So radiological picture, most of them had ground glass opacities. There was a right lobe or the right lung predisposition. Crazy paving pattern, consolidation, always seen with respect to the standard protocol, standard clinical findings, what we usually see. So, this is the most important slide that I'd like take a minute to discuss about it. See, we plotted patients who had mortality and who do not had mortality. If you can see on the left hand top corner, the patients who presented more than 8 days after their symptom onset, they had the highest mortality. Patients who presented within 1 or 2 days of the symptoms, they had the least amount of mortality. With respect to the patients who expired and improved, there was no significant difference with respect to the duration of the hospital stay with remdesivir. So if I have to talk about the biochemical, sir requested the other speaker to talk about the biochemical improvements. So this is what we had done with respect to the biochemical. So at admission and at discharge, what happened to both the groups. So if I have to talk about neutrophil to lymphocyte ratio, patients who improved, the pink one are the patients who expired and the green one are the patients who improved. So there is a significant improvement. So with respect to NLR. So if your NLR is increasing, the chance of mortality is higher, and if your LDH in the patients who had mortality, the LDH doubled from diagnosis at presentation to closer to the discharge or death. So ferritin, same thing happened with all the inflammatory markers. C-reactive protein also shot up in patients who had mortality. C-reactive protein decreased by more than 2/3 in patients who had improved. Similar with the D-dimer, similar with interleukin. So all the inflammatory markers had improved in patients who improved, and they worsened in patients who had mortality. So CT severity score, sir was asking about the radiology. Patients who improved had a lower CT severity score than compared to patients who had higher mortality. So in conclusion, in our subset of patients, this is a real world evidence. We did not have a control arm, but very difficult in the midst of a pandemic to have a control arm. So we did not have a control arm, but in summary, the subset of patients who are admitted with moderate to severe pneumonia, our center experienced finding inclined towards early use within 8 days of symptom onset of remdesivir for better clinical outcome and help in reduction of the associated mortality and morbidity. Diabetes had the highest mortality rate. 40% of the patients who had diabetes, of those 16 patients had diabetes, and symptom onset to seeking care of more than 8.5 days was associated with a higher mortality. Thank you, sir.
Thank you very much, Dr. Swaraj. Am I right in understanding, irrespective of the clinical class, WHO class they are in, the moment they are admitted, if you feel you should start remdesivir, irrespective of their clinical condition? Is that the message you want people to carry home?
The message I would like to give is, if the patient has presented to you with breathlessness, decrease in saturation.
They won't present otherwise.
No, sir. So because it was
If they are asymptomatic and you gave remdesivir as a control group, that would have been a better idea.
Yes, I totally
But here, all these are symptomatic patients.
Yeah, moderate to severe.
So the moment they become symptomatic, you should start remdesivir.
Yes. At least
Is that the?
Yeah, this is what we found. Remdesivir is an antiviral agent. Definitely, yes. If we are presenting with symptoms, earlier the use, the better it is.
Okay. Any questions for Dr. Swaraj? Thank you very much. So we conclude this session. If my co-chairs, judges are ready with their marking, we will hand it over to sir. You're right.
Thank you, judges, and the active participation from the students. So with this, we will conclude this session, and I would request the chairpersons to kindly collect their gifts from the ACP counter. Thank you very much, and please give the compiled results to me. So now I would request Dr. Dhruvi Asnani to take over for the next session.
So good afternoon, everybody. We are having a wonderful second day of the American College of Physicians India Chapter Conference. We've had such important clinical case discussions since the morning, and all of us are pepped up. I am here to, start the next session, which has some really good recorded sessions by some foreign Japanese speakers talking on the clinical tips and focus for internists. I think it'll be something new and interesting. But our opening speaker is a very Indian speaker. And for that, can I request our chairpersons, Dr. Mukhya Prana Prabhu sir from Manipal University. Sir is a senior physician. Can we have his CV, please? Sir is a senior physician, consultant physician, and a professor, and we worked together on the COVID Diabetes India study, and we've learned a lot from him through that process. Our second chairperson is Dr. Vinod Abhichandani, sir. Sir is on his way, so let's wait for him. He's a consultant endocrinologist from the city of Ahmedabad. Again, a very senior physician also by experience and an endocrinologist. With that, may I request Prabhu sir to take it up. Thank you, sir.
Thank you, Dr. Dhruv.
It's our great pleasure to have Madam Shilpa, Dr. Shilpa. She is an oncologist and she is the council member of Andhra Pradesh Medical Council. So, ma'am, a warm welcome. And please, thank you for gracing this occasion. Over to Dhruvi, please.
I've already talked so
Yeah.
much. I think
Yeah.
I've taken quite some amount of time. So, Prabhu sir.
Yeah, the
Yes.
first speaker, yes. Yes, sir. Hello, sir. Yes, sir.
We welcome our second chairperson also,
Yeah.
V.K. Abhichandani sir. Again, a senior endocrinologist and a very senior physician and a teacher to all of us from the city of Ahmedabad.
Okay. On behalf of chairpersons, thanks Dr. Dhruv and all the organizers for giving this opportunity. And we have got 3 talks. First is approach to a case of vertigo by Dr. Ashish. Can we have the slide of introduction? Slide for Dr. Ashish.
Good morning, sir.
Yeah,
Thank you for
good
calling.
morning, good morning, yeah.
Yeah, wait for a second till we formally
Yeah,
introduce.
yeah.
So
Yeah.
can we have?
Yeah, they put the slide, yeah. Sir is a senior consultant physician and practicing for last 38 years. Yesterday we had a book released by Dr. Ashish.
Yes, sir.
What not to miss in OPD.
What not to miss in a busy OPD? The
Yeah.
busy was deleted.
Yeah.
Seeing the legal part.
Yeah. I just was going through it, and vertigo is such a topic and a busy topic. We will busy OPD. We will have a vertigo when the patient comes with
Yes,
vertigo.
sir.
So
And
to
thank you,
talk
sir.
on that, we have got Dr. Ashish, senior physician. Yeah.
Yeah, so we welcome you to begin your, what is going to be a very informative and educative talk for all of us, including myself. So I'm going to be a richer physician at the end of listening to your talk. So kindly go ahead, sir. And congratulations for the book release.
Good morning, sir, and namaskar to the beautiful city of Visakhapatnam, Vizag. Perhaps one of the most beautiful city of India. And respected my faculty members, chairpersons, and dear delegates, senior and junior, all. So when this topic was given to me, I developed vertigo. Because in our UG days, and not only in UG days, but in PG days, vertigo was something, chakkar aa gaya, doctor ko bhi chakkar aa gaya. So, theek hai. And there is one disclaimer that I am not a ENT physician, ENT surgeon, so I do not know much about all those maneuvers and tests, calorie test, etc. I will go through the physician's perspective. And neither I am a very learned neurologist, though our MD days, neurology TM was there and I left it, but neurology was the main subject, but we will go the clinical neurology way. So this is all I have to say about this topic. Now, architecture of this presentation is why dizziness and vertigo is to be taken up seriously, and that too at ACP. Why is dizziness and its broader subsets? What is dizziness and its broader subsets, including vertigo? What is vertigo? The true medical vertigo. The next will be how vertigo is different from pre-syncope and syncope. Then there will be common disorders of vertigo, the peripheral ones and the central ones. Then there will be common misconceptions about vertigo. Then there will be approach, the main topic, how to approach a case of vertigo, keeping in mind the life-threatening ones. Due to time constraints, various maneuvers and tests, they have been deleted from this talk because this talk is meant for, I think, about 15 minutes. Why dizziness and vertigo is to be taken up very seriously? Because it's a clinical presentation. It can present to a physician, to a pain MBBS, to ENT surgeon, to neurologist, neurosurgeon, ENT surgeon, ops and gynae, surgery people, anybody. Number one. Number two, it has got myriad of manifestations. Myriad of manifestations. कोई कहता है हमको चक्कर आ रहा है, lightheadedness, generalized weakness, pre-syncope, syncope, sometimes even seizures. Number three, often, of course, this has been covered, often it is confused with the generalized weakness, giddiness, lightheadedness, pre-syncope, etc. Number three and number four, it is a very common presenting feature in OPD, constituting about 20% in all the disease structure. And sometimes patient, but majority of the times, patient, him or herself, may not be able to tell exactly what they mean by vertigo and allied symptoms of dizziness. And for a clinician also, many a times, including myself, I am emphasizing, including myself, it becomes difficult to exactly pinpoint what patient means by telling dizziness or vertigo. Now, what is dizziness? Dizziness is an imprecise, non-specific symptom which is used to describe many common variable sensations as vertigo, the true vertigo itself, lightheadedness, faintness, imbalance, going to fall, and lot of vernacular language words. Dizziness is not always vertigo. I am repeating. Dizziness is not always vertigo. Rather, vertigo is a definite sensation which comes under the wider domain of dizziness. The broader domain of dizziness. Dizziness can be divided into a cluster of three major subsets. First is vestibular dizziness with imbalance, with or without imbalance. This is true vertigo. Harrison says if it is V for vertigo, then it has to be V for vestibular or its connection. Then pre-syncopal dizziness, all the causes of syncope and pre-syncope. They can be cardiac, arrhythmias, valvular, CMP, etc. Then postural hypotension. Then neural causes like vasovagal, cough syncope, micturition syncope, fright, extreme anxiety, fear, medication effects, etc. Then dizziness can be due to non-vestibular lesions like non-presyncopal dizziness, like in imbalance disorders, Parkinsonism, sensory ataxias, and in severe anxiety. So this was about dizziness, not vertigo. What is vertigo in a true medical sense? Because we all know, we all get daily bombardment. Sir, humko vertigo hai, humko chakkar aa raha hai. But what is true vertigo? If we know what true vertigo is, then our 50% job is done. It's a sense of spinning or other motion that occurs during or after a sustained head rotation. It may have illusion of self-spinning or outer environment, side to side or forward and backward. Now I am going to show how we can produce physiological vertigo in ourselves. Because if I know the sensation of vertigo, then only I will be able to delineate from the patient. Sir, please give me 3 seconds, 4 seconds to show me how to produce physiological vertigo. Just keep like this. Now, this sensation which you get is vertigo. And if it is vertigo, it is vestibular or its connection. Talk is over. If this sensation, any movement, your movement, environmental movement, forward, backward, falling down, whatever, but this sensation, if this sensation is there, it is vertigo, and if it is vertigo, then it has to be vestibular or its connection. Talk is over. Now we are going forward. So vertigo can be physiological, which I showed, and it can be pathological, and according to our Gita, our Quran, our Bible, Harrison's, if vertigo is there, it has to be vestibular or its connection. Thank you, sir. Next. Vestibular dysfunctions, again, the vertigo can be divided into peripheral disorders and central disorders. Peripheral disorders means affecting labyrinth or vestibular nerves, and then there are central disorders which may result from any disruption of central vestibular pathways to the cerebrum, to the cerebellar tract, to cerebellum, or to the spinal cord, or to the basal ganglia, anywhere, any central connection. Now this is my own diagram. I have just shown that first this is all dizziness. BP high, low, heart rate high, low, sodium high, low, glucose high, low, hormones high, low, temperature high, low, output, cardiac output high, low, hemoglobin low, plasma low. This is all giddiness. But if there is vertigo, it has to be from this reason. Nothing can be from these. You cannot say that this is vertigo. The vertigo is this. Then again, for academic purpose, psychogenic vertigo, central causes, cerebellar causes, then craniovertebral junction, Arnold-Chiari malformation, then all these peripheral causes. Again, a vestibular nuclei. So, if a patient has got vertigo, then it has to be from these connections, nothing outside. Now, it is almost always customary to differentiate between vertigo and syncope. In our MD days, I asked one of my senior physician, Professor Asarga, sir, why there should be any confusion? Because vertigo, it's a positive heightened sensation of spinning and imbalance. Positive heightened sensation of spinning and imbalance, while in syncope, it's in fact a type of negative sensation, loss of consciousness. It may be associated with nystagmus, where the nystagmus is not there. And in vertigo, patient himself explains, oh, hame chakkar aa raha tha. He will explain. While in syncope, he will say, oh, I don't remember what happened to me, or relatives will tell you. So there shouldn't be any confusion just by 1.5 minute talk to your patient. Some crisp examination and test must be done for any vertigo. These are general examination, gait, neuromuscular loss, ear examination, nystagmus, checking the eye movement, and head thrust test, and few more, which is out of domain of this 15-minute topic. Now, true vertigo. Now, before going to the approach, I am enumerating some true vertigo causes like vestibular neuritis. We all know it is a very common thing, presents with nausea, vomiting, oscillopsia, and it may run from few minutes to few hours up to days. Then there is paroxysmal, benign paroxysmal positional vertigo. It is provoked by change in head position. This is very important. It is provoked by change in head positions related to gravity, as lying down, getting up, extending the neck up or down, getting neck down, and rolling over on the bed. So paroxysmal, this BPPV is, all these maneuvers, they are diagnostic of BPPV. With migraine, yes, some of the migraines, they turn into vestibular migraine, or migraine per se can have vertigo, or some of the migraine, it can be a variant of migraine where there is only vertigo and there is very less component of headache or vomiting. So it's another entity within the migraine. Then clinically with hearing loss, Meniere's disease, we all know. There will be tinnitus, there will be auditory loss, and there will be repeated vertigo starting from 1 year, unilateral, and later it can become bilateral. Then there are vestibular schwannomas. Now here, there is a catch. This has been added just because of academic interest, because vestibular schwannomas or CP angle tumors, classically, they do not present as vertigo. Vertigo is a minor symptom. Classically, they present as progressive sensory neural deafness. Then come the central vestibular disorders, long list. then they can be acute, subacute, or chronic, but they are very important. If they are acute, all the vascular causes, ischemia, hemorrhage, infections, then subacute to chronic, like immunological processes, paraneoplastic processes, neurodegenerative disorders, and tumors. Then comes the psychosomatic and functional disorders. They should be, their diagnosis should be made, of course, after exclusion. And it has been written that severe depression, major depression, and severe anxiety or panic disorders, they may produce a true vertigo. And sometimes the fright and fear of having vertigo also develops vertigo. These were the common disorders which present as vertigo. A common misconception about vertigo. Patient come to your clinic, he has got this cervical collar. Oh, kya ho gaya? What happened to you? Sir, I have got severe vertigo. Oh, okay. Then, sir, this is due to cervical spondylosis. My professor, Professor Devika Nag, neurologist, she used to fail any MD or DM candidate if ever he came out with cervical spondylosis as the cause of vertigo. If at all cervical spondylosis is going to produce vertigo, it has to be very extreme end. By that time he will be having quadriplegia, pains. He will not come to you with vertigo because there will be severe destruction, vertebral artery impinging, being impinged upon the bones, and then producing vertebrobasilar insufficiency and vertigo. So in general, cervical spondylosis is not the cause of vertigo. For the approach, some common observations must be sought. Is it pure vertigo or have other features, central connection features? Is it acute, subacute, recurrent or chronic? Is it first or repeat? And if repeated, then how often? Is it unilateral, bilateral or asymmetrical? Now, approach to a case of vertigo. Approach in any medical case is always life first. Avoiding mortality, saving the man, saving the woman, it is the first priority. We should attend the life-threatening situation, and then reducing the morbidity and complete recovery and rehabilitation should be the aim. A case of vertigo of short duration comes. First is to delineate it from dizziness. Then first confirm clinically, is it true? If it is true, then rule out head injury and trauma, and then rule out about the vestibular toxic drugs like aminoglycosides. Now, acute vertigo with acute additional central neurological signs and symptoms like central signs like diplopia, dysarthria, dysphagia, ataxia, numbness, variable motor weakness, facial deviation, altered sensorium. You must get MRI done to rule out potentially life-threatening situations of cerebrovascular lesions, hemorrhage, infarctions, etc. So that you have diagnosed a vascular insult and manage accordingly. Now, second scenario, acute vertigo but no central cause. As I have already enumerated, acute vestibular neuritis, it is acute, repeated, recurrent type of presentation. Then it can be BPPV, as I have already talked. Then there can be vestibular migraine, then Meniere's disease, and then vestibular schwannomas. Now, about if it is subacute to chronic progressive central vertigo or vestibular hyperfunction, note their presentation is not predominantly vertigo. They may be, number one, neurodegenerative disorders like Parkinsonism associated with Parkinsonism or subacute neurodegenerative disorders. Disorders due to immune as well as paraneoplastic syndromes. Then there can be multisystem atrophy. Then there can be gait disorders, sensory ataxias, SACTs, etc. The conclusion and take-home message. Not all dizziness is vertigo. Vertigo is a definite sensation of illusionary relative moment within the subset, as a subset within dizziness. One must distinguish it from presyncope, It may be due to some very benign disease or it may be a life-threatening situation. Physicians themselves must know how it feels to have vertigo. They must get a spinning test on themselves. In any acute setting, one must rule out the life-threatening situation by clinical as well as radiological tests. Other than acute central vertigo, which can be life-threatening, all other cases give ample time to clinicians to make a proper diagnosis. And last but not the least, even in benign disease, it is our duty and our attendant's duty and subject duty to prevent fall and trauma. Thank you, sir. Thank you very much.
It's really a talk of back to basics because it is a very basic topic in general our routine practice, and you have demonstrated very well on the dice the initiation of the vertigo. It's really a good message for all of us how to evaluate the patient. Any question from audience?
Thank you, Dr. Ashish, for such a lucid and wonderful talk. In my clinic, I have seen many patients. They were suffering from intermittent complete heart block, but they were treated for cervical spondylosis for months together by orthopedic surgeon. Or so many patients, they were sent for permanent pacemaker implantation because on clinical examination, when the patient visited a physician or a clinician, the incomplete heart block is not there. It is only intermittent. So just by missing because the patient has no positive findings, the patient is being treated for cervical spondylosis. The problem is that patient himself doesn't know whether he is suffering from giddiness or vertigo. He will always say कि साहब चक्कर आ रहा. Then he visits from neurologist to orthopedic surgeon and where not. But most unfortunate is that the patient of incomplete heart block who are intermittent, they have been treated like cervical spondylosis for months together.
And in
Very well said, very well said.
In most of the cases,
Thank you,
anti-vertigo medications are started very early without evaluating anyone.
One thing more I would like to add, I missed somehow, because treatment part was not there. We should not use all these medications like Vertigon and all these, I'm taking a name, because if you use it for more than 3 to 5 days, then the central compensatory mechanism, they do not come into play. So we should use it for just for few days. It is written in leading neurologists, leading neurological books, and also in Harrison's. It should be used for 3 to 5 days maximum to avoid severe vertigo.
So thank you very much, sir.
One more. Yeah. My question is how to differentiate between BPPV and Meniere's disease.
BPP and good. I told you in BPPV there is no auditory loss, no hearing loss. While in Meniere's disease, the presenting symptom can be auditory loss and tinnitus. In Meniere's disease, you can have heaviness in the ears. While BPPV, because both of them can have recurrent vertigo. It's a good question. But if there is hearing loss, it cannot be BPPV.
Sir.
And I think, give me a second, please.
Yes, sir.
I think I have been a really enriching experience for me. Till now, I knew only of 3 simple, categories of vertigo: objective, subjective, and pseudo vertigo. But you have changed the scale for me. Thank you for doing that. Wonderful talk.
One question. Sir, it's a nice presentation. Post-COVID, we are seeing more cases of BPPV, which are very refractory to the treatment. What is your experience on this?
Sir, I am basically a medical physician. Yes, I have seen refractory cases, and they are not responding. And due to some academic discussion here, I am not writing all these medications for more than 7 days. Rather, I tell them about the about the exercises, eye exercises, all those exercises which may improve, some kind of improvement is there with those positional exercises. But I don't have any experience of any steroid or any other drug.
Is there any association with COVID infection to BPPV?
Sir, as per yeah.
Okay.
And one thing more, was that really vertigo?
Yes, sir. Yes, sir. After completed
Was that really
evaluation.
vertigo or dizziness? Yeah.
Okay. Thank you, sir.
Thank you, sir.
So we have got a Japanese speaker who is giving a recorded talk. Her detailed CV is enclosed. She is from St. Mariana University School of Medicine, Associate Professor of Emergency Medicine, Diploma at American Board. And she will be talk on clinical tips from the in-clinic translational project. Maybe it's a basic translational research project. She will be speaking. Well, over to Yuko Kitano's recorded talk.
I'm currently located in my office, and I have already sent the pre-recorded session of PowerPoint, so I assume the pre-recorded session will be delivered there. I sent the pre-recorded session to your secretary.
Yes, madam. She is keeping. You are on the live available, and I think they will share the recorded version. If any questions are there, we will directly pass. I hope I am audible to you.
Of care in your daily bedside practice and for the resident education. Let me first introduce how this in the clinic translation project was initiated in 2016. This project came to fruition about 6 years ago with an informal chat between myself and Dr. Ando. I was the vice chairperson and Dr. Ando was the chairperson for ACP Japan Chapter Public Relationship Committee back then. At that time, the main work of PRC was posting newsletters from each committee's chairperson, which of course is an important work, but not so exciting for clinicians. In 2016, at the ACP Japan Chapter Annual Board Meeting, Dr. Ando and I talked. Yuka, we PRC would like to do some exciting project to attract new members to both ACP Japan Chapter and to the Public Relationship Committee, other than posting the newsletter on Facebook. Do you have any thoughts, Yuka? And I said, how about translation project of In the Clinic? In the Clinic is, as you know, they are famous resource among my colleagues during my residency in the United States. Dr. Ando said, sounds good, but it's going to be a huge project. Are you sure you want to do it? And I said, yes, let's do it. We were both very excited about this project, and we started a pilot project as an initial step. I first translated the whole hepatitis C article by myself, and Dr. Ando recruited volunteers from the PRC to go through proofreading process. At that time, we were not sure whether this project would have an official green light or not. However, all the members supported this pilot trial as total volunteers. Then we sent the proofread article to Dr. Osaki for subspecialty comment. Dr. Osaki is one of the leaders in hepatology in Japan and also my lifelong mentor from my residency at Osaka Red Cross Hospital. After the successful completion of this pilot project, we talked to Dr. Ueno, the governor of the ACP Japan chapter at that time, and other core members of ACP Japan. They had built strong and constructive connections with the ACP. As a result, we were able to complete a contract. That meant we had an official way forward for this project. Right away, I sent out emails recruiting participating teams membership. These are the translation teams from all over Japan. Many renowned medical schools have applied for this project, making a dedicated team. They translated the in the clinic article, and these are subspecialty commentators. They gave us concise comments in case there were any significant discrepancies in etiology or approved medications between the United States guidelines and in Japanese guidelines. And also, important thing is these translation teams and subspecialty commentators were all volunteers. And these are, for their credentials, the Public Relationship Committee members who proofread the translated article, Group A, Group B, Group C. The roadmap was built by Dr. Oshima, the chairperson of PRC, and we couldn't have completed this project without Dr. Oshima's significant IT support. And there was also a dedicated team called Quality Control, which was led by Dr. Yoshino. And the Quality Control team has done meticulous, detailed job of successive checks of the articles to make sure that there are no typos and could cause any misunderstandings. We picked out terminology and double-checked them with the Japanese Society guidelines as well. We often went back to the citation of the original article to have more accurate translation. This is the product and the most exciting part. You go to the In the Clinic web page. This is the original article, and you see right here it says also Japanese version, and if you click here that will bring to the page. And if you click this PDF, it's our translated article is posted on the Annals of Internal Medicine page. Our translated article is here. we'd like to make this project like a hub airport or the real community for young aspiring general internists and hospitalists throughout Japan. And including this in the clinic translation project, the ACP Japan chapter's activity was recognized and we received Evergreen Award in 2019. And in the clinic translation project is currently up and running. And what I am most proud of is that this project is thriving after I retired from PRC chairperson to move on to the current position of SPC chairperson, Scientific Program Committee chairperson. This project gives early career physicians to be a leader in a project. And also this gives the opportunity for community hospital-based physicians who are not located in university-affiliated positions to have a lifelong opportunity to be involved with some academic activity. And we just did not want to be satisfied by completing the translation. We'd like to make this project as an opportunity or stepping stone for young internists throughout Japan to feel comfortable and confident that they can reach these resources throughout their career as continuing medical education. And based on this, in the clinic resources, we continue to do workshop, what we call bedside 5-minute teaching workshop at our ACP annual Japan chapter meeting. It's kind of like digestible teaching. The whole article is, of course, a great resources, but for early career physicians, they may not be able to utilize what they have learned, what they have read. I like the saying of nothing is particularly hard if you divide it into small jobs. And let's say regarding hepatitis C virus. This is the summary, the 5-minute bedside teaching material that I made. And these are the take-home messages. And we make take-home messages, what we call 5-minute bedside teaching, summarized like this. So the contents are like somebody who has hepatitis C virus positive, what we know as a primary care physician or hospitalist or general intern GIM clinic physicians. There are important things we should know, we should go through. First, of course, recommend the patient to stop alcohol completely and vaccinate. And if the patient is hepatitis C virus positive but hepatitis B virus negative, then he or she should be vaccinated for hepatitis B. And if the patient has already developed liver cirrhosis, then pneumococcal vaccination is recommended. And also annual influenza vaccination is recommended. If the patient has already developed liver cirrhosis, screening for varices with upper GI endoscopy annually. And if already liver cirrhosis, the patient should undergo hepatocellular carcinoma screening every 3 to 6 months with some kind of imaging, either ultrasound or contrast CT. And it is important that the physicians know and let the patients know that even by achieving SVR, sustained virological response, hepatic fibrosis may improve to some extent, but not back to baseline. Your liver does not recover to as the normal people. And the patient needs to have lifelong hepatocellular carcinoma screening. And this is another example of 5-minute bedside teaching material, and this is regarding aortic stenosis. So what we primary care physicians should know is there are two types of aortic stenosis. The first is more common one, senile calcified aortic stenosis, and the second one is this occurs in younger population with congenital bicuspid aortic valve. And it is important that we know this category, the second category, so that we can detect AS in younger population earlier. And AS symptoms can be memorized as ASD. I call it AS death. And A is angina, and S is syncope or presyncope, and D is dyspnea. And the prognosis without treatment or intervention are 5, 3, 2 years respectively. And it is important to memorize the gestalt of aortic stenosis so that we can recognize if somebody with aortic stenosis comes to our clinic. Slow and small pulse and systolic murmur at the right upper sternal border, and signs and symptoms are like this ASD. And EKG pattern is, LVH pattern. And these are another example. I apologize that I did not have time to translate everything into English, but I made these handouts, total of 30 topics for the workshop, and they were very appreciated by the workshop participants. And I believe that this has led to increase of the membership of the ACP Japan chapter to some extent. The field, these are another example, and the field we need to cover as a generalist, either as an emergency physician or hospitalist like me, or primary care physician or GIM clinic physicians, is the field is quite broad, and the medicine and the guidelines change often. And it is quite difficult to catch up with the latest after you finish your residency. And ACP is playing an important role in continuing medical education for generalists, and I am proud that ACP Japan chapter is doing that very effectively as well. And I'm delighted that ACP Indian chapter and Japanese chapter are developing interaction by inviting lecturers from each other's chapter. It was our honor to have Dr. Maheshwari and Dr. Muruganathan from Indian chapter to speak at our ACP Japan chapter meeting in June 2022, and also Dr. Ahasan from ACP Bangladesh chapter. We would like to continue this strong academic network of ACP in Asian region. Thank you very much for having me to talk here today.
Thank you, Dr. Yuka Kitano, to give a glimpse on the various aspects in the clinical setting. Now, I would like to invite Dr. Tonu Yamada. He gave the focus on for the internist with the multiple images and the movies on the particular emphasis on focus, that is the point of time ultrasound. And it is a new concept when we perform the ultrasound, when the patient is distant enough and is not in ICU or in the clinical emergencies, and we find out the various aspects of the diseases right beside the bed, and in the ambulance is a very distant aspect, and we can gain a very informative role within a few matter of time to have a better images, have a better quality of management, and that will help in a good prognosis and the recovery of the patient. So over to Dr. Toru Yamada on his very interesting topic of POCUS.
You can't the question, we were not able to, who will ask the question?
Hello everyone, I'm Toru Yamada. I've already sent my presentation to your secretary, so Department of General Medicine, Tokyo Medical and Dental University. Today, I'm going to present on shock assessment by POCUS. Thank you very much for your attention. Disclosures is as shown.
We can't see here, so I can't concentrate.
The concept of POCUS is simplicity. POCUS is an ultrasonography as an extension of the physical exams. That is like stethoscope. Limiting the number of evaluation items and clarifying evaluation criteria are key points of POCUS. It's to reduce learning difficulty and maintain test quality. There are a few things to keep in my mind when doing POCUS. POCUS is one of the findings and it's not a definitive test. It's important to use combined with history and physical examinations. If the POCUS findings clearly differ from the diagnosis based on the history and physical examinations, consider additional other tests. There is no need to stick with POCUS findings. POCUS is distinguished from comprehensive ultrasonography. It's a method for screening at the bedside. Today, we have only 20 minutes, so I'm going to omit the details of the method of each domains. For example, focus, lung, DVT ultrasound, and abdominal ultrasound. The objective of this lecture is to get one idea of how POCUS is used in shock assessment. When we do shock assessment by POCUS, we usually use following four domains: focus, lung ultrasound, vascular ultrasound of lower extremities, and abdominal ultrasound. We can shorten time and increase certainty of shock assessment by using POCUS. This is a checklist for each domain in the shock assessment. As for focus, we check LV contractility, RV enlargement, IVC diameter, and pericardial fluid. For lung, A-line, B-line, lung sliding, and pleural fluid. In some cases, C-profile, pneumonia may be checked. For vascular ultrasound, we check the DVT of lower extremities to check the risk of pulmonary embolism. For abdomen, mainly screening for causes of septic shock or hypovolemic shock. For example, AAA rupture, cholecystitis, CVD dilatation as a collateral for cholangitis, hydronephrosis, bladder distension as a collateral for obstructive UTI, and unsuspected ascites, etc. This figure shows the four taxonomies of shock assessment. First, we evaluate for cardiogenic and obstructive shock. The reasons are that the treatments are very different and they are more urgent. Next, we evaluate hypovolemic shock and distributive shock. These conditions are absolute or relative intravascular volume loss. Of course, if the cause of the shock is obvious, treat the cause regardless of this flow. Now, I will start with an assessment of tension pneumothorax that is included in obstructive category. The diagnosis of tension pneumothorax is shock and hypoxia and risk factors and physical exams. Risk factors include, for example, a history of trauma, ventilator, etc. Basically, if the vital signs are unstable, we should promptly do thoracentesis without imaging test for diagnosis. If we can do a quick ultrasonography, checking lung sliding help you to perform thoracentesis more confidently. If lung sliding is positive, we can rule out pneumothorax. If lung sliding is absent, pneumothorax or other abnormal conditions are present. Tension pneumothorax has no lung sliding. These are the lung ultrasonography movies. Left side is lung sliding positive. Right side is lung sliding negative. This case is pneumothorax. Next, I will show an assessment of cardiac tamponade in obstructive category. Pericardial fluid is measured at the depth where it accumulates the most. The appropriate view to be measured is plaques, if spine. Depth gives an estimate of the amount of pericardial fluid, like this table. The point is that a large amount of pericardial fluid is not necessarily a cardiac tamponade. Even a small amount of pericardial fluid can cause cardiac tamponade if it accumulates rapidly. And a large amount of fluid may not cause cardiac tamponade if it accumulates slowly. It is important not to rule out the possibility of cardiac tamponade if there is even a small amount of pericardial fluid. When the shock case with a history that should not have pericardial fluid. Pericardial fluid is sometimes difficult to distinguish from pleural fluid. The first step in distinguishing it is to identify the descending aorta in a plaques view. The fluid that close to the heart side from the descending aorta is pericardial fluid, and the fluid that leaves the heart side is pleural fluid. This is subcostal four-chamber view. This view has high sensitivity to pericardial fluid. It is also important that this view is easy to acquire. Next, I will show an assessment of pulmonary embolism in obstructive category. As for pulmonary embolism, we check focus, vascular of lower extremities, and lung. Check for IVC tension and RV extension by focus. Vascular ultrasound, rule out the DVT by compression test. I will show you about compression test later. Normal pattern of lung ultrasound, A profile of blue protocols and hypoxia is one of the characters of pulmonary embolism. Focus allows rapid screening before contrast-enhanced CAT scan. These three views are Prax, Sachs, and apical four-chamber view. All of them are from the same pulmonary embolism case. As you may have noticed, the RV dilatation is not clear in Prax. In Sachs and apical four-chamber view, RV is enlarged beyond the LV. Only part of the RV is observed at Prax. So RV dilatation should not be excluded even if the RV is not dilated by Prax. Compression test is an easy method to evaluate DVT. A linear probe is used to compress veins of 5 regions from the site to popliteal fossa. If the veins completely collapsed by compression test, there is no DVT. DVT evaluation with focus is limited to the site to popliteal fossa, as thrombus below the knee are not a risk for pulmonary embolism. Arteries and veins are differentiated by shape, size, wall thickness, pulse, and compression test. In a typical case, there is no doubt. But if you are not sure about the distinction between arteries and veins, check these 5 findings. These are the movie of compression test. Left side is thrombus negative. Vein is completely collapsed by compression. Right side is thrombus positive. Note that new clots may not be clearly visible on ultrasonography. Compared to color Doppler and pulse Doppler ultrasonography, diagnostic accuracy of compression test is equivalent. Next is cardiogenic shock assessment by focus. Cardiogenic shock can be easily evaluated in 3 categories: myocardial, valve, and heart rate. Cardiac output consists of stroke volume and heart rate. Heart rate is checked by ECG monitor. You checked myocardial abnormality and valve abnormality by focus. As for valve, focus does not evaluate valve details. Only a gross evaluation is performed. As for myocardial abnormality, you evaluate contractility on a 4-point scale. Ejection fraction is not measured by focus. This is a method to evaluate contractility. There are 3 checkpoints. First is endocardial excursion. All endocardium uniformly contracted inward. Second is myocardial thickening. Myocardium thickened more than 40% in systole. Third is septal motion of anterior leaflet of mitral valve. It gets closer to septum until less than 1 cm in diastole. Ejection fraction is not measured by focus. LV contractility is evaluated by the presence of these 3 points. If these 3 points are present, contractility is normal. If these 3 points plus LV wall kissing in systole, it's called hyperdynamic. If any of 3 is absent, it's called reduced. Severely reduced is less than reduced. The boundary between reduced and severely reduced is approximately 30% in EF. This method is used in Planck's view. How about the contractility of this case? First, all endocardium uniformly contracted inward. Second, myocardium thickened more than 40% in systole. Third, anterior leaflet of mitral valve gets closer to septum until less than 1 cm in diastole. So this case is normal contractility. How about this case? First, endocardial excursion, negative. Second, myocardial thickening over 40%, negative. Third, anterior leaflet of mitral valve does not get closer to septum until less than 1 cm. So this case is severely reduced. There are several methods of lung ultrasonography, such as 3, 4, or 6 points to be scanned for one lung. But all of them are not so much different, so any of them will do. In this time, we will introduce the 4-point method. The 4 locations are second intercostal mid-clavicular line, fifth intercostal anterior axillary line, eighth and ninth intercostal mid-axillary line. It's above the diaphragm, and the dorsal side of the same intercostal space. The important thing is to evaluate the entire lung by sliding headward or caudally, not just at the location. The probe can be linear or sector. Pleural edema is assessed by the presence of B-line. The B-line is an artifact seen in fluid retention or inflammation. It's called ring-down artifact. 3 or more B-lines in a single intercostal space is called multiple B-lines, a finding that suggests fluid retention in the alveoli. Bilateral diffuse B-lines plus lung sliding has high sensitivity and specificity for pulmonary edema. The sensitivity is 97% and the specificity is 95%. Last part is distributive and hypovolemic shock. Area pressure can be estimated by IBC diameter and the rate of change of IBC diameter by sniffing. The table shows the estimated area pressure. The most useful part of this table is that if the IBC has collapsed, there is an intravascular volume loss. For other findings, area pressure can be estimated, but it is important to note that area pressure does not equal intravascular volume. Focus is somewhat useful in screening the cause of shock. For example, unexpected or cloudy ascites suggests intra-abdominal infection or vascular injury. The presence of an abdominal aortic aneurysm can be easily assessed by focus. Focus should be used as a screening tool, and additional tests should be considered. These are take-home messages. Thank you very much for your attention.
So are the learned speakers available for any questions?
Okay, you can ask one question.
I think by our time we'll wish you good afternoon. And this one is for Dr. Yamada. Thank you for that very elegant presentation. It taught us a couple of new things. Now, I would like to humbly ask you about what are your comments on use of POCUS during gestation and while assessing skeletal-muscular disorders.
Excuse me, I couldn't catch well. Dr. Kitano, could you catch it?
Can I repeat?
Well, it looks like the connection is not so good. What I could understand so far is you wanted to ask Dr. Yamada regarding what's the focus use in musculoskeletal disease and one is digestive disease.
No, gestational, during pregnancy.
During pregnancy,
Yeah.
okay. So question was how to use ultrasound during pregnancy and also in musculoskeletal disease.
Okay, it's a good question, but I'm a hospitalist and my subspecialty is gastroenterology, so one of my colleagues use POCUS for musculoskeletal disease, but I don't know where. Sorry.
And that's fine.
Let me add a little bit. And Dr. Yamada is one of the directors of POCUS course, and I am one of the two associated directors of that course. And we mainly focus on the cardiac ultrasound and lung ultrasound and DVT detection and diagnosing in acute setting like kidney evaluation and gallbladder. And our course do not cover pregnancy and musculoskeletal disease. But that is also a very important field, I think.
Yes, because there is a lot of literature covering this aspect of use of POCUS, you see. Now, I think a small comment for your brilliant talk, which honestly we could not comprehend completely because it was most of the time in Japanese language. But your clinic translation project, I think as I tried to Google and find out, one of your last meetings described on the internet was in June 2018, that 5-minute bedside training and some 12 rules to be followed. Am I correct?
So we do annual meeting, ACP Japan chapter annual meeting, and we do 5-minute bedside teaching workshop annually. And also, what I could not share in my presentation was that we are proud that we have annual meeting of the ACP Japan chapter, but beside that, I could not introduce today in my presentation, but there's a committee called the Residency Fellowship Committee that is a committee committee composed of early career physician, and they do regular workshop of mix-up questions and career development. And I think we are thriving to function as a role model of clinical educator track. I think in Japan, clinical researcher track is well developed in medical school, but there is not good organization or role model of clinical educator track. So ACP Japan chapter is functioning that role.
Thank you, Yuka Kitano and Toru Yamada from ACP Japan and interacting with us in ACP India chapter. We will all of you give a big hand.
Big round of applause.
Big round of applause.
Thank you very much for
Thank
having
you.
us. And
We
please tell
hope to-
Dr. Maheshwari that we are delighted to be invited to your session.
Yeah. We hope you are here in the next year ACP or something in person, because whatever it is virtual, in person is in person. Thank you for giving us an opportunity to listen to you from online, and it was a wonderful listening to you, both of you.
Thank you, Dr. Yuka Kitano and Dr. Toru Yamada. It was such a wonderful talk, and we all learned a lot from this very informative talk, and we hope in future to continue these interactions and so many newer hopes and newer interaction, the knowledge in your field work. Thanks a lot. Thank you.
Thank you very much.
Thank you very much.
Thank you.
The chairpersons, and thank you, Dr. Bharat Gupta sir, as well for joining us. We've had a wonderful session by some really good speakers, Dr. Ashish, Dr. Kitano, and Dr. Yamada. For the next session, can I request our moderator, Dr. Shivam Verma sir? All right. Okay, so we have him here. So Dr. Shivam will take up the proceedings further. Thank you.
Very good afternoon to everybody. So first I would like to invite Dr. Srinivasan, MBBS MD and physician in Lanka Hospital, Colombo. Please sir, come on dais. And Dr. NK Soni, MD, FRCP, FACP, Senior Consultant, Head of Department, Head of Internal Medicine, and he is great renowned practitioner in Greater Noida. Thank you.
Okay, no, we'll do that. It's a nice meeting, isn't it?
Well, good afternoon, friends. After this virtual meeting, virtual talk, we are coming back to the physical talks here. And in this session, we are having two very important topics to be discussed. And the first topic, the two speakers are Dr. Akash Sheel Bhattacharya and Dr. Ashish Dhingra. The first talk is on very important topic, I feel, is the extra pulmonary tuberculosis. It is not a diabetes and management, rather it is a diagnosis and management which should be there. So I would like to invite first Dr. Akash Sheel Bhattacharya for his deliberation on extrapulmonary tuberculosis, diagnosis and management. Dr. Akash Sheel, please. Can we have his introductory slide? Next you will be elected in Manila. Yes, invite. Yes, but they are in the yes. Dr. Akash Sheel Bhattacharya, he is DM in infectious diseases, MD in microbiology. He is a consultant in infectious diseases and microbiology in Paras Hospital, Gurgaon. He is just my neighbor. I am coming from Greater Noida. He is in Gurgaon. He is the lead author for the first research paper on the efficacy of COVID vaccines in India. He has written many book chapters. He is the co-researcher in ongoing research in on novel hypothesis on pathogenesis of COVID-19 associated mucormycosis, which is a very, very important and the recent topic of the interest of most of us, and use of nasal swab RT-PCR for screening of mucormycosis. Very interesting, and we would be keen to know the results. But anyway, before wasting much of our time, I would like to invite Dr. Bhattacharya for his deliberation. Dr. Akash, your stage.
Thank you, sir. Thank you, everyone. So, I was in contact with Dr. Anuj, and he asked me to suggest a topic. So, I thought it would be a very important topic to bring in, as we know that extrapulmonary tuberculosis, it is most of the times there is a diagnostic dilemma. True. And we don't have any standardized global guidelines for this. So, my name is Dr. Akash Bhattacharya. I did my DMA in infectious diseases from AIMS, New Delhi. And currently I am working in Paras hospitals in Goa. So, I will be discussing on the broad meanings, CNS TB, lymph node TB, pleural pericardial TB, as you know. So, each of the topic, it can be dedicated 1 hour for each of the topics. So it will be just an overview, and I will highlight important points and important updates on this. So there is only a single extrapulmonary TB guidelines all over the world. That is the index TB guidelines. It was published in 2016, and it was published from the All India Institute, New Delhi, in collaboration with WHO. And we are still awaiting an update to this document. So if you see this document, in most of the cases you will find that the guidelines are very sketchy. So the reason being, there is a very, very big lack of evidence in extrapulmonary tuberculosis. Not even in India, not even from developing countries, it is also from the developed world. So to formulate a guideline, we need to have a great and good amount of review literature, like systematic reviews, meta-analysis, which is very lacking in this field. So the first topic is CNS tuberculosis. That is, you know, that it might be tubercular meningitis, tuberculoma, cerebritis, cerebral abscess, and tubercular radiculomyelitis. So my focus would be in the salient points on diagnosis and management. So in CNS TB, so if it is tubercular meningitis, we know that any tubercular process, it is a subacute chronic process. But oftentimes we see patients presenting in the emergency with altered sensorium fever with a short history, 3 to 4 days, and you are finding that gene expert is coming to be positive. So not in all cases, in acute cases like acute benign meningitis, you have to have the suspicion of tuberculosis. In most of the cases we find that the focus is lung, and it is a secondary dissemination to the CNS, which has led to tubercular meningitis in those patients. So we have to be very watchful that even in acute conditions, you should suspect TB in countries like India. So other features like altered sensorium, fever, vomiting, meningeal signs of increased ICP, it will be there. So I'm in CNS tuberculosis. Radiology is it plays a very pivotal role. Firstly, in diagnosis. So any imaging, you should have, it should be a contrast enhanced imaging. as you have to look for basal exudates and you have to look for meningeal enhancements. Without contrast studies, you will not be able to find out these things. So these are typical brain imaging, contrast imaging of tubercular meningitis. It is showing basal exudates. Along with brain, in case of TB meningitis, you have to have a screening MRI for spine. I will come to that, why you should have. And apart from CT, apart from the diagnostic purpose, you have to have a brain imaging in hand to decide for the lumbar puncture. As in case of obstructive hydrocephalus, high ICP, you have to postpone it. You have to postpone your lumbar puncture in case of high intracranial pressure, and you have to go for other indication for peritoneal shunting, like AP shunt or your ventriculostomy. So radiology plays a very important role whenever you are suspecting CNS tuberculosis. So next, coming to CSF analysis. When you are safe, you see that you are able to perform CSF lumbar puncture. So in most of the cases it is lymphocytic predominance in CSF. But in many cases it has been seen that in early CNS meningitis by TB, early CNS tubercular meningitis, it is the neutrophilic predominance. So that neutrophilic predominance often mislead us to rule out tuberculosis. But in most of the early cases of tubercular meningitis, it is neutrophilic predominance in CSF. In biochemistry, it is high, it is high protein. Often it presents with very high protein in CSF and with normally low sugar. Now, it is the adenosine deaminase. In my subsequent slides, I will also show that this adenosine deaminase levels, it has got a significant value in identifying and in suspecting tuberculosis in the extrapulmonary region. In CSF, it is from a very big meta-analysis. We can say that if you take the cutoff of 9 or 10, it has a very good sensitivity. I am comparing the sensitivity with, of course, with TB culture, that is a gold standard. So the sensitivity comes to 79% with a high specificity of 91%. So whenever there is a diagnostic dilemma, so you have to get an additional clue from the CSF ADL level. So next is the microbiological tests. So in any case of tuberculosis, be it pulmonary and be it extrapulmonary, it is a routine and it is in the guideline now. You have to have a microbiological diagnosis. This is mainly for two reasons. One, it confirms your diagnosis, it establishes your diagnosis, and secondly, you have to obtain some information regarding drug resistance. So in the microbiological tests, xenin staining, and apart from culture, gene expert is widely available, but it gives you the resistance pattern for rifampicin only. So it is advisable for all samples to be tested for TB. You have to request for a culture, preferably a liquid culture by the MGIT system, that is the Mycobacteria Growth Indicator tube. This is a backtech system, just like blood culture backtech. They have 96 small tubes which provides a very good growth condition for Mycobacterium tuberculosis and for other atypical mycobacteria also. So it is a very confirmatory test, and compared to conventional LJ media culture, it gives a much better culture positivity rate. So whenever you are able to grow the bacteria in culture, so it becomes easy to identify the drug resistant pattern, either by conventional drug susceptibility tests, but in the national guidelines in India and worldwide, it is almost the same that everyone is suggesting to go for blind probe assay. It is a very simple test and can be done as a point of care test also. So depending on the bands formed for each drug, you can say that for isoniazid, rifampicin, ethambutol, pyrazinamide, for first line and for the second line NP are also available. So you can test for each and every drug you are giving to your patients. So if it is gene expert positive and rifampicin sensitive, you do not know the sensitivity pattern of other three drugs you are using. So it is always advisable to make your efforts to the fullest to grow the bacteria in culture so that you can get a full spectrum of the sensitivity pattern of the strain. So in the treatment, so it is the conventional regimen plus dexamethasone. So there are multiple school of thoughts. So people have come up with ideas, and it is still to be established, still to be circulated in guidelines, but it is well established that in case of CNS TB, ethambutol you can avoid for low CSF concentration. See, in early CNS tuberculosis, CNS TB meningitis, there is disruption of blood-brain barrier, so any drug can penetrate, even streptomycin will penetrate. So ethambutol will also penetrate. But considering a long course of the treatment, when there is the damage has been taken care of and blood-brain barrier is intact, ethambutol will not reach CNS to have a good penetration. So, and also the ocular toxicity, and in case of CNS meningitis, CNS tuberculosis, you know there is cranial nerve involvement. So you would really try to avoid another drug which can cause ocular toxicity. So the eligible alternatives to ethambutol are linezolid and levofloxacin. And in most of the good centers in India and in all over the world, people are not using. It is an expert opinion that you can omit ethambutol and you can add levofloxacin or linezolid to the HRZ regimen. So what are the complications? The complications are like vasculitic stroke. So in many cases of tubercular meningitis, you see there are ischemic areas, ischemic stroke happening. So is there any point to treat that ischemic stroke? Yes. There are very good amount of data that is saying that either low dose or high dose aspirin you can give to prevent the progression of this ischemic stroke, that is a vasculitic stroke in case of tubercular meningitis. The second and the most dreaded thing is the hydrocephalus. The very high number of cases in CNS TB, we see there is obstructive hydrocephalus. So the key to management is the early identification by imaging and sending the patient to the specialist, neurosurgeons for neurosurgeons for either revision or endoscopic third ventriculostomy. And next is vision loss. Though very rarely reported, but it has a very high incidence. The high output, high admission centers have reported a very incidence of optochiasmatic arachnoiditis in cases of tubercular meningitis. So I'm coming to it. And a rare complication that is transverse myelitis. It has been written in traditional literature as a rare complication, but in a recent study it has been found that these complications are really not very rare. They are rarely detected or diagnosed. So what is optochiasmatic arachnoiditis? That you are treating a patient with CNS tuberculosis, tubercular meningitis, and patient is complaining of bilateral vision loss, which is subacute in onset. So in this case, vision loss is almost found in 14 to 35% of cases. So you have to suspect, and you have to go for a contrast MRI to find you can see in the radiology that optic chiasma there is exudates and enhancements. So the treatment is early detection and pulse steroids. Many people have tried thalidomide. Even I have my experience with thalidomide. It acts very well in this case. And apart from this, neurosurgical decompression that you can think of going for a vision if you suspect that the vision loss might be due to high intracranial pressure in case of optochiasmatic arachnoiditis. So transverse myelitis is TB. So traditionally it was taught to us that it is a rare cause of transverse myelitis. But in a recent paper and in recent literature, it has been increasingly reported. So it is mostly in TB, it is in CNS TB, it is longitudinally extensive transverse myelitis, which we call AVT in neurology. So there is the importance is there to have an MRI spine whenever you are suspecting CNS tuberculosis. It presents with quadriparesis. Either it may be paraparesis with bilateral involvement. The risk factor for developing transverse myelitis in TB is the very severe disease in presentation and high CSF protein. So if you ask me the treatment for transverse myelitis, that is not well delineated in literature, but we prefer to go for pulse steroids to treat transverse myelitis in TB. So my next topic, that is the lymph node TB. It might be superficial or deep. So I'm highlighting the important points that in case of lymphadenopathy, when you suspect tuberculosis, apart from the constitutional signs, so TB lymphadenitis, it often goes like in a waxing and waning pattern. The patient says, I had some lymph nodes and then it was painful, but it subsided, but I am still losing weight. So this is the exact scenario when you should suspect TB lymphadenitis. And if examination, if you find matted lymph nodes or lymph node abscesses or sinuses, then the suspicion is very high for tubercular lymphadenitis. Important point to mention that in case of cervical lymph node, it is more than 1 centimeter, and in case of inguinal lymph node, it is more than 2 centimeter to call the lymph nodes significant. So in diagnosis, apart from routine imaging, CT, thorax and abdomen is very good adjunct, very good test to perform to find out any lymphadenopathy. And if you are finding necrotic nodes, so the diagnosis of TB is very high in presence of constitutional symptoms. So sampling. So FNAC and biopsy. So we often prefer FNAC, but biopsy should be preferred over FNAC. In many studies, it has been proven that to find out tubercular granuloma, biopsy is much better and it is much sensitive than FNAC. So whenever you are targeting a lymph node, either going for an FNAC, it firstly distorts the architecture of the lymph node. If you go for further biopsies, so it is better to take out the lymph node either surgically or you can get a true cut biopsy done. So in case of deep-seated lymph nodes, the imaging guided like USG or CT guided lymph node, and in case of peribronchial lymph node, you can go for EBUS. So in extrapulmonary tuberculosis, as it involves different body systems, you can see that the referral to the experts, refer to the specialists. At times, that is a call you have to take. That you have to refer a patient to pulmonologist to get a bronchoscopy and EBUS done to get a biopsy from a peribronchial lymph node. So these are typical tubercular mediastinal lymphadenopathy, and you are seeing heterogeneous enhancement showing necrotic lymph nodes. So this is a typical histopathology where you can find KZAD or non-KZAD granulomatosis. You can find positive AFB stain from histopathology and Langerhans giant cell necrosis. These are typical findings of lymph node tuberculosis. And whenever you are sampling a tissue and you are sending it for microbiological tests, it should be kept in mind that it should be sent in normal saline. So formalin treated samples, it will neither grow the bacteria nor it can be processed for a polymerase chain reaction, that is PCR. So for gene expert culture and microbiological test, you have to send the tissue in normal saline. So it is a standard treatment for lymph node tuberculosis, 2 months intensive phase and 4 months continuation phase. But I'm giving a case scenario that 25 years male who presents with mediastinal lymphadenopathy completed 6 months of treatment, but there is persistence of lymph nodes in your imaging. So what should you do? Or clinically there is persistence of lymph nodes. So if there is no persistence of symptoms, that there is resolution of symptoms, and no interval change in imaging or clinically for 4 months, so you can safely discontinue ATT if that person has completed 6 months of full course. So there is no need to continue ATT for longer as the lymph nodes are persisting. In most of the cases, these are scarred lymph nodes, and AFB, the bacteria is not viable inside. This is a second scenario that you have started ATT after microbiologically confirmed cervical lymph node TB. After initial improvement, there is pain and rapid enlargement of nodes after 4 weeks of ATT. And you are finding this type of a lesion. So this is IRIS, that is immune reconstitutional inflammatory syndrome, or we call it paradoxical syndrome. So when you suspect IRIS or paradoxical phenomenon, so there is no need to discontinuity. So you do not think that patient is not cured or there is a failure to therapy if there is initial improvement. So you always suspect it's a paradoxical reaction. You just assure the patient and you give some anesthetics for pain. If there is an abscess, you can aspirate it. So this is a very common phenomenon, that is a paradoxical reaction which occurs 3 weeks to 4 months when the patient is on ATT. It can be present, it is in all cases of APTB, this paradoxical reaction can happen. So briefly about pleural and pericardial TB, that pleural biopsy samples you can take. So pleural fluid ADA, the cutoff here is 40. So it has a high negative likelihood ratio. So in case of negative ADA, that is a cutoff, that is a below 40 level of ADA in pleural fluid, you can safely rule out, I won't say safely, you can rule out pleural tuberculosis. It has a very good sensitivity and specificity. And these are the other tests. And in case of pericardial effusion, you always have pericarditis, you always have to go for echocardiography to find out if there is any tamponade, which needs urgent attention. The treatment is the same. So for pericardial TB, there is a role of steroids. So it prevents the conversion to constrictive pericarditis and prevents cardiac tamponade. So surgical options, you can go for surgical pericardectomy in case of constrictive pericarditis due to TB. So in gastrointestinal TB, it is peritoneal TB, intestinal TB, hepatobiliary TB, pancreatic TB, there is a long list of things. But the important thing is, whenever you are suspecting GI TB, if it is tubercular peritonitis, in most of the cases it is easier to diagnose. But if it is intestinal TB, patients roam around for months, for years with constitutional symptoms and many things, and you are not finding it in colonoscopy, in CT enterography. So there should be a high threshold of suspicion for this intestinal tuberculosis. And you can also go for therapeutic trials of ADT in case of GIT. So CECT with CT enterography is very sensitive to detect idiopsychical involvement. Apart from this colonoscopy and biopsy and laparoscopy, and even you have to go for laparoscopy to take some biopsies in case of tubercular GIT. So in case of ADA, the cutoff is 39 in peritoneal fluid, that is the ascitic fluid. So it has a high positive likelihood ratio. It is more than 39, so you can say it might be GIT. So I am coming to urinary tuberculosis, that mainly urinary TB, male genital TB and female genital TB. The thing is that in case of urogenital TB, you have to be very watchful that patient that is not progressing to hydronephrosis. There is a normal size TB in urogenital TB which can lead to hydronephrosis. So whenever you are suspecting hydronephrosis in urogenital TB, you have to refer the patient to a urologist for interventions. In male and female genital TB, it can causes fertility and sexual dysfunction. So the diagnosis, it is mainly imaging and biopsy, and in case of urogenital TB, CECT with CT urography. This should be the standard approach for to diagnose urogenital tuberculosis. So the treatment is the same here, and the last one is the skeletal TB. So whenever there is prolonged back pain, local tenderness, constitutional symptoms, you should go for a good imaging, contrast enhanced imaging, apart from the synovial fluid and bone or tissue biopsies. So I have come to the end of this presentation. I just want to show why it is very difficult to identify EPTB even by the molecular methods. So the fluids, body fluids, peritoneal, pericardial, and pleural fluids. So the sensitivity of gene expert is very low. But whenever you are going to tissues like synovial fluid, bone and joint, so it is very high. So whenever there is local sparse, you can take out a bone, a piece of bone, a lymph node, TB. So you should target for that biopsies and to go for a gene expert, which can give you a diagnosis. So this is the last scenario. That was the same thing, that there is a paradoxical reaction, and we have to be more careful in case of HIV. We oftentimes misses the cervical lymph nodes. When patient comes with us with HIV, we start straight away for antiretroviral therapy. So this iris happens very badly in case of HIV positive patients. So it can be missed by the routine investigation, cervical lymph nodes, but it can only be detected by your clinical examination. So that is the theme to this conference, that we have to be back to our basics, that we should not miss any lymph node, any structure, if we want to be very watchful for TPP. So this is the take-home messages for this presentation, and thank you all for your kind attention.
Thank you very much, Dr. Bhattacharya, for giving us the details of extrapulmonary tuberculosis diagnosis and management, which I think is a very, very important topic for the clinicians to practice. If there is any question, one or two. Okay, let me put the ball rolling. That as you said, that in CNS infection, tubercular infection, after these drugs, ethambutol, we should avoid, as far as the ocular complications are concerned. Levofloxacin can be used. But then levofloxacin, fluoroquinolones, usually these have also got little complications as far as elderly patients are concerned. Once they are having a little altered sensorium or meningitis, the features of meningitis, how much do you prefer levofloxacins to be added as anti-tubercular drug in those elderly patients altogether?
Yes, sir. In tubercular meningitis, there is always a fear for seizure when we are discharging that patient home. So, if you think that you don't have any other options but to continue with ethambutol, so you can go for it. But in most of the studies, they are using levofloxacin safely and even linezolid, levofloxacin or linezolid. So linezolid might be a better option, but it has also associated with optic atrophy and pancytopenia. So there is the therapeutic dilemma is always there. Many people they directly go to the second line drugs. They give isonamide.
Those are better choice. Yes, it's a mixing and matching, and then it's an art of the medicine which you have to practice. But then, is there any role, any importance of TB interferon test to be performed in any of the patients for the extrapulmonary tuberculosis for the diagnosis?
Sir, two tests. One is that is a traditional tuberculin test, that is a marker, and TB interferon, that is a quantiferon gold. So in high prevalent settings like in India, where the incidence of TB is so high, these tests should not be used as an adjunct to diagnosis. In diagnosis of tuberculosis, these are not at all reliable. So these tests have only value in identifying latent tuberculosis. So whenever you are planning to start any immunosuppressive therapy and prolonged steroids, so you want to rule out and treat. If it is latent tuberculosis, the protocol is treat latent TB and then start the immunosuppressive therapies. So these two tests, quantiferon TB and tuberculin skin tests, these should be used in identification of latent TB.
Would you mind just giving 2 lines regarding mycolic acid assays in TB diagnosis?
Is that mycolic acid?
Assay in TB diagnosis.
Mycolic acid.
Are we still doing it? Because it's very specific for TB.
It is very specific, but sir, the issue comes with the sensitivity. Like urinary lipoarabinomannan, urinary LAM, that is a test that is in place for I think 10-15 years. But we do not prefer these tests for routine use due to the lack of sensitivity, actually.
And dark field microscopy? Are we still doing it?
Sir, it is for actually spirochetes. So in acid first bacilli, it is only resistant.
Okay, thank you very much. Yes, one more question. Yes.
One thing I would like to add on, Dr. Bhattacharya,
yes,
that you have told that for the management of the hydrocephalus, it is the BP shunt which we use, but most of the time we physicians, we use only the steroids and we add on to acetazolamide in our practice. We are not going unless otherwise there are complications and we find severe hydrocephalus, only then we refer to the neurosurgeons for this BP shunt. So the choice of treatment for we physicians are steroids plus combination of this Diamox or acetazolamide. Second thing is that you have told about the use of thalidomide, but hardly we practitioners are using thalidomide, since we read during the pharmacology days that thalidomide tragedy, that seal limb. So I don't think it is so frequently available and we are using it.
I mentioned it in case of optochiasmatic arachnoiditis,
Yeah.
when there is vision loss.
Ethionamide rather we prefer sometimes.
Ethionamide is different.
Yes.
Now, what I am
rather
talking
than
of thalidomide. Thalidomide he has told.
Yes, PAS and ethionamide are usually the drugs which we go
Ethionamide,
for rather than.
pyrazinamide and
Yes.
say isonex, they are along with levofloxacin or moxifloxacin.
Even-
That is for the resistance.
Even
tuberculosis.
if renal functions are normal, initially at least for 2 months, 3 months, till there is a meningeal inflammation, at least streptomycin has got a good penetration.
Yes,
there.
yes, very good. I do
Yes.
agree with it. And one thing more I would like to ask you, that what is the role of this tuberculin test in these patients which are non-specific, having symptoms of tuberculosis, but the other test they are negative. So Mantoux test.
Sir, in case of, it is very clear that in case of high prevalent settings like in India, this skin tests, that is a delayed type of hypersensitivity test.
Yes.
So these tests has no role in diagnosis of tuberculosis.
True. With endemicity, with you have received the BCG vaccination. Usually it has lost the as far as diagnosis.
Pointed out that in case of BCG vaccinated patients, so if you compare tuberculin skin test and quantiferon gold, so TST will be falsely positive in BCG vaccinated patients. So even in case of latent TB, you should go for that quantiferon assay.
Right.
Yeah.
Thank you very much. We would like to close the session here and would like to invite the next speaker. My co-chairperson will. Thank you very much.
The next speaker is Dr. Ashish Dengra. He is MD, MBBS MD, excuse me. And he's going to speak to us on electrolyte imbalance in ICU settings. He's director of Mahi Diabetes Thyroid Care Center, diploma in diabetes from Cardiff, CPS Diabetes, All India Institute of Diabetes. He's got lot of, he was the president of API, organizing secretary, Jabalpur Diabetic Update, Jabalpur Thyroid Update, president of the Jabalpur Endocrine Society, organizing secretary of RSSDI, and many, many more awards and fellowships. Let me invite him to give us another good talk on electrolyte imbalance in ICU setting, which is very, very important, and most of us would encounter it almost on everyday basis.
So, thank you, respected chairpersons, and at the outset, I would like to thank Anuj and Srinivas to invite me here to deliver an important talk on the very important topic, that is the electrolyte imbalance in ICU setting. And when I was discussing with Anuj, he told me I don't want, as I am a diabetes specialist, but he wanted me to speak on something different than diabetes. So, these patients are usually admitted in my hospital. Electrolyte imbalance is a very important part which we should cover in our any day-to-day practice, because we can miss a patient who is coming to your OPD also, and you can refer him to a neurologist. So, we have to be vigilant that patient coming to your clinic should be thoroughly investigated, as our old teachers are there, that still we require the clinical examination and history. So, electrolyte disorder is an imbalance of certain ionized salts like bicarb, calcium, chloride, magnesium, phosphate, potassium, sodium in the blood. So, these are the various important electrolytes which are important for the body, tissues and the cells. They are either cations or which are positive charged, and anions are negative charged. They help to balance the pH and acid-base balance of the body, and they are important for the osmosis also. We have learned it in our school days or college days. So, it plays a part in regulating the function of neuromuscular and endocrine and excretory system. Throughout the body, it is an essential element. So, sodium, it helps to balance fluid levels in the body and facilitates neuromuscular functioning. Potassium is the main component of cellular fluid, which helps to regulate neuromuscular function. Even the osmotic pressure depends on it. The calcium, we all know, skeletal growth, neuromuscular performance, blood coagulation, and magnesium is important for muscle contraction, intracellular activity. Similarly, chloride, it is very important agent for blood pressure regulation, phosphate imparts metabolism and regulates acid-base balance. And the bicarbs, as we know, they are the lifeline of our body. They regulate the pH. So after this initial introduction, the normal levels should be remembered by all the physicians. Sodium is 135 and between 135 to 145, potassium 3.5 to 5.5, calcium is 8.8 to 10.4, magnesium 1.4 to 2.1, and so on. So to begin with the very important part, that is sodium, 135 to 145 is the number, and it helps the kidneys to regulate the amount of water the body retains or excrete. So it is a very important molecule of the body. And one of my patient, suppose he came to 3 days back only with he was a known case of diabetes, nephropathy, and he was on various drugs and insulin, and their family members came that he is talking something absurd. So we should remember that it is not always the neurological problem, but you should check the drug history also. So I will let you know how this patient landed up into which diagnosis and he improved. So to begin with the hypernatremia, that is excess of sodium more than 145, it can be due to inadequate water intake, increased sodium intake, or excessive free water loss through extrarenal causes like burns, sweating, tachypnea, or through the renal causes by central diabetes insipidus, nephrogenic diabetes insipidus, craniopharyngioma, or postoperative. So these are all the causes. The symptoms of hypernatremia can be non-specific. Patient may be irritable, restless, or hyperreflexia, spasticity, tachycardia, decreased JVP, and reduced skin turgor. So the treatment is very important to diagnose first whether it is acute hypernatremia or chronic. If it is acute, it should be corrected rapidly, and if it is chronic, that is more than 48 hours, it should be corrected slowly. If hypernatremia is corrected very fast, so osmotic imbalance can cause cerebral edema and potential severe neurological impairment in the future. So aim for serum sodium correction should be slow, 12 mole per liter per 24 hours. So volume in liters to be replaced because it is hypernatremia, so we should maintain the volume for correction. So current total body water into sodium minus 140 divided by 140 is the formula where total body water is typically 50% of total mass in the woman and 55% in men. So hypernatremia can be with hypovolemia or euvolemia. So if the patient is hypovolemic, the patient should receive isotonic saline to restore the euvolemia and to treat hyperosmolarity. The adequate volume resuscitation with normal saline, then you can shift to half normal saline or 5% dextrose to replace any remaining water deficit. Now this second group of patient may be euvolemic with hypernatremia. So water ingestion or simply IV 5% dextrose will result in excretion of excess sodium. Now another set of patient may be hypernatremia with hypervolemia. So the diuretics will be helpful to get rid of sodium plus free water replacement with 5% dextrose. Alone furosemide will aggravate the hypernatremia due to dehydration. So dialysis may be required in oliguric renal failure patients. So this was the hypernatremia part, which is not so common in our clinical practice, but still we can see in the some group of patients I have told you, like renal losses or extra renal losses. So all this should be kept in mind during the diagnosis. The second part, that is the hyponatremia, which is the most common, electrolyte imbalance in the ICU setting or in the clinical setting, which we see in our hospitalized patient. It usually reflects the excess water retention relative to sodium rather than the sodium deficiency. So it is a relative imbalance. So the clinician should be very vigilant about hyponatremia, since the mismanagement can lead to cerebral pontine demyelinosis. So you should be vigilant while treating it also after diagnosing. So the Govardhan Gujarati, the patient who came to my clinic 3 days back, he was taking all the medicines from the nephrologist, and insulin and OHs were continued through our clinic. So he came, the family members came, he he is getting off his clothes, he is running here and there, and he is talking absurd. So we definitely came to the diagnosis of hyponatremia. It was 108. So he may land up into seizures also at this stage. But before that, we should see the hyponatremia, whether it is patient is having the osmolality hyponatremia or hyperosmolality. So we should first check the osmolarity. If it is normal, low or high, then it is diagnosed as isotonic, hypotonic and hypertonic. If it is isotonic, the cause can be hyperprolactinemia or other causes like hyperlipidemia. The hypertonic hyponatremia, which is seen in our clinical diabetes practice, is due to the hyperglycemic stage which we see in our clinical practice. Or while giving the mannitol in a CVA patient, it is very common, radiocontrast agents, and third part is the hypotonic hyponatremia, in which we have to check the volume status also. If the patient is hypovolumic, it is due to the extrarenal cause if the urinary sodium is less than 10. If the urinary sodium is more than 20, it is the urinary sodium loss. Then the euvolumic is SIADH, hypothyroidism is also common in our clinical practice, and thiazide diuretics. That is very important, which we should keep in our history. So edematous state is hypervolumic. In the heart failure, ascites, cirrhosis, we see these patients with hyponatremia. So this was the chart how you should diagnose the group of hyponatremic patients. So symptoms and signs are depending upon the severity and chronicity. If it is chronic disease, it can be severe, like it is having the less than 110 sodium, but patient may still be having mild symptoms. But in acute cases, we will have very severe symptoms, because in chronic cases, the brain adjusts to the hyponatremic state. So the symptoms may vary from nausea, abdominal cramping, vomiting, headache, muscle weakness, paralysis, and disorientation. Even we have seen the patients with seizures in our clinical practice and coma. So you can do wonders. ये डॉक्टर तो हमारे लिए भगवान है. इन्होंने हमारे पेशेंट को बिना CT स्कैन कराए खड़ा कर दिया. That is the beauty of the clinician, good clinician. When you diagnose the hyponatremia, when you treat it, the patient becomes conscious, and you are the God for the patient and relatives. So the complications while treatment is osmotic demyelinosis, that is to be taken care. You have to give sodium, hypertonic sodium, very slowly and according to the formula. So correction depends upon the etiology, type of hyponatremia, as I have told you the chart, and the clinical condition, the sodium levels, that is whether it is mild, moderate or severe, and ongoing losses due to the various causes. So regardless of the patient volume status, another common feature is to restrict free water and hypotonic fluid intake in these patients, otherwise it will exacerbate hyponatremia. So free water intake should be limited to oral plus IV less than 1.5 liters. So hypovolumic patients require adequate fluid resuscitation from isotonic fluids to suppress the hypovolumic status for ADH release. And the cerebral salt wasting may require hypertonic saline to prevent circulatory collapse. Hypervolumic patients, in contrast, may require loop diuretics or dialysis. Euvolumic patients, they respond to water restriction. So simple formula to calculate the, or to give the sodium or 3% saline, first you have to calculate the deficit, that is total body water, into desired sodium minus actual sodium. So one patient coming to your clinic with 70 kg body weight, 122 sodium, and the desired is 132. So how you will calculate the sodium deficit? 70 into correction of 0.5 into 132 minus 122, it is 350 milliequivalent, and 3% saline contains 514 milliequivalent of sodium per liter. So delivery rate should be calculated by a simple formula, the deficit and divided by 514 in the 24 hours. So 350 was deficit, 514 is the amount which is available in the 3% saline. That is, this patient requires 28 ml per hour of sodium to recover from the hyponatremia. Hypertonic saline, I have already told you, it can be hazardous if you give it very fast. Now coming to the potassium, another very important electrolyte, because one of my patient came to clinic, that patient is having loose motion, vomiting since 3 days, and she is not taking anything, and now she is not able to walk. And when we examined her, she was having flaccid bilateral paralysis, lower limb paralysis. And when we admitted her, gradually her upper limb and both the upper limbs also became paralyzed. And I was accused कि आपने क्या treatment कर दिया, patient हम सिर्फ पैर नीचे के नहीं चल रहे थे, now all the 4 limbs are not working. So we immediately planned for sodium potassium, and potassium was 1.9. So this havoc you can face with the hypokalemic stages. So to begin with the hyperkalemia, if the potassium is more than 5.5, the signs and symptoms can be tingling, weakness, numbness, paralysis, palpitation, and the ECG changes, that is very important. The tall T waves, the tall peak T waves, that is pulled up effect, is very important part which you have to take care in your ECG of the patient if you are dealing with the hyperkalemia. So peak T waves, prolonged PR interval, bradycardia, biphasic QRST, and bundle branch blocks, or even cardiac arrest can be seen with the hyperkalemia. So hyperkalemia etiology can be inadequate excretion due to renal failure, excessive intake in the diet through the excessive intake of banana, oranges, tomatoes, or high protein diets. The shifting of potassium from the tissues due to crush injuries, hemolysis, this when we were studying for competitive exams, this was the common question, that through the crush injuries or hemolysis we have hyperkalemia. And the drugs, always drug history is very important when we are dealing with electrolyte imbalance. So the digoxin, beta agonist, potassium sparing diuretic should be seen. So mild potassium hyperkalemia, 5.5 to 6, stop intake of potassium, stop offending drugs, and restrict the diet. Moderate to severe, 6 to 8, glucose insulin infusion, soda bicarb, calcium gluconate, and nebulization through salbutamol should be given. And in the resistant cases, dialysis is the last option. Now hypokalemia, which I was talking about, less than 3.5, it is very common feature which we see in our clinic, and even you may get flaccid paralysis patients. So increased potassium loss can be seen through the extrarenal causes like diarrhea, like my patient had vomiting and diarrhea, and then she landed up into paralysis. And other causes are RTA, endocrine causes like Cushing's, malnutrition, shift into intracellular compartment, alkalosis, hyperinsulinemia. That is very important when you are giving the insulin infusion in your DK patients. When you are giving the insulin infusion, you may land up into hypokalemia. So you have to monitor electrolytes regularly to prevent hypokalemia when you are dealing with DK patients with insulin infusion. Symptoms can be varying from muscular weakness, fatigue, cramps, and patient may land up into paralysis, flaccid paralysis, hypercapnia, tetany, or patient can come to your clinic with distended abdomen and ileus. That is also very common we see in our clinical practice. So laboratory diagnosis, if potassium excretion is less than 20 milliequivalent, it is extrarenal cause, that is diarrhea, vomiting. If it is more than 40 in the urinary potassium, so it is the renal cause, like mineralocorticoid excess, Barter's, Little syndrome. ECG changes, very important in the hypokalemia, the shallow T waves, ST depression, and prominent U waves. So you can pick up from the ECG that this is a patient of hypokalemia. So treatment, oral potassium supplementation for mild to moderate, and in severe cases, IV potassium should be given. Concentration of up to 20 milliequivalent can be given through central venous catheter, ECG monitoring every 3 to 6 hours. Magnesium deficiency should be corrected in refractory cases. We have seen the cases where we are giving potassium but it is not getting corrected. So one of the cause can be magnesium deficiency. So you should first check the magnesium also, and you should correct it simultaneously. Formula is very easy. Potassium 0.3 weight into desired plus desired minus measured, deficit corrected over slowly 24-hour period. Now hypercalcemia is the another part. which we should cover fast, that is the more than 12 milligram. We can see in the multiple myeloma, vitamin D excess, thyrotoxicosis, sarcoidosis is very important. In our clinical practice, you can see hypercalcemia, metastatic cancers, Paget's disease. Again, the drugs, that is antacids, which the patient take, the liquid antacids, they contain calcium. So symptoms can be fatigue, constipation, muscle pain, nausea, increased urination, or nephrocalcinosis. So forced saline diuresis with furosemide, bisphosphonates for malignancy patients, it is helpful to reduce the hypercalcemia. And in emergency cases, last option is dialysis. Hypocalcemia, when it is less than 8, it can be commonly seen in our Indian population. Females, when they are given the calcium supplements, they feel very good. All bone pains go away. So vitamin D deficiency, malabsorption, abnormal metabolism, again the drug history of phenytoin, and the renal tubular necrosis or furosemide therapy. Metabolic causes can be there, hypoparathyroidism, pseudohyperthyroidism, acute pancreatitis, or hypoproteinemia can cause hypocalcemia. Again, the patient coming to your clinic like this, tetany, many females come to our clinic with the complaints कि हमारे हाथ पैर ऐसे अकड़ जाते हैं. So you can check the calcium levels, mood changes, brittle nails. Yesterday only one patient came, she was telling मेरे नाखून टूट रहे हैं. So I asked her whether you are taking milk or curd. She was not taking anything. So she might be having calcium deficiency. So we have prescribed her, and let's see what happens. But we have seen in our clinical practice, many patients respond to calcium in these brittle nail cases. Trozio sign, chopstick sign, all these are old age signs which we have learned in our clinical practice. Management, if the patient is having severe tetany, spasm, or seizures, 2 ml of 10% calcium gluconate should be given immediately. Later oral calcium supplementation should be continued. First you have to treat vitamin D deficiency also along with hypocalcemia. In the last, hypermagnesemia, Addison's disease, overload of magnesium salts, patient may have lethargy, hypotension, muscle weakness. Treatment is that is exogenous source of magnesium should be discontinued. Calcium antagonizes magnesium and may be given intravenously as calcium chloride, and hemodialysis or peritoneal in the kidney failure. And hypomagnesemia, again a common feature which can be seen in alcoholism, malnutrition, pancreatitis, and the signs and symptoms can be leg and foot cramps. Now you are seeing the bombarding of products coming to the market with magnesium, MGD3, they are telling to give in the cramps patient. Why? Because patient may have magnesium deficiency, and most of the patient coming to your clinic with diabetes, they complain of calf muscle pain or cramps, they may have magnesium deficiency. So symptomatic hypomagnesemia can be treated with IV magnesium sulfate, 1 to 2 gram over 5 to 60 minutes, mixed in either dextrose or saline. So my dear friends, to summarize, the electrolyte imbalance diagnosed timely and treated adequately can save a lot of patients' life and money, because the patient can land up into neurologist, he will be admitted in ICU, he may be prescribed CT scan. So by clinical examination and history and timely diagnosis of electrolyte imbalance in your clinical practice, you can save adequately many lives in your clinical practice. Thank you. Thanks a lot for listening.
Thank you, sir. Thank you for a short but very, very important topic that you've discussed. If there are 2-3 questions we can take from the audience. Yeah, hyponatremia is a very common disease, hyperkalemia, and especially if you are using ARBs, aldosterone, beta agonists. So, anything else? Any questions? If there
probably it's a
the hypoglycemia.
Yes, probably it's a very complicated topic, and that is why people are grasping whatever you had told. Yes.
Yeah. Mic chalu.
Hello. Sir, good afternoon, sir. Sir, nowadays, many times we are managing hyponatremias in ER or in the OPDs sometimes, and we try to give 3% NaCl, but many times the patient refuses to get admitted or detained. So we are now practicing with 12 ton. So How long can we give tolvaptan for? How many days, or is there any cutoff that we should not give after
I have
1 week
already
or so?
told you that if it is mild to moderate, you can manage it in the OPD scenario. And tolvaptan is a very good agent which we are seeing in our clinical practice using since many years, and it is giving very good results. If there is very mild, you can give for 5 days, recheck the sodium potassium and supplement oral salt also. And if the patient is not responding after 5 days, you can continue till 14 days.
Would you like to ask? Okay. Okay. If there is no question further, we would like to close the session and would like to thank both the speakers for the wonderful talk. Thank you very much. Just give them a big clap.
From Medicube stall in KCP stall area. And for the next session, I would like to invite our chairperson, Dr. K.G. Suresh, MBBS, MD Medicine, Fellowship in Diabetes and Endocrinology, Fellowship in Indian College of Physicians, FRCP and FSCP, Consultant Physician and Diabetologist, Manipal Hospital, Bangalore. Sir, please come on desk. And Dr. Ashish Saxena, MD, FRCP, FIAE, FIACM, FISH, MACP, Consultant Internal Medicine, Diabetes and Non-Invasive Cardiology, Diabetes and Heart Care Center, Ludhiana. Thank you, sir.
It's an honor to introduce my team. Actually, this is the investigator trial which we have conducted all across the country by 14 centers, and our PI is Dr. Daria, who is an MD Medicine, who is a national governing member of API as well as the treasurer of API, an executive member of RSSDI, a joint secretary recently for IACM. He'll be taking us across along with Dr. Vinayak. Can I have the slides of Dr. Vinayak also? Yeah. Dr. Vinayak Hiramat, who is an MD and MRCP from UK. He has got lots and lots of laurels at a very young age, a prestigious member of the Royal College of Physicians in MRCP UK. In 2019 on Kargil Vijay Divas, he was honored by the Government of India for the Pride of the Nation Award by our Defence Minister. In 2021, during the COVID pandemic, was awarded top 10 health leaders, noble cause, involved in lots and lots of primary healthcare programs, and he's a philanthropist. He's one of the good leading practitioners of Kochi. So along with Dr. Daria, Dr. Vinayak will be joining and presenting the TP-TOS trial. And I thank Dr. Anuj for giving us this opportunity to present it in ACP.
Thank you so much, Dr. Ashish Saxena, for a kind introduction. So, we will be discussing interesting TP-DOS, that is a tri-parameter diabetes observational study, which is a population-based study done in type 2 diabetic patient across the country. And our chief PI is Dr. Ashish Saxena, sitting there, he is chairing the session. And I'll present with my colleague, Dr. Vinayak. Okay. So here you can see the study investigators. We are having Dr. Anuj Maheshwari sir, who is a governor ACP. With him, the others are Dr. Astha, Dr. Vijay Patni from Kolkata, Dr. D. Kumar, Dr. K.P. Chandra, Dr. L. Meenakshi Sundaram from Chennai, Dr. Mohammad Aslam from Hyderabad, Dr. Mukulesh Gupta from Lucknow, Dr. N.K. Singh, Dr. Raka Hare, Dr. Sajid Ansari, Dr. Surjit Patra, along with me and my colleague Vinayak. Our scientific and knowledge partner is Medeva, who is a comprehensive healthcare tech service provider, and the financial supporter is USV. At the outset, as Chief PI already have shown the gratitude to Dr. Anuj Maheshwari sir to present this TP-DOS study in this prestigious ACP conference India chapter. Thank you so much, sir. So as we all know that diabetes is a metabolic disorder of multiple etiology by a chronic hyperglycemia with disturbance in all three carbohydrate, protein and fat, and which results into both insulin secretion and insulin action defect. The diabetes is a global epidemic mainly in Southeast Asia region, and as per the IDF Atlas 2021, we are almost 74 million diabetic patients in India. And if this continues, then till 2040, there will be more than 640 million patients of diabetes. Earlier we said that it's a disease of older people or the rich people or the urban phenomena. Now it has changed. Now you can see the diabetes everywhere. In villages you can see the patient of diabetes. So that is why the goal of diabetes management, we should have to achieve the good glycemic control, prevent the complication and manage the comorbidity. The ICMR INDIBE study, which was done in India only since last, they follow for 10 years, and they observed that the HbA1c level less than 7% was only in 31% population. And more than 25% patient had their HbA1c was more than 10%, which shows that how much of diabetic patient have uncontrolled blood sugar. So to control this blood sugar, we should achieve the ABC goals. And what is ABC? A for your glycated hemoglobin, B for your blood pressure, and L for LDL cholesterol level. The Wikipedia study have shown if there is a reduction of 1% HbA1c and reduction of 10 mm of Hg in systolic blood pressure, there is 37% reduction in the risk of microvascular complications in diabetic patient. Same with the LDL also. If LDL is reduced, then there is a reduce in CV events and deaths. The ADA standard targets have shown that ABC, HbA1c should be below less than, the blood pressure should be less than 130/90, and the LDL cholesterol level should be less than 100 milligram per deciliter. The same target set by our RSSDI also. That is why it is crucial to set the ABC targets, and we can reduce the risk of complications of the diabetes. In advanced trial, they have shown that in more than 11,000 patients, the diabetes, they assigned their intensive glucose arm and the standard glucose arm. In intensive, they have shown that 0.8% HbA1c was greater than the standard arm. So however, we should reduce in major microvascular events of 14%, and the non-significant reduction was in major macro was only 6%. So that is why in intensive blood glucose and in BP control arm, we can reduce the peripheral artery disease, we can reduce the type 2 diabetes risk to the risk of stroke by reducing the HbA1c. The LDL cholesterol plays a very vital role in development of early atherosclerosis, and which is equally important to maintain as like the hyperglycemia, because this atherosclerosis is a major cause of atherosclerosis, and that lead to the CVD, and which is a major cause of mortality in patients with the type 2 diabetics. So the objective of our study was to estimate the prevalence of meeting these ABC goals, the HbA1c, the blood pressure, and the LDL cholesterol in type 2 diabetic patients in India. The secondary objective was to estimate the prevalence of meeting ABC goals individually, partially, or not at all. This was a prospective multi-central real-world design study. We recruited patients from primary and the secondary care settings, and it was conducted in 14 cities across the country. The time period was from March to August 2022, and we included the patient who were diabetic more than 18 years of age, and we excluded the patient who were pre-diabetics, who were type 1 diabetics, and the gestational diabetes patient. Ethical approval taken from the Udayan Healthcare. The sample size was considering the incidence of 10%. It was around 865, but we achieved the sample size of 2,202. and we collected the parameters of demography and vitals, lipid profile, blood pressure, and the glucose measure, all for random, fasting, PP, and the A1C. The data was collected on Medeva, an analytic-based EHR platform, and the data collection was done between 28th February 2022 to 20th July 2022. So I would like to call my colleague Dr. Vinayak from here. He will take the charge. Dr. Vinayak.
Thank you, Dr. Daria, and thank you, Jay, for that warm introduction. Once again, thank ACP, Dr. Anuj, sir, for providing us this platform. So when I connected with, just a few words, when I connected with Dr. Ashish, his first word was, leave about the newer drugs like semaglutide, studying because I was interested to study about the semaglutide. So he said, like, leave about that. We'll start the basics. Basic hi kharab hai hamare paas. The patient's ABC is not controlled. So we will show that data to the doctors. So then we can move ahead, right? So with this platform, back to basics on ACP, we are presenting our data. So I'll start from the analysis. So this analysis was done on the Medeva, as told by Dr. Daria. This was a descriptive static mean with a mode and standard deviation compared for the significance between the patient group. One-way variance was done to determine if there was any statistical difference in the mean of 3 or more independent groups. The two-way ANOVA was also done to determine whether or not there is a statistical difference between the means of 3 or more independent groups. So when we got the p-value of less than 0.05 and 0.2, we concluded that there was a statistical significance of 5%. So this is the cohort, the characteristics. You can look at gender. We had the gender-based analysis, the male of 1238, females of 964, and we had the age group gender also, like less than 34 age, 34 or less than 34, 133, and to the age more than even 90 also we got, that is like more than 65, we had 455 patients. So this was the analysis. So we got a very striking analysis, or the result would, I would say, like you can see at this pie chart, where like only 23.3%, if we are talking about the individual goals, not about all the three, the individual goals, like 23.3% were having just HbA1c under control. And the same is with the blood pressure, that is 23.7%. And if we talk about the cholesterol, that is LDL-C, most of us are focused on this thing, so maybe like we had a good result of 44.8%. But when we talk about all the three parameters which were under control, it was just 3.5%. So this is really very striking that all the three parameters being under control is just 3% or 3.5%. And if we talk about individual, that is 42% are with one under control and 19.5 with any two under control, and over 1/3, that is 34.8% patient had not all the three under control. So this is the graphs which is showing that an A1C of 23.3, BP blood pressure of 23.7, and LDL of 44.8%. So again, in a brief, the data, all the ABC under control 3.5, any two, it's just 19.5%, only one of three, 42.1%, and none of the ABC parameter under control was 34.8%. So the ABC goal achievement, if we look at the age and gender wise, it's all under control was 3.5%. Males, if we are talking, we are having just 3.6% under control, and females 3.4. This is the really striking input of our study, that is like age less than 34 had only 1.5%. So our focus of treating the diabetes or looking at the patient group should be this, because these are the group of people, the younger India, the next generation, which are going to come and get the complications of diabetes, which they didn't have the good control, that all the three parameters. And if we talk about the non-achievement of any ABC, that was 34.8, again in the males 34.7, and females 35. Less than 34 was 39.9%. Again here, 35 to 44, 37.8%, 45 and above, 36 to 34%. So I'll skip this, I'll go for the discussion. So if we talk that overall achieving the HbA1c, that we kept it the standard definition, HbA1c of less than 7%. In the present cohort was 23.3%. And prevalence in meeting the HbA1c goal was higher in the patients more than 50 and above. So the elder people had a good A1C control. The younger people, that is less than 34 and less than 34, had very poor control. In terms of blood pressure, maybe like the older people have a lot of stress and tension. So there the blood pressure was not much controlled, but like the younger generation, somehow this seems to be little well controlled. And about the LDLC, as I mentioned earlier, that like 44.8% had good control, 51% in the age group of more than 65 years had a good control. And again here, that the less than 34 years had a poor control. So if we talk about all the three parameters, ABC, that is HbA1c goal, LDL goal, and more evident, these were more evident, the blood pressure more evident in the older adults compared to the younger. So finally the talk is like 3.5% is the only people who have all the three goals under control. So this is the result. We compared our study with the Brazilian National Survey study, which showed that like the ABC control were almost more than 46%, that is near to 50% of good control. But again, when we compare our study with the Brazilian study, the IDF data, if we are speaking of, it's just like Brazil has low prevalence compared to India. India has the highest prevalence in the top 3 countries in between China and Pakistan. So this is again the individual goals which I talked about. So this is the focus where we need to focus, like the non-achievement of goals. If we see the other side of spectrum, that is 34.8% of patients were not able to achieve any of the ABC goals with both the genders, the females and the males, and 76.7% were unable to achieve the A1C goal, 76.2% were not able to achieve the blood pressure goal, and 55.2% were not able to achieve the LDLC goal. So the major age group patients who should be focused is age less than 34. And our study concluded that like we had the higher prevalence of diabetes in India, and also not the prevalence, the control of all the 3 parameters, that is ABC, was very low, and this was more prevalent in the younger generation. These were the strength and limitations of our study. That the study we provided an estimation on recent burden of diabetes and comorbidities in India. So this study is just an add-up or an update to the previously conducted such studies. The few limitations of this study included we could not capture the duration of diabetes and at the respective sites, and also we could not compare the urban and rural prevalence and socioeconomic conditions which are not being studied. And this study also did not identify the subtypes of diabetes. So leaving with you all some questions, because we are again going, like Dr. Ashish has already promised us that we are again going back to come, maybe next time when we meet, we'll be bringing back another paper. Until then, I'll be leaving with you some questions here. So picture abhi baki hai hamara study ka. So like, are these targets very too stringent? Like, what are the achievable or yet relevant goals? What are the main reason, if we are talking why the patients are not able to achieve all the 3 goals? Is it like lack of self-management skills, poor awareness, or poor compliance, which can be at the patient end, also some towards the doctor's end? So assessing the impact of various treatment methods and combination on goals. So to conclude, despite of advances in the treatment, the various technologies being adopted at every centers, right, we are reaching the urban, rural, everywhere the diabetes care is reaching, but we are failing the primary goals, that is the control of A1C, LDL, and blood pressure. And this, the more prevalent to be the age group, what we came up in our study was age group of less than 34 or less than 34. So, thank you once again for this patient's listening.
Hello. Any questions from the floor?
It is a prospective study, sir, so definitely, yeah.
No, we are continuing more with it, sir. All these questions will be addressed.
Yeah, the question which I was planning to ask, that in this previous study you did not look into the what are the causes why they didn't have this type of good control. You just have an only observation of not a good control, but what are the etiologies why they are not in good control, whether it's the patient factor or the physician factor or the cost of the drug, they were not looked into.
Right, sir. That needs to be retrospective analysis. Like we are going to bring that in detail, but this is a very vast data. What we got is like these many patients were not under control. And apart from that, what I would like to add is, if we are talking of blood pressure and the cholesterol, this could be controlled with the medicines what we are going to give to the patients. But whereas when we talk about the A1C, lot of things come into picture. His lifestyle, the way he eats the food, everything comes into picture. Or maybe, as we have put a question like this, it's very stringent to say that keeping a A1C less than 7 or having a blood pressure at 130/80 itself, maybe in the Asian population, this needs to be still introspected. We'll definitely come up with the data in the future, sir.
And whenever we are looking into the HbA1c, because there is a great proportion of people, those who are anemic as well in this population. Right. So that also has to be taken care of, because when there is anemia, we cannot take HbA1c as a indicator for monitoring of diabetes control.
Correctly mentioned, sir. Like HbA1c is not the definite thing to say that whether your diabetes is under control, but we are also conducting a similar study where we want to show that like why HbA1c is not recommended to say that whether your diabetes is under control. There are many other tests, because as you mentioned that the patient's hemoglobin directly matches with the HbA1c. So, but when we came up with this study, we just had some discussions with the people outside India, abroad and all. What I gathered was the other tests, whatever we are going to prescribe to patient, making it universal, the cost will be on the higher end. So the HbA1c, if you want to measure HbA1c, just take an hemoglobin of a patient also, so at least you can correlate something. But the other test, if you want to replace this HbA1c and add some other tests to say that whether your sugars are well controlled, then there is a lot of financial issues going to come, and like the affordability issues are going to be faced. So, yeah.
Because similar type of study was done in Tamil Nadu with STEMI pilot program, and what they have done that initially, they have seen both that before the implementation of hub model and spoke and hub model for reperfusion therapy for acute MI patients, what was the percentage of people those who are getting a reperfusion therapy, and after the implementation of spoke and hub model, what was the percentage of patients those who are getting a good reperfusion therapy. So this was done, a very good study published in Indian Heart Journal for the STEMI program in Tamil Nadu. So if we start doing the next study in a way that what interventions we can do in some subgroup of patients which is going to help them and improve their outcome in the subsequent study.
Sir, I'll take that. Sir, when we started the study, we started just with the observation of all these patients who are coming to the 14 centers, and they are all the centers where almost very top end cardiologists, diabetologists and endocrinologists are sitting. So as the results came in, this was the first phase which we have done. Now as the result come in, we will be now becoming more particular in seeing these were the limitations. So what you have said, this has already been designed for the next phase of the study. So the main intention of pointing out this is that the importance is that the young population is burdened with diabetes, hypertension, and they are going to grow old and they will be having complications. So all the aim is that we are focusing on the elderly. The focus has to be on the young generation also. We need to look why they are missing their targets. We need to look what is the cause, whether it's a patient barrier or a physician barrier or the cost barrier. So the next study will be more detailed, where we'll be taking all what you have said, or as well as considering the HbA1c versus the hemoglobin also, so that we can have a concluding data. So maybe by the time, next time we present, we might present in a much better way. So this was just an initial phase of study.
Yeah, and just restricting to the guidelines on the ADA, what HbA1c we routinely do. So we can come up with the new added data as you mentioned, like if you want to see that whether the sugars are really well controlled, add an glycated albumin level, then see that because that is more reliable when we compare to HbA1c. So, but again, the cost effectiveness, since it was a non-interventional, we did not ask our patient to do anything particular. It was just an observational. Routinely, a patient visits us. How we are routinely practicing, we just captured the data. We just didn't want to make much interventions in the first study. Yep.
Thank you. I think we'll move to the next session. So it's pleasure to invite Dr. Amit Dey. So Dr. Amit has done MBBS MD and diploma in geriatric medicine. He is a consultant physician, diabetologist, and also interested in obesity, metabolic disorders. He works in Apollo Sugar Clinics in Eden Health Plus. Today we'll be talking on sarcopenic obesity, a new challenge in clinical practice.
Good afternoon, everyone. Thank you, dear chairpersons, for the kind introduction at the outset. Thank you to Dr. Anuj Maheshwari, sir, for giving me the opportunity to talk on a topic which is yet to get established into our clinical practice. Obesity is a challenge that we are all facing in our clinical practice as clinicians, as metabolic physicians, and a new entity called sarcopenic obesity is emerging. So my talk over the next 20 minutes would predominantly be a review of the literature, which I have explored, and also with an intent to highlight that sarcopenic obesity is a separate clinical entity, and we need to look at it from a separate point of view. So to start with, older obese people with decreased muscle mass or strength are always at a risk of adverse outcomes, that we always know. Now, so there is a concurrence of obesity and muscle impairment, which will have an impact on health and disability. Now, the prevalence of sarcopenic obesity amongst adults is rapidly increasing worldwide. And in the next few slides, I will show you the prevalence data. But however, there is a lack of universal definition of sarcopenia, which limits the comparison between the studies. Now, sarcopenia and obesity, we know, have similar pathophysiological factors, like, for example, lifestyle behaviors, hormones, immunological factors, all of which will be synergistically affecting the risk of developing a series of health issues. And that would impair the quality of life. And as a result, it will have a direct impact on the increased risk of cardiometabolic disease and thereby impact mortality. So therefore, it is very important that we identify sarcopenic obesity in our clinical practice, especially for the aging society. So that is the introduction to the talk. So this is what we are looking at. We are looking at obesity, which is increase in fat deposition. And on the other hand, we are looking at sarcopenia, which is reduction in lean mass and muscle strength. Together, we are calling it sarcopenic obesity. So what I'm going to do is to define the terms. We're going to take each of the terms separately. So first, what is sarcopenia? Sarcopenia comes from the Greek word sarx, which means flesh, and penia means loss. So, which was originally meant to represent age-related loss of muscle mass with aging. Definitely there is a loss of muscle mass, and then there is also a loss of muscle strength. That is very important, which is evolving over the years. And there is a decline in muscle quality and muscle function. This is very pertinent in the elderly population. Now, Baumgartner et al. First defined sarcopenia as an appendicular lean mass. Now, this appendicular lean muscle mass is calculated from DEXA scan, which is divided by height whole less than 2 standard deviation below the mean of a young reference group. This measurement is on the research end, but there has to be a clinical way of identifying sarcopenia and sarcopenic obesity. There has been various groups giving consensus. So in 2010, the European Working Group for the Study of Sarcopenia required the presence of both low muscle mass and low muscle function for the diagnosis of sarcopenia. Likewise, the International Working Group for the Society for the Study of Sarcopenia provided a consensus definition of sarcopenia, namely the combination of low appendicular lean mass, ALM, and poor physical functioning, which was calculated by the gait speed. The European Working Group also focused on low muscle strength, and that was found out by the grip strength as the primary parameter of sarcopenia, used low muscle mass quantity and quality to confirm the sarcopenic diagnosis using DEXA scans or alternatives. And they also suggested measures of physical performance, so that the gait speed or timed up and go test, that is the tuck test, to assess the severity of sarcopenia. So this is a summary slide, a bit cumbersome to look at, but these are the various consensus on how we can identify sarcopenic obesity. And what is very important in our clinical practice is the hand grip strength, the gait speed. I think these things can be easily done clinically, although ALM is from the research front and it will require a DEXA to calculate that. Now let's look at obesity. This is something we all know. It's a chronic metabolic disease. There is an increase in body fat stores, and the definition given by the WHO is based on BMI. But we know from our practice and also from the various other guidelines that we must also use waist circumference, which is the amount of abdominal fat, to define obesity. So the American Association of Clinical Endocrinology recommends the use of the WHO body fat thresholds for the diagnosis of obesity, 25%, more than 25% in men, and more than 35% in women. Now, combining both the two, we look at sarcopenic obesity as a confluence of the two epidemics that affects the aging population and an increase in the rate of obesity. And there is a persistent inflammatory change that triggers it. So there is inflammation, there is insulin resistance, there is fat deposition, which plays a complex role in the association between obesity and sarcopenia. If you look at the prevalence, this is a worldwide prevalence, and I'm talking about the National Health and Nutrition Examination Survey, which was carried out by the CDC on the US citizens. They included individuals from the American, African, and Hispanic ethnicity, and they had the prevalence of sarcopenic obesity as 18.1% in women and 42.9% in men. A similar Korean study of the same group have shown a prevalence of 7.6% in men and 9.1% in women. So the question is, do we have a prevalence in India? And this was one paper that I found, and this kind of goes on to show that it's a prevalence of the normal weight obesity, and it's associated with the cardiometabolic risk factor. And 1/3 of the study cohort is mentioned here, and 2/3 of the apparently normal weight individuals had normal weight obesity. So that was the Indian prevalence data which I could find. We know that sarcopenia has a complex molecular mechanism. It is related to various inflammatory and pro-inflammatory markers, various cytokines, and it depends upon the functions of the hormones, the IGF-1, the insulin, the muscle fiber composition, the neuromuscular drive, and various other pathways which stimulates sarcopenia and obesity together. Now, the pathway to the obesity and muscle impairment syndrome is quite complex, and it would look a little monotonous here, but I couldn't cut down on the slides because I thought it needs to be highlighted. So first, there is an age-related change in the body composition. So fat mass increases with the age, and it peaks at about 60 to 75 years. The muscle mass and the strength starts to decline progressively around the age of 30 years, and it is more accelerated after 60 years of age. At the same time, we see visceral fat and intramuscular fat tends to increase, while subcutaneous fat in the other region of the body tend to decline. And there is also fat infiltration that happens in the muscle, which is leading to lower muscle strength. So this is how the age-related change in the body composition happens, and that pushes an individual towards sarcopenic obesity. This is coupled with various pro-inflammatory state, malnutrition, and the various complex factors. Physical activity is, of course, plays a very important role. Sedentary lifestyle would be an important risk factor for weight gain. And the obese individuals would obviously tend to be, less physically active, and they would have a decline in their muscle strength that would promote towards sarcopenia, leading to muscle atrophy. The inflammation I have already discussed, but what is very important to understand that this inflammatory cascade, just like we discussed about diabetes, goes together. The inflammatory cascade of obesity and sarcopenia goes in together, and probably that is why we see that there is a higher risk of cardiometabolic disorders in patients having sarcopenic obesity. Insulin resistance follows, so there is the inflammatory molecule mediates obesity-related insulin resistance through the various cytokine receptor and insulin receptor signaling pathways. Now this is interesting. So increased adiposity is often associated with high circulating free fatty acid, which inhibit the growth hormone production, and that decreases the plasma IGF-1. Recent studies have also shown that sarcopenic obese persons have depressed growth hormone secretion compared to that of the other categories of obese individuals. And they also have been found to have lower levels of testosterone. So low levels of these anabolic hormones have been reported to be positively associated with low muscle strength and may therefore contribute to muscle impairment in obese individuals. Weight loss, malnutrition plays a very important role because there is a misbalance between energy intake and energy expenditure, and that pushes an individual towards sarcopenic obesity. So these are some of the studies which I came across. I won't take you through the details of the study, but these are some of the relevant studies which I came across regarding sarcopenic obesity and muscle impairment syndrome. So to summarize what I just said, this is like the vicious physical cascade, what it looks like. You have sarcopenia on one side, obesity on the other, triggered by various inflammatory markers, oxidative stress, insulin resistance, hormonal change, decreased physical activity, and it leads to various cardiometabolic conditions like dyslipidemia, diabetes, coronary heart disease, hypertension, and very important, frailty. That's very important. So disability has been found to be associated with sarcopenic obesity. This was shown in the Concord Health and Aging Project, which showed that there is a 2-fold higher risk of frailty and 1.5-fold increased risk of disability during their 7-year follow-up period. And the decreased physical performance was characterized by gait speed, increase in the risk of disability in the elderly people. The nutritional study carried out by the CDC had also shown that patients having sarcopenic obesity had a higher likelihood of nursing facility use. And there was a longitudinal observation study which reported that midlife obesity to be associated with an increased risk of nursing home admission in later life, especially if the older adult persisted with obesity. The British Regional Heart Study showed that there is an increased risk of mortality in men in patients having sarcopenia with obesity as compared to those having those patients without sarcopenia or obesity. And overall high cause mortality rate was also found to be high. Now I've already spoken about the correlation about the metabolic disease. These are some of the studies which established a strong correlation. And you can see there is a higher risk of metabolic syndrome, hypertension, dyslipidemia, diabetes, also vitamin D deficiency, and higher 10-year CVD risk in patients of sarcopenic obesity. So this is a summary slide of what I said. You have physical inactivity, metabolic syndrome, and that runs in a vicious cycle with sarcopenia and sarcopenic obesity. Some of the other comorbidities which can exist is impaired balance in the elderly people, in the elderly individuals, increased risk of fall in community dwelling older adults, higher risk of osteoporosis that coexists, also leading to low mineral bone density and high risk of vertebral fractures in the older adults, and also an increased risk of depression. I should mention here about the Asian Indian phenotype, otherwise it will not be complete. We are talking about the thin fat Asian Indian. So at any BMI and age, Asian Indians definitely have a higher body fat, visceral fat and waist circumference, and lower skeletal muscle mass, thinner hips, short legs, which definitely leads to further increase in insulin resistance, metabolic syndrome, and they classically fit into the categories of sarcopenic obesity. So the South Asian phenotype, in spite of having lower BMI, they have more abdominal fat. That's what we call them as the thin fat Indian. They have more insulin resistance leading to hyperinsulinemia, and there is higher levels of the circulating CRP levels and also lower levels of adiponectin. All these characteristically associated with insulin resistance, and also there is a great degree of dyslipidemia found in these individuals. There is increased susceptibility to type 2 diabetes and coronary artery disease. This shows how aging and sarcopenic obesity coexists with a persistent decline in physical activity, and there is a correlation with the dietary intake. So that is also very important in terms of the protein intake. So that's something which is important. So when we are treating sarcopenic obesity, we should keep a focus on the protein intake as well. This is how it looks, lean and sarcopenic. So you have fat mass high and low, and based on the muscle mass, we can categorize sarcopenic obesity or obesity. Now, clinical picture. As clinicians, we always want to know that how we can actually assess a patient clinically. So muscle strength we can look at by hand grip or the lower limb muscle strength. Muscle function can be assessed by the walking speed, sit to stand, chair stand test, or the balance test. And of course, the muscle mass can be calculated by the appendicular lean mass or the anthropometric measurements, or thigh circumference, BMI, and waist circumference. So this is how these calculations can be done. And this is a short physical performance battery wherein you do the balance test, the hand grip test, the 4-meter gait speed, the chair stand test, and the timed get up and go test. So how to approach a case of sarcopenic obesity, and I took this slide from CME India. I think it's very famous. Dr. N.K. Singh is there with his permission. I'm presenting this particular part, and it was beautifully demonstrated as how one can approach a case of sarcopenic obesity. So I think we need to have a clinical suspicion. That's very important, because we look at obesity, we look at sarcopenia, but we definitely need to look at them together. And using some basic bedside tests, we can try to categorize the patient as sarcopenia probable, and then probably use a DEXA scan, CT or MRI to confirm sarcopenia, and then assess the severity based on their physical performance. Can we treat that? That's very important. So this is, again, a cumbersome slide, but I wish to take you all through it. The first most important is, of course, we need to make the patient lose the body fat and improve the physical function. So calorie restriction, and then a maintenance. That's very, very important. So, of course, the calorie here, it's about 500 to 1,000, but in an Indian context, we would individualize the calorie based on the patient's need. Exercise plays a very important role, because remember, we are talking about the elderly population here. So aerobics exercise would definitely play a very important role in improving the cardiorespiratory fitness, along with resistance training, which will improve the muscle strength and mass, attenuated the loss of muscle and bone during the weight loss effort. So that's very important. What I already mentioned is protein supplementation. That is very important, because it will mitigate the loss of muscle mass to strength. So approximately 1 to 1.2 kg per day of protein in divided doses can be given, and also 2.5 to 2.8 grams of leucine daily can be added. Along with this, calcium supplementation and vitamin D supplementation is very important, because it prevents the potential disturbances in the bone metabolism. This is, again, a beautiful slide taken from CME India, how the two phases of exercise can actually help in improving the various biochemical pathways in our body. That is the glycolysis, the glycogen synthesis. So we have to have a patient-centric approach towards obesity, and most importantly, like we say for diabetes, this should also be an individualized approach towards obesity, if I can so call it, for sarcopenic obesity. We need to understand the current practices, we need to understand what's suitable for the patient, and most importantly, we need to identify the patients who are at risk of developing the metabolic comorbid conditions, patients who might progress into sarcopenic obesity. Healthy eating, diet is very important, so I think platter system and everything we should explain to the patient, take them through it in details, give them a proper portion of how much they should eat and how much they should not. So to summarize, and I will take you through 1 minute, I think what we have, just a few take-home points for the audience. Sarcopenic obesity is definitely a combination of low muscle mass and also high fat mass. And also muscle strength plays a very important role, because that's what most consensus says, along with poor physical function. That's calculated, measured by the gait speed. So there are various definitions, various cutoffs, bit cumbersome to remember, calculated by the appendicular lean mass. The cutoffs which we can take for weak hand grip strength for men and women are less than 26 kilos and less than 18 kilos in Asians, and less than 30 kilos and less than 20 kilos in Caucasians. The most common cutoff point for slow walking is less than equal to 0.8 meters per second in both men and women. And the average prevalence from all the studies that we have seen is about 5 to 10%, and I think that is quite a substantial amount of our sarcopenic obesity we are seeing in the society. So the older adults will definitely have a higher impact because of sarcopenic obesity, leading to mobility, disability, metabolic disease, hypertension, cardiovascular disease, and definitely mortality. The pathogenesis I have already discussed. The treatment will include physical activity, fitness, exercise training, and a focus must be given on a balanced diet with proper protein intake and amino acid supplementation. Thank you.
Thank you, Dr. Amit. So if there are any questions from the floor, we can take 1 or 2 questions.
Thank you for a wonderful presentation. This is the thing which we are now facing. See, it was in the West where we had obesity, and now slowly India, because of the affluence of so many things, we are fortunate to have these obese people. But now with obesity comes a problem, and fat turns out to be the culprit. Now, I'll just like you said, the grip test. This is one of the very good tests which has come up. What will be the role of medical nutrition therapy in these type of patients? Does they have some say? I want to know, what is your opinion about it?
I think this is a part that we all need to actually explore and see, to be very honest, whether a proper guided or titrated medical nutrition therapy can actually, we need to see whether it actually brings an improvement in the hand grip. As you understand that this entire entity is all new to all of us, and these clinical tests that we said, these are things which we all need to explore and see. But like you rightly said, sir, I think this is something that we can work on, graded medical nutrition therapy, to see if there is an improvement in the functional capability of the individual.
Because how it happened, this role of medical nutrition therapy came because of COVID.
Absolutely.
So that is how our thought processes have changed. Another thing you told about the anabolic hormones. We use a lot of decadurabolin in our patients. Yes. So that is one aspect, and testosterone that can be used for these population.
Yes, testosterone.
So any other questions? I think so it was a wonderful session, so we bring a close to the session so that we continue. Thank you, dear speakers.
Thank you, chairpersons. And I would like to request our chairpersons to go for facilitation and take their gifts from, and as well as speakers also from Mediquip stall. And there is a good gathering after post-lunch session, and so it's quite difficult. to have such gathering after lunch. So for the next session, I would like to invite our chairpersons. Professor D. Raghunandan Rao, MD DM, FAPS, FRCP, FACP, Professor of Medical Oncology, GSL Medical College, Raja Mahendravaram. Dr. Ashish Kumar, Professor and Senior Consultant of Gastroenterology and Hepatology, Sir Ganga Ram Hospital. Sir, please come on, dais. Dr. Ashish Kumar. Yes. Sir, please. Sir, Dr. Vidwani, please, sir, come on stage. So, great applause for sir. Sir, please come on stage. Thank you. Over to chairpersons.
Good afternoon, everyone. We have two papers. The first one is by Dr. R.R. Singh, who is the president of the Indian Medical Association from Jhansi, as well as the president of the Jhansi Nursing Homes Association. He was the past president of the organizing secretary for the UP DACon and the UP Epicon in 2014, and of course the UP RSSDI chapter. And he is now the chairman of the UP RSSDI chapter. He is a fellow of the Cardiological Society of India, Indian College of Physicians, American College of Physicians, and a speaker at most of these well-known conferences. And he will talk to us on what do we miss in a CBP report. Over to Dr. R.R. Singh, please.
Thank you, our chairpersons, respected Dr. Raghunath Mohan Rao and Dr. A.K. Birmani Saab. At the outset, I would like to thank Dr. Anuj Maheshwari, Dr. N.S. Verma, Dr. Anubha Srivastav, and Dr. Srinivasan, who has made very good arrangement for this conference and invited me for this particular talk. This is what I am going to talk regarding the CBC, which we do in every patient almost whosoever comes to the OPD, and especially it's a topic of interest for the PG students and the newer doctors who hardly bother for this investigation after seeing the TLC, DLC, hemoglobin and platelets. But really we miss many parameters which may help us to approach to diagnosis of various diseases. These are the objectives. Whenever we see the CBC report, we just interpret and which are useful for the diagnosis of the various types of anemia, whether it is microcytic, macrocytic or normocytic anemia. It can reflect acute or chronic infections. Friends, it is also useful in various kinds of allergies and problems which are related with the clottings and the malignancies like leukemia. So normally in every CBC we find this RBC, hematocrit, hemoglobin, MCV, MCHC and many other things, almost 18 parameters. So we normally see for the RBC count, which everyone knows, then the hemoglobin and hematocrit value, and then we come to the MCV and MCHC, which is very important because this value of MCV is responsible for, if it is small, then for the microcytic, if normal, then normocytic, and if large, then the macrocytic anemia may be there in the person. Similarly for MCHC, which is decreased in the hypochromic anemia and is normal in the normochromic anemia. These are the values for the MCH, which is 27 to 32 picogram. For RDW, which we call as red cell distribution width, that is also very important. Then we come to the degree of N-isocytosis, which is related with the RDW. Reticulocyte count, which often we miss and we don't see, This is an important value which is needed in the evaluation of any kind of anemia. And in normal range, it is 1 to 2%. When it goes up, that means there are features of hemolytic anemia. We should see for the serum bilirubin, which should be normally up to 3 to 4 milligram percent. And if reticulocyte count goes down, then it may be related with the nutritional deficiency or some bone marrow ailment. When we centrifuge a sample, we find that in a normal sample of the blood, the upper 57% part, which is straw colored, is the plasma and which is containing most of the platelets over there. Then there is a buffy coat, which is around 1%, which carries WBC, and lower down 42%, which we called as packed cell volume, and that is having chiefly the RBCs. Then there is a rule of 3. Suppose the RBC count is 5 million, then in adult the hemoglobin should be 15 gram percent. And similarly the hematocrit value should be around 45 to 45. So this is rule of 3. Say this is 3 times, hemoglobin is 3 times of the RBC and hematocrit value is 3 times of hemoglobin. And if not, that means it indicates micro or macrocytosis or hypochromasia. When we look at the workup of the anemia, which I told you it could be microcytic, normocytic, macrocytic, I will show you certain slides also. So microcytic, it is seen in the patients, especially in the iron deficiency and chronic infection. And we should not forget that microcytic anemia may be there in the thalassemia, despite of repeated transfusions. Normocytic may be there in the certain hemoglobinopathies and primary bone marrow disorders. And macrocytic, which we see in the megaloblastic and certain diseases which are related to the liver, especially alcohol-induced hepatitis. Here is a slide, especially for the important of for the PG student, those who are doing MD. This is showing that the RBC count, hemoglobin, and this third thing is MCV, that is low. So this is seen, this picture is seen in the iron deficiency anemia when we look at the slide. One thing is very important while looking at the CVC, we should also ask to the pathologist that what about the peripheral smear? What did you find in the smear? Which 90% people, they don't give it. They just give a printed report which is having 18 parameters and that finishes the story. Neither the clinician nor the pathologist, they bother about it. But we should always ask that please give me a peripheral report. What did you find? Is there any parasite also, or what is the, say, shape of the RBC, and what is the size of RBC? Normally WBC is 10 micrometer, and this RBC is around 8, and similarly the eosinophils, they are around 12 micrometer in diameter. So this microcytic hypochromic anemia picture, in which we see that the RBCs, they are hypopigmented, they are small in size. Normal size is, as I told you, it is around 8 micron meter, but this is smaller than that, must be around 5 to 6. And this is the picture which look in the microcytic hypochromic anemia. And microcytic hypochromic anemia, we find we have to differentiate with the other investigations like serum iron, total iron binding capacity, and bone marrow pearl stain. See, in the iron deficiency, we find that serum iron level is low. Similarly, if we see the downward, there is a sideroblastic anemia in which the, say, serum iron load is too much, and that we find in the cases of thalassemia. Similarly, in chronic infection, the iron goes down. But in iron deficiency anemia, one thing is very peculiar, that bone marrow pearl stain is negative. It is, the value is 0. Another film, a report of the CVC, which is showing that hemoglobin is around 10 and RBC count is 2.69, that is low. But this MCH value is very high, that is 39.6, and MCV is also high. So this kind of picture we find in the megaloblastic anemia. When we look at the film, the size of RBC is bigger than the normal, and it is almost equivalent to the WBC size. or say like small lymphocyte, we find this picture, and there is a macrocytosis in this film. So RBC size, when it is different, we call it anisocytosis, in which we find different size of RBCs. And in poikilocytosis, there is a different shape of the RBC which we find. I am just going little fast because we have many of the slides, so which will give us some clue regarding the shape of the RBC, how different they are in different kind of diseases. This is the polychromasia, in which there is hyperpigmentation. Such kind of picture we find in the cases of thalassemia, in which because the overdoses of the iron, the RBC they get hyperpigmented. Then there is a spherocytosis, which is seen in certain diseases like liver disease, thalassemia, hemoglobin disease, and post-splenectomy patients. Now we just see little bit of WBC. We all find that the normal range is 4 to 18,000 per say cubic liter, and the neutrophil value is 50 to 70, eosinophil is 1 to 5, basophil is up to 1%. So neutrophil, when the TLC count is more, we must suspect 3-4 conditions. It could be because of the bacterial infections in which the TLC count is very high, but most of the time if the infection is acute, then the polymorphs are very high. In children, the lymphocytes, and in chronic infection, again the lymphocytes, they are very high. Then second condition is the tissue destruction, tissue infarct or burn. After that, the neutrophil count goes very high. Third is the leukemia reaction, and fourth is the leukemia itself, in which we find count even in the lakhs. And neutropenia, when we talk of the less count, that is less than 4,000, that is seen in the bone marrow diseases, certain infections like typhoid fever, like viral fever, brucellosis, and in certain anemias and the bone marrow disease like megaloblastic anemia. Eosinophil count, whenever it is high, more than 6, then we must consider about something like allergy or parasitic infection. And sometimes in chronic bronchitis also we find the eosinophil count. So these are the conditions in which the eosinophil count is very high. Now we talk of the platelets. This term has become very popular after the dengue fever, in which dengue we find, say, platelet count is low, it is 10,000, it is 15,000, it is 1 lakh, like that. Every day we just see the report and we just see for the platelets. We never see for the PLCR. That is written in the lower part of the, say, CBC report. So platelet count, it is normally 1.5 to 2.5 lakhs per cubic mm. But if the platelet count is low, suppose if it is around 10,000, but the PLCR value is very high, it is more than 55, then don't worry whether it is dengue or anything, the count will go up. But if PLCR, that is large platelet cell ratio, if it is low, and even if the platelet count is around 1 lakh, you must be sure that this count will further go low, and you must be mentally prepared for the platelet transfusion in future in these patients if they are suffering of some disease like viral fever or some dengue-like diseases. So talking of the platelets, in the part where it is increased is the after exercise, in pregnancy, high attitudes, and splenectomy patients, and the count is very low in the physiological disease like, say, menstruation. It may be less after hemorrhage and certain viral infections like septicemia and dengue fever. And some of the diseases of the bone marrow, they are associated with the, say, low count of the platelets, and sometimes in the patients of leukemia we may find like this picture. Talking of the red blood cells, they are decreased in trauma and surgery, and after GI bleed, there may be a impaired, say, after a impaired production like, say, anaplastic anemia, and there is an increased destruction like some G6PD deficiency or hemolytic anemia, maybe certain kind of infection or disseminated intravascular coagulation. The count of RBC is increased in polycythemia vera or in high attitude persons, and certain diseases like COPD, pulmonary hypertension, and obstructive sleep apnea, we may find a high count of the RBC. When we talk of the reticulocyte count, which is normally 1 to 2%, and we note that this is causing anemia inside or outside. So this distribution of the red cell, distribution with the BIT, is quantitative, which measures a numerical expression of N isocytosis. And that indicates the distribution of individual with RBC volume. When we see RBC on the peripheral smear, we may find many of the diseases which we can diagnose, like megaloblastic anemia we can see. If the size of the RBC is equal to the size of the WBC, then this is megaloblastic. In iron deficiency, the size is less, so that is microcytic. Then certain other conditions like, say, sickle cell anemia, in which it is like that the shape of the, say, sickle. And thalassemia, we may find a nucleated RBC. So the cells of RBC, they may be different in different kind of diseases, like macrocyte cells, which we may find in vitamin B12 diseases and chronic alcoholism and in the certain liver diseases like NAFLD. Then there are the teardrop cells. Hardly we have heard these names, but they are seen in the newborn and in thalassemia major. Then there is spirocytes, that's again a variation of the RBC, and in which the hereditary spherocytosis is there. There sometimes after AVO incompatibility, these kind of cells develop, and these kind of cells are also seen in the after post-transfusion and certain patients of burns. Then the elliptocytes. There are normochromic cells which are normally less than 1% of the RBC, and they are seen in certain patients, which is very common in malaria and megaloblastic anemia. Then we come to the Burr cells, which is known as echinocytes, because the shape that looks like echinocytes, cyst, and they are seen in the renal failure patients in dehydration, and after giving the fluid and correction of the, say, electrolyte imbalance, the cells, they become normal. Then we come to the spur cells, or they are also known as acanthocytes. They are having small spurs like the osteophytes. It looks like that. They are seen in the patients of vitamin E deficiency, malabsorption syndrome, and after post-splenectomy. Bite cells, which are also known as degmacytes, they appear as a cookie, look like a cookie, and with a bite taken out. You just see the shape of these two cells which are visible over here, and they are seen as G6PD deficiency. We find this kind of, say, cells, and there is some serum bilirubin is raised, or especially after taking certain drugs like chloroquine, then we should go for a G6PD test in these patients. Then stomatocytes. When we examine on a dry smear, it has a central slit or stroma which is seen in various conditions of liver diseases and certain malignancy, especially the cancers. Howell-Jolly bodies. It's a very popular term. Sometimes we find a short note for this Howell-Jolly bodies. It's associated with a rapid absorption of the RBC, and which is seen in the newborns. It is seen in megaloblastic anemia. Then it is seen in the hereditary spherocytosis. Hinge bodies. Hinge bodies, they are visible, they are inclusion of the denatural hemoglobin, which is caused by oxidation of hemoglobin portion on the hemoglobin. And the causes responsible for these bodies, which we find in the peripheral smear, the certain drugs and certain foods like the flava beans and onion, they can also give rise. Sometimes there is a reaction also, so after that these bodies are produced. Sideroblastic granules, which are seen after repeated transfusion in the patients of hemolytic anemia and thalassemia, and also in the lead poisoning. Then we come to the sickle cell. It is very popular. If someone is having sickle cell anemia, then the chances of malaria are least in these patients, because this parasite does not survive in this kind of RBC. So if you find a sickle cell, that means he is not going to have any malaria. People, they are homozygous for hemoglobin S and heterozygous for hemoglobin S and other thalassemias, in which we find this kind of picture. Now we come to the nucleated RBC, and these are the cells which shows that there are immature cells seen in various kinds of anemias, especially the megaloblastic anemia and certain fungal or mycobacterial tuberculosis infections. These kind of cells, they are seen, but often they are missed. Then we come to the basophilic stippling. That is the numerous small purplish inclusions which results from the RNA and mitochondrial remnants. And this kind of, say, especially stipplings, they are seen in the lead toxicity patients, thalassemia and macrocytic anemias. Here we see the carboat ring, which is very common in the pernicious anemia. We find a ring-like structure inside the cell with a small nucleated elements, which is seen in various leukemias, lead poisoning, and alcoholic jaundice. That is the Rolex formation. Lux formation is seen in the, it's a kind of stake-like arrangement of the red cells, where the biconcave double surface of the RBC and they are next to each other put like this. So erythrocytes, they are put in a different fashion, look like a ring. So they are seen in the connective tissue disorders, some patients of diabetes, uncontrolled malignancies and multiple myeloma, and increased in the cathodal proteins such as immunoglobulin deficiencies. So coming to the end of the talk, CBC, which is, we all know that it is an inexpensive tool and powerful tool which provide information about the blood and also about the marrow and the health state of the body. It is mainly used to diagnose bone marrow aplasia, nutritional deficiencies, thrombocytopenia, autoimmune conditions, infectious and parasite condition, malignancies, other than the, say, anemia and the basic things like, say, some infection. So these are the things. And that is all I can share with you. Thank you all members of ACP and our governor, Dr. Anuj Maheshwariji, Dr. N.S. Verma and Anubha, who is the scientific chair. So we enjoy the hospitality and skill of our friend Dr. L. Srinivas, who is organizing, say, secretary for this conference. Thanking you very much.
Thank you, Dr. R.S. Singh, for a wonderful, clinically informative talk. I am sure there must be some questions, if there are any questions.
Sir, normal platelet count is 1.5 to 2.5 lakhs, right, sir? And if you see PLCR, it is around 13 to 25, 13 to 45. If you see the PLCR value, say it is 13 to 45. Suppose the platelet count, it is around 1 lakh and PLCR value is 10, less than the normal. I told na 13 to 45. It is, if it is 10, then you must be sure that there is no formation of the platelet because it is a precursor. Say large platelet cell ratio, it is a precursor of the, say, platelet. So there is no formation. So this count will further go down. Suppose patient is suffering of dengue, then this count next day may be 70, maybe 65, maybe 45. So you need to worry that sometimes there may be need of, say, platelets. Next day you may have to give jumbo pack. And if this patient, the other patient who is having a platelet of 40,000, but his PLCR is 57 or 65, it is seen in the report, if you just see it, it is 57. Need not to bother. Start just give infusions, normal saline, sometimes DNS, and after 2-3 days you will find that suddenly there is, say, a normal count like 1.54, 1.96. It goes very fast. In 3 days, patient recovers most of the time. So if we say, if there is villagers or they don't, the person, those who have not been investigated, they never got their, say, CBC done during the fever, they don't realize. But if they improve, that means their PLCR was good. That's why they recovered well from dengue. That's the only reason. Thank you, sir.
Thank you, sir. We will go to the next speaker.
Thank you, persons, and thank you, audience, please. Thank you.
Can I have the biodata of the next speaker? Yeah. Dr. Jyoti Bajpai. She is Assistant Professor, Department of Respiratory Medicine, KGMCU, Lucknow. And she is a co-nodal officer, NDP Core Committee. She has 54 publications, both national and international, received number of awards, recognitions, and fellowship. And she'll be talking on combination therapy in pulmonary arterial hypertension, a paradigm shift. Over to you.
Very good afternoon to all present here, my seniors, colleagues, and dear juniors and respected chairpersons. Myself, Dr. Jyoti Bajpayee, I am going to present coming 20 minutes about combination therapy in pulmonary arterial hypertension, a paradigm shift. This is my working institute, King George's Medical University, and my department. So let's start with the introduction. So pulmonary hypertension refers to elevated pressure in the pulmonary circulation that are caused by either pulmonary vascular remodeling and inflammation or increased pressure known as precapillary or postcapillary pulmonary hypertension. Its prevalence is around 15 to 50 patients per million in Europe and United States. Different types of pulmonary hypertension can require different treatment, but all forms of pulmonary hypertension are serious and can be life-threatening. This is a very beautiful paper from Lancet Respiratory Medicine Journal, published in 2016. It's about the prevalence of pulmonary hypertension globally. So there are three kind of areas like red, yellow and green. So green areas are high prevalent, green areas are countries where the high prevalence of pulmonary hypertension, and the yellow are the area where the prevalence is medium, and oranges are the area where the prevalence is low. And the 80% of the population with PH are from developing countries. It is due to lung diseases, heart diseases. And one beautiful paper in Kerala registry by Dr. Hari Krishnan in India about the pulmonary hypertension. This tells about 48 per million adult population belongs to pulmonary hypertension. Now coming to the groups of pulmonary hypertension. There are 5 different groups of pulmonary hypertension that are based on the causes. Group 1 is pulmonary hypertension. It is known as PAH. So there is a lot of confusion what is PAH and what is pulmonary hypertension. So pulmonary hypertension is totally divided into 5 groups. Group 1 is known as PAH. So I am going to discuss about this therapy in PAH group. So these are the 5 groups. Group 1 includes like about 9 entities, including the idiopathic pulmonary arterial hypertension, heritable PH due to BMPR2 and other gene mutations, drug-induced and toxic-induced PH, and PH due to CTD-associated HIV, infection, schistosomiasis, portal hypertension, congenital heart disease, and pulmonary vascular occlusive diseases, pulmonary capillary hemangiomatosis, and persistent pulmonary hypertension of newborn. These classes and these groups comes under the group 1 PH. This is known as PAH. And the group 2, which is the most common kind of type of PH, is due to left heart disease. Group 3 is due to the lung diseases like ILD, COPD, and the other diseases which can lead to hypoxia. And group 4 is CTEPH and other pulmonary artery obstruction. This is a revised classification from 2022 ESCI ERS guideline. And group 5 includes due to the multifactorial mechanism like hematological disorders, some thyroid disorders, systemic and metabolic disorders. These are the common drugs which are associated with pulmonary hypertension. So aminorex, fenfluramine, dexfluramine, and there are some possible causes like cocaine abuse and some alkylating anti-cancer drug like alkylating agent and bisotinib. So these are the drugs which can cause pulmonary hypertension. So pulmonary hypertension is a very complex disease because it is a pathophysiological disorder that may involve multiple clinical conditions that may be associated with a variety of cardiovascular and respiratory diseases. And the complexity of its management requires a multifaceted, holistic and multidisciplinary approach with active involvement of patient with PH in partnership with clinicians like cardiologists, pulmonologists and physicians. Little bit about historical background of PH. So first description was given by von Romberg in 1891, and then after that first human right heart catheterization was done by Forsman on himself in 1929. His 2 students, Conrad and Richard, go through this, and they have received Nobel Prize in Physiology in 1956 because they have studied a lot about pulmonary circulation. In 1951, Dresdel described some case series of PH. And in 1960, it was a very remarkable year, or maybe worse year, because at that time, pulmonary hypertension epidemic was happened due to the aminorex, the anorexic agents. After that, the consensus was made. The first World Symposium was happened in 1973 in Geneva, Switzerland. They defined classical and historical definition of pulmonary hypertension on basis of right heart catheterization. So they defined pulmonary hypertension when the mean pulmonary artery pressure is more than equal to 25 millimeter of Lg. After that, the recent in 2018 in Nice, France, the 6th World Symposium was happened, and they they cut down this value up to 20 millimeter Hg. Now the new definition is mean pulmonary arterial hypertension if more than 20 mmHg. Why this happened? Because they have seen in multiple registries and multiple data, the pressure in between 20 to 24, they have a progressive disease and they have a greater mortality and morbidity. So they have reduced this value from 25 to 20. Normal pulmonary artery pressure is about 14 plus minus 3.3 mmHg. So the two standard deviation value has been taken as a pulmonary hypertension. MPAP is more than 20. So this is on the right side, this is a pathological form of pulmonary hypertension artery. It is an intimal fibrosis, endothelial proliferation, and medial thickening, smooth muscle cell hypertrophy, and hyperplasia. So now recently in 2020, the ESCRS guideline for the diagnosis and treatment of pulmonary hypertension has been published, and there are a lot of changes in the definition, management, and risk stratification criteria also. So now coming to the one more point included in this definition is pulmonary vascular resistance. Initially it was more than 3, but now it is more than 2 Woods units. So pH is defined as mean pulmonary artery pressure more than 20 mmHg. Pre-capillary pulmonary hypertension was defined by mean pulmonary artery more than 20, pulmonary artery wedge pressure by right side pressure less than equal to 15 mmHg, and pulmonary vascular resistance more than 2 Woods unit. Post-capillary or isolated post-capillary or due to the left heart diseases, pulmonary hypertension is due to where all two things were same, but only pulmonary artery wedge pressure more than 15 mm of Hg. And they have also included the exercise pH definition, also included in this new guideline. So what are the challenges with this new definition? Old definition was the basis of all treatment trials because all the trials they were included the old definition of pulmonary hypertension. Now our definition is new criteria has been changed, but still we are having the same drugs and same trials. There is no new, maybe new trials are going on, but with the new definition, but the old trials which we have, the basis is only old definition. So we don't know how to treat patient with MPAP between 20 and 24 millimeter of Hg. New definition may lead to overdiagnosis and overtreatment for pulmonary hypertension. So what are the common presentations for pulmonary hypertension? They are very non-specific symptoms and include exertional dyspnea, fatigue, weakness, chest pain, lightheadedness, syncope, less frequently cough. Initially these symptoms are induced by exertion, but later in a stage, the disease when progress, it occurs at rest also. Due to non-specific nature of presenting symptom as well as lack of awareness, appreciation of pH in the medical community, the diagnosis of pH is often delayed. These are the physical findings: raised second heart sound, right ventricular heat, JVP distension, hepatojugular reflex, ascites, hepatomegaly, splenomegaly can be seen, edema, TR and PR murmurs, and S3 gallops. Now coming to the one case. A 44-year-old woman with hypertension with complaint of progressive dyspnea for last 6 months only. She reports having dyspnea when walking up the stair, despite being physically active prior to this experiencing dyspnea. She also reports fatigue and occasional dizziness. She used to smoke but quit about 10 years ago. No history of cough, wheezing, orthopnea and palpitation. Her medical history is otherwise remarkable. These are the physical laboratory findings. All were within the normal limits like hemoglobin, blood sugar and other parameters. Her BP was 130/80. Body mass index was 28 kilogram per meter square. No evidence of peripheral edema, auscultation, breath sounds normal, heart sounds are normal. Only on ECG unremarkable except for non-specific STT wave changes. A chest X-ray and PFT was normal. So my question is this: what is the most possible diagnosis? After pH is a diagnosis of exclusion, so I have to exclude all the causes of which are given in the options like acute pulmonary embolism, heart failure, COPD and pH. Patient not belong to acute pulmonary embolism because patient is having dyspnea for last 6 months. Heart failure, there is no sign, symptom and other parameters are normal, so no evidence of heart failure. COPD, she quits smoking and her PFT is normal. And other things are, age is also not so much. So COPD is also excluded. So I just want to highlight here is the pH could could be the possibility for this patient, the most possible diagnosis for this patient, because this is a diagnosis exclusion and we have to exclude all the causes of dyspnea. My next question is about what should arouse the suspicion of PH in this patient. So her prior history of smoking, her history of hypertension, her symptom of fatigue and dizziness. No, these symptoms are not provide the suspicion of. So that common cause of dyspnea have been ruled out. So first thing, whenever you see the patient of unexplained dyspnea, first to rule out the common causes of dyspnea, then again further proceed for the diagnosis of PH. It could be the PH. So delayed diagnosis of PH, as I earlier told you, it is a very important factor for the prognosis and management of the pulmonary hypertension. This has been shown in the multiple registry that the median delay of about 2 years in 21% of the pulmonary hypertension. The French registry show there are about 27 months of delay. Revealed these are the very famous and common registry for the pulmonary hypertension. 33 months in the United States, and Australia registry show there are about 47 months of delay in pulmonary hypertension diagnosis. So diagnosis is very challenging for PH. So we have one good tool for screening is transthoracic echocardiography. It is the most important non-invasive screening tool, but still right heart catheterization remains a mandatory to establish the diagnosis. It is a gold standard. This is I have taken this slide from the 2015 ESCRS guideline. So I'm just highlighting the feature of pulmonary hypertension on the basis of decay. So most common, most sensitive parameter for this echo is TR velocity. Whenever we see the peak tricuspid regurgitation velocity more than 3.4 meter per second, and there is no need for the presence of other echo PS signs. So there are high probability of pulmonary hypertension. Then we can go ahead with the right heart catheterization in those patients. But whenever patient has a TR velocity less than 2.8 or not measurable, then there is no other signs of PH, then there is a low probability, and in between the patient lie in an intermediate group. So these are the probability criteria of pulmonary hypertension: low, intermediate, and high probability. Now coming to the management, PH management is moving forward the use of combination therapy in respiratory field, in the cardiology field. There are a lot of combination therapy, like in COPD and asthma, we are using a combination inhaler therapy. Like in hypertension, we are using a combination hypertensive therapy. In heart failure, we are using. So now therapy, combination treatment in the picture now. So better management to stress is early diagnosis. First to stratify your patient on the basis of criteria, combination, then start with the combination therapy. And when patient not respond to combination, then escalation. There is one more option to starting with escalation therapy, like triple and quadruple combination therapy also. This is a very important slide. I think it is visible, but it is a very complex slide, and this is a very important on the basis of what, when we diagnose the PH, first to identify the risk, stratify your patient. On the 3 strata, this guideline prescribe only 3 strata and 4 strata risk stratification classification. So on the basis of this, there are 10 values have been given, like sign and symptom of heart failure, progression of disease, WHO functional classification of PS, 6-minute walk test, and cardiopulmonary exercise testing, borderline BNP and anti-pro-BNP test, echocardiography, and cardiac MRI also, and hemodynamic means right heart catheterization. There are a lot of parameters have been given. I can explain only 2 or 3, like 6-minute walk test. If your patient is having 165 meter or less than 165 meter of 6-minute walk distance, it comes under the high risk of category. Your PVR BNP values are if more than 800 and more than 1100 in anti-pro-BNP, then if a patient comes under the high risk of category. So after categorization, you can identify what kind of management to be given in this patient. So 30 years ago, no treatment for PH. 20 years ago, only one treatment for PH. Today, only we have a dozen of drugs for management of PH. And revealed registry showed that improved survival from 2.8 years to approximately 9 years after the diagnosis. There are 3 target therapy pathways in the PH: prostacyclin pathway, nitric oxide pathway, and endothelin pathway. And the prostacyclin pathway, we have iloprost, antiprostacyclin, and selexipag. We have an oral prostacyclin with us now, is a selexipag. Nitric oxide pathway, we have sildenafil, tadalafil, and riociguat. Riociguat belongs to the soluble guanylyl cyclase stimulator. And endothelin pathway, we have bosentan, ambrisentan, and mesentan. So first therapy was developed in 1996, epoprostenol. After that, so many of years, we have a lot of therapies with us for pulmonary hypertension. So early is better, like in every disease. So same as in PH also, early is better. So early intervention gives no functional impairment and prolongation of life. Late intervention leads to progressive remodeling and right heart failure. These are evidences for upfront combination therapy like Ambition trial, Italy trial, Triton trial, and Sitbon, and there are various studies for this combination therapy. In 2015, ACRS also recommended for ambrisentan, tadalafil as a first combination therapy, and it has a group 1B recommendation. Those patients who is having WHO functional class 3 kind of presentation, and other ERA and phosphodiesterase 5 inhibitors got the recommendation of 2AC. So this is a slide about risk stratification in medical therapy of pulmonary hypertension. Whenever a patient who is a new patient without any treatment is coming to us, and we diagnose as a case of pulmonary hypertension confirmed by the expert, and we did not do any non-vasoreactive test was not performed, then we have applied the risk stratification criteria for those patients, which was I have shown you in 2022 guideline. If patient comes under the low or intermediate risk, we can immediately start initial oral combination therapy. If patient belongs to high risk group, we can start with the dual or triple combination therapy, including the prostacyclin analog. Then after 3 to 6 months, every PH patient should be followed by after 3 to 6 months by different 4 strata risk stratification like WHO functional class, 6-minute walk test, and NT-proBNP. On the basis of this, we can again classify these patients into low, intermediate, and high risk. If patient belongs to low risk, then continue the same treatment. If patient belongs to high risk, we can add a sequential selexipag or other combination, other therapies to those patients. So this is a recommendation from ASCRS 2020 guideline. Recommendation for initial oral drug combination therapy for patients with idiopathic heritable or drug-associated pulmonary arterial hypertension without any comorbidity, cardiopulmonary comorbidities. The recommendation said that initial combination with ambrisentan tadalafil as a class 1B recommendation. An initial combination therapy with macitentan and tadalafil also recommended, and they have a same recommendation of 1B. So these two drugs can be used for the upfront combination therapy in our patients.
2 minutes more, please.
So these are the slides of the dosing of ambrisentan. Dose is 5 mg, 10 mg, and macitentan 10 mg for managing our patients. So PH is an incurable disease and may progress silently even on the days when the patient feels fine. 22% of the patient in Triton trial and Seraphim in 32 patients in Seraphim trial and 29% in Ambition trial. It means 22 to 32% of PH patient progress despite dual therapy. So this is an Ambition trial in which 18 to 75 years of age patients were enrolled from class 1 PAH, and it has shown that 18% of the participants have very less outcome in comparison to monotherapy and dual therapy. They have higher risk of progression in the disease process. This is an Optima trial about the macitentan and tadalafil. They showed that about at the 16th week when we performed the right heart catheterization, overall pulmonary vascular arrest is reduced by 47% by combination therapy. This is a Triton trial which showed the selexipag, macitentan, and tadalafil combination, but it doesn't fit the primary outcome criteria. So this is not recommended by this 2022 guideline as an upfront therapy, upfront selexipag, macitentan, tadalafil combination for management of PH. But it can be added as a sequential way for those patients who are still on a high risk and not responding to those drugs. Now, suggested assessment and timing for follow-up to our patient. Every patient should be followed at every 3 to 6 months on the basis of 6-minute walk test, blood testing, NT-proBNP, ECG, echocardiography, ABG, and cardiopulmonary exercise testing if we have, and right heart catheterization. So my take-home points are: suspect, diagnose and treat early. Stepwise approach to optimize risk stratification is a key. Current practice guidelines for the treatment of PH propose a treatment algorithm according to the patient risk factor. A more aggressive approach improves survival in PH. Data support the rationale for targeting multiple pathways in PH. Upfront, dual or triple combination therapy is recommended to improve outcome as per risk stratification criteria. Selexipag is a novel, orally available, highly selective prostacyclin receptor agonist with us now from the Griffon trial data showed very promising data from Griffon trial. These are my contribution to pulmonary hypertension from our department. Thank you.
Thank you for a very exhaustive coverage of pulmonary arterial hypertension. We are running 20 minutes late. I think the secretary is angry with me. And the next speaker is none other than the dynamic secretary, Dr. L. Srinivas. I don't think he needs any introduction, but he has promised me that since he's very busy, he'll finish his talk in 10 minutes.
So good afternoon, sir. Thank you very much, sir, obliging the time, because we are running late and there is a felicitation program supposed to start at 6:15. There are a lot of people who are eagerly waiting, and the next stall is running about 50 minutes late. So that's why we thought the timer. So
We are much better off. We are much better off.
The change will start with me. So be the change you want to be. So good afternoon. Thanks again for being here in this conference and making it very successful. Let's move on to this novel approach for diabetes control. We know we've been getting a lot of drugs in our armamentarium to approach diabetes in different ways. And today we are talking about the glimins, which is a newer class of molecules, which is supposed to have a basic pathophysiological defect correction through their novel mechanism of action. Just to say the background, type 2 diabetes starts at younger. We have complications at younger. 1 out of 3 patients in our country have CVD, and 36% only have got a good control in spite of all these class of drugs which we have. And we know CAD accounts for about 80% of deaths and 75% of all hospitalization in diabetic subjects. Timer is not changed. Timer has to change. So diabetes definitely remains a huge risk for most of our patients, and as you can see, this is another study which shows that the micro and macrovascular complications appear very early in our country. And this talks about diabetes-related complications, which again appear quite early, whether it's hypertension-related, kidney disease, dyslipidemia, nerve disease, and this is a progressive disease which, in spite of your basic drug metformin and others, it is not still well controlled. And this is an interesting subgroups classification which is done in the Europe, was translated to our country, and it was found that the severe insulin deficient diabetes, you can see, you can see the severe insulin deficient diabetes there, which when you extrapolate this data, of course, we are also doing a lot of data is being done now of late about these types of subtypes of insulin, and the severe insulin dependent, that is something which is there, and these were described in the Europeans earlier. So the beta cell dysfunction is the key defect with reduced glucose reuptake at the liver, and increased hepatic gluconeogenesis is something which is the basic, and these are the reasonings why the metabolic derailments happens and eventually results in systemic hyperglycemia. You can see there the increased lipolysis and increased insulin resistance at the level of pancreas is the one which happens eventually in most of our patients. And hyperglycemia and mitochondrial dysfunction. So this is what is the new concept now, that the mitochondrial dysfunction and the basic irregularities need to be corrected, and this dysfunction can be either due to genetic or environmental factors both, and eventually there is an inappropriate fuel substrate utilization. I'll just explain that. And as you can see here, we know at the heart of the matter, the mitochondria is the kitchen of your body, which fires the metabolic reactions in the body. And this is all well explained. I think biochemistry, we need to just replenish in our memories that the ATP or the electronic transport chain or the complexes, what we call, this beta cell or the smooth muscle activities depends on whether you're fasting or in a fed state. And the mitochondria has got a capacity to switch between these two. And when this switch defect happens, either due to obesity or insulin resistance, or when there is a pro-inflammatory markers because of your obesity, the metabolic syndrome, then this gets off. And that's how it eventually results in metabolic syndrome. So this is what I was talking about, the underutilized nutrient substrate, where in a healthy diet, you can see on the left-hand side, the glucose and fats oxidates pyruvate and acetyl-CoA that enters your TCA cycle, and the mitochondrial transport complexes 3 and 5 mediates the insulin sensitivity and the insulin resistance. That means it increases the insulin sensitivity, reduces the insulin resistance, preventing the complications. Whereas this gets in diabetes or obesity, gets affected, and that is where you result in increased oxidation, increased the TCA cycle gets stimulated, and you have the mitochondrial transporter defect, that is your complexes, transport complexes, and it eventually results in the rage, all the other inflammatory markers. So the nutrient overfeeding or underutilization eventually results in mitochondrial dysfunction. That's the new theory, and this is the triad which is around this mitochondrial dysfunction. So this imiglumin is a mitochondrial re-energizer which is supposed to correct this. This is the innovator molecule, the brand name you can see there. It's approved in Japan and in China in about 2 years, and this is the first glimins class molecule. Now what are these? Let us look at the imiglin as a molecule. It very clearly mimics the mitochondria, I mean the metformin, and except that there is a 2 additional C atoms with a cyclopentane ring, and thus it suggests that the complementary unique cellular targets of mitochondrial respiratory chains and the redox factor synthesis, which we just saw the basic defect, and it tries to correct that. So it's a first in the class molecule which is recognized by WHO. It was researched in 2007, and it's a unique mechanism of action. Targets basically the impaired glucose uptake by muscle tissue, the excess hepatic gluconeogenesis, and increased beta cell apoptosis. It is supposed to tackle all these 3. And of course, it's been studied in various randomized clinical trials. So it modulates these mitochondrial complexes, the 2 and 3, and eventually results in 5, which is helpful. So this is the proposed mechanism where the red arrows indicate changes in the levels or activity observed in experimental models. And imiglumin, as you can see, it increases the complex 3 and increases the redox factor, and thus you saw this earlier slide in diabetics and obese patients. It reverses this and reduces this compensatory hepatic glucose output, and thus it is supposed to reverse and reduce this pyruvate cycle which is stimulated in that fed state, and supposed to reverse these basic defects, reducing the pro-inflammatory markers. So as I said, it's a mitochondrial re-energizer where it increases the beta cell function, reduces the hepatic gluconeogenesis, increases the glucose reuptake at the liver level, and all these 3 basic defects it is supposed to correct it. So this is again what we are showing. Beyond the glycemic control, the pleiotropic effects apart from at your pancreatic level. And also it's supposed to improve this SERT. That is a pathological stimuli which predisposes to the sudden cardiac death, where this NAD depletion will happen, and imiglumin is supposed to replenish this. We will not get into these mechanisms for want of time now. So eventually it increases the ATP, AMPK, and the SERT to modulate early control of this mitochondrial dysfunction. Now this is an interesting slide where we are showing the mechanism of action of this imiglumin complements DPP-4 and SGLT2 inhibitors. You can see imiglumin on this first one where beta cell at the skeletal muscle level, the cardiac energetic, insulin secretion, inhibition of hepatic gluconeogenesis, insulin sensitivity. and it complements some of these actions which these class of drugs cannot act on. So what are the pleiotropic benefits? I'm showing some evidences. Short and long-term administration of imeglimin counters cardiorenal dysfunction in the rat modules. Mitochondrial targeted drugs for DKD, where it showed the favorable safety profile in CKD3B and stage 4, and there is no serious adverse events. Another study, imeglimin prevents heart failure with preserved ejection fraction, HFpEF, recovering with impaired unfolded protein response in mice subject in cardiometabolic stress, where it reduced the body weight, visceral fat, and improved glucose tolerance and systemic inflammatory response. And that's the basic pathological defect it tries to correct. It also optimizes glycemic control in the OAD responsive cases, and that's the evidence to assess the efficacy and safety of imeglimin monotherapy compared to the placebo for 24 hours. And it's a Japanese study where the primary efficacy endpoint was change in the A1C level from baseline to week 24. Secondary endpoints usual, including the HOMA, to study your insulin resistance. And these are all the evidences of phase 2B. For want of time, we are not discussing this. You can see 500 mg, 1000 mg, 1500 mg, all were studied. And eventually, this is the time studies which talks about the phase 3 studies of RCTs, 1000 mg, twice a day, 24 weeks. And you can see the number of subjects in each study. They are called time studies. And this is an open label parallel group trial that assesses the long-term safety and efficacy of imeglimin in Japanese patients. 1 year long study clearly showed A1C reduction from baseline ranging from 0.5 to 0.9%. And that's something as an add-on to all our class of drugs which are available. So it is supposed to be an add-on good molecule whenever you're looking for some alternatives in your treatment. Major metabolic added effects, that is pleiotropic effects, the better insulin release in both phases of insulin, so it tries to correct both phase 1 and phase 2 of your insulin secretion, protects beta cell better than exenatide, shows cardio and renal benefits in preclinical rat modules, and 500,000 mg tablets, currently I think only 500 is available for the treatment of diabetes, as monotherapy, as an add-on at whatever level you think you can look into. There is a complementary A1C reductions when it's monotherapy up to 0.9%, add-on to metformin you can see 0.6, Sita, SGLT2 insulin, it's about, so 0.6% on an average, it can also reduce the proinsulin, thus increases the insulin levels, and improvement in the 24 hours glucose profiles. There are studies, for want of time I'm skipping that. So to have highlights about this molecule, it's a first in class glimin with unique site of action. It improves the respiratory chain complexes and redox factor, which eventually impacts the insulin sensitivity and secretion, modulates, corrects the beta cell function, hepatic gluconeogens and glucose reuptake. There are 8 RCTs involving about 1,600 cases, which has clearly shown the efficaciousness of this, and it's safe and tolerated with negligible GI or hypoglycemia issues, unlike metformin. Thank you very much for the patient here.
Thank you. We just finished in 10 minutes for keeping the promise. Any questions?
I have to, no questions are allowed, sir.
No questions.
Questions, they can ask me off the stage, not
Okay. Then they can ask you questions over dinner.
Yes.
Thank you.
Thank you, sir. Thank you.
Thank you, honorable speakers and chairpersons. I would like to request our chairperson and speakers to collect their facilitation gift from MediEquip stall. And for the next session, I would like to invite Dr. Ritu Tiwari to conduct the next session.
Very good afternoon to one and all gathered here. So let's move on to the next session. So regarding this, I would like to call upon the judges, chairperson of this session, Dr. S.K. Gautam, Professor of Medicine, GSVM Medical College, Kanpur, and Dr. A.P. Yadav, sir, MD Medicine, Consultant Physician, Cardio-Diabetologist, Varanasi, Life Membership of API, RSSTI, ACP India Chapter, UPDA. I request you to please introduce and invite the speakers of the session. Over to chairperson.
No questions. 16 minutes.
Okay, moving to the next topic, straightforward. So our next
speaker is Dr. Dhruvi Hasnani, and the topic given to her is multiple autoimmune syndrome. Dr. Dhruvi is a MD Fellow, Royal College of Physicians, is a Fellow of American College of Physicians, is a consultant diabetologist at Rudraksh Institute of Medical Sciences. He's a HOD there in the Ahmedabad and treasurer of RSTI Gujarat chapter, winner of the Torrent Young Scholar Award for Diabetes, faculty of National Diabetic Education Program, and many more. So he's having many publications in the national and international journals. And over to you, Dr. Dhruvi.
Thank you. Good afternoon, respected chairpersons, all our audiences. We are a small group of people, so, we'll make it as interactive as possible and we'll make it like a story. I am Dr. Dhruvi Hasnani, and at the outset, I would like to thank the organizers, Dr. Anuj sir, Dr. LSM sir, and Dr. Anubha ma'am, Dr. Narsingh Verma sir. My topic today is, multiple autoimmune syndrome. We fell upon this topic while saying that, I'm a physician, I'm a trained diabetologist, and now I'm training myself in endocrinology, and this would be my choice to talk upon today. So it was late in the 1950s where people started to talk about immunology as a specific branch. And there was this scientist who said, that it was autoantibodies giving the autoimmune disorders. And in the late 1980s, there was this doctor called Dr. Newfold. He said, let us classify all of these autoimmune disorders and let us see when they are clubbed together or when they are happening together in a certain person, what happens. So I start with the case. Dr. Chavda has been very gracious enough in allowing me to present a patient of his. This was a 23-year-old lady, she came to us with signs of vitiligo. And she also had a pre-established alopecia. And this was early in the 2019. And she's a very routine patient, comes to us for normal physical assessment and all. And then suddenly one day, she appeared at our doorstep with, some abdominal pain and signs and symptoms of DKA. And we identified it. We started her treatment for management of DKA, but then we started to do her full metabolic workup. We did her antibodies, and then we found out that she's a type 1 diabetic. That is why, of course, that is why she landed up in a DKA-like situation. And she also had positive thyroid antibodies. Now, it so may happen that in spite of being, having normal thyroid function tests, she still had positive thyroid antibodies. And this is what we will be talking on today. So there is a common origin of autoimmune diseases. There could be a co-occurrence of autoimmune diseases because of an individual or a familial predisposition. There are similarities in the pathophysiological mechanisms that underline these diseases when they occur together. And there could be a genetic proof or susceptibility in an autoimmune patient phenotypically because of environmental predisposition as well. So there are two terms now, if you see over here. There is multiple autoimmune syndrome and there is something known as familial autoimmunity. So these autoimmune comorbidities that you are looking at the big screen right now, I am focusing on the third row of it with type 1 diabetes, all autoimmune thyroid diseases, and along with it, there are some gastric autoimmune diseases as well, which we see in our patients with autoimmunicity. So this multiple autoimmune syndrome was a nomenclature which was defined in the 1980s as autoimmune polyglandular syndrome, when multiple endocrine glands were involved to portray out different autoimmune disorders like the thyroid disorders, the pancreatic disorders, type 1 diabetes, celiac diseases, or ulcerative colitis, or vitiligo, candidiasis, ectopic dermatitis, even primary biliary disorders. All of these were, together termed as autoimmune polyglandular syndrome until the 1980s, when it was this Dr. Newfold that I'm talking to you about came up and said that let us call it APS, autoimmune polyendocrine syndrome. And it is now that since the origin is not just endocrine system and it involves also gastric disorders and skin disorders, that we call it multiple autoimmune syndrome. There might be an overlap syndrome as well with the person having at least 2 autoimmune diseases in the same patient. They can be overlapping with the connective tissue disorders or they can be overlapping with the liver disease. So now, how do we define this MAS? There could be a coexistence of more than equal to 3 autoimmune diseases in an individual person. There could be a dermatological autoimmune diseases. It should be a key, especially vitiligo, like I presented in the case. 25% of the patients with an autoimmune disease, they will tend to develop another autoimmune disease. And that is why we are here talking about multiple autoimmune syndrome. The pathogenesis could be environmentally triggered, like the cytomegalovirus, and all of us are talking about the post-COVID autoimmune onset of a lot of diseases. And multiple autoantibodies could be present, and it could lead to multiple organ reactive autoantibodies, which we are calling it as multiple autoimmune syndrome. So now this is a beautiful slide. This comes from the Research Center of Seattle. It's a very latest slide. And it talks about the genetic basis of MAS. And why are we talking about the genetic basis? Because these autoimmune disorders are now in the process of being prevented. The latest news, the latest FDA news is that a molecule called teplizumab has been, made useful in preventing the onset of type 1 diabetes, which is an autoimmune disorder. That is why it is pertinent for all of us to understand that there could be some sort of genetic predisposition for all the disorders that we regularly see in our OPDs, rheumatoid arthritis or type 1 diabetes or multiple sclerosis, inflammatory bowel diseases, as well as lupus. So when we talk about the history, the disease history, there it is defined that this immunity, autoimmunity iceberg is what it defines or how it describes the natural progression of an autoimmunity disease. So it could be in the potential phase, meaning that the lymphocytic infiltration and autoantibodies have not yet expressed or attacked the target organ, but the autoantibodies are positive, and the person is still at a higher risk or susceptible at getting the autoimmune disease. The second is a subclinical phase, wherein the infiltration, the lymphocytic infiltration has happened. We have a subclinical format of the disease, and the person is showing some sort of symptoms or may not be showing them at all. And the clinical phase is an overtly manifestation of the disease altogether. So now when we talk about examples of this combination of MAS, the conditions may be present in either one of the format. It could be in the potential phase, it could be in the subclinical phase, it could be in a clinical phase. So if you look at these examples, it could be chronic thyroiditis or Graves' disease in the clinical format, along with another clinical overtly manifestation of an adrenalitis. It could also be along with a subclinical adrenocortical disorder. So all of us need to understand that the person might be manifesting the symptoms and signs or not, and you have to assess and screen the patient for other autoimmune disorders. So now, these again are some examples of all of these autoimmune diseases, and majorly that we are observing in all our routine practices is type 1 diabetes, along with some thyroid autoimmune diseases, along with autoimmune gastritis, celiac disease, and Addison's disease. The classification of multiple autoimmune syndrome is into 4 basic types. Type 1, which has APECD. It started when a family in the Texas, the Whittaker family, had a consanguineous or incestual reproduction. And that is why, since this is an autosomal recessive format of MAS, they could find mucocutaneous infestation of candidiasis, hypoparathyroidism, along with Addison's disease. And that is the type 1. Type 2 is, again, very, rarely found. It is the Schmidt syndrome. It also has type 1 diabetes along with the autoimmune thyroid disorders. The type 3, which is very, very prevalent in comparison to the type 1 and type 2, has the thyrogastric syndrome. It has type 3A, 3B, 3C, and 3D. Let's not go into all of the details, but it has endocrinological, gastrointestinal, the skin, muscles, and nervous tissues involvement, and also SARDs. There is also another type 4, but maybe some other time. Possible combinations of type 2 MAS could be, again, subclinical format or a clinically overt manifestation of the disease. The subtypes of type 3, again, I have made a slide specifically on this, or put it up, because this is a more prevalent format, and all of us are looking into thyroid disorders, specifically autoimmune thyroid disorders, very, very prevalently in our OPDs, and we need to understand that we have to check these patients with thyroid disorders, autoimmune thyroid disorders, for all the other autoimmune manifestations, or at least antibodies at some period of time, or at least screen the patients for signs and symptoms for other autoimmune disorders. This is a very old paper of 2003, but it was quite interesting to understand that what is the most maximally prevalent, the first disease manifestation in patients with MAS. And the first is type 1 diabetes, second is the Graves' disease, third Hashimoto's thyroiditis, Addison's disease, and then vitiligo. This is another slide which is talking about the most frequent combinations. Diabetes and thyroids are two frequent combinations of autoimmune disorders which need to be assessed and learned about in our people. Thyroid and adrenal score second, diabetes and vitiligo score third, and so on. Another interesting thing to understand is that there could be a time interval of manifestation. Not all of the autoimmune disorders manifest at the same time. It could be one after a period of time, there could be the second autoimmune disorder, and so on and so forth. So this slide, again, from the same paper is telling us that the most, the interval between two disorders from diabetes and thyroid, if you can appreciate the first bar, is 10 years. The least amount of time is between the development of thyroid, autoimmune thyroid disorder, and adrenal disorders or adrenal Addison's disease. All of these are very, very interesting to read, and this is a very old paper, but maybe we could, through the ACP, study more about that in the recent times. So now there are simple 5 W's which we should follow, and I'm almost summarizing it. Why, what, who, when, and how. So the first W of why, we have to test antibody profiles, which is important for differential diagnosis, monitoring, as well as prognosis of these autoimmune diseases. Early diagnosis is important, especially in clinically incomplete form of these diseases. Who should we screen? Who should we, identify MAS in? A case with one autoimmune disorder will also have the risk of having a second autoimmune disorder. And this is the person wherein you have to, try and detect or find out and screen for other signs and symptoms or autoantibodies. Index cases in MAS could be multiple sclerosis, rheumatoid arthritis, autoimmune thyroid disorders, type 1 diabetes, of course, IBD, and vitiligo. Even gastric ulcerative colitis or celiac disease is some place wherein you could find out other autoimmune disorders. In these cases, again, it is important to understand that positive autoantibody may or may not be present, and it ranges from 5% to 40%. Now, what should you check? There is a panel of autoantibodies to be measured, and it is clearly independent and on the type and nature of the index autoimmune disorder that is occurring in this person. Automated, there are multiple immunoassays that you can read or ask your laboratory to conduct, and we might not recall or remember all the autoantibodies for all the autoimmune disorders, but maybe we can go back, read our books, and come back with it. This is a simple table which I found for all these autoimmune diseases and some autoantibody assays that could be performed. Now, when should you perform? So autoantibody positivity may precede the clinical diagnosis by several years, and it may not manifest into an overtly clinical phase of the autoimmune disorder. Almost 5% of the patients who are affected by an index autoimmune disease may develop a second autoimmune disease even before or after the first disorder. A careful follow-up needs to be done of all of these patients, and it would suggest an autoantibody screening to be performed at least once in a year. So for our type 1 patients, we always say that you have to perform a thyroid autoantibody test at least once in their lifetime, a celiac autoantibody test once in 3 years. So a screening recommendation by the guidelines says that a requirement of high index suspicion of additional autoimmune, if you know all the types, you can conduct only those types of autoantibodies for those particular autoimmune disorders. Patients with MAS type 2, this reads PAS because it was the older one, now it has to read MAS, and their first relatives with isolated Addison's disease or type 1 should periodically undergo screening for development of hypothyroidism in particular. Screening of these antibodies may go against the thyroid panel, but again, make sure that you are checking the signs and symptoms. Absence of the autoantibody does not exclude the disease. A positive serology may or may not be present in all the patients. Requirement for a long-term follow-up and observation is necessary. Now, where should you do it? This is a big question. All of us are physicians or diabetologists or, primary care physicians and may not be working into setups where multidisciplinary help is, available. But it is important that we have the competence or referrals for multidisciplinary approach. You might need a gastroenterologist, you might need an endocrinologist, you might need an immunologist, and of course, a physician is the basic pillar for all of this. We need to optimize the use of autoantibody detection test, and we need to provide proper counseling for the test results that come up. And we need to choose the optimum therapy for the type of MAS that comes up in these different people. So the management and the key points, the management always depends on the type of index case or the index autoimmune disorder that is occurring in this particular patient. Endocrine autoimmune diseases may have a privileged associations with other organ and non-organ specific autoimmune diseases in the context of MAS, which we are talking about. And then there are 4 major types which we all read about. In patients with one clinical autoimmune disease, an antibody screening may discover other potential or subclinical formats of MAS. So with that, I'm going to thank you all for a patient listening. Thank you to the organizers and the chairpersons. Thank you, sir. Thank you, sir.
Well, that was very remarkable and ingenious presentation. Thank you, Dr. Dhruvi, for giving your valuable time, and chairpersons. Now, we'll begin with the next paramount session of the day. So I would like to call upon the judges of this session, Professor and Head of Department of Physiology, King George's Medical College, Professor Narsingh Verma, sir. Dr. Amitesh Agarwal, sir, Professor, Department of Medicine, University of College of Medicine, GDP, Hospital, Delhi.
Thank you, Ritu. So, for the next session, we are inviting to talk, pre-diabetes is real. Don't let the pre fool anyone. And for that, none other than Dr. Vasant Kumar, sir. I think Dr. Vasant Kumar do not need any introduction. Everybody knows him. He is past president of RSSDI, a very senior consultant physician at Apollo Hospital, Hyderabad, and immediate past president of RSSDI, founder and president Diabetes and Youth Society, and he is actively involved with RSSDI from last 15 years. Not only RSSDI, he is also very active in other societies. He is also vice president of the Indian Society of Hypertension and involved in other various important societies, guiding force for all of us, Dr. C.H. Vasant Kumar.
Thank you, Dr. Narsingh Verma, and all my friends here. This topic is coined by none other than Dr. Narsingh Verma himself. He wanted to make it very impactful, the word pre-diabetes is real, and don't let the pre fool anyone. So we're going to talk, and I'm sure I'll also try to take only 15 minutes to save some time. We're talking about pre-diabetes and prevention of diabetes. We know diabetes is not only a pandemic, it is also a global emergency. The way the numbers are, you can see we are expecting to have around 74 million people with diabetes in India, almost 1/5 of us. But what is the depressing situation is that 50% of our diabetic patients do not know that they have diabetes. That means they are not detected. And out of them, not even half of them have gone to the doctors, and out of those who go are not well controlled. So what does it mean? It means that maybe 10% of the diabetics are really under control for whatever means it is. I just wanted to know tell you the gravity of the situation. Now, let me focus on pre-diabetes, which is very important for all of us if we need to prevent diabetes. Basically, we diagnose pre-diabetes based on 2 factors. One is the fasting blood glucose, if it's more than 100 milligrams, or the impaired glucose tolerance after giving 75 grams of oral glucose, if the blood glucose is more than 140. we call it impaired glucose tolerance. Both can, one of them is enough to diagnose pre-diabetes. So what happens is if you are diagnosing pre-diabetes based on the fasting impaired glucose, we are almost seeing about 10% of the adults having diabetes, whereas if it is based on IGT, the number could be less. And of course, the WHO projects the numbers to go up more than double in another next 22 years. And this is ICMR study, we know that. So in this study, the overall prevalence of pre-diabetes in 15 states was almost 10%, 10.3%. So see, this is almost equivalent to the incidence of diabetes. So if you are looking at pre-diabetes and diabetes together, we are looking at 25% of the population, more or less. So this is what it is. We will look at the other things now. So we have, our biggest challenge is we have high number of young people in India. You also know that these are the young people who are prone for pre-diabetes before they develop diabetes. We all know that Indians are more prone to develop diabetes at a younger age, maybe below 30. And out of 1.3 billion total population, we have, but an average of 29. The Indian average age is only 29. That means we have many, many young people. So India has more than 50% of its population below the age of 25. Can you believe it? It's very important for all of us to understand. 50% of our population has youngsters below the age of 25, which is very important to handle these people. These are potential diabetics. These are already pre-diabetics, and they have a lot of other issues, and it's very difficult to manage them. And in 2020 itself, the average age of an Indian is 29, whatever I told you, compared to China and Japan. Imagine this is happening in spite of aging population in our country too. So it's a paradox actually, if you see. And I was surprised. I recently gathered this material. Now just see the cities, what's happening. Have you seen some of the cities where they did this study? National Council of Applied Economic Research, they have studied in 6 cities, metropolitan cities, or cities which are not metropolitan, and they have found out about 70% of the people inhabiting these cities are below the age of 35, which is amazing. This is happening because of migration of the youngsters for the jobs, all kinds of jobs, the software people and others. And Surat happens to have the highest number of 74. Lucknow has 68.8. Rest of them too have, Delhi has 70, which is really important. Of course, we all know that diabetes starts early in India, and we are genetically predisposed. We have obesity, physical inactivity, and we are also thin fat individuals, as all of us know. Despite being lean, Indians are more insulin resistant and hyperinsulinemic. He's one of the typical Indians who is going in a rickshaw. Now see this, when I talked about pre-diabetes incidence, this has been studied across the states. This is also a study funded by ICMR. What is surprising is that some of the northeastern states have very high incidence of pre-diabetes. So what is happening in these states? Why is diabetes suddenly becoming like a huge epidemic in these people? Because rapid change in the lifestyle of these people who were either too very active, hill climbing, eating the traditional food. So there is a change. So Northeast could be the focus of pre-diabetes. That means all diabetics next 10 years. This is very important. We know that pre-diabetics will progress to diabetes. This is one of the Stride 1 studies done in South India, Madras. What is surprising is it was reported that diabetes and pre-diabetes prevalence increased in all locations. The rise was significant only in towns and peri-urban villages. So don't just think about cities, it's also the towns, semi-urban areas, villages. The situation is rapidly changing. We also know that pre-diabetes independently has a risk factor for cardiovascular disease and other conditions. This is what you see that. I mean, they don't need to really become diabetic. Even at the stage of pre-diabetes, they have a higher risk of these situations, cardiovascular risk factors and other things. And this goes on. So pre-diabetes increases the risk of major clinical events and death independent of subsequent development of diabetes. So what we are worried is pre-diabetes, whether they become diabetic or not, leave it. Even this period of pre-diabetes, they have a higher risk. And of course, dyslipidemia, if it's combined with pre-diabetes, things become worse. As you know, cardiovascular problems will be more. Hypertension is a common condition that faced by most of the Indians, and young people are no exception. So hypertension with pre-diabetes, things are worse, you know that. So it's very difficult. Vitamin D has been talked about it. Dr. JP is here, he has been talking on the value of vitamin D. And this is one of the studies done by none other than Anup Mishra, where they have supplemented vitamin D to pre-diabetic people, and they did find reduced incidence of conversion to type 2 diabetes. This is just to tell you. And so what is important is we need to handle them right at the stage of pre-diabetes. To do that, first of all, we need to investigate them. We need to do a screening, simple fasting blood glucose. Let's do that. And if somebody's fasting blood glucose is more than 100 milligrams, let's concentrate on them. Let's tell them that you need to watch your blood sugars, you need to change your diet, you need to change your lifestyle so that you provide yourself. So how do we prevent type 2 diabetes? We know that it is the same as you do in managing diabetes. Both are equally important, but it will be much more fruitful if we can prevent both pre-diabetes as well as diabetes. And management of pre-diabetes, all of us know non-pharmacological methods are the most important ones. Talking to the person, I won't call him a patient, person, and explaining. My younger people are not easy to understand. They won't listen to you so easily. So we need to spare some time, tell them convincingly about the importance of losing weight if they are overweight, and if they have genetically already history of diabetes, so they need to be even more careful. They need to exercise, do something, change their habits. And we always talk about aerobic exercise. We also talk about resistance exercise now, which can really help to reduce the insulin resistance, not only in diabetics, but also the people who are prone to develop diabetes. We also talk about the importance of having good sleep, stress-free life, apart from the diet and regular exercises. And when we are talking about reduction of the calories of the person, now we just don't talk about reduction of calories, we talk about reduction of carbohydrates and also increasing the protein content, which can really help in the insulin metabolism, reduce the insulin resistance in these people. So we need to concentrate a little bit about when telling the patient how they can take, what kind of a protein they can substitute by taking, whether they are lentils, dal. Most of the plant-based proteins are equally good, and they are healthier also with less fat in them, and reduce the carb diet, which is very important right at this stage. We also talk a little bit about pharmacological intervention, even at the stage of pre-diabetes. What does this mean? So there are some studies done on diabetes prevention. This is one of the studies done in India by Dr. Ramchandran and others from Chennai. And these are also some of the studies where they have given metformin of different doses. Of course, ADA did mention that metformin can be given and it helps people, especially if they are overweight or they have some other comorbid conditions where you really want to give them and keep their blood sugars much below low. And even ICMR studies have done, did show that when the lifestyle alone is not sufficient, it is the time that you act and use a drug like metformin, which is relatively safer and effective. And even RSSDA guidelines says that try lifestyle, and if it doesn't help in the 6 months, if the blood glucose still happens to hover around more than 100 or touching the border of 125, better not to wait, start the person on metformin, watch him, and perhaps treat him as a diabetic, which is the best. So the first oral treatment to be approved even in India, it's been approved, the metformin. The dosage can depend. Generally, it is said that lesser dose can be effective. And none of these are recommended. I just mentioned that. We don't need to give anything else. What is important is lifestyle modification, then metformin. Don't hesitate to give it whenever required. The whole idea is you want, the best thing is see that they revert to non-diabetic state. Let us see that pre-diabetics revert to non-diabetic state. If that doesn't happen, at least they don't become diabetic. That is important for us. So what are the future directions? This is what it is. Pre-diabetes is a precursor. We know that. Many of them get converted into type 2 diabetes, especially Asian Indians, and they're already in the risk of both macro and microvascular complications, even at this level. And it's also linked with some of the microvascular complications. There are also other biomarkers. Most of the time, we don't need to do that. We don't need to check the other aspects like insulin resistance and other things. We know what's happening. So what is important is that don't focus on pre-diabetes, don't ignore it. Start screening all the younger population for pre-diabetes, detect it, and then manage them by your good advice. So we have a distinction of being among the top 3 countries amongst us diabetics, but now pre-diabetes population is much higher than diabetes in our country. So we need to work together, we need to do a lot of awareness programs, talk to our patients, and do something about it. Otherwise, we are not going to win over this situation, which can only become worse. I think I tried to be short, and thank you very much.
Thank you so much, sir, for giving such a pertinent talk in such a crisp way. I personally believe that the major problem with the pre-diabetes is the public perception, that pre-diabetes somehow connotes that it is a pre-disease state. And unless we let the people know that it is a separate pathological entity with its consequences, I think that message has to be given, and so that people realize the importance of pre-diabetes.
You're right. People always suspect us. When you say pre-diabetes, now they are thinking doctors are coining this new word so that they want to give drugs to the patient. So we need to impress on this. Probably somebody said, why not change the word pre-diabetes and say something else? You have anything in your mind? Yeah.
Sir, I think WHO has been using the word now intermediate hyperglycemia. Just probably
High risk individual is
yeah, but I think WHO is using the word intermediate hyperglycemia just to separate it from a pre-disease state. Okay, thank you so much, sir. Now may I request the next speaker, Dr. Muklesh Gupta. He is a director diabetologist and physician, and he is a secretary of the Lucknow Diabetes Study Society, and he has been rendering services in rural areas of Jagdishpur and Hyderabad for more than 32 years as a social commitment. So over to sir. He will be speaking on vitamin D. It is still a very much talked about and still very controversial topic as on today.
So at the outset, I would like to thank Dr. Anuj Maheshwari and specifically Dr. N.S. Verma, because once again this topic is given to me by Dr. N.S. Verma, and this vitamin D, the bird's eye view. So I am not allowed to dive deep into the subject unless and until the bird is kingfisher. So I'll do just the superficial job, but still I'll try to make the topic a bit interesting because these are questions. There are many questions which are around vitamin D, which are asked by patients to us. And because this is back to basics, so I'll be running very swiftly because most of this information is well known to you. So vitamin D, we know that it's a fat-soluble vitamin, and it is both a nutrient and a hormone. The basic function is to help the body to absorb and retain calcium and phosphorus. And then it is also associated with a great variety of diseases like asthma, cancer, type 2 diabetes, hypertension, cardiovascular diseases, and strikingly to mortality, which I'll discuss. There is a widespread presence of the vitamin D receptors, and that's why it is acting at multiple places in the body, which once again I'll superficially talk about. Now, if we talk about the generation of vitamin D, which happens with the exposure of sunlight onto the skin, the dehydrocholesterol converts into the cholecalciferol, and then the dietary supplementation also, if it is coming, then everything is stored in liver. There, it is hydroxylated to 25-hydroxycholecalciferol, and then further hydroxylation takes place in kidney, that is 125-dihydroxycholecalciferol, which is the active vitamin D known as calcitriol. Here, the important thing is that the season, the latitude, the time of the day, and the duration of the exposure all matters once it is the exposure of the sunlight. Coming to the diet, because we know that it is found scarcely in a few food elements like fish, liver oils, or fatty fish, mushrooms, egg yolks, and liver. There are two vitamin forms which are available, that is vitamin D2, that is algcholecalciferol, and D3, that is the cholecalciferol. Now, interesting fact here is that sun rays, they are capable enough of giving us adequate amount of vitamin D. But if suppose we want to get that amount of vitamin D through food sources, then we will have to basically ingest nearly 100 eggs or almost 170 cubes of the cheese every day to get to the recommended amount of vitamin D. So this is why we have a lot of vitamin D deficiency, because we have sun-avoiding behavior, and probably we will not be able to consume that much amount of vitamin D through diet. Now, is there a difference between the vitamin D3 and D2 supplements? If we get it from market, we have these two forms available. But basically, the plant source derived, generated or synthesized vitamin is D2, and the animal source generated is D3. And if we talk of the debate on D3 and D2, now it is clear that the D3 supplements, they tend to raise the blood concentrations much more than D2. And here is the effect. The D3 is capable of giving that incremental increase in 25-hydroxycholecalciferol as compared to the D2. And this is why we see that most of the formulations which are available to us in market are D3. Coming to the differential effect of 125-hydroxycholecalciferol and 25, there are a bit of differences here also. The 125-hydroxycholecalciferol, it basically affects the calcium, muscle, bone health, and it is also responsible for regulation of blood pressure and insulin production. If we talk of the 25-hydroxycholecalciferol, it has got some better response as far as the regulation of cell growth is concerned, the cancer prevention is concerned, or regulation of the immune functions, diabetes type 1, multiple sclerosis, and other autoimmune conditions are concerned. So there is a bit of difference as far as the action is concerned. Now coming to the major targets of vitamin D, if we talk of kidney, there it helps in absorption of calcium and phosphorus. If we talk of the skin, we know that it leads to generation of vitamin D3. If we talk of parathyroid, there it is acting as a negative feedback mechanism, suppresses parathyroid hormone. Talking of pancreatic beta cells, Dr. B.M. Akkar has given quite a significant talk on this, that it leads to increased insulin secretion and synthesis. We talk of bone, it is responsible for bone health. But importantly now, because we know that a lot of immune functions, they are being rooted through vitamin D. And there it is lead to monocyte differentiation to macrophages, or maybe the antigen presenting capacity of the macrophages that is affected, that is decreased, and there are many other immune related functions, and that's why vitamin D is linked to many autoimmune disorders. Coming to vitamin D absorption, once ingested, there is a passive transfer into the intestinal cells. This is through the brush borders, but further on it needs energy and calcium sodium exchanger, or maybe the pumping out of the cal-binding protein. And this is why the common question asked is, suppose we are continuing to consume vitamin D, this calcium in our as a supplementation, will we be leading to hypercalcemia? The answer is here, that probably in most of the cases that is not going to happen. Now, if we talk of the action of 125-cholecalciferol on kidney, we know that it helps increasing in the calcium resorption. If we talk of action on the bone, it is the osteoblastic activity which goes up. So there is a remodeling, which is a continuous process in the bone. The osteoclastic differentiation, it happens, and it stimulates the osteoblast alkaline secretion. If we talk of the negative feedback mechanism, if there is adequacy of vitamin D, then there is an inhibition of parathyroid hormone, and the bones are kept intact. But if there is a deficiency of vitamin D and deficiency of calcium, then the body has priority to maintain the homeostasis of calcium. And though this negative feedback mechanism now is converted into a positive feedback mechanism, and there is more of parathyroid hormone secretion, which will lead to bone resorption, and we are aware about the secondary bone disease. Once there is, this is happening, once the kidney is involved, the conversion of the calcitriol is hampered, and then this negative feedback mechanism onto the parathyroid hormone, more of the parathyroid hormone secretion, and that will lead to the bone of, more of the bone resorption, leading to secondary bone disease. If we talk of the vitamin D receptors, they are present in many of the tissues in the body, but the action here is that upon arrival onto the target cell, the 125-dihydroxycholecalciferol dissociates from the vitamin D binding protein, enters into the cell nucleus, and there it will interact with the vitamin D receptors. And this is happening at multiple places, and this is what was discussed yesterday by Dr. B.M. Makkar. Coming on to the recommended daily allowances for the vitamin D, these are the ICMR 2020 guidelines that accepting for infants where the recommendation is 400 international unit, rest everywhere it is 600 recommended units. Somewhere it is also mentioned that adults more than 70 years of age, they require 800 international units. But then we know that most of the times we give 2,000 international units in Indian subjects, and this is something which is once again debated, and probably that is something which has to be revised. And that's why that recommendation of 2,000 international units per day is there. Now coming to the classification, where do we say that it is deficiency, insufficiency, sufficiency of toxicity? The level of deficiency is less than 20 nanograms per ml. Where from it comes? It comes basically from the fact that below that level of 20 nanograms per ml, this will lead to elevation of parathyroid hormone and a decrease in the intestinal calcium resorption. And therefore, this 20 nanogram figure is labeled as a deficiency level. And beyond that, it is insufficiency 21 to 29, sufficiency more than 30, and I'll come back to this figure once again, what is the optimal. And then toxicity is more than 150 nanograms per ml. As far as the magnitude is concerned, this is the most undiagnosed and undertreated nutritional deficiency in the world. Of course, various studies, they use different cutoffs, and therefore the values are different. But we know that the reason behind is the pigmented skin, what we have, skin covering clothes and sun-avoiding behavior, that is responsible for vitamin D deficiency in most of us. If we talk of the figures, then this is the community-based studies, multiple studies. They have given us that figure of 50 to 94% prevalence of vitamin deficiency in a country like India where we have ample amount of sunlight. Coming to the hospital-based studies, once again this figure is between 37 to 99%. I have already said the cutoffs are different, but then once again it is a mind-boggling figure of nearly 100% in patients, those who are having vitamin D deficiency. So coming to the fact that vitamin D deficiency in whom? So vitamin D deficiency may occur from a lack in the diet or a prolonged breastfeeding, because we know that vitamin D concentrations are very low in human milk. There is poor absorption or having a metabolic need for higher amounts, does not have or receive enough ultraviolet sun exposure, people who cannot tolerate or do not eat milk or other products which are having some amount of vitamin D in them, people with inflammatory bowel disease, ulcerative colitis, Crohn's disease, or other conditions that disrupt the normal digestion of fat, people who are obese and tend to have, they have lesser amount of vitamin D levels because vitamin D accumulates in the excess fat tissues, but it is not available. Conversely, if these patients, if suppose they lose weight suddenly, then there is more of vitamin D which is released, and this is something which is also seen, observed in the population. Patients, those who have undergone gastric bypass, because there is a removal of a small, the upper part of the small intestine where the vitamin D is absorbed. In other conditions where the catabolism is increased, like the use of certain anticonvulsants, glucocorticoids, or there is a decrease in synthesis of vitamin D, like in liver failure, in case of urinary loss, like nephrotic syndrome, or decreased synthesis, like in chronic kidney disease. So all these conditions, if suppose they are there, then it can lead to vitamin D deficiency. Another interesting fact, that is, suppose you are exposed to sun rays, but you are in a glassed sort of environment, maybe sitting in a glassed office or maybe in your car, probably this is not going to help, and this is something misnomer. Coming to the associated diseases, if suppose we talk of bones, then we are all aware that it can lead to rickets, osteomalacia, osteoporosis. If we talk of muscles, then it can lead to muscle pain, then the proximal muscle weakness. If we talk of association of conditions, then it is diabetes where it is associated, hypertension, cardiovascular disease, various sorts of infections where it can even affect the outcomes. If we talk of autoimmune disorders, then it is linked with various autoimmune disorders. If we talk of skin diseases or if we talk of cancers, there also it is associated. Parkinson's disease, where vitamin D deficiency was seen in patients with Parkinson's disease. Even suicide, the lower vitamin D levels were associated with an increase in the risk of suicide. autoimmune diseases like vitamin D is a potent modulator of immune system and is involved in regulation of this cell proliferation and differentiation. So many places where vitamin D is really linked. When I was preparing this, I came across these striking headlines, and these are very recent headlines in Times of India and the Medical News Today and Medscape, that low vitamin D is linked to increased mortality. So I was forced to go into the literature further. Do we have more evidence to it? And this is another study which is published in Annals of Internal Medicine 2022, October, just a couple of months back. And it's a very long study. It's a follow-up, 14 years, nearly 3 lakh individuals were followed on, and it has given that all-cause mortality has an L-shaped sort of risk death. So there is, suppose the levels are somewhere around less than 50 nanomole per liter, so the more you have less below this, the more is the mortality. And therefore, this figure of 20 nanomole per liter of vitamin D is probably the optimal level which we should target. So there is a causal relationship between vitamin D deficiency and mortality, and this is something which was new to me and very striking as such. Coming on to COVID and vitamin D, because we have been giving we give vitamin D to COVID patients, and here is one study. This is the SHADE study. Briefly going on to this, it has given us that summary that great proportion of vitamin D deficient individuals with this COVID infection, they turned COVID negative with the significant decrease in the fibrogen on high dose of cholecalciferol supplementation. Going on to another study, which is the meta-analysis of 13 studies, 10 observational and 3 RCTs, once again gave insight that vitamin D supplementations might be associated with improved clinical outcomes, especially when administered after the diagnosis of COVID-19. Coming on to vitamin D and diabetes, this was nicely taken up by Dr. B.M. Makar yesterday, but briefly, this talking about a very big trial involving 83,000 women diabetes at baseline and followed in the nurses' health study for development of diabetes. And here, nurses, those who are on vitamin D supplementation, they had 13% lower risk of developing diabetes. And if they were taking calcium along with vitamin D, then there was 33% lesser chance of developing diabetes. So this gives that insight that if suppose there is a person who is consuming vitamin D along with calcium, probably will be protected from getting diabetes. In addition to the vitamin D in diabetes, it influences the renin-angiotensin system, inflammation, and mineral-borne disease, which may be associated with the cause and progression of the kidney disease in diabetic subjects. Another interesting fact that we do a BMD in our patients to know the bone health, but in diabetic subjects, it is found that doing BMD and getting a normal BMD still will not decrease the chances of getting fractures and fall. And this is because of the bone quality, which we are not able to assess with the just BMD. So another interesting fact that there is some improvement in the structure of the bone, which happens once we are supplementing vitamin D. So if we talk of cancer, here I'll just run short on this, because we know that there are a lot of cancers wherein vitamin D is associated with. Colorectal cancer is something which is greatly associated, but there are trials wherein they did not show significant difference between the vitamin D and the placebo, but the median years of study was 5 years, and the study itself mentions that we have to continue this study for at least 15 years to know what really happens in terms of getting more cancers here. But the important part here is, in cancer patients, there is 13% lower risk of cancer mortality in those assigned to vitamin D, and vitamin D may have a stronger effect on the cancer progression than for the incidence. Coming on to the mechanisms, I'll just cut short. I'll go to the cardiovascular disease. Here, once again, the Framingham offspring study participants who were free of cardiovascular disease at the baseline, nearly 1,700 patients. And here it was seen that in this, there was a significant decline or decrease in the mortality, the cardiovascular mortality in patients, those who are having good vitamin D levels as against patients, those who are having less vitamin D. So there is a dose-response association between the circulating vitamin D and the risk of cardiovascular disease, and there are various studies to it. Coming on to another point which might have come to everyone's mind by now, that we should be continuing with supplementation. But here, that taking vitamin D supplementation has not been found to reduce cardiovascular risk, though there are various studies, significant ones. They say that once the patient is having lesser vitamin D concentration, they will have more of mortality. But once we are giving supplementation, we are not getting that sort of response. So here there is a dilemma, and we need more of research here. But if we want to go in for the vitamin D and hypertension, then certainly vitamin D supplementation is capable of decreasing the systolic and the diastolic blood pressure significantly to the tune of nearly 3 to 6 millimeter mercury decline. If we talk of the immune functions, then multiple sclerosis incidence is something, if suppose we give a good amount of vitamin D, then the incidence of getting multiple sclerosis goes down significantly in the population, and there are prospective studies to it. Coming to another question which will come to anyone's mind, could vitamin D supplementation help boost our body's defenses to fight infectious diseases such as tuberculosis and seasonal flu? And here, if we talk of the autoimmune disorders or these common ailments, then certainly daily or weekly vitamin D supplementations lowers the risk of acute respiratory infections. The effect was particularly prominent with very deficient individuals. Tuberculosis, though we find vitamin D levels less in tubercular patients, but then the relationship, once again, here is not very clear. It is as far as the cause is concerned, as far as the effect of the improvement is concerned. But if we talk of other autoimmune disorders, then it is found to reduce the incidence of autoimmune diseases by about 22%. And here if we talk of rheumatoid arthritis, psoriasis, Hashimoto's thyroiditis, autoimmune thyroid disease, etc. So vitamin D and metabolic syndrome, another important area because it is found to be implicated with hypertension, lipidemia, hyperglycemia, and obviously it is going to affect the metabolic syndrome. Vitamin D and obesity, once again, because vitamin D is affecting the adipogenesis, and therefore, here it plays a role in development of obesity. Depression, once again, is associated patients, those who are having vitamin D, they have more chances of getting depression. And in the last, this is my last slide, we cannot talk of vitamin D without talking about vitamin D toxicity. So vitamin D toxicity is most commonly happening once we are supplementing vitamin D. Low amounts of vitamin D found in food elements, and whatever amount you consume, you are not going to get to those toxic levels. And if we talk of the excessive exposure to sun, once again it is not going to give toxicity because the temperature in the skin will prevent the vitamin D from forming. What are the signs of the toxicity? Anorexia, nausea, poor appetite and weight loss, constipation, irregular heartbeat, hardening of blood vessels and tissues due to increased blood vessels in the calcium, urinary lithiasis, metastatic calcification in alveoli, muscles, gastric mucosa. And therefore, in summary, vitamin D deficiency is certainly very common to the tune of more than 90%. And apart from dietary intake, basically we'll have to focus on to some exposure, and if that is not happening, then supplementation is the answer. Certainly, oral supplementation should be the choice, not the injectable ones, because they are something which can lead to toxicity. Thank you so much for your attention.
Thank you, Dr. Mukesh, for talking very clear concept about vitamin D. Once I read an article about vitamin D, and I was telling to you as well that vitamin D is pseudo-vitamin for pseudo-disease. But you have very beautifully spoken about the need of vitamin D and its uses and where to be used. And very consistently you have said that injectables are not welcome. Vitamin D oral supplements are good because we need a constant concentration, not a up and down. Thank you. Thank you very much.
Thank you so much.
So with this, we close the session.
Kumar sir for providing us unique perspective and presentations. Now I will invite the chairperson for the next session, Dr. V.K. Chaudhary sir, MBBS MD, Kalyani Hospital Visiting Consultant, and Dr. R.R. Singh, MD Medicine Consultant Diabetologist and Cardiologist, Raghaved Hospital and Heart Center, Jhansi. Please invite the speaker of this session. Over to Chairperson.
So good evening, ladies and gentlemen. Now next talk that is by Professor Dr. J.K. Sharma, and he is a known figure. Recently he was the organizing secretary for the IPF meeting in Delhi. He is also vice president or this American College of Physicians Indian chapter. He is also vice president for Geriatric Society of India. He is founder secretary for General Innovative Physicians Forum and treasurer for RSSDI National. So that way he holds so many, posts nationwide, and this evening he is going to talk on nature's defense and what is our strength. So he is going to talk nothing other than the gut flora. What is the status of gut flora in health and in the disease? This we will learn this evening. I welcome Professor Dr. J.K. Sharma, please.
Is that okay? Thank you, respected Chairperson, sir, Dr. R.R. Singh and Dr. Chaudhary. I extend my heartfelt thanks to the organizers, my friend Dr. Anuj Maheshwari, the Governor of ACP India chapter, Dr. Narsingh Verma, our scientific chair, Dr. L. Srinivas Murthy, and all the organizing team who are involved into this. I think this topic seems very close to the heart of Dr. Narsingh Verma. So he asked me to talk on nature's defense, our strength, the gut flora in health and disease. So, we all know that, please make the timer to 20 minutes. So, in the next 20 minutes, I'm going to speak on this gut microbiota. And in front of me is sitting Professor Ashish Kumar from Sir Gangaram Hospital Department of Gastroenterology. We all know that the human microbiome, the ecological community of commensal, symbiotic, and pathogenic microorganisms that literally share our body space and have been all but ignored as determinants of health and the disease. And this has been said by the American molecular biologist, not now, but in the year 1958 when he received the Nobel. So he is a Nobel laureate. The various functions of the gut, they are regulated by the sophisticated interactions among the functional elements, including the gut microbiota. And these microorganisms, they play a crucial role in the gastrointestinal and mucosa permeability. So the mucosa permeability is the crux here. They control the fermentation and absorption of dietary polysaccharides to produce short chain fatty acids. So another important point is the short chain fatty acids. And in addition, they play a crucial role in the host immune system, modulation of inflammatory processes, extraction of energy from the host diet, and alteration of the human gene expression. The simple therapeutic strategies targeted at attenuating the progression of chronic low-grade inflammation and insulin resistance are urgently required to prevent or slow the development of diabetes in susceptible individuals. This is one point regarding the diabetes. Now, when we talk about the definition, the microbiota, they are the community of microorganisms including the bacteria, the archaea, viruses, and some unicellular eukaryotes living in a specific environment. And the microbiome is the entire collection of all the genomic elements of a specific microbiota. And the metagenomics, they are the field of molecular research that studies the complexity of these microbiomes. The human microbiomes, as I told you, they are the bacteria, they are the archaea, the viruses, and the fungi. And when we talk of the gastrointestinal tract, you see that in the stomach, in the duodenum, in the jejunum, distal ileum, and also in the colon and the proxima ileum, they are present, but the maximum concentration we can see that they are in the colon, 10 raised to the power 12 to 14. The normal gut flora, in the stomach they are the lactobacilli, in the large intestine they are the Enterobacteriaceae, Enterococcus fecalis, bacteroids, bifidobacteria, Peptococcus, Peptostreptococcus, Clostridia, and Lactobacilli. And at the small intestine, they are the Streptococci and the Lactobacilli. In the liver diseases, we see that, as I told you, the maximum number is present in the colon. The major 4 phyla, the firmicutes, they are the phylum of gram-positive bacteria, large classes. One is bacilli, that is the lactobacillus and the streptococcus, and another the clostridia. Then the actinobacter of medical significance is in the subclass Actinobacteridae, and they are the notable source of antibiotic like the bifidobacterium. And then the bacteroids, they are the species significant clinical pathogens and are found in most anaerobic infections with an associated mortality of more than 19%. Then the proteobacteria phylum, that is the gram-negative bacteria, wide variety of pathogenic genera like the Escherichia, Salmonella, Vibrio, Helicobacter, Yersinia, and the Legionellis. Dysbiosis is another very important term and which is gaining importance at the present time. If you look at this diagram in 2000, 2001, and up to 2006, there were hardly any importance given to the dysbiosis, but if you look in the year 2018, the number of articles published containing the topic dysbiosis are more than 2000, so it is gaining importance. But what is dysbiosis? It can be described as a compositional and functional alteration in the microbiota in individuals with disease compared with the healthy subjects. And it can feature a loss of beneficial microorganisms, expansion of potentially harmful microbes, and or a loss of overall microbial diversity. Now, researchers still do not agree on what constitutes a healthy microbiome. It is not clear how to define an important one. And if you look here, a loss of beneficial microbe, expansion of the pathobionts, and loss of diversity, they are the events that encompass the dysbiosis. And the various factors that affect the gut microbiota, they start even before the birth or at the time of the birth, and early onset at 3 years, then the adult onset, and then the late onset. And you see here from the genetics, birth route, the geography, the hygiene, stress, then the diet and nutrition, and not only that, the drugs. These are all the factors which affect the microbiomes. So dysbiosis may occur anywhere in the body. You can see that oral microbiome, then the gut, even in the placenta, the skin microbiomes, and in the vagina also there are the microbiomes, and this dysbiosis can occur anywhere, and it can lead to multiple diseases like the obesity, metabolic syndrome, diabetes, then the C. difficile infection, colorectal cancer, inflammatory bowel disease, psychiatric disorders. From the skin microbes, there may be allergies, acne, psoriasis, atopic dermatitis, ectodermal dysplasia, skin cancers. Then oral microbiomes, they are also very important and can lead to caries, periodontal diseases, and the gingivitis. Then placental microbiome, the preterm birth, chorioamnionitis, and the torch infections, which have become very important. The vaginosis, sexually transmitted diseases, and the yeast infections. So this may occur anywhere in the body. And the cause or effect disease, we have seen that in the health, when there is diversity and change in the functions, then leads to the disease, and that is the dysbiosis. And this is the imbalance between the various types of microbiomes in health and disease, and they lead to all these diseases which I told you, especially in intestinal. There is IBD, irritable bowel syndrome, celiac disease, the colorectal cancer, then obesity, type 2 diabetes, metabolic syndrome, which I have already mentioned. So dysbiosis is an association and not a causation, but it has not been proved the cause as yet. Now, the gut dysbiosis is a complex interplay of counts, diversity, and ratios, which we can see that in the healthy controls and in the patients. And we see that the inflammatory bowel disease, when the proteobacteria or bacteroids, they increase and the firmicutes, they decrease, then from the healthy control, these patients' problems start. What is the role of diet in the dysbiosis? Prudent diet and the Western diet, and we can see here that the phylohemicals, the omega-3 fatty acids, high dietary fibers, and various others, they have an effect on the short-chain fatty acids. So this is with the prudent diet, and when there is Western diet, the main problem is there is a leakage, or we can see that the role of oligosaccharide in the dysbiosis, it acts as an antiviral and the antimicrobiasis, which affects the immune cell functions. It acts as a prebiotic for beneficial bacteria, and it favorably modulates the epithelial and the mucosal barrier. So when there is a break in the epithelial and the mucosal barrier, here comes all the problems they start. And according to the diet, if we take a high-fat diet, the bifidobacteria species, they get altered, and the effect on the bacteria is they get decreased. So high fat and high sugar, again there is effect on the Clostridium and the other bacteria, they get increased. Carbohydrate reduced diet causes the effect on the bacteroids, they are increased. So these are the various bacterial alterations are there as per the diet. Now gut microbe and the brain axis. The gut microbiota production of the neurotransmitters, the bacterial produced neurotransmitters might travel retrograde to the brain via the vagus nerve, where they can induce the central nervous system effects. And then gut microbiota, they may stimulate the inflammatory cell production of the cytokines, and these inflammatory cytokines might travel to the brain via the systemic circulation. And this also gut microbiota production of the metabolites is there. So the bacterial metabolites may reach the brain. Such metabolites might also stimulate the intestinal cells to produce neurotransmitters that may result in the neural defects. So the CNS neurotransmitters like the serotonin and the dopamine, brain to microbiota, there is neuromuscular control of the peristalsis. So there is fight or flight or the stress response through the cortisol secretion of the mucus. So the microbiota gut-brain communication becomes important, and through the vagus nerve stimulation, the microbiota to the brain through these neuropeptides, the immune signaling, barrier integrating signaling, and through these short-chain fatty acids, they have an effect. Now, the various diseases associated with alteration in the gut microbiome, when the gut microbiome is no longer healthy, look at the central nervous system at the brain level, there may be multiple sclerosis, chronic fatigue syndrome. At the cardiac level, there may be atherosclerosis or idiopathic thrombocytopenic purpura, non-alcoholic fatty liver disease. Obesity is also an important, and the insulin resistance or type 2 diabetes, then irritable bowel syndrome, inflammatory bowel disease. And here you can see that the insulin resistance, the green beneficial effect and blue beneficial effect in case series. So diseases in which microbiomes may play major roles, irritable bowel syndrome, then the inflammatory bowel disease, irritable bowel syndrome, then the chronic liver disease, then the alcoholic liver disease, NASH, which has gained a very important aspect nowadays, obesity, allergies, Parkinson's, type 2 diabetes, metabolic syndrome. Now, what is dysbiosis in the irritable bowel disease or inflammatory bowel disease? Intestinal lumen. On the left side, you see the normal microbiota. There is a mucus layer. Then there is the epithelial barrier and the lamina propria. But when there is a break in this epithelial barrier or the mucus layer, then the chronic inflammation starts through the host genetic factors and the environmental factors leading to the inflammatory bowel disease. Now, dysbiosis in inflammatory bowel disease, there is decreased or depleted species and there is excess of species, decreases like the roseburia or the butyrate producers and the mucin degraders, there is excess of the species and no significant or consistent benefit in Crohn's disease. In ulcerative colitis, a modest effect in inducing and maintaining remission in mild to moderate ulcerative colitis. And you see that for Crohn's, there is no supporting data, but there is some clinical benefit with this. So pathophysiology of irritable bowel syndrome, the gut-brain axis, I have already told you there is influence on the motility, secretion, nutrient delivery, microbial balance, and then there is an influence of the neurotransmitters, stress, anxiety, mood behavior. Now, dysbiosis in irritable bowel syndrome, that is the diet through the fat, the fermentable carbohydrates, stress and cyclic comorbidity through the HPA activation and the symptomatic activation. There is altered host immune function through the altered bacterial recognition via the TLRs, abnormal cytokine and chemokine secretion by innate immune cells and altered secretion of the antimicrobial peptides, immune activation and low-grade inflammation. So the unstable gut microbiota cause the chronic gut disinfection. The host factors alter the microbial habitat in the gut, and the unstable gut microbiota, they contribute to the unstable habitat. So the gut dysbiosis leads to altered fermentation, increased production of short-chain fatty acids and release of 5-PAST, and there is activation of intestinal immune system and inflammation. And these are the symptoms because of this, because the production of excessive intestinal gases, there is abdominal pain and bloating. There is diarrhea and urgency, abdominal pain, diarrhea, bloating and urgency. So any patient of diabetes or any patient of any chronic illness, if he comes to us and says that there is gas formation or there is dyspepsia, please don't take it lightly. There is definitely a problem with the gut microbiota. Now this again we can see in the alcoholic liver disease and disruption of the intestinal barrier, translocation and liver immunology. The last 10 overwhelming this barrier leads to the bacterial translocation. Now look at the dysbiosis in liver cirrhosis. We see that portal hypertension, PM and starvation, the urea cycle, clearance of toxic substances, hypermetabolic state, hypercatabolic stage, all these they lead to the UPP activation, hyperammonemia, then there is skeletal muscle sarcopenia, and this is the complex mechanism of dysbiosis in the liver cirrhosis. In NAFLD and NASH, again this is a complex mechanism when the unhealthy diet, sedentary lifestyle and the genetic factors, they have effect on the gut epithelia, and there is again dysbiosis and NASH. And again in obesity you can see that multiple composite mechanisms are there which affect the CNS, the blood and the gut. So it is a complex mechanism. We can see that in NAFLD there is increased dysbiosis, decreased bacteroids and firmicutes, increased inflammatory signaling. Then the increased dysbiosis, increased intestinal permeability and increased small intestinal bacterial overgrowth in the alcoholic liver disease. In cirrhosis also and hepatocellular carcinoma, there is increased dysbiosis. In hepatocellular carcinoma, the E. coli is increased and the inflammatory signaling is increased. So, dysbiosis is a heterogeneous pathophysiological state. There is a broad consensus that loss of beneficial microorganisms, expansion of potentially harmful microorganisms, and or loss of overall microbial diversity. Dysbiosis may occur anywhere. Most documented manifestation associated with the gut, and the gut dysbiosis is mostly associated with decrease in the firmicutes and increase in the bacteroids. So the diet, gut microbiome, brain axis and the leaky gut, that plays an important role as the central dogma in manifestation of dysbiosis associated with obesity, NAFLD, alcoholic liver disease, cirrhosis, IBD, and IBS. Now, in next 2 slides, I'll tell you how to manage this. Dysbiosis, genetics, drugs, xenobiotics, pollution, stress, diet, epigenetics, circadian disruptors, antibiotics, increase pathogen load. So the functional microbiome through the dysbiosis leads to the pathogen bloom, loss of diversity and leads to the disease, and this loss of diversity again leads to the rebiosis, and here is the role of prebiotics and probiotics in managing the dysbiosis, and the various factors which we cannot change like the genetics, but other changeable factors we must look for and we must treat them. Now this last slide, the probiotic platter, you must have seen the prescription where VSL3, the Econom, Antrozermina, Deroleg, Valgard, Bifileg, Prepro, Progrard. All these, so we should not go for what commercially is available, we should find out what exactly our patient needs and in which combination they are available to us. With that, I thank you very much. Thank you, Dr. N.S. Verma sir, for allotting me this.
Thank you, Professor Dr. J.K. Sharma sir. Very nicely you have discussed this very difficult topic which we were not understanding in the beginning, and how nicely you have taught us the treatment of this dysbiosis, that is with the prebiotics and the prebiotics and the prebiotics, probiotics, which are the live organisms which when given exogenously they produce the beneficial effect to the host. That is the definition, I think. So thank you very much. Since we are running already late, I will request not to ask any questions, and meanwhile we will invite the other speaker.
Thank you, sir.
And this way I give my mic to my co-chairman.
Now coming to the next speaker, Dr. Pratap Jetwani. He is MBBS MD, PG Diploma in Diabetes, Cardiff UK, Fellow RSDI, Fellow Diabetes India, presently Joint Secretary RSDI National, Executive Member All India RSDI 2020-22, and now the platform is yours to Dr. Pratap Jetwani, sir.
Thank you.
Over to you, sir.
Thank you, sir. Thank you, chairpersons, for kind introduction. Let me thank Dr. Anuj, Dr. Narsingh Verma, Dr. Srinivasa Murthy, and Dr. Anubhav for making me part of this 7th annual meeting of ACP India chapter with the theme of Back to Basics. And I will be talking on the basic drug which we use in type 2 diabetes day in and day out, that is sulfonylurea, and how it is relevant in modern times when we are having a lot of drugs to, I think, target each and every pathophysiological defect which is there in type 2 diabetes, which is described by Professor Ralph Di Fronzo in the form of ominous octet. How sulfonylureas they fare in current times, that is what I'm going to talk about. So sulfonylureas have been classified depending on the hierarchy of development in the conventional and modern sulfonylureas, and based on the duration of action, they are classified into short-acting, intermediate acting, and long-acting. And currently, we are having intermediate acting in the form of glipizide, gliclazide, and long-acting in the form of glimepiride, gliclazide MR, and glibenclamide. We all know how they act, so I will not go in details of their mechanism of action, but ultimately they increase insulin release from the beta cells. And that is one of the important pathophysiological defect which is there in type 2 diabetes. This is the PK/PD profile of various sulfonylureas which are available, but I will be focusing mainly on modern sulfonylureas which are nowadays being termed as glimepiride and either gliclazide or gliclazide MR, because they have got the best evidence to support their use in type 2 diabetes. Way back in 2014, this paper suggested that sulfonylureas as a second line agent They generated glycemic control and quality of life adjusted years comparable with newer agents like DPP-4 inhibitors. And this regime was resulted in the longest time to insulin dependence. So this was in 2014, and after that we have observed a sea change in the management of type 2 diabetes. Now we talk about comorbidities-based selection of oral anti-diabetic drugs, because many of newer drugs, they are having pleiotropic benefits. And because of that, probably sulfonylureas, which were considered the good agents as far as diabetes management is concerned, they are being highlighted as evil. And I will try to justify the major concerns which are there with sulfonylurea, starting with first, the myth, that is beta cell exhaustion and durability. Do sulfonylureas, they result in beta cell exhaustion, and there is accelerate the decline in beta cell function? This is a myth. Even UKPDS data, the principal investigator, Professor Holloman, himself said that no solid evidence for beta cell exhaustion in the clinical setting over 6 years in the UKPDS. It is a natural history of type 2 diabetes, and there is no role of sulfonylurea as far as beta cell exhaustion is concerned. This is a small study which was carried out in Korean patients over a period of 1 year. Patients who are failing on metformin, they were given either sulfonylurea, glimepiride, and glargine, and their effects on beta cell function in the form of glucagon-stimulated C-peptide change that was observed after 48 weeks. Various other parameters were also studied, and this showed that the glimepiride was equivalent to glargine as far as glycemic control is concerned. Rather, it was better, and the C-peptide was maintained, so it was not associated with any decline in beta cell function, thereby suggesting that it is not associated with beta cell exhaustion. The great study which is just recently released, which was carried out in USA to find out the best agent to add on top of metformin in type 2 diabetic individuals. And they have divided around 5,000 eligible patients who were having type 2 diabetes duration of less than 10 years with baseline A1C of 6.8 to 8.5%, and they were on maximally tolerated dose of metformin, at least 1 gram, and maximum of 2 gram. And then they were divided in 4 groups. One group was given glimepiride, second was given DPP-4 inhibitor, that is sitagliptin, third was given liraglutide, and fourth group was given insulin glargine. And they have tried to find out their effect on glycemic control, whether they were able to maintain their HbA1c below 7 for how long. That is primary outcome, and secondary outcome was how long they were able to maintain their HbA1c below 7.5%, and tertiary outcome was those where the HbA1c was more than 7.5 and further treatment was added, whether they were able to maintain that HbA1c below 7.5. And if you see here, they say that all 4 drugs, they affect in a variable manner, and the best effect is seen with injectables, that is insulin glargine and liraglutide. But here sulfonylureas, they fared better, far better than sitagliptin, thereby suggesting that they have got some durability as compared to DPP-4 inhibitors when added on top of metformin therapy. Another important aspect from this trial, that depending on baseline HbA1c, the response of drugs, they differ. When the baseline HbA1c is 6.8 to 7.2, almost all drugs, they fare equally. But as the baseline HbA1c increases, and when it goes to 7.8 to 8.5, the best is liraglutide, then glargine, they are almost comparable. Then comes glimepiride, and then comes sitagliptin. So this gives you a clue that they provide durable glycemic control, and durability is better, at least as compared to DPP-4 inhibitors, as evident from this great trial. Let us see how its glycemic efficacy as compared to the newer agents. So this is as compared to DPP-4 inhibitors. They are providing equivalent or better glycemic control, and so it will be suitable for many of the patients. And there's a variety of trials, starting from canagliflozin to liraglutide to glargine to sitagliptin. Almost all the trials, they have demonstrated that glycemic efficacy is same, whether you use glimepiride or SGLT2 inhibitor or DPP4 inhibitor or liraglutide. Only canagliflozin 300 or liraglutide in high dose, they were having better glycemic efficacy as compared to glimepiride. And that's why all the combinations, if you see glycemic efficacy, it is almost same whatever agent you add on top of maximally tolerated metformin therapy. There is concerns about weight gain with sulfonylureas as it was highlighted previously. This is the trial START study, which was an open label real world data where they have compared glimepiride metformin with sitagliptin metformin, and there was no major weight gain was seen with either of the combinations. Same way, this is Zodiac 39 trial where they have tried to find out whether adding sulfonylurea to metformin any effect on body weight. And this is a prospective observational cohort study in around 3,000 patients, and the weight was almost same. There was not much weight gain with sulfonylurea in this cohort. And if you see, they have compared 3 different sulfonylureas: gliclazide, glibenclamide, and glimepiride. Here, glimepiride is not associated with any weight gain as compared to glibenclamide or gliclazide. The same has been observed in this study where glimepiride was compared with sitagliptin and GLP-1 analog. Again, the weight was almost same. There was no much weight gain with glimepiride in this randomized controlled trials. The Carolina trial, which established the cardiovascular safety of glimepiride, again, it has shown that the weight gain was only to the tune of 1.5 kg. Although the number of hypoglycemic events were very high in this category of patients in Carolina trial, because glimepiride was used in the dose of 1 milligram and then it was titrated to the maximum dose of 4 milligram, and the baseline HbA1c in many of these patients was around 6.8 to 7.5. Generally in clinical practice, we do not go beyond 2 milligram in this category of patients. Otherwise, it will result in increased risk of hypoglycemia, and that was observed in this Carolina trial. And in spite of so much hypoglycemia, there was not much weight gain observed, and the weight gain was to the tune of only 1.5 kg with glimepiride in this trial. Whether the weight gain is detrimental or not, this is observational data, retrospective cohort data from the Tehran lipid and glucose study, where they have tried to find out whether the weight loss and weight gain, what is their effect on incident CVD and coronary artery events. And they have highlighted that the weight gain of more than 5% was protective as far as cardiovascular events or coronary artery events are concerned, and they concluded that probably the sulfonylurea-induced weight gain has got no major impact on cardiovascular outcomes. Although this is observational data, we cannot find that it is having some causal association. Regarding hypoglycemia, we all agree that sulfonylureas do increase the risk of hypoglycemia, but of that, glimepiride is better, and I think as far as hypoglycemia is concerned, gliclazide and gliclazide modified release, they are having the best evidence of list hypoglycemia even as compared to glimepiride. This is as compared to DPP4 inhibitors, but most of the trials, treatment discontinuations because of hypoglycemia is not there, and that is the beauty of these molecules. This is the Carolina trial. Definitely the hypoglycemia was very high, but if you see here, it was for first 2 or 3 months the rate of hypoglycemia increased because of titration of sulfonylurea, and I have already highlighted that it was titrated up to 4 milligram in people who were having baseline A1C of 7.5 only. As far as CV safety is concerned, till date we were not having good evidence, so these are various observational cohort studies where it was quoted that glimepiride was better as compared to either glibenclamide or glipizide in people who were either having coronary artery disease or who were hospitalized with coronary artery disease or likewise. But the Carolina trial and the Tosca-IT trial, advanced trial, various trials, they have proven that at least they are not associated with increased risk of cardiovascular events. The Tosca-IT was carried out in Italy, where patients who are failing on metformin monotherapy, they were either given pioglitazone or sulfonylurea. Most of these patients were either on glimepiride or gliclazide, and the cardiovascular outcomes were not different whether you use pioglitazone or sulfonylurea, although there were many flaws in this trial because at that time the controversy of pioglitazone with bladder cancer came out, and because of that many of the people in the pioglitazone arm, they discontinued their medication. Probably that might have skewed the data, but still it says that both are equivalent. VADT follow-up data says that if you intensively control based on sulfonylurea therapy, then after 12 years, there will be a significant relative risk reduction in major CV outcomes, although this doesn't prove that glimepiride is providing cardiovascular benefits, but it gives you a clue that it is not associated with increased risk of cardiovascular events. And the main thing, Carolina trial, where linagliptin was compared with glimepiride in around 6,000 patients, median age 64 years. This was a multinational, multicentric trial, and where the patients were either given linagliptin or glimepiride, and the hazard ratio of cardiovascular outcome was 0.98. So linagliptin was non-inferior to glimepiride as far as cardiovascular outcomes are concerned. So this was the trial which established that at least out of sulfonylureas, glimepiride is the drug which, when used in patients with established cardiovascular disease or high CV risk, does not increase the risk of cardiovascular outcomes as compared to DPP-4 inhibitor linagliptin. And these are the various Kaplan-Meier curves from the same trial. GRADE trial, which I have shown you, again they have tested whether the outcomes, they are different when you use different agents on top of metformin therapy. And here they have tried to find out the impact of second-line agent on cardiovascular disease, on all-cause mortality, on CV death, on heart failure, and various other aspects. And they have concluded that the hazard ratios for any CVD were 1.1 in the glargine group, 1.1 in the glimepiride group, 0.7 in the liraglutide group, and 1.2 in the sitagliptin group. So only liraglutide was having some benefit. All other three, they were having same impact on CVD when they were added on top of metformin therapy. So another trial which established that at least sulfonylureas, they are not associated with increased risk of cardiovascular events. Special population, when you want to use, you have to be careful because they are associated with increased risk of hypoglycemia in this category of individuals like elderly or renal impairment. Then you have to use it in the smallest possible dose. Even during Ramadan, it is associated with an increased risk, but there is data to support use of gliclazide during Ramadan for glycemic control. I will just touch upon three guidelines, that is ADA standards of medical care. They say that modern sulfonylurea has got high efficacy. As far as CV outcomes are concerned, it is neutral, cost is low, and renal benefits are again neutral. And we all know that the ADA algorithm now suggests that depending on the presence of established atherosclerotic cardiovascular disease or renal disease or heart failure, you have to choose your therapy after metformin, or even at the beginning, you can start with SGLT2 inhibitor in this category of patients. IDF again says that sulfonylureas, they are neutral as far as major CV events or CHF is concerned, and S again focuses on newer therapies as far as in people who are having underlying cardiovascular disease. So, do sulfonylureas still have a place in clinical practice? This is a beautiful article by Professor Kamlesh Kunti, last slide only, that modern sulfonylureas, they have got robust evidence base, 5 decades of experience, very good glycemic efficacy, durability is there, they are weight neutral or marginal weight gain, hypoglycemia is definitely there, but then you have to use it smartly. They do not increase the risk of cardiovascular events, and definitely they are cost effective, particularly in our country. So they should be used judiciously, preferably in lowest possible effective dose, careful patient selection, and these drugs are only for glycemic benefits. They are only for lowering blood glucose. They have got no other pleiotropic benefits like SGLT2 inhibitors or GLP-1 analogs. So everyone has two sides, good and evil. How you treat me will determine which side you see. That is what sulfonylureas are asking physicians in the current modern times. Thank you very much.
Thank you. Thank you, Dr. Pratap Jethwani, for a very wonderful deliberation, and especially about the modern sulfonylureas, that is, are they better? Definitely they are better, and there is no solid evidences about the beta cell exhaustion. And the study, that is the Carolina study, which states about the cardiovascular outcome, that is the in comparison to linagliptin versus the glimepiride, that is the 11.8%, while it is 12% in cases of the glimepiride. So thank you for, you have presented very well. Thank you.
Thank you. Thank you.
Now coming to the next session.
Thank you,
So
Chairperson.
concluding the session.
Yes, thank you, Chairperson. For the next session, I would like to invite the new chairpersons of this session, Dr. Rajiv Srivastav, well-renowned cardiologist and physician from Sultanpur, and the next one, Dr. Sabiha Sajid Ansari, senior medical senior consultant in UP Medical Health Services. Thank you, ma'am.
Slide changes.
Without wasting much time, I would request Dr. Sabiha, our co-chair, to introduce our first speaker.
नहीं ये नहीं है, ये हो जाए किसी को ऐसे ऊपर इसको ऊपर बढ़ा, आपको पॉइंटर कौन सा है? ऑन कर दीजिए, लगा दीजिए उसको, नहीं फुल कर दीजिए, स्लाइड शो कर दीजिए इसको. Can you put it in slideshow, please? Remove the, yeah, thank you. Honorable chairpersons and dear friends, at the outset, thank you, Dr. Narsingh Verma, for giving me this wonderful topic. About a couple of days back, the FDA approved a new drug known as teplizumab. This drug would delay the onset of stage 3 type 1 diabetes by 2 years. It's a 14 days injectable course, and the cost of the drug only is a whopping $200,000. Can you imagine? And I am going to talk about, and this is just the tip of the iceberg. And what I'm going to talk about, what is the true cost of illness and health. Now, let me introduce you to some terms. When we talk about cost, it is meaningless. Cost should always be talked about in terms of what is called as cost-benefit analysis, cost-effectiveness analysis, and cost-utility analysis, and I'll talk about it a bit later. And this is usually expressed in monetary terms because that is only one thing we know, money, money, and money. Cost of illness and burden of disease is another aspect, and that encompasses various aspects of the disease on health outcomes in a country, specific regions, communities, and even individuals. The category of cost of illness can range from the incidence or prevalence of disease, its effect on longevity and morbidity, along with decrease in health status and quality of life, financial aspects including direct, indirect expenditures that result from premature death, disability, or injury due to the disease or its comorbidities. Now, the whole purpose of a cost analysis, I will call it cost analysis, is to formulate and prioritize healthcare policies and interventions and to achieve policy efficiency. Now, that is the basic criteria. Now, this subject is known as pharmacoeconomics. And when we talk about pharmacoeconomics, I talked about cost-benefit analysis. That basically is both cost and benefits of a new drug or of a health intervention are converted into monetary terms, although it's very, very difficult to attach monetary value to healthcare. Cost-effective analysis, when two or more alternative strategies are compared by measuring the costs and outcomes of each, they can be assessed as natural units like life year gained, reduced mortality, morbidity, blood pressure, etc. Cost utility analysis,
The intervention outcomes are measured in terms of utility or preferences like disability adjusted life years or quality adjusted life years. Now, the daily can be seen as one of the lost year of healthy life. Daily adjusted is 1 year of healthy life is lost, and computed as the sum of years lost due to disability for people living in ill health condition, and the years of life lost due to premature mortality. The quality of adjusted life years is measured on a scale from 0 representing death to 1 representing 1 year of perfect health, and it is routinely used to measure the outcome of health evaluations for all kind of individuals and for all kinds of drug or diseases. So this is basically, once these two you have, then you look at the incremental cost effective ratio, and this is further going into details. Now look at the cost of employees' health in US, a whopping $178 billion for wages and benefits for incidental absences due to illness. $198 billion for diminished productivity. 1.4 billion, 73 billion. Look at the amount of cost that is lost if the employee gets sick. Let's look at the Indian healthcare. In 2013-14, the data that I could get, India's total health care expenditure was 4.5 lakh crores. Unfortunately, we are spending, majority of us spending from our own pocket, and that was 2.9 lakh crores was being spent from this portion. And this is equivalent to 4% of the GDP. Look at what the US is doing. In comparison, the government's expenditure on healthcare was just 1.5% of the GDP. The Indian government is not spending much on healthcare. They have realized this after COVID, and now because our Honorable Prime Minister has become wiser after COVID, he has now increased the GDP. Meanwhile, 1.5 lakh crores of Indians' healthcare cost goes towards pharmacy. If you look at US and European, 17.3 and 9.9% of the GDP was there in healthcare way back in 2014. So this is, I talked about what is the expenditure. Now coming to the cost of illness, what studies do they do? They evaluate the economic burden that an illness will impose on the society as a whole. Itemize, value, sum of the cost of a particular problem with the aim of giving the economic burden, and I'll give you an example of it later. The underlying assumption is that this represents the potential benefits of a healthcare intervention if it can eradicate the illness. And it also measures the burden of years of life lost due to premature death and years lost due to disability or morbidity. And these two categories, as I talked about, disability adjusted life years. Now there are various formulas they use. One is the population attributable fractions, which is product of relative risk and prevalence risk factor, and they calculate. Now let me give you some of the evidence prevalence based studies that are analysis that are done. What is the cost incurred during year by persons with a particular illness? Estimates the magnitude of disease costs on annual basis, assesses economic burden attributable to acute or transient conditions, and does not quantify long-term consequences of behavioral illness. That is very important. It is not taking into account behavior. Now let's look at some of the costs, direct costs. What is the value of resources? Personal health care, hospital care, professional services, medications, etc. And there are certain indirect costs. The value of lost output due to morbidity, as I talked about the employee getting sick, or mortality, the future earnings in a family, young person dies. What is the cost? Look at the huge list of direct healthcare costs. I'm not going to read it. But this is again, as I said, tip of the iceberg. There are direct non-healthcare costs like social services, counseling, transportation, time, etc. And indirect costs like morbidity, impairment, absenteeism. And these are something, you add up, it's enormous. Now let me give you an example of obesity and diabetes because they both go together. 7 out of 10 of the countries with the greatest number of diabetics are in the global south, we all know, and this is going to increase. I'm not going to go on that. And greater incidence at earlier stages of life, as has already been discussed. Nearly 1 out of every 3 hospital bed days is occupied for diabetes-related causes. Imagine. In India, 15 to 25% of the household income is required to cover treatment cost. I won't go into Tanzania, China, they have got others, but I'll talk about India. But look at the cost, total cost of obesity, economic. Patient will have diabetes, $11.5 billion. Gallbladder disease, 2.4. Cardiovascular, $22 billion. Hypertension, cancer. The cost keeps on adding up. Total cost comes to around $40 billion. You revise the estimate because the patient is going to develop musculoskeletal problems, and it jumps to 45 or almost $46 billion. You add the indirect cost, lost productivity, 20 billion in US, 23 billion updated study, and then level of sickness absence, then 7% of total productivity lost due to obesity, 27% of the growth in real capita spending between 87 to 2001, and this is prevalence of obesity is increasing, so the cost is recurring and is increasing. You can imagine the enormous cost spent in the treatment of obesity and diabetes. Now look at pain, another very common thing. It has a lot of problems, sleep disturbances, depression, anxiety, decreased quality, disrupted routine life, reduced social activities, disability, absenteeism, etc. And if you look at the productivity, almost 12 hours are lost due to pain in 15 days. So what work the patient will do? And that is not counted. Look at the critical illnesses in our country, cardiovascular, lung, cancer, liver, kidney diseases, and look at the cost. Look at the cost, 3,50,000. However, we are still much better off, because if you compare it with, say, abroad, the cost of a heart bypass surgery is $144,000 in US, but only $5,200 in India. So that way we are much better off. And there are other things also, like the cost of hip replacement, $50,000 in US, $7,000 in India. The question comes, are these cost-saving studies really needed? They are either fully or partially preventing a given disease to a large extent is basically illusory. Assuming all the costs attributed to a given disease could be measured accurately and that adequate prevention were introduced, the cost savings from using cost illness calculations are likely to be overestimated, because there are very few diseases that can be eradicated. So the total cost of treatment will not be saved. When prevention fails, there are certain capital investments already done, like clinics, they'll continue to treat those patients who still have the disease. So that margin of cost again comes down, cost saving comes down. Although treatment cost may be high, the cost of prevention could be greater at times. So that is also another aspect. And a high cost condition, it is not necessarily amenable to treatment by current medical technology. In contrast, a condition which presents a low cost to society may be fully amenable to prevention with very low cost, leading to high individual health gains. Now let us look at 2 examples, phenylketonuria and breast cancer. If you just screen patients for phenylketonuria, the amount of benefit that you're going to get is much better than screening every lady for breast cancer. And this is what the whole thing is about. Prevention is simple and inexpensive, and the health gain to the individual is great in patients with phenylketonuria. So these studies may divert decision makers' attention away from areas where important health gains can be made at a low cost. So though they are widely undertaken, the cost of illness studies add little to the creation of an efficient healthcare system. But it should be better focused on undertaking economic evaluations such as cost-effective analysis, and this is looking at both the cost and the outcomes. That is more important. Now, let me show you one wonderful study published recently, cost effectiveness of empagliflozin in patients with heart failure with preserved ejection fraction. And this, what did this study do? It shows that the cost is $437,000. This is done in US, and the cost of SGLT2 inhibitors is exorbitant there, not like our generics. And they said it is of low economic value. Now try explaining this to a patient who comes to you with heart failure with preserved ejection fraction and has come and heard from Eugene Braunwald that this is the only treatment which is a game changer in heart failure with preserved. Will you tell him, no, it is not cost effective? No, you will not tell him. You will write to him. No cardiologist will deny a patient of heart failure with preserved ejection fraction the benefit of SGLT2 inhibitor. So they are saying that, okay, we are going to look at this study again when the cost of EMPA comes down. Now, see, when people get old, over the age of 50 years, they start getting ill. So this is another very good study which was done, how much money they have saved for their health. 40% said we have enough savings to pay for health care that we might need. 27%, I can't afford health care. 18% did not care about health care. 13% never thought that they will get it. So this is the current situation. So what is the answer, friends? I would like to quote Warren Buffett, the investment guru, who said, the best investment you'll ever make is in yourself. So prevent illness. Exercise daily, sleep well, reduce salt intake, maintain healthy eating habits, and the cost will come down. Thank you.
Thank you. Thank you, Dr. Vermani. It's a very wonderful talk, but it is beyond our purview. Sir, you have talked about the budget of the healthcare provider. What is the budget of the patient? Because we have read somewhere that 65% of the cost in India is borne by the patient himself.
Absolutely. Majority, not 65, I'll say majority.
And
we don't have an insurance system.
And healthcare is our birthright, constitutional right. But where they are, the government hospitals are free, but they are catering only 20% of the population. 80% of the population is being cared out by the private doctors and private hospitals. So what is the best solution? I think after prevention is the best, but in between there is something, I think, if we ensure, if there is health coverage of all the population, would it reduce the cost?
See, the best solution, as I said, is preventing illness.
That is
Number
true.
2, when having said that, if you cannot prevent illness, then you need to have a system where the government takes over the total health care. And all private health care is abolished. But unfortunately, that can never happen in our country because ours is a very vast and heterogeneous population. So it is impossible to have. Third option would be to see that everybody gets insured.
Yeah.
But again, the problem is that the insurance companies,
they don't
take
agree.
advantage of that and they give inflated bills.
Yeah.
So it's a very, very dicey situation.
Yeah.
The best way is prevent illness, as simple as that.
Thank you, sir. Thank you very much. Such a nice and wonderful talk. Our next speaker is Dr. Shankha Sen. He is MD FRCP, nephrologist and fellow of Hypertension Society of India. He is from West Bengal. He is a very eminent physician from West Bengal. Now over to Dr. Shankha.
Thank you, sir, for your kind introduction. At the outset, I thank the organizing committee, particularly Dr. L. Srinivasmurthy and the whole team of the SCP India chapter for awarding me this talk. My talk will be on what combinations of drugs that can cause acute kidney injury. So I belong from Shiliguri, it's in the northern part of West Bengal. And I'll be speaking on acute kidney injury, which is a syndrome characterized by the rapid loss of kidney function, and it is clinically diagnosed by the accumulation of nitrogenous metabolites and with decrease in urine output or both. And AKI supersedes the term which was previously used, acute renal failure, and is a spectrum extending from a less severe form to an advanced form which necessitates the need for renal replacement therapy. The incidence is quite high, and AKI in hospitalized patients is more than fourfold increased likelihood for death. So it's quite a huge problem, and acute kidney injury is something quite different from chronic kidney disease. And the hospital survival, the rates are also quite high in patients who are having more higher stages of acute kidney injury from no AKI to stage 1 to stage 2 or stage 3. The AKI definitions are, multiple definitions are there. We know the Rifle classification, which involves risk, injury, failure, loss, and ESRD, and the Akin classification where stage 1, 2, and 3. So AKI is mainly defined as with an increase in serum creatinine of more than or equal to 0.3 milligram per deciliter within 48 hours of the onset, or if it is more than 1.5 times the baseline, and if the urine volume is less than 0.5 ml per kg per hour for last 6 hours. So we have to pick it up early also, so we have to treat it early. Now regarding community-acquired AKI and hospital-acquired AKI, the number is huge. Sepsis leads, then CKD, background CKD is also another thing which you should keep in mind when we are thinking of the severity of AKI. There are certain modifiable risks like volume depletion or hypotension, exposure to concomitant nephrotoxins, high-level exposure to nephrotoxins, and excessive medication dose for underlying GFR. And the non-modifiable risks are advanced age, comorbid conditions, high-risk settings like ICU and burn units, shock states, stem cell transplantations, and genetic vulnerability. The patient factors are also quite important, but how common is my topic, that is drug-induced AKI? In USA, it is around 14 to 26% of adults in prospective cohort studies and 37.5% in cross-sectional study. And in developing countries, more than 85% of the global burden of AKI is drug-induced. So it's a huge burden. The medications are a common cause of AKI, and that's the point of today's discussion, especially for patients who are admitted to hospital wards and ICUs. Now the medications can cause injury by various mechanisms. Direct acute tubular injury develops from several medications which are toxic to various cellular functions. The respiratory pathways through the proximal tubules contribute further to AKI. Drug-induced acute interstitial nephritis also occurs when the medications elicit a T-cell mediated immune response that promotes tubulointerstitial inflammation leading to AKI. Several medications cause acute tubular injury due to their innate toxicity and kidney handling, and another pathway of injury results from the insolubility of drugs in urine leading to their intratubular precipitation and crystals which are associated autoinflammatory response. There is another term that is pseudo-acute kidney injury, which is caused by drugs that blocks the tubular creatinine excretion, as well as hemodynamic causes of increases in serum creatinine should be considered while evaluating our patients. Now etiology, there are pre-renal etiologies, there are renal etiologies, and post-renal for AKI. Now the drugs which are discussing is regarding the renal etiology, and the renal cause of AKI is very important. It can occur in various stages. There are various stages of development of AKI, and most importantly, the vasoconstriction in the afferent arterioles, NSAIDs, as you all know, is quite important as an injury, which causes injury to the kidney. The SGLT2 inhibitors by the tubuloglomerular feedback. Now the AC inhibitors and ARBs, they act on the efferent arterioles. Proximal convoluted tubules, the molecules which act on are aminoglycosides, amphotericin B, tenofovir, cisplatin, and polymyxins. The thick ascending loop of Henle, the diuretics and the aminoglycosides act there. So very importantly, we are certain areas of the nephron are affected by various mechanisms, and their risk factors of nephrotoxicity are inbuilt, and we have to be very careful. And this diagram summarizes quite a bit. Now, can we halt the progress of drug-induced AKI? Yes, see, there is a window period. From the initial renal injury to ultimately their detection and the ongoing injury over time, there is a window period from 8 to 48 hours. But what is important, we always measure urea creatinine, but the creatinine will start rising after 48 hours. So we can't wait for that. So we need better biomarkers so that we can pick them early. So instead of serum creatinine, cystatin C is available for AKI. And most importantly, in patients with AKI, serum creatinine does not increase until there is moderate to severe reduction in GFR. Thus, its use for estimating GFR in early AKI delays the detection of the kidney damage. And serum cystatin C is a better marker in early stages as it is less affected by age, gender, muscle mass, and ethnicity. And multiple logistic regression analysis revealed cystatin C-based GFR reflecting decline in GFR with worsening AKI is better than creatinine-based GFR. And another important thing, MDRT is meaningless in acute kidney injury. We use serum creatinine to calculate the eGFR. It's for chronic kidney disease, not for acute kidney injury. And very importantly, a small change in creatinine is also very meaningful if you are dealing with kidney. Now, I am going into some clinical scenarios where multiple medications are causing acute kidney injury. Scenario 1, a 60-year-old gentleman with congestive cardiac failure was on Ramipril, developed proteinuria, and was started on an ARB, like a Sartan. Serum creatinine levels started rising from the next day. So we all know the lesson is SC inhibitors and ARBs should never be used together. Scenario 2, a 65-year-old diabetic gentleman who was on oral hypoglycemic regimen, which was dapagliflozin, an SGLT2 inhibitor was a part of it, and he presented with pedal swelling. He was found to have pedal edema, proteinuria, and the BP was quite high. So Ramipril was started because it will help not only in the hypertension, but also in treating proteinuria. What happened? There was an acute rise of creatinine after 5 days. These are small things we should keep in mind, so I put this case scenario. See, the SGLT2 inhibitors are commonly included, and we all prescribe SGLT2 inhibitors and ARBs together. But certain cases like SGLT2 inhibitors specifically alter the renal hemodynamics, which contribute to increased sodium delivery to the macula densa, which is sensed as an increase in circulating volume at the level of the juxtaglomerular apparatus, and thereby there is a secondary autoregulatory vasoconstriction of afferent arterioles, a decrease in intraglomerular pressure, and there is a reversible decrease in GFR. So after the initial fall in GFR, there is a trend towards increase over time. But we should keep in mind, initially there will be a fall in GFR when you are adding the molecules together. SGLT2 inhibitors have a positive effect on the progression of CKD, particularly diabetic kidney disease, but there is a concern that they might cause AKI. So this one we should keep in mind in the acute setting. And there is no contraindication for simultaneous use of both molecules, but better to introduce both of them sequentially, not together. Now the scenario 3, a 60-year-old lady detected to have CA ovary, underwent contrast CT abdomen, thereafter started on cisplatin chemotherapy. Rise of serum creatinine levels occurred after 2 days. Here also, 2 molecules which are nephrotoxic are important. We have to use least possible isosmolar contrast. Hydration should be there. We should give a gap between the contrast study and the cisplatin chemotherapy to be started. We should check whether the patient is on metformin or diuretics. And we should always try to delay starting non-critical nephrotoxic medications by 48 hours after the contrast study. So this is also an important take-home message. So anti-cancer drugs cause AKI, and there are by various mechanisms, and this diagram says it all. Scenario 4, a 45-year-old lady with rheumatoid arthritis on methotrexate, she received zoledronic acid for severe osteoporosis, and she developed acute tubular necrosis. We know that zoledronic acid causes acute tubular necrosis, but on the background of usage of methotrexate, the patient can be renally challenged by that time because there are multiple mechanisms by which methotrexate can have a background of kidney disease. So the lesson is methotrexate nephrotoxicity is dose dependent. Methotrexate toxicity and renal impairment may be a fatal situation, and it can be removed by high flux dialysis. Scenario 5, a 55-year-old HIV patient with hepatitis C co-infection on indinavir, lamivudine, abacavir regimen was started on amphotericin B for cryptococcal meningitis. She developed AKI with hypomagnesemia. And what is important is it was crystalline nephropathy, and crystalline nephropathy is common with these molecules, and this can cause acute kidney injury. Scenario 6, a 65-year-old gentleman with left ventricular failure developed frequency and burning sensation during micturition. Urine culture yielded the growth of MDR Klebsiella pneumoniae sensitive to amikacin. So we get many patients in our ICU where the patient with LVA presents with UTI, and as it was an MDR Klebsiella pneumoniae sensitive to amikacin, which was started, the serum creatinine levels started rising after 3 days. So what was the scenario there? The patient should always be on diuretics because the patient is having LVF, and diuretic and aminoglycoside together, the excessive diuretics caused volume depletion, and the cell necrosis by the proximal convoluted tubule by the aminoglycoside led to this clinical deterioration in this patient. The scenario 7 is a frail 60-year-old nursing home resident admitted with cellulitis, and for that the person was put on vancomycin after initial less response to coamoxiclav. Later she developed pneumonia and started on piperacillin tazobactam. So after vancomycin, piperacillin tazobactam was added, and AKI set in after 2 days. So piperacillin tazobactam potentiates the nephrotoxicity of vancomycin. So both are important because potential toxicity is the acute interstitial nephritis associated with the beta-lactam agents like piperacillin tazobactam, and the direct tubular toxicity associated with vancomycin came into the picture and caused the harm. Scenario 8, the 55-year-old lady taking ibuprofen for chronic knee pain, that she is on NSAIDs. She presented with flank pain, reduced urine output and raised creatinine after starting on pantoprazole. And we always commonly prescribe pantoprazole or any PPI along with any NSAID we prescribe. And the patient developed acute interstitial nephritis. The NSAIDs, as I said, it causes acute afferent arterial constriction, I showed in the previous diagram. And for PPI, acute interstitial nephritis ranks amongst the rare adverse events. This immune-mediated reaction involves the interstitium and renal tubules, and it causes acute inflammation, tubulointerstitial damage, which in the long term leads to interstitial fibrosis and chronic interstitial nephritis. And approximately 30% of patients who recovered from AKI remain at increased risk of progressing ultimately to CKD. So we should keep in mind that PPI long-term use, and in certain patients we can do more harm than good. So all these combinations, as I said, are causing harm because we should keep in mind the mechanism of action and mechanism of it causing renal injury. So will COX-2 inhibitors be safe? Because they only have GI toxicity is less, but the renotoxicity and cardiotoxicity is there. So not even COX-2 inhibitors are safe among NSAIDs. So we should discontinue the drug if the patient is having acute interstitial nephritis. Corticosteroids should be started. Even then, if it fails, may progress to CKD with interstitial fibrosis and tubular atrophy. So clear recommendation, clinicians should attempt to identify other patient-specific risk factors before starting empiric therapy. If a patient is at increased risk of AKI, we have to think of antibiotic options which have a decreased risk. If the patient does experience AKI, we should discontinue the offending agent immediately, decrease the doses of all other medications, and adjust the dosages. A clinician should attempt to correct, stabilize all modifiable risk factors prior to initiating therapy with a nephrotoxic antibiotic. All clinicians should de-escalate antibiotic therapy once causative pathogens have been identified to potentially limit the duration of treatment. Drug combinations can cause AKI in both OPD and indoors, including ICU. Prior knowledge about unsafe combinations is the need of the hour, and that is our point of discussion today. And early recognition with drug discontinuation is critical to avoid CKD from irreversible kidney fibrosis damage. I have 30 seconds left because 2 minutes were shortened. Just my last slides, that drug combinations are important, and there are teams of scientists developing tools and calculators to better predict AKI. Good days are coming because these Rank and colleagues are testing a recurrent neural network. These networks are coming up. Clinicians would then be able to provide optimal care early to minimize risk and long-term adverse effects of AKI. So prediction of AKI is important, and certain tools are there. And over the next 5 years, we hope that clinical utilization of cystatin will provide more data about its generalizability and utility in drug dosing and AKI detection. Other biomarkers will likely start being evaluated in patients, but will still likely lag behind cystatin in implementation. The research needs to focus on epidemiological studies, and finally, the importance of antimicrobial stewardship will only be emboldened by support from the certain authorities. Thank you for your patient hearing, and I hope I concluded more or less on time, sir.
Thank you, Dr. Shankasen. You have done a very nice job. It's a very wonderful and nice presentation. I am really wondered to hear about SGLT2. Does it cause AKI?
Because, sir, my points, sir, 8 to 10 cases I've described. I was also, when I was thinking about what combinations, sir, in an acute setting, it's better not, the patient is critically ill, admitted in those settings, because it is helpful in CKD and particularly diabetes kidney disease. But sir, this one, and in AKI, because concomitantly it is acting on the macula densa, and what is happening, there is afferent cortical constriction is there. So
what is the incidence of AKI with the SGLT2 inhibitors?
Sir, that has been recorded, and these are literature. I can't give you the exact study, but AKI, in AKI setting where the patient can land into AKI, we shouldn't introduce this patient on this. And sir, another important thing I mentioned about the 7th case was we usually forget about the proton pump inhibitors. And we co-prescribe with all molecules nowadays. So
wonderful.
This is probably the important point, and when Dr. Narsingh Verma sir gave me this topic, I thought that this point should be highlighted because these are the take-home messages.
Great. Any question from the floor of the house? Yes, Dr. Virmani, sir.
Sir, no questions, please. Comments, please, sir. I can't answer your questions. You please comment. Give him the mic, sir.
The meta-analysis of SGLT2 inhibitors have shown that they are very safe. They do not cause acute kidney injury. But when initially they start, there is a slight increase in serum creatinine or a dip in the eGFR. And this dip is because of hemodynamic reasons. And then the eGFR gradually rises and plateaus off. What he was trying to say is, in a patient who is critically ill with acute kidney injury, SGLT2 inhibitors are contraindicated. But as such, they do not cause there is no significant increase in AKI.
They are the wonder drugs. Thank you, sir.
I'm supporting him, just to support him.
And sir, you have not mentioned certain homeopathic drugs like containing arsenic, lead and gold. They do cause.
Yes, sir, very importantly, sir.
Mostly Ayurvedic, not homeopathic. Most Ayurvedic drugs are containing heavy metals like mercury and lead, and they are the major cause of chronic kidney disease or acute kidney disease in our country. Major cause.
Yes, sir. Various kadha. Thank you, sir. Thank you so much. Thank you. Now I conclude this session.
Thank you, chairpersons. For the next session, I would like to invite Dr. Subrata Bhattacharya, Senior Consultant Physician working in field of cardiology and diabetes from Kolkata, and Dr. Kiran Soni, ma'am, Senior Consultant Anti-Obesity, Yatharth Super Specialty Hospital, Greater Noida. Ma'am, please come on board. Over to chairpersons.
Good evening to all. Now the sessions we started with the diabetes in women. How is it different? And managing the pregnancy in lupus. There are two speakers. The first speaker is Dr. Urbi Chawla, who is a life member, the consultant physician and head of the ICU Lifeworth Hospital, Raipur. Life members of PPI, RSSDI, DIPSI, and IRA. Chairman of API, Raipur chapter, district coordinator of state, RSSDI, and so on. No. Oh, sorry. The managing pregnancy with lupus. You are the first speaker. Sorry. Is Dr. Arun Kumar Kedia. I have already given the his CV, the CV. He will talk about the managing pregnancy in the lupus. Please start.
Thank you, sir. Thank you for the kind introduction. At the outset, my sincere thanks to Anuj sir, Narsingh sir, Srinivas Murthy sir, Anubha madam for giving me this opportunity. and giving this very pertinent topic to me, which is something very close to my heart, which I personally take it very seriously in my practice, that is managing pregnancy in lupus. So when it comes to pregnancy, I think it is a prerogative of every woman, irrespective of whether she is diseased or she is normal. You name any disease, you ask that female, she will be always ready to become a mother. But it is our responsibility to decide whether she can safely carry out the pregnancy or not. And that is where the onus on doctors lie, that we need to learn to manage pregnancy in all chronic as well as acute diseases. So with that introduction, the basic principles of managing pregnancy in lupus are 4. Number 1, we must remember that a successful pregnancy is possible. So prior to the older thinking that we clinicians used to dissuade the patients from carrying the pregnancy forward, now with good drugs, with good understanding of SLE, it is possible to carry a successful pregnancy. But we need to remember that it is possible only if it is properly planned, properly monitored, and properly managed. Second important thing that we need to remember is successful does not mean uneventful. So we must counsel all the patients and the relatives that despite all precautions that we will be taking, there may be some untoward events and there is a chance that we might lose the fetus or might lose the mother. So counseling is very important. At the same time, we must keep in mind all the absolute contraindications, which I'll come later. And what is most important is the disease must be kept under optimal control for at least 6 months prior to conception. So these are the basic principles. If we keep in mind, probably we will be able to manage all our patients well. So the very important thing is we must remember that SLE may affect fecundity as well as fertility. And the various reasons are most of the SLE patients become mother at a very delayed age because they require some time to get over into disease remission or a drug washout. At the same time, all these ladies have menstrual irregularities due to inflammation, due to disease activity. There are certain corpus luteum antibodies and they have a high circulating FSH. At the same time, these ladies might be on drugs which might be gonadotoxic like cyclophosphamide. There may be steroid-induced reduced libido. There may be menstrual irregularities. There may be renal failure due to lupus nephritis which cause hyperprolactinemia. There may be antiphospholipid antibody syndrome which leads to recurrent thrombosis and recurrent fetal loss, and there can be psychosocial problems leading to depression and decreased libido. So all these factors contribute to decreased fertility. So what is important is a preconceptional counseling and assessment, which includes the foremost is to assess the disease activity so that we can ensure a good conception occurs only before the disease is into remission. Second, we must assess the disease burden and the presence of organ involvement, especially the target organs. Look for presence of antiphospholipid antibodies, anti-Rho, anti-La antibodies. Check the medication regime. Take a detailed history of what drugs the patient has already been on. Look for other comorbidities in these patients, including diabetes, hypertension, and discuss on contraception issues if the patient is unlikely to become pregnant for the next time till the time she is into remission. So these are the absolute contraindications which we have to keep in mind whenever a patient comes to us, and we must not let them become pregnant if they have any of these, including severe lupus flare, a stroke within the last 6 months, pulmonary hypertension, moderate to severe heart failure, kidney failure, severe valvulopathy, and uncontrolled hypertension or previous severe early onset preeclampsia. So these absolute contraindications have to be kept in mind. Pathophysiology, I'll not go into details. Mostly it is the hormonal changes that occurs in the pregnancy which causes the flare. And what we need to also remember that there is a decreased level of anti-inflammatory steroids, elevated levels of prolactin, which all lead to flare intrapartum as well as the postpartum period. So once the patient decides to become pregnant, we need to have lab evaluation at the confirmation of pregnancy. And the basic tests include a complete blood count, a renal function test including determination of GFR, urine analysis, and UACR. At the same time, we must look for the test for anti-Rho, anti-La antibodies, look for lupus anticoagulant, anti-dsDNA levels, and the complement levels. So if you do these basic tests, this will help you to judge whether these patients can safely carry on the pregnancy. At the same time, you will also be able to guide on the disease activity. But what we need to remember is that pregnancy and lupus, they work both ways. So one exacerbates the problem of the other, and there are certain risks of lupus to pregnancy. At the same time, there are certain risks of pregnancy to the lupus, and both have to be kept in mind while managing these patients. So if the flare occurs during pregnancy, this is the most common and most dangerous dreaded fear that we look for, and they are not uncommon. They usually occur in the first or second trimester, but the best part is the flares are usually not severe. They are mostly mild, related mainly to the skin and the musculoskeletal system, sometimes to the hematological system. Most of the time, de novo flare of kidney disease is very, very uncommon, almost to the less than 2%. And the predictors for lupus flare is usually a disease activity at the time of conception and the presence of lupus nephritis in the past. So if the patient has these two things, then you must think of a disease flare in the intrapartum period. So there may be a flare during pregnancy, and the flare risk increases with the active disease in the last 6 months of pregnancy, active disease at conception, history of highly active disease prior to pregnancy, and the most important and the most dreaded thing that we need to understand is the discontinuation of hydroxychloroquine. So if a patient has discontinued hydroxychloroquine, remember that she is likely to have a flare. So this is very important message. At the same time, there are certain physiological changes that occur in pregnancy which might mimic to flare of lupus. So the cloasma of pregnancy might look like malar rash. There may be proteinuria secondary to preeclampsia, which could be mimicking the proteinuria due to lupus nephritis. There can be preeclampsia, which might mimic a lupus flare. Then thrombocytopenia of pregnancy due to HELLP syndrome, mimicking the ITP or TTP in lupus flare. And then the pedal edema and fluid accumulation in joints, which could mimic the arthritis of SLE. So these mimics have to be taken into mind. They must be evaluated well, see them clinically, judge them clinically before jumping onto a diagnosis. These are the differentiating features between preeclampsia and lupus nephritis. Very important, urine sediment. If you have an active urine sediment, it favors always and always lupus nephritis. This is the most important differentiating feature. Apart from that, you can use anti-dsDNA levels, which are likely to rise with lupus flare. Then you can have complement levels, which will serially go on decreasing with lupus flare. And of course, the uric acid, which rises with preeclampsia, could be another differentiating feature. So there are adverse pregnancy outcomes associated with lupus in the form of preeclampsia, preterm labor, thrombosis, loss of fetus, hematological complications, IUGR, pregnancy loss, and all these things have to be kept in mind whenever we discuss these issues with the patient. At the same time, these patients are prone to urinary tract infections, gestational diabetes mellitus, hypertension, and premature rupture of membranes. All complications of pregnancy have to be borne in mind while managing these patients. Now, once these patients come for follow-up, we must, during the first trimesters, you do a monthly platelet, a CBC, and in addition, you must determine eGFR, measure the urinary albumin creatinine ratio, do complement studies wherever possible, do anti-dsDNA wherever possible, especially in every trimester. And if there is a difficulty in differentiating preeclampsia versus lupus nephritis, then in very selective cases, you might go for a renal biopsy, though most of the time we defer. So the key to management is an integrated team. The team should consist of a rheumatologist or a physician who is active and trained in managing SLE, an obstetrician who is experienced with high-risk care, a pediatric cardiologist who can take care of fetal heart blocks, and preferably a nephrologist should always be there in the team whenever there is a risk of lupus flare in the form of nephritis. So this is a very busy slide from the International Journal of Women's Health, which summarizes the lupus management during pregnancy. But I'll just show you another slide which gives a very comprehensive way, and it says that during the preconception, go for clinical review, drug review, antibodies, and avoid pregnancy wherever I have told all the contraindications. Once the patient is pregnant, go for clinical review, look for disease activity, look for disease manifestations, check the drugs that the patient is taking, look for antibodies, and once the patient has delivered, then again you need to do a clinical review, check for antibodies, look for drugs. So The monitoring of the patient is throughout the pregnancy, right from preconception to postpartum. It is very, very essential. Now, there are certain management guidelines. This is ACR 2020 guidelines. The first line, it says counsel women. So all women with SLE must be counseled regarding pregnancy, regarding the improved maternal and fetal outcome associated with entering pregnancy only during low disease activity or in remission. This is the first thing that you must do. And then there are tests which I have already told, especially the tests that are strongly recommended are the anti-Ro, anti-La antibodies and the testing for antiphospholipid antibodies. At the same time, in patients who have positive anti-Ro, anti-La antibodies, you must go for fetal serial echocardiographic examination starting from 16 weeks up to 28 weeks. And if the patient has a past history of congenital heart block in the previous pregnancy, then these fetus need a weekly monitoring in the form of fetal echocardiography to look for complete heart block. Pharmacotherapy, most important drug is hydroxychloroquine. It should never be stopped. All pregnant patients should continue taking hydroxychloroquine. Low-dose aspirin may be added in order to give more benefits. And those patients who test positive for anti-Ro, anti-La antibodies should continue taking HCQS because that is the only drug to prevent complete heart block. And for those patients who show first degree or second degree heart block, then these patients are preferably started on oral steroids so as to prevent the fetus from going into hydrops fetalis or complete heart block. The EULAR guidelines, again, they give a stress on hydroxychloroquine. They also mentioned that there are certain drugs which are to be avoided totally. One is mycophenolate, the other is cyclophosphamide, leflunomide, and methotrexate. So these are the 4 drugs which have to be completely avoided during pregnancy. So this is the list of drugs which are safe to use in lupus, though we have to check the doses. And this is the table which says which drugs to be given preconception, which drugs need to be stopped prior to conception, and which drugs are totally not compatible with pregnancy. This table is available in all standard books, and we must keep it in mind whenever we manage patients of lupus with pregnancy. Now, what happens when the patient develops renal disease? We must explain to them that there is an increased risk of fetal loss. These patients have to be managed with IVs, pulse steroids, and sometimes, if required, in order to save the mother, you might have to use even IV cyclophosphamide or IV rituximab. So these patients, if they are mild disease, then they can be pulled on with azathioprine or low-dose corticosteroids. A brief word about neonatal lupus. This is a temporary condition which lasts around 6 to 8 months after the birth. This is due to the passive transfer of the maternal autoantibodies into the fetus, and that is why it wanes off. It typically presents with either a congenital heart block or a lupus rash. Lupus rash is much more common than complete heart block, and usually it is uncommon. Not more than 10% of the fetus will develop neonatal lupus. Congenital heart block is dreaded. It occurs in 2% of newborns. The recurrence is high. If the previous pregnancy, the fetus had a complete heart block, then there is a likelihood that this pregnancy also the fetus will have a complete heart block. The mortality is almost to the tune of 20%, and most of the patients who survive, 70% of these fetuses will require a pacemaker. And that is why you need to have a pediatric cardiologist in the team. Coming to management of antiphospholipid antibody syndrome with lupus, so we have 3 categories of patients. One could be asymptomatic carriers where the antibodies are positive, but patients do not have any obstetric complications or thrombosis. So these patients usually just require observation, and a low-dose aspirin can be used. For patients with obstetric antiphospholipid antibody syndrome where the antibodies are positive and there is a history of previous obstetric complication but without thrombosis. So these patients are treated with a combination of aspirin and prophylactic doses of heparin. But for those patients who have established antiphospholipid antibody syndrome with prior thrombosis, then these patients require therapeutic doses of heparin throughout the pregnancy and up to 6 weeks postpartum. So these conditions have to be kept in mind. This is the most important slide that I would stress upon in the last 1 minute. The potential deficiencies and issues we still face in the adequate care of lupus pregnancies. And the areas that we need to work upon is the lack of risk stratification, lack of multidisciplinary care, lack of dedicated lupus pregnancy units that we have, cost or access to investigations, cost of medications, poor access to fetal echocardiogram, lack of adequate awareness, lack of preconception counseling, poor adherence, unplanned pregnancy in our country, delayed diagnosis of lupus, delayed referral, and inadequate number of trained people with lot of infections contributing to both fetal and maternal poor outcome. So in conclusion, a multidisciplinary team involving a rheumatologist or a trained physician with an obstetrician is highly desirable for management of lupus with pregnancy. The lead should be taken by the rheumatologist because he knows the pathophysiology of lupus, which is very important for management of pregnancy. And the existing rheumatologists, it is necessary that they take an interest in managing pregnancy lupus because most of the time the rheumatologists defer to manage these patients or they take more interest in arthritis than in reproductive rheumatology. So with that, I thank you all for a patient listening.
Of very uncommon topic and giving such a deep insight into the topic. Thank you very much.
Thank you, ma'am.
Chalo, bhaiya. ये ऊपर आ जाएगा।
Yes, sir. Our next speaker, Dr. Sajid Ansari, will speak about the synuria to dioxin, whether any role left. Here is the organizing secretary of BPCon 2020, the coordinator of preventive cardiology and the Cardiological Society of India, President-elect Clinical Cardiology, Cardiodiabetic Society of India, and so on. Please start.
Thank you, Chairperson and whole organizing committee. Topic given to me is really very interesting. Those drugs we are using since last maybe 100 years. Is it time to say farewell? Bye-bye? Let us come and discuss. What was happening and what still happen when patient is coming with the heart failure? Patient coming with a rheumatic mitral stenosis from very poor bed. Those don't having option for the replacement for MVR and so on, even PTMC. Even in the government setup rate is around 1.5 lakhs. How to control the rate if suppose patient is having a fast ventricular rate? Option is only 3D, diet, diuretic and digoxin. So let us come and discuss these things. We know digoxin was used since long, and in 1954, this was approved by US FDA. And since that, we are using continuously. And me as a cardiologist, practicing cardiologist, I am confessing I am using digoxin here and there. Problem arises when, and this is true, not only matter of afraid, toxicity of digoxin. This need to discuss with the patient, this drug I am using, why I am using, and how to reduce their toxicity and how to monitor it. So as a physician, as a cardiologist, we know everyone having their ECG in our clinic. Go for free ECG. Let us monitor their side effect and interaction. So this is my purview regarding this dioxin. Coming to their effect and electrophysiological and electrocardiographic effect, this has some effect on the neurohormonal axis, electrophysiological axis at cellular level and at hemodynamics level. At cellular level, we know this inhibit the enzyme sodium potassium ATPase
and this in turn there is an excess of sodium ion in the cardiomyocytes, and this in turn causes diminished extrusion of calcium ion from the cardiomyocyte, and cardiomyocyte get overloaded with the calcium ion, and this in turn causes increased force of contraction. There is a various mechanism of action: cardiac, extracardiac action, vascular smooth muscle cells. So this is a positive inotropic effect, negative chronotropic effect, and negative dromotropic effect, if I will summarize it like this. There is some pros and cons related to this digoxin, and what is the pros and cons? If you see the benefit of digoxin, really this is a very cheaper molecule and we can use easily. This having positive force of contraction, having some anti-adrenergic property, improve ejection fraction. This is a wonderful molecule, especially when you are having the poor LV function. What happened in HFrEF patient? Nowadays in our armamentarium, we are ORNI and SGLT2 inhibitor. Now that is a very cost effective. But when SGLT2 inhibitor was very expensive and ORNI is still expensive, what we can do for this HFrEF patient? And this is true regarding this digoxin, that this never causes a reduction in the mortality. Absolutely true. So many data will show DIG study, delivered trial, so and so, that this never causes reduction in the mortality. But this is well proven fact, and that is head-to-head comparison from the beta blocker, calcium channel blocker, and this diuretic, that this causes reduction in the recurrent hospitalization. So if someone is very cost-effective molecule, if this has property to reduce the recurrent hospitalization, definitely having some beneficial role in our community to prevent a recurrent hospitalization. But there is always concern while using the digoxin. Therapeutic, the range for this molecule is very narrow. So therapeutic range is around 0.5 to 0.9 nanogram only. And digoxin, this toxicity arises when this concentration raises above the 1 nanogram per ml. And usually if it is more than the 1.5, there's always a problem arises. Drug interaction, this is very important. If you remember our pharmacology and medicine classes, digoxin can cause any type of arrhythmia except type 2 AV block, Wenke-Wag phenomena. So this causes Brady, tachyarrhythmia, and so and so. Any kind of side effect is possible with the digoxin. This is some preparation, and that is the old way. Regarding current status and ACC and AHA, this is one DIG study, Digitalis Investigation Group, and they found digoxin never reduced nor increased overall the mortality, through it reduced hospitalization both overall and for worsening heart failures. So concern is always there. Right now, while managing HFrEF patient, me and all my friends, we have a group of drugs. But how to reduce the recurrent hospitalization? So issue concerned with digoxin, I will come in the subsequent slide, what should be taken in this, consideration. Subsequently, it was demonstrated that higher blood level of digoxin were associated with worse outcome, while lower blood level associated with better outcome. So what does it mean? Therapeutic concentration of this digoxin is important. And practically what happened? Most of time, this always we are using where LV function is poor, and always we are having diuretic subset when using the digoxin, rheumatic mitral stenosis or HFrEF patient. And both digoxin and this diuretic, this causes hypokalemia, and this is a very important soil for development of arrhythmia. So these things should be maintained. So therapeutic concentration, as I mentioned, this is the 0.5 to 0.9 nanogram per ml, and if it increases more than 1, 1.2 and 2 nanogram, this seems to be worsening outcome. Blood level of digoxin, as I discussed, this is the important parameter while managing this, using this digoxin. This debate regarding this mortality rate and digoxin, is it true that it increases mortality? Not at all. This is a various meta-analysis, and this was used in two subsets of patient, in patient with a poor LV function with the sinus rhythm and in the atrial fibrillation patient. Always when digoxin was used in the atrial fibrillation patient to control the heart rate, there was no worsening of mortality as the comparator group, that was the placebo as in the digoxin arm. Digoxin reduces the incidence of death or hospitalization due to worsening heart failure. Yeah, there is definitely reduction in the recurrent hospitalization in the worsening heart failure. Incidence of death or hospitalization due to worsening heart failure in the digoxin or placebo arm. This is going to compare here. You see in the digoxin arm and the placebo arm and having the p-value significant less than 0.001. So recurrent hospitalization reduction was noted in digoxin arm as compared to placebo. Digoxin did not increase or decrease the mortality, but it did reduce the readmission for the systolic heart failure. As I mentioned in my discussion, when their LV function is good and patient is not having the sinus rhythm, patient having the atrial fibrillation of fast ventricular rate, this molecule is always a very wonderful molecule. Digoxin therapy may be improved prognosis in advanced heart failure with atrial fibrillation under normal optimal medical therapy, but no patient in the sinus rhythm. This is the one trial, two arm and this comparison, one patient with a low ejection fraction and 40 months survival was studied in the sinus rhythm and atrial fibrillation arm. So you see in the patient when they were having atrial fibrillation, cumulative 40 months survival in patient with atrial fibrillation is stratified according to digoxin medication, so better response while using the atrial fibrillation arm as compared to sinus rhythm arm. This result shows that this may be improved patient selection for the digoxin therapy. The selection of patient is important. Coming to digoxin significantly improve all-cause mortality in the atrial fibrillation patient with systolic, severely reduced LV function. As I discussed, digoxin is not a good molecule while used in the sinus rhythm or good LV function. This one, rate AF study, rate atrial fibrillation study, and this was discussed in the different NYHA classes from class 1 to class 4, and it was found that when it was given in the NYHA class 4 patient was severely symptomatic and with a very poor LV function, outcome was better, and it was persisting improvement in the reduction in the recurrent hospitalization was noted up to 12 months in when NYHA functional class was high as compared to NYHA class 1 and 2. So it is possible that result of this rate F trial will rejuvenate digoxin therapy for heart rate control in patient with atrial fibrillation. Despite the result of rate F trial, I am sure that debate over the benefit versus risk associated with this 2-year-old drug will be continued. Yes, debate and discussion should be always there. This is one important trial, device registry, that is latestly carried out in the 2014, and here the comparator was even this ICD and other molecule was there. So what the recommendation regarding the use of digoxin? There is a Brazilian study and Canadian study, ESC, SEC, and HA. One thing, be cautious when you are using digoxin in the atrial fibrillation, in the supraventricular arrhythmia with this poor LV function. But if some problem there is in the accessory pathways, they are never use digoxin. That is not supposed to be a better drug. This is good drug for supraventricular arrhythmia and atrial fibrillation, but not when patient is. So this should be ruled out accessory pathway. So what is the recommendation for the ESC guideline in the management of the role of digoxin and where we can put it? So you can use this molecule. This was carried on the 2016, recurrent in heart failure, heart rate control in patient with AF with the ejection fraction both with less than 40 and more than the 40. I am not telling 55 and 60. You can use with the reduced ejection fraction and maybe with the mid-range ejection fraction, not more than the 50. So where is the stand for SEC and HA? That is a big boss for deciding every drug and class of recommendation. So recommendation for the pharmacological treatment for the stage C HFrEF patient. What does it mean stage C? SEC classification, patient is strongly symptomatic and having some structural and functional heart diseases. So stage T HFrEF patient, the reference studies that support a recommendation are summarized that this is class 2B indication and level of evidence is B to R. So in patient with symptomatic HFrEF patient, despite GDMT guideline-directed medical therapy, for who is unable to tolerate GDMT, digoxin might be considered to decrease the recurrent hospitalization. 2B level of evidence B2R, we can use this molecule. This is a recommendation from the ACCHA for reducing recurrent hospitalization. There is some ongoing trial is going on, DIGIT-FHF decision trial and DIGI-STA trial is going on, and there is still very good hope for a molecule in the future. So before thank you, I'll summarize in my words because sir is here and sir given me this talk. Should we say bye-bye to this molecule? In my words, if I will say, I will not say bye-bye, but I will be patient-specific. Is it really requirement for the patient? So I will choose subset of patient that in my patient, the rheumatic mitral stenosis, and I know few intervention cardiologists are sitting here in the government setup. If you are sending in the Lari and PGI for the PTMC, even they cost around 20 to 25,000, and for valve replacement 1,50,000, and waiting time is 3 years. What to do with that kind of patient? So that kind of patient, I am supplementing digoxin with the fast ventricular rate, with atrial fibrillation, with the diuretic and supporting medication. Regarding this HFrEF patient, now we have the option like SGLT2 and ARNI. Now SGLT2 is a quite cost effective. So in that cases, okay, might be say we can bye-bye, but while managing the rheumatic mitral stenosis, there is still hope that we can make it customized that our patient is having fast ventricular rate with atrial fibrillation, not in sinus rhythm. There is no possibility of toxicity for in the recurrent visit. Let us go and check their ECG, may go complementary ECG and see the some electrolyte abnormality that can be judged by ECG. So this thank you all from my side. So there is still hope and some ongoing trial and some pleiotropic benefit might be considered with this molecule is going on. Thank you. This is all from my side.
With permission of the chair, can I comment? With permission of the chair, can I comment? Very well presented, Dr. Sadiq, and the cardiologists who are primary care cardiologists who are practicing in small districts. I think Lanoxin is the only drug that is saving thousands of the patients. Can you imagine a patient coming to your clinic with 150 heart rate, BP 90, and acute pulmonary edema? I think anybody in the audience cannot have courage to use metoprolol and ARNI like drugs in this situation. I think Lanoxin is the only drug which can save the patient, and I have saved hundreds of the patients. Except for the patient who are already volume depleted, they are stabilized. We can use metoprolol and ARNI and whatnot. But I think Lanoxin is the only drug which can save the patient life in acute pulmonary edema. Thank you very much.
We agree. Thank you very much, Dr. Saab, for covering in and out of very heart-friendly, the oldest molecule, digoxin. And we all know that this is the most precious molecule we are using since long to save our patients, cardiac patients. So now I think you are the last speaker of today's academic feast. The house is open for the questions if anyone wants to discuss.
No, still more is here. More session is going on.
Ma'am, if you allow, Dr. Sajid has given an excellent lecture.
I was expecting question from Dr. Ajay.
No, there is no question. Cardiologist, you can say I practice both clinical cardiology, interventional cardiology, non-interventional cardiology, everything. I fully agree with Dr. Sajid what he said, that we cannot say no and bye-bye to Lanoxin, because Lanoxin is still a very good drug for all our patients of heart failure with atrial fibrillation. Definitely for atrial fibrillation with heart failure, it's a wonderful drug to control the heart rate. And even in the patient, those who are having heart failure with severely reduced ejection fraction, what you have rightly said, that not you only sitting in Lucknow, we sitting in Varanasi also, and people sitting in Sultanpur also, we also face the similar type of problems. that people are unable to afford cardiac transplant therapy. You send them wherever you want. The rejection fraction is 15%, 20%. In those patients, we need to give them digoxin therapy. The only point which I will like to highlight here that whenever you are prescribing lanoxin, whenever patient comes to you, just do 2 investigations every time. One is ECG, other is creatinine electrolyte. Why? Because these patients are on diuretic, these patients are on aldactone group of drugs and furosemide and all those. We need to know what is the potassium level, because lanoxin can, if the higher the potassium is lower the level, more arrhythmias will occur. And we should need to see what is the QRS duration, PR interval, because whenever you're giving a lanoxin, so ECG and creatinine electrolyte in every visit of all patients who are on lanoxin therapy, and we cannot say bye-bye to lanoxin, it's still a wonderful drug.
Thank you. Thank you.
Persons for the next session, I would like to invite Dr. Syed Atikul Haq, Dr. Syed Atikul Haq, Dr. Ramesh Arora, well-renowned clinician and diabetologist from Kanpur. So, Dr. Syed Atikul Haq is not here. I would like to request Dr. Preeti, young and dynamic HOD, Department of Medicine, AIMS, Bhatinda. Please, ma'am, come on stage.
The next topic, it's the last session, but a very interesting and very important session. Dr. Purvi Chawla is with us. She is going to tell about diabetes in women. How is it different? What is the difference between a male person having diabetes and female person having diabetes? Dr. Purvi Chawla is a consultant diabetologist and director of clinical research, Lina Diabetes Center, Diabetes and Beyond Diabetes Center. She has got very many achievements. Due to lack of time, I request her to start.
Thank you so much. Good evening, everyone. This is one meeting I would have gotten extremely upset if I wasn't invited. So I'm extremely thankful to the entire team of ACP and for giving me this wonderful topic. Speaking to a hall of cardiologists primarily, I think this is just setting the tone, trying to get your attention to how diabetes, is a conducive environment for cardiovascular disease and how is it different in women. So without much ado, well, seemingly it appears that probably there are more men with diabetes than women in the world, and so is the case in Southeast Asia as well, the topmost for diabetes. But look at the lifetime risk in young women, especially when confounded with obesity or overweight. It's accentuated even more. If you now consider the number of deaths due to diabetes in adults, again, yellow is women, pink is men, you can see that there is more death due to diabetes in women than men. Now let's understand biological sex versus gender differences. Well, biological sex causes the sex differences attributable to the genetic and the hormonal attributes, and it impacts not only the disease pathophysiology, clinical manifestations, and the response to therapy as well. Gender, on the other hand, is an outcome of lifestyle, environment, nutritional habits, exercise, smoking, etc., etc. And that the gender constructs determine the patient's perception of the disease, the help-seeking behavior, also the use or access to health care, decision-making, and therapeutic response as well. So here you can see that all the factors impact both the sexes differently, males as well as females. Well, specifically the metabolic challenges in a woman's life cycle present themselves at puberty, menstrual cycles, preconception, pregnancy, breastfeeding, perimenopause and postmenopause period. Looking at the global trends in obesity, although obesity is a rising problem around the world, in India itself there are at least 9 million more women who are obese as compared to the men. So it's a huge, huge problem here. And the dual burden of malnutrition and overweight and obesity in women is also more prominent, is higher in women, whether it's malnutrition or overnutrition. Both are more prevalent in women in urban as well as rural areas as well. Generalized obesity and abdominal obesity and the prevalence of metabolic syndrome. Metabolic syndrome with its components of dysglycemia, dyslipidemia, obesity and hypertension and liver fat, etc. So again, the prevalence in women is very high. And why are we talking about obesity and why am I digressing from diabetes? Because the relationship, large studies like the Nurses' Health Study and the Health Professionals Follow-Up Study have clearly shown that with every BMI increase, BMI unit increase, the women in green, you can see that the risk for type 2 diabetes increases exponentially as compared to the men. And these numbers are only going to increase further as projected by these and given in the 10th Atlas of the IDF. Coming to polycystic ovarian syndrome, a complex metabolic disorder characterized by hyperandrogenemia, visceral obesity and insulin resistance. It creates a conducive milieu internally that is not only more prone to diabetes but also a perfect combination or a perfect storm for cardiovascular disease. Women with PCOS have 4 times higher risk of diabetes than their controls. Well, pregnancy, hyperglycemia in pregnancy affects 16.7% of the women globally, and Southeast Asia has the highest prevalence, 28%. And we know in India it varies up to 18 to 20% as well. So why is this hyperglycemia in pregnancy important? Well, the maternal lifestyle given over a genetic predisposition, and this lifestyle, whether healthy or unhealthy during the preconception and gestational period, impacts the fetal programming in the baby and renders the baby, in case of unhealthy lifestyle choices, renders the baby more susceptible to childhood obesity, early onset of diabetes and cardiovascular risk. And this vicious cycle, this baby goes on to becoming an unhealthy parent as it grows further. So you know the cycle continues with all these epigenetic modifications that it causes at the time of the fetus. So this fetal programming period or the hyperglycemia in pregnancy has to be tackled extremely critically. Well, again, a BMG 2020 publication from Kamlesh Kunti, Melanie Davis and group clearly showed that if the chance of getting type 2 diabetes when you have GDM is 10 times higher than in the healthy controls. And similarly, the risk for cardiovascular disease, the relative risk is 1.98, which is significantly higher in those with prior GDM. In fact, even if you had GDM and you did not develop diabetes in the subsequent few years, your risk for future cardiovascular events is as high as 56%. I think that's a significant number to deal with. And that too in the first decade postpartum, so you're still in your middle age. The Singapore Chinese health study clearly showed that higher the parity, higher the risk for type 2 diabetes. In fact, pre-gestational diabetes, that is diabetes before pregnancy, and non-alcoholic fatty liver disease are also very closely interrelated. And women with GDM, in fact, the risk of NAFLD increases twofolds. The other factors for NAFLD are menopause, metabolic syndrome, older age, ethnicity, unhealthy diet, sedentary lifestyle, and of course genetic predisposition. And you can see that estrogens, the ones protecting against NAFLD, are all gone or low at the time of menopause, which increases the risk further. In fact, the diabetic female as compared to a diabetic male has much greater liver fat, and this has been seen in the study which did the MRI at the L5, L4 lumbar spine. And this, because of the gradual decline of ovarian, the gradual decline in the occurrence of ovarian senescence and the decline in the estrogen levels increases the fat as well as the steatohepatofibrosis in the aging woman. This brings me to menopause and diabetes. Several factors like central deposition of fat, increase in the visceral fat, increase in the testosterone, decrease in SHBG, and that entire inflammatory milieu within renders the woman more prone to diabetes in that perimenopause or postmenopausal period as anything else. And also to cardiovascular risk if in case the lifestyle is really, really unhealthy. Early menopause and premature ovarian insufficiency are also associated with a higher risk of type 2 diabetes, and a later menopause at 55 years of age is also associated with higher risk of diabetes. Diabetes, again, at menopause is associated with very low HDL levels and high levels of LDL, again increasing the cardiovascular risk in the woman. Consequences of diabetes. As far as microvascular complications go, well, increase in neuropathy and nephropathy are seen much higher in women as compared to men with diabetes. But the most important is the macrovascular risk or the cardiovascular risk shown by the Framingham study right in the beginning, 20-30 years ago, that if you are a man with diabetes, your risk for cardiovascular disease increases only twofolds. But if you are a woman with diabetes, and your risk for cardiovascular disease increases 4 to 5 times. Well, this is further corroborated by a very recent systematic review and meta-analysis, which said that women with diabetes as compared to men with diabetes had 13% greater risk of all-cause mortality, 30% significantly greater excess risk of cardiovascular mortality, 58% greater risk of coronary heart disease, and 8% greater risk of stroke mortality. Again corroborated by another meta-analysis as well. Diabetes as a risk factor for stroke was also studied, and women with diabetes seem to have greater stroke incidence than the men with diabetes. And smoking in women seems to have a much worse outcome because it's associated with a high risk of early heart disease, as smoking decreases the estrogen levels and even precipitates early menopause. The female-specific risk factors associated with cardiovascular disease, and you can see across the spectrum of cardiovascular disease, it's PCOS, gestational diabetes, pregnancy-induced hypertension or preeclampsia, and preterm birth. Cardia study, again a wonderful study that showed that the risk for cardiovascular disease is very high in women, and you can predict this if they've had a preterm birth or if they had a small for gestational age baby. And in fact, if they had both, the risk would be more than 10%. Coming to the gender differences in diabetes, as far as depression and anxiety go, women with diabetes experience twice as much as depression and anxiety as women without diabetes. Again, sexual dysfunction is highly prevalent in women with diabetes. It's also prevalent in men with diabetes. The incidence is up to 50%, but in women, you can see that this systematic review and meta-analysis published just in 2019 showed that it was as high as 68.6%. And if we ask ourselves, none of us are even asking or leading that or eliciting that history from our patients today. So again, because of vascular dysfunction or psychological distress or vaginal dryness, infections, decreased desire and ovulation, early menopause, and the havoc created by the ovarian hormones, all these lead to sexual dysfunction in females with diabetes, and it's an important outcome that must be asked. Osteoporosis and fracture risk, well, women with type 2 diabetes have more than 30% increased risk of major osteoporotic fracture and more than 90% increased risk of hip fractures compared to those without diabetes. And again, drugs have to be very carefully chosen for those with diabetes. Diabetes and cancer, we know again the relationship is well established by several reviews and meta-analysis. And in fact, as far as women is concerned, the risk is high as far as breast, bladder, colon, colorectal, gallbladder, and so on. Cancers of these organs are much higher in women with diabetes than otherwise. And all the reasons for the same are listed here. So why the inertia to prevent diabetes? Well, there are several barriers. Again, these also have been studied. So we know we have quite a bit of information about it, but we are just not intervening in the right manner and the right time. So due to lack of time, which comes under personal barriers, there may be health system barriers, where there may be socio-cultural barriers, economic barriers, psychological barriers, so on and so forth. But women do not prevent diabetes. There is also pay inequality which exists, and this is a global phenomenon. It's not just in India. Decision making may be more with the male partner at home rather than the woman, and healthcare expenditure, drug costs, doctor consults, laboratory tests, etc. may become a priority for the man as compared to the woman with diabetes. Underrepresentation of women in cardiovascular clinical trials. Again, across the spectrum, whether it's a hypertension trial, coronary artery disease trial, diabetes trial, women are underrepresented, which means we learn less, we have knowledge gaps which adversely impact the women. Even the lipid medication, whether it's the addition by the physician or the adherence by the patient, it's really, really low in women as compared to men. Therapeutic inertia is also high and severely high in women as compared to men with diabetes. There are several social determinants of these differences. This is the gender impact which I was talking about, whether it's early marriage, or medical and social complications of complete lack of preconception care, childhood experiences, housing, family income, so on and so forth. Everything seems to impact this evolution or occurrence of diabetes in women. Again, digitization, we know it's a great boon, but it also comes with a price that we pay. Women are less physically active and more sedentary, and that is rendering them more overweight, obese, as well as more prone to diabetes. Gender-wise pattern of physical activity has been studied, and guess what? Women, whether it's urban or rural, are the worst in recreational physical activity as compared to men. Again, leading them more to non-communicable diseases like diabetes. So why women and diabetes? Diabetes in women is different, difficult, disabling, dismissed, and associated with more death. So let's come together and apply that gender lens, and I'm hoping that this astute crowd today or audience today that we have, some of you will raise that voice for gender-specific guidelines that we all can apply for our patients. Thank you very much. The entire team of ACP, Dr. Anuj Maheshwari sir, Dr. Narsingh Verma sir, Dr. Srinivas Murthy sir, Dr. Anubha Verma, and Dr. Sridhar sir, for this wonderful opportunity, and for all of you for staying back for the talk. Thank you very much.
Thank you, Dr. Purvi. It was a very informative and very interesting topic. You have very nicely explained the metabolic changes in females and how important it is to address diabetes and CVD in females.
Wonderful presentation. She's so busy. She came 10 minutes after the scheduled talk. She's so busy. But wonderful presentation. The basic difference is due to variation in hormonal level in different stages of life. Pregnancy, lactation, menopause, anything. Very nice thing. Thank you. Very nice presentation.
Thank you so much, sir.
Our next speaker, the last one of this today, is Ajay Pandey. K.N. Manohar. Right, K.N. Manohar, right. Statins. Why should When should we start and not to start or stop? In 1976, in Japan's Senecio, one biochemist named Akira, he isolated statin from a fungus, and statin was welcomed throughout the world. Millions and millions doctors and patients used and got better effect. We all know the all aspects of statin, but there are few questions. Let us revise statin, when to start, when to stop, and when not to start. For this, we have excellent doctor, Dr. Manohar KN. He is MD, DNB, triple RCP. Due to shortage of time, I think this is enough. He is consultant physician in Manipal. Over to Dr. Manohar.
Thank you very much. It's fine. Well, thanks for the opportunity, ACP chapter, and thanks for the introduction. Statins somehow are always in the midst of the controversy. So let's see. I don't have any disclosures. Thanks to the ACP for bringing me down here. Cardiovascular disease, we all know, is a major cause of mortality worldwide. Some points, other points we need to know. We traditionally do the fasting lipid profiles. So how about the non-fasting? LDL was the thing which is always being talked about. What is the scope of non-HDL cholesterol and lipoprotein little a and apo A and B? I think they are gaining momentum and importance. So I thought fasting versus non-fasting, and most of the guidelines, if you look at it, you say calculate the ASCVD risk score. So how many of us really use the calculator? Any show of hands? Every time a patient walks in with dyslipidemia, how many of us open the calculator on the net and type it down? Every time I give a talk on statin, I do it for a few days and then leave it. But say one slide will tell you it's not always required. I'll come to that. Fasting versus non-fasting, what is the difference? The difference is, as you can see, is only in the triglycerides component of it. It also depends on what food they have taken, how long after the meal we have done the lipid profile, and also the water consumption. These are the three factors, and the marginal difference is about plus 26 milligram per deciliter. Otherwise, if you look at the total cholesterol, LDL and non-HDL cholesterols, they show slightly lesser value when you compare it to fasting to non-fasting state. That's why the Lipid Association of India brought up a beautiful guidelines. We always allude to the other guidelines, so I thought I will put our own guidelines. In the 2 visits, if you take it, if someone has done one lipid profile in fasting, next time you get it in the postprandial state, which is required to determine the postprandial hypertriglyceridemia, which is also equally important marker of cardiovascular disease. So if first time they have done fasting, next time random you can choose, or vice versa. So is there any evidence about statin benefit? Well, overwhelming evidence. If you look at across high-risk group to primary prevention to secondary prevention, with all the statins, what I have listed there, the relative risk reduction for ASCVD is 20 to 50%. So there are some debaters in our own fraternity who talk against statin. At least if you want to go by the evidence-based medicine, it has to be there. As Sir was introducing, Akira is the person who started working on it, and Joseph Goldstein won the Nobel Prize for the work on statin. So if you want to classify natural versus synthetic, lipophilic versus hydrophilic are the usual classification we look at. Rosuvastatin is hydrophilic and atorvastatin is lipophilic. Mechanism of action, we all know HMJ-CoA reductase inhibitor, statins work there, and now the new kid on the block, bempedoic acid, works 2 steps ahead of it. So what they say is possibly it has glycemic benefit. We all know statins are associated with new onset diabetes, but bempedoic acid, which works 2 points above that, also activates the AMPK and has possibly a beneficial role in glycemia. And the effect of lipid lowering drugs, of course, statins are by far the most powerful one, especially when you look at the LDL and the HDL, unless you consider PCSK inhibitors, PCSK9 inhibitors, which are much more numerically beneficial with respect to that. High-dose fish oils, especially useful in triglycerides, lowering, and the dose should be 1 gram twice a day at least. And ezetimibe is a good add-on to statin therapy, and niacin came and went because of the side effect profile. The other thing what we talk about, the intensity of statin therapy. Previously we used to write some statin at a small dose is good enough, or we need to go intensifying the statin therapy with respect to high intensity statin therapy, which lowers the baseline LDL by 50%, or the moderate intensity, which lowers between 30 to 50%. And again, adding on these medications, which I showed in the previous slide, will give you an additional benefit of LDL reduction over and above what we get it from the statin usage. Basis of treatment is risk stratification. Very, very important, busy looking slide. But if you look at major ASCVD risk factors, other high risk features, and moderate risk, non-conventional risk factors like the calcium score and so on. That's how you stratify your patient and then decide whether you want to put them in the lowest risk group to extreme risk group, which has come up of late, who have CAD with more than one feature of very high risk group, or recurrent acute coronary event, or ASCVD. Despite LDL of less than 50, now they put it to the LDL level of 30. Why? They say that was the number you had it when you were born. LDL was around 30, and unlike other animals or mammals, we keep increasing our LDL. So the goal in this extreme risk group is to get it down to 30. Again, the lipid association risk stratification, what I said, I'm sure it is a busy slide, but if you can dissect, that is what, when should you add on the medications? And this is a newer classification of extreme risk group, where even at 50, if they are having coronary events, we look at reducing it to around 30. Otherwise, the high risk group was the usual talked of, where we targeted LDL cholesterol to keep it less than 70 milligram per deciliter. This is the calculator what I was talking about. Few features we need to keep in mind, but do we really do it, or how often should we do it? So the answer to that question, I'll come up again later. Another important aspect is the changing guidelines. This is very interesting, isn't it? When we were in the college time, maybe 160 LDL was okay. Now, when you look at a high risk group, you want it 50 or even lower. So in the consultation, it could be like that. Your cholesterol has stayed the same, but the guidelines have changed from the last year, and then you didn't need a statin, but now you possibly could need it. If you look at the European guidelines, again beautifully depicted here, treatment goal for LDL is based on the low, moderate, high and very high risk group. Again, it is all numerical values what we need to look at it. We will calculate the ASCVD risk group, and if score is more than 10%, and if they have ASCVD or another major risk factor, or a CKD, diabetic and other target organ involvement, they will have a very high risk group, and we need to go less than 55 is what European Society tells us. Again, how do we approach it? Again, statins are the most potent of them, not only to reduce the LDL cholesterol, but also to provide mortality benefit. There's no point just reducing a cholesterol with any agent, but if we can add on mortality benefit, may it be due to pleiotropic effect or whatever we call it as. So that is the number one drug to be used. Others like ezetimibe can be combined, and maybe PCSK9 inhibitors, as the case may deem, based on the LDL levels and the risk group and where you want the LDL cholesterol to be figured out. So coming to the main question, indications for statin therapy. So are we justified for statin in high risk group? Very, very important slide. If you look at the statin eligibility, ASCVD or just an LDL of more than 190, or a diabetic with ASCVD of more than 7.5 or less than 7.5, the number needed to treat that, to give any benefit, is depicted there. So if someone has an ASCVD, you just have to treat 9 individuals to get them to avoid one more coronary or cerebral event. So that's the very, very importance of this discussion is that the number needed to treat, even though we have other medications now, even in diabetics, the number needed to treat, if ACVD is more than 7.5, is just about 15 patients. So, which are the 4 major statin management groups? Again, the star suggests that here, only in the primary prevention in a non-diabetic, where you look at the LDL cholesterol between 70 to 190, that's where we need to open our calculators if we need to open. Otherwise, if, as a secondary prevention, if someone has a LDL more than 190 and is about 20 years of age, or a primary prevention in diabetic, and LDL more than 70, no need of calculator, you can just go ahead and prescribe the statin dose. If you split up into the ASC, clinical ASCVD, if the age is less than 75, go for the high intensity statin therapy. Or if they are more than 75, moderate to high intensity statin therapy is fine. And again, you look at the ASCVD risk and potential adverse event and frailty of the patients and then decide. Previously, it used to be told that more than 70, there was no evidence, so don't use the statin, but that doesn't hold good there. And if someone has a heart failure, we know that life expectancy is less, but if it is more than 3 years, definitely consider moderate intensity statin therapy. And the other group where LDL is more than 190 and age 20 to 75, again, high intensity or maximally tolerated statin therapy is advisable. So primary prevention in type 2 diabetes, again LDL 70 to 189 and age above 40, moderate intensity statin therapy, irrespective of your 10-year risk, is advisable there. And if the age is 20 to 39, even in a younger population, you can consider the statin therapy if the long duration of diabetes or microvascular disease exists. Again, we used to not use much of statin between 20 to 40 years. So again, the evidence says that you can still consider the statin therapy based on the duration of diabetes and the presence of comorbidities or multimorbidities, as we say now. So how do you follow up the patient? Lipid panel 4 to 12 weeks after initiation and then every 3 months to 12 months depending on the spectrum, and responses are defined by the percentage of LDL reduction from the previous baseline. That's where we decide about high and moderate intensity of statin. And if ASCVD patients are at very high risk, LDL more than 70, trigger consideration of adding non-statins to maximize the benefit of statins. And the last point is you don't have to routinely measure the transaminases. So you decide that this is a very important place of talk. Like you have decided that patient needs statin therapy. How do you know it was really needed? So this meta-analysis, if you look at it, adherence to cardiovascular therapy, what it said is if more than 80% of the statin dose have 45% relative increase in total mortality. So if more than people have missed taking statin when indicated, if you look at the forest plot, it says every time they have missed it in a significant way, their mortality also goes up. So that underscores the importance of use of statin therapy. Side effect, well, everyone knows myalgia, myopathy, and sometimes people have cognitive defects, and new onset diabetes is always a point of debate. And statin resulted in higher odds definitely of diabetes mellitus and transaminase elevation, but the risk-benefit ratio definitely points to the use of statin than not using it. So various trials, if you look at again the meta-analysis, it is skewed. Some studies have shown increased incidence of diabetes, some not so much. So how do you tackle the associated side effect? We said liver disease definitely is a contraindication, but if it is a chronic stable liver disease, you can discuss with the patient, monitor the transaminases, and still you can utilize the statin therapy if they fall into a high risk category. And also side effects of myalgia should not stop it. We can use a lowermost dose or shift to a less potent statin as compared to the higher potent statin or higher the doses. So when not to start, definitely when not needed as the famous 4 indications. And in acute care setting, especially when there is a risk of renal failure like rhabdomyolysis, sepsis, hypotension and trauma, you should be careful. And of course, when there is an intolerance, hypersensitivity, pregnancy and lactation, or acute or chronic liver disease where you can't monitor the transaminases, it should be avoided. So ASCVD risk reduction is the key parameter, not just the dyslipidemia. Now we are looking at ASCVD risk reduction, and no better drug to reduce the risk other than the statin. The big 4 indications I told you, and new onset diabetes definitely exists, but you need to weigh the pros and cons and then decide about its usage. So this is my last slide. As always said, the statin gets into controversy. You want to think of using an ounce of prevention to prevent tons of treatment, or you want to think about the side effect and say like primum non nocere is lefty. Thank you very much.
Thanks. Nice presentation. Nice. Of course. Suppose the patient is alcoholic. He has got liver impairment and he is having ischemic heart disease. What strategy you are going to prefer?
Yeah, as I showed really there, we need to first is a discussion point has to be there. Second is monitoring of the liver enzymes. If there is a high risk group and if he is willing to comply, which is always difficult in an alcoholic, to abstain from alcohol and come for regular follow-up, still on a guarded basis, we can still use the statins. But all these criteria should be ticked and then only.
Okay, thank you. Thank you, sir.
Thank you. More than 3 times of normal, cautious. More than 5 times, don't use it. Yeah. Thank you.
Thank you. Thank you. Our next speaker is Dr. Manoj Chawla, and the topic is very, very interesting and useful: nocturnal hypoglycemia, the fear in the dark. I invite Dr. Chawla. He is MBBS diabetologist, and he has got many achievements, but due to shortage of time, I am asked only to introduce Dr. Manoj Chawla. He has been elected All India Executive Member, RSSDI 2022, and many achievements he has got.
Evening, everyone, and thank you, Chairperson, sir. Apologies for my late arrival, but I'm glad that the organizers could still allow me to speak in this hall nonetheless. Over the next 14 minutes, let me focus on nocturnal hypoglycemia. Why do we need to talk about nocturnal hypoglycemia? How is it different? ये काम करता है? Okay, sure. Right, so we all understand when we talk about managing diabetes, it's all about the balance. We of course don't want our patients to have hyperglycemia. At the same time, we want to avoid hypoglycemia, which is the most common and most serious complication, especially of insulin therapy. There still continues to be lack of understanding among the healthcare practitioners and patients, and the fear of hypoglycemia, especially if it happens in the night, and which is why the focus of the fear in the dark. Now, what is nocturnal hypoglycemia? It usually occurs during sleep, disrupts the sleep quality, the quantity and the functioning the next day. It may affect up to 41% people with type 1 diabetes, 16% people with type 2 diabetes. The important part impaired cognitive function, poor concentration, resulting from recurrent hypoglycemic episodes. Now, cardiac impact of nocturnal hypoglycemia, how is that different? So we know hypoglycemia can have cardiac aspects also, and there are subtle differences what happens during a nocturnal hypoglycemic episode. So bradycardia and atrial and ventricular ectopics or arrhythmias are found to be significantly higher during nocturnal hypoglycemia. And that's one of the clinking factors for nocturnal hypoglycemia and cardiac correlation. Consequences? Well, undetected nocturnal hypoglycemia in our patients may lead to anxiety, loss of vitality, physical injuries due to falls, and of course poor quality of life. It may also sometimes lead to seizures and unconsciousness, which have their own consequences. How do we define hypoglycemia? So the levels are pretty similar. There's no differentiation between nocturnal and daytime. The levels of hypoglycemia would be level 1 hypoglycemia when your patient's sugars drop to less than 70. Level 2 is when it drops to less than 54. And level 3 or severe hypoglycemia does not actually have a value to it, but any amount of severe hypoglycemia which makes the patient go for third-party assistance or requires an external factor to help him or her is defined as severe hypoglycemia. The symptoms, of course, most of us understand. The initial sympathetic symptoms of shakiness, headache, eventually leading to the neuroglycopenic symptoms of seizures, unconsciousness, and sometimes hypoglycemic coma. Now also interestingly, what really do you mean by the nocturnal window? And there's been a lot of different debates and a lot of different papers on what is really nocturnal. Is it a period between evening injection and breakfast? Is it between bedtime and breakfast? Is it between bedtime and getting up in the morning? Is it just 11 p.m. to 8 a.m.? So a lot of different aspects, but today, largely the consensus, especially when you look at the regulatory aspects in all the new drug trials, it is between 12 a.m. to 6 a.m. So some may define it as 12:01 to 5:59, and that's largely considered as your nocturnal period. Also important to dissect when somebody has nocturnal hypoglycemia, when did they really have it? Because there again, you have a difference in the first 3 hours as compared to the latter 3 hours. In the early part, you have slow wave sleeps, lower glucose needs, 30 to 40% of nocturnal hypoglycemia happens between 12 and 3. And a bedtime snack very often can prevent the nocturnal between 12 and 3. But when you look at the period, the second half between 3 and 6, which is where majority of nocturnal hypoglycemia usually occurs, it's part of your REM sleep, the higher glucose needs for an individual, and bedtime snack will not be effective. So your patient has hypoglycemia at 4:30 in the morning, do we advise them to take a bedtime snack? That may not be as useful as in the first half of the night. How do you capture this hypoglycemia? Well, history is extremely important. There are also hypoglycemia questionnaires that you can address, make the patients address, and of course the monitoring, be it SMBG, be it CGM, we have these tools today to pick up any of the hypoglycemia. So you have the Stanford Hypoglycemia Questionnaire, you have the Australian Health Association questionnaires where they're asking patients about aspects of do they feel depressed, how is the sleep quality, do they have trouble concentrating and so on. And each of those symptoms that they tick will add up to the score, increasing our suspicion of patients' hypoglycemia. And then of course you also have the Clark method and Gold method for picking up hypoglycemia awareness, and hypo-AQ questionnaires, which again will increase the suspicions towards hypoglycemia. A lot of this was used in the past, questionnaires for suspicion. What's important as clinicians to be aware that your patient who's complaining of tiredness, lethargy, excess sweating in the night, bed sheets getting wet, nightmares, they could be having nocturnal hypoglycemia. You could pick it up by CGM today, by a 3 a.m. SMBG, or any of these methods which are far more validated and accurate than just the questionnaires. When to suspect nocturnal hypoglycemia, and I'll quote RSSDI, nighttime sweating, nighttime hunger and anxiety, nightmares, labile morning sugars, and early morning headaches are some of those symptoms which should make us suspect nocturnal hypoglycemia in our patients. So detection through SMBG, CGM, and FGM is what we strongly promote. And if you look at the RSSDI consensus on SMBG, it does speak about the need for intermittent 3 a.m. sugars in our patients where you are suspecting or where you want to pick up a different point in range percentage as well. How do you really prevent and manage nocturnal hypoglycemia? Well, again, you look at the RSSDI ESI, and I would always love to focus on those recommendations than the American ones. The causes for nocturnal hypoglycemia could be metabolic defects, autoimmune conditions, dietary aspects, alcohol consumption, stress, infection, starvation, and severe excessive exercise, especially in the evening. So every time somebody starts a new exercise regimen, especially if they are on insulin, they are prone to nocturnal hypoglycemia, and there is an adaptation that you need to do in their dosage and their eating habits. There are many other risk factors, as we can see. Female gender more prone, progressive insulin deficiency, onset of CKD, worsening of CKD, and many such factors which make our patients prone for hypoglycemia. Risk factors for nocturnal hypoglycemia, we further look at the data there. Risk factors for excessive insulin levels is again exogenous insulin administration. Wrongful or erroneous insulin administration can lead to that. Reduced caloric consumption, of course, can lead to hypoglycemia. Long duration of diabetes. Patients who are insulin deficient themselves, which also means that they have poor counter regulation, will again be more prone to hypoglycemia. And there, those patients where we try intensive glycemic management are again the ones likely to be prone to hypoglycemia. So, what are the risk factors specifically associated with nocturnal hypoglycemia? Variations in daily routine, increased exercise and change in meal timing, size or content of meals, alcohol of course becomes a contributory factor, and type and timing of the insulin regimen or the specific insulin that our patients are using can again subject them to more hypoglycemia. Patient counseling and education is extremely important, and in the interest of time, I will not go in the details, but when you have your patient experiencing hypoglycemia, picking up hypoglycemia, having the conversation, looking at every aspect of their diet, their exercise, and their treatment, their insulin injection technique, what is the time of their meal, the nature of their insulin, do we need to move to the newer analogs which may have less hypoglycemia? All of these factors have to be considered besides the counseling and education of our patients. So how do we manage? The management doesn't change much. It's the same as your daytime hypoglycemia. The rule of 15 applies. Pick up hypoglycemia, 15 grams of simple sugar, glucose, whether it's glucose gels, glucose tablets, your glucose powders. Repeat sugar after 15 minutes. If it's still less than 70, you again subject them to 15 grams of glucose. In terms of severe hypoglycemia, those who are conscious, you increase the glucose amount. And for those who may be having recurrent nocturnal hypo or non-responsive, especially in type 1 children, you may consider using glucagon and keeping the glucagon injections at home to avoid rushing to the casualty and the hospital. Modification of ongoing treatment is important. So when you have patients with nocturnal hypoglycemia, revisit their therapy. Improvisation of the target, so slow down. If you are looking at 6.5, start loosening the target. Convince your patients it's okay to stay at 7.5 and 8, especially the ones who have hypoglycemia unawareness. They do not pick up the symptoms because of recurrent hypoglycemia. You loosen your control, let the sugar stay around 160, 150, 180. In a while, they'll be able to pick up in case hypoglycemia happens, their awareness improves. So bring down the targets, titrate your therapy, look at which of the ones are hypoglycemic agents, look at the insulin nature and try and titrate that. And of course, as I said, choice of insulin becomes extremely important here. The future direction in nocturnal hypoglycemia, it's often missed and increased awareness is required. And hence, we did have an expert group recommendations almost 2 years back in 7th of October 2020. Management of nocturnal hypoglycemia and insulin-treated patients is what we focused. An expert group meeting was held. And this finally, the fruit of that work was published in July 2022. It's an excellent clinical topic which all of us should focus more, and I'm thankful to the organizers here for bringing nocturnal hypoglycemia to the front line. So this was the advisory which has been published in Diabetes and Metabolic Syndrome. All of you who are interested in reading it in detail, please look it up in Diabetes and Metabolic Syndrome today, which is gained as the #1 peer-reviewed journal in Asia, Dr. Anup Mishra being the editor there. Finally, let me end by saying we did decide a couple of years back to recognize 20th November, which happens to be tomorrow, as World Hypoglycemia Day. This is to commemorate and honor Dr. James Collip, who was amongst one of the 4 insulin discoverers. We all remember Banting and Best and MacLeod. James Collip was the 4th amongst them, not celebrated as much as Banting and Best, but probably one of the major contributors. He's the one who actually coined the term, in that sense, hypoglycemia. And during his experiments on rabbits, by injecting the insulin, when the rabbits experienced seizures, hypoglycemia as a concept was realized. So here it is on his birthday, 20th November. We wish all of us celebrate World Hypoglycemia Day. With that, let me thank you for the patient hearing and staying back till late this evening. Thank you, Chair.
Thank you, Dr. Chawla. Excellent presentation, simple way to recognize, simple way to treat, and in short time. Excellent. Thank you, Dr. Chawla. Over to moderator.
Thank you. Thank you, chairpersons. And I would like to request to everybody, please come in next hall, that is BC Roy Hall, for the facilitation. So please come there, and dinner will be afterwards. So please come. Thank you.